and you probably don't give it a second thought. It's just, basic mundane nutrition.
Yeah, wholly harmless.
But if you step out of your kitchen and into an emergency room, that exact same mineral is suddenly the primary ingredient used to instantly, irreversibly stop the human heart.
Which is a pretty terrifying pivot when you think about it.
It really is.
Yeah.
So, we are talking about potassium today. Welcome to the deep dive.
Glad to be here.
Our mission today, for you listening, is to unpack potassium imbalance from like a clinical and nursing perspective. We're looking at this comprehensive medical text that covers the physiological first principles, the diagnostic cascades, the history, and really just how this one everyday electrolyte turns deadly.
Yeah, and while potassium imbalance might sound like standard dry textbook material, the underlying mechanisms here reveal a biological balancing act that is incredibly fragile. It's highly contested, it's easily misunderstood, and it really requires us to completely rethink what it means when a lab test tells you that your blood is perfectly normal.
Yeah, and that paradox you just mentioned is exactly where I want to start. Because to understand how potassium can stop a heart, we have to understand why doctors and nurses struggle to even measure it accurately in the first place.
It's surprisingly difficult.
Right. So the standard normal range for potassium in your blood, which is serum potassium, is usually listed as 3.5 to 5.0 milliequivalents per liter.
Exactly.
And if you drop below 3.5, you have hypokalemia. Go above 5.0, you have hyperkalemia. So on paper, it sounds pretty binary, like you're either in the safe zone or you aren't.
Yeah, but the problem with treating it as a binary is that the normal range is really just a population statistic.
Okay.
It's not this strict physiological cutoff that applies to every single human body in the exact same way.
So it varies from person to person.
Massively. A chronically ill patient, for instance, someone with long-standing kidney disease, they might walk around with a potassium level of like 5.8 for years.
Why?
And they might have zero symptoms, perfectly fine.
I guess because their body has had time to sort of adapt to that higher baseline over months or years.
Precisely. The adaptation is key there. But if you take a perfectly healthy person with a normal heart, and if their potassium suddenly drops from a 4.0 to a 3.0 in a matter of hours...
Like from a stomach bug or something?
Yes, severe vomiting, or maybe a new diuretic medication, that rapid rate of change can trigger life-threatening arrhythmias.
Oh, wow.
So the absolute number on the lab report matters significantly less than the rate of change or, the patient's baseline kidney function.
Right. Context is everything. So let's unpack the math behind this, because there's a physical reality here that the sources highlight as a major stumbling block for medical students. And that is the 2% rule.
Right. The 2% rule, this is crucial.
Yeah. So when a phlebotomist draws your blood to check your potassium, they're only measuring about 2% of the total potassium in your body.
Exactly.
And the remaining 98% is just hidden away, like locked inside your cells.
Yeah, and that distinction changes everything about how we interpret lab results. The blood draw is only looking at the serum. It is an incredibly poor proxy for total body potassium.
It's basically like judging someone's entire net worth by only looking at the cash they currently have in their wallet.
That is a great way to put it.
Like, they could be completely bankrupt. Their total body potassium might be entirely depleted from weeks of illness, but the wallet looks full because they just went to the ATM.
Right.
The body just shifted whatever potassium it had left out of the cells and into the blood to compensate, just to keep the serum level looking okay.
Yeah, that analogy captures the illusion perfectly.
Yeah.
I mean, the body will fiercely protect that 2% in the blood to keep the heart beating, even if the cellular reserves are entirely empty.
That's wild.
And the deception actually goes both ways.
Yeah.
You can also have a terrifyingly high serum potassium reading that is completely fake.
Wait, how can a lab result be fake? Like, if the machine reads a high number, the potassium has to be in the blood, right?
Well, it is in the blood when the machine tests it, but it wasn't in the blood when it was actually circulating in the patient.
Oh, weird, okay.
This is a phenomenon called pseudohyperkalemia. So imagine the phlebotomist uses a needle that is too small, or they leave the tourniquet on the arm for way too long.
Okay, so a bad blood draw.
Right. The physical pressure and that tight squeeze can actually cause the red blood cells to physically rupture inside the plastic collection tube.
Oh, I see. And because 98% of potassium lives inside the cells, when those red blood cells burst open in the tube,
They spill all of their hidden intracellular potassium directly into the serum sample.
Wow.
So the lab machine analyzes the fluid and spits out a critically high panic value, but the patient sitting in the waiting room actually has completely normal circulating potassium.
Which means if a doctor or nurse just treats the number on the screen and aggressively lowers that patient's potassium, they could accidentally cause a fatal heart arrhythmia.
Exactly. It really highlights why you have to treat the whole patient, not just the lab value.
Man. But it also makes me wonder if measuring this stuff is so incredibly deceptive and tricky, how did we ever figure out its life and death importance in the first place?
It's a great question. And to understand that, we actually have to step out of the modern hospital entirely.
Okay, where are we going?
The origins of this discovery take us back to London in 1883. A British physician named Sidney Ringer was working at University College, and he was studying isolated frog hearts.
Isolated frog hearts.
Yeah, he was trying to figure out how to keep them beating outside of the body in a saline solution.
Which sounds like something straight out of a mad scientist novel, honestly.
I mean, it was pioneering physiology at the time. Ringer was meticulously testing different mixtures, but the real breakthrough came from a happy accident by his lab assistant.
Oh, I love a good lab accident.
Yeah, right. So the assistant was supposed to use distilled water to make the saline solutions, but instead they just used London tap water.
Wait, London tap water, which is notoriously hard water, meaning it's just full of minerals.
Exactly, full of calcium and potassium.
Ah,
And Ringer noticed that the frog hearts bathed in the tap water solution kept beating for hours, while the ones in the pure distilled water solutions died almost immediately.
that is incredible.
Yeah, so through trial and error, he realized that the heart would only maintain its rhythm if it was bathed in a very specific, delicate ratio of sodium, potassium, and calcium.
Okay.
If he added too much potassium relative to the calcium, the heart went completely flaccid. It just relaxed and stopped beating entirely.
So Ringer essentially founds electrolyte cardiology by accident in 1883.
Basically, yeah.
But the sources mention this massive gap in the timeline here. We used his mixture, what became known as Ringer's solution, for decades in medicine without actually knowing why it worked.
Yeah, the 70-year gap is one of the most fascinating delays in medical history, honestly. I mean, Ringer proved that the ratio governed the heart's electrical behavior through pure empirical observation.
Right, he saw it happening.
Right. But the scientific tools of the late 19th century were just not advanced enough to see the molecular machinery at play.
They didn't have the microscopes for it.
Exactly. The mechanistic explanation required the invention of better technology, and eventually, a Danish scientist named Jens Christian Skou in 1957.
Okay, so what was Scow looking at that Ringer couldn't see?
Well, Skou was researching crab nerve membranes, of all things.
Perhaps.
Yeah, he was looking for the physical engine that controls cellular electricity, and he ultimately discovered the sodium-potassium ATPase pump.
Okay, the pump.
Yes, this is an actual molecular machine that sits embedded in the membrane of almost every cell in your body. It uses one molecule of ATP, which is cellular energy, to actively trade 3 sodium ions out of the cell for 2 potassium ions brought into the cell.
Oh, so he found the actual mechanism that maintains that 98-2 ratio we talked about earlier.
He did, yeah. And it actually earned him a Nobel Prize in 1997.
Wow.
But the clinical bridge here is even more profound, because around the exact same time Skou was mapping the pump in Denmark, Willem Kolff was refining the artificial kidney.
The dialysis machine.
Right. So for the first time, doctors treating kidney failure patients who were dying because their bodies couldn't excrete potassium could hook a patient up to a machine, systematically scrub the excess potassium from their blood, and literally watch the patient's electrocardiogram, the ECG, stabilize in real time.
That must have been like magic to see.
It was. They were finally mapping Skou's invisible cellular pumps to the visual electrical tracings of the human heart.
And that connection brings us to the core of the clinical text, right? The cardiac cascade. Because once you know this molecular pump exists, you can understand exactly what happens to a human heart when that potassium gradient just collapses.
Exactly. And the foundation of that collapse is the resting membrane potential.
Okay, break that down for us.
So every single heart muscle cell, every cardiomyocyte, maintains a negative internal charge of roughly negative 90 millivolts at rest.
So the inside of the cell is deeply negative compared to the outside.
Yes. And that negative 90 millivolts exists almost entirely because potassium is highly concentrated inside the cell.
Right, like 140 milliequivalents inside versus just the 3.5 to 5.0 outside.
Precisely. You can think of it like a massive hydroelectric dam.
Oh, I like that.
Yeah, that steep gradient, that huge difference in concentration creates immense potential energy.
Right.
So when the cell needs to fire, it opens the floodgates, the ions rush across, and you get a crisp, clean electrical spike that travels in an organized wave across the heart, which causes a heartbeat.
But if the potassium outside the cell starts rising, like if the water level outside the dam gets too high, the pressure difference just drops.
Right. The gradient is compromised.
And this leads to a very specific sequence on an ECG that medical professionals have to memorize, right?
Yeah.
Because it literally predicts cardiac arrest.
Yeah, it's known as the hyperkalemia ECG cascade. As serum potassium rises to about 5.5 to 6.5, the first thing you see are the T waves on the monitor becoming incredibly tall and sharply pointed.
Okay, the peaked T waves.
Exactly. They call them peaked or tented T waves.
And if it continues to climb, hitting like 6.5 to 7.5, the sources say the P wave flattens out and the PR interval gets longer.
Right, because the upper chambers of the heart, the atria, are physically struggling to initiate the electrical signal.
Wow. And then at 7.0 to 8.0, the QRS complex widens.
Yeah.
And the QRS represents the main pumping chambers, the ventricles, right?
That's right. Because the electrical gradient is so severely compromised at that point, the electrical signal physically struggles to travel through the heart tissue.
So it's literally just moving sluggishly.
Exactly. It moves sluggishly. And because it takes longer to finish its path, it literally draws a wider, fatter line on the EKG paper over time.
That makes perfect sense. Like the widening isn't just some random shape. It's a direct visual representation of the electricity slowing down.
Exactly.
And then if you go above 8.0 or 9.0, you get the absolute nightmare scenario. The widened QRS merges with the T wave into what's called a sine wave pattern.
Yeah, it just looks like a smooth, undulating wave on the screen.
Which is terrifying.
It is. And within minutes, that usually degenerates into ventricular fibrillation or just flatline asystole.
So practically speaking, for the patient in the bed, does a medical team wait for the lab results to confirm this cascade?
Oh, they absolutely cannot wait.
Really?
Yeah, emergency departments treat a new peaked T wave combined with the right clinical context as a life-threatening emergency before the blood draw ever comes back from the lab.
Wow, just acting on the visual alone.
You have to. You cannot afford to wait 45 minutes for a centrifuge to spin down a sample when the electrical stability of the entire cardiac system is literally unraveling on the monitor in front of you.
It really emphasizes how fragile this gradient is naturally.
Yeah.
Which makes the hook we started with even more terrifying, honestly.
Yeah.
Because the starkest illustration of this system failing isn't an accident. It's the standard U.S. 3-drug lethal injection protocol developed in the late 1970s.
It is, yeah. The pharmacology of that protocol relies entirely on exploiting the resting membrane potential.
Right.
The third and final drug given is a highly concentrated solution of potassium chloride, administered rapidly and undiluted.
So it artificially drives the serum potassium up so incredibly fast that the heart's electrical conducting system is wiped out instantly.
Exactly. It induces massive hyperkalemia to produce immediate cardiac arrest.
Wow.
It is a dark but irrefutable demonstration of exactly what clinical teams are trying to prevent. And it is the precise reason why, in any hospital setting, IV potassium is classified as a high-alert medication.
Right, because of the danger.
A nurse will never, ever push undiluted potassium rapidly into a patient's vein. It is always heavily diluted and given slowly over hours.
That makes total sense. But intentional extremes aside, the sources also dive into how medications interact with this system in deeply paradoxical ways.
Yes.
Like the classic example in the text is the digoxin paradox.
Oh, digoxin is a venerable drug. I mean, it's been used for decades to treat heart failure and rhythm problems. And nursing students are taught very early on that if a patient is taking a daily dose of digoxin, having low potassium makes the drug more toxic and dangerous.
But then the text brings up research from 1973, Charles Bismuth's criteria, showing that in a massive acute overdose of digoxin, the strongest predictor of whether the patient will live or die is actually high potassium,
Right.
which feels completely backwards.
It does feel backwards, but the clinical data backs that up entirely. You just have to look at the mechanism to understand why the context flips.
Okay, so how does that work?
Well, digoxin works by actively binding to and inhibiting that very same sodium-potassium AT-PACE pump we talked about earlier.
Oh, so a normal dose of digoxin is almost like a minor traffic jam.
Right.
It slows down the cellular pumps just enough to help a failing heart contract a little harder and pump more efficiently.
Exactly.
But if a patient takes a massive overdose, they've essentially thrown a spike strip across a 10-lane highway.
Right.
Like every single cellular pump shuts down.
The pumps are completely paralyzed, so
Yep.
the potassium trying to get back into the cells just piles up in the bloodstream.
Oh, man.
The serum potassium rises sharply above 5.5, and the context totally flips from a low potassium problem to a high potassium emergency.
Wow.
And without administering the specific antidote, which is called DigiFab, to unbind the digoxin from the pumps, the mortality rate is incredibly high.
That is fascinating. And it's not just external drugs causing these extremes, right? Our own internal hormones play this game too, specifically the renin-angiotensin-aldosterone system.
Yeah, aldosterone is a hormone that tells your kidneys to hold on to sodium and get rid of potassium.
Okay.
So if your body develops a tumor that makes too much of it, a condition called Conn's syndrome, you end up urinating away your stores and developing severe hypokalemia. But if you have Addison's disease, where your adrenal glands are damaged and don't make enough aldosterone, your kidneys hold on to potassium, leading to hyperkalemia.
It all just comes back to that delicate balance.
Always.
Which brings us to perhaps the most unsettling part of the source material, honestly. The medical mirages. Because this balance is so precarious, our attempts to fix it in emergencies haven't always been perfect. Let's talk about the illusion of treatment.
This is a really important concept.
So when a patient comes into the ER with severe life-threatening hyperkalemia, the standard emergency code involves pushing high-V insulin along with glucose and sometimes giving albuterol, right?
Pushing calcium gluconate to stabilize the heart muscle directly so it doesn't fibrillate. Yeah.
Right, so the calcium protects the heart, but with the insulin and glucose,
Yeah.
wait, the sources say this doesn't actually remove any potassium from the body?
It doesn't.
So a medical team can run a code, give these drugs, the monitor goes back to green, the lab says their potassium is normal, but the potassium's just hiding.
Exactly. We are essentially bailing water out of a sinking boat and throwing it into a closed cabin.
Oh, geez.
We haven't patched the hole, and we haven't removed the water from the ship. Insulin and albuterol simply rev up the sodium-potassium pumps, so they artificially force the excess potassium out of the blood and shove it temporarily back inside the cells.
You're just buying time.
You are buying maybe a few hours to protect the heart from that deadly ECG cascade.
Right.
But if you don't follow up with therapies that actually remove potassium from the body, like dialysis, diuretics, or gastrointestinal binders, that potassium will seep right back out of the cells into the blood, and the patient will be right back in lethal danger.
So how do we actually remove it? Because historically, the text points out that even our methods for removing potassium have been fraught with massive errors.
Yeah, they have.
Like the Kyaxylate disaster, for example.
Right. So introduced in the 1950s, sodium polystyrene sulfonate, known by the brand name Kyaxylate, is a resin you swallow. It binds to potassium in your gut so you can excrete it in your stool. And for over half a century, it was the absolute standard of care for chronic hyperkalemia, often mixed with a sugar called sorbitol to induce diarrhea and prevent constipation.
But from the 1980s onward, case reports started trickling in, linking this Kyaxylate-sorbitol combo to intestinal necrosis.
Yes.
It was literally causing the tissue of the bowel to die, especially in vulnerable patients who had just received kidney transplants.
And despite those early warnings, it took until 2013 for the FDA to issue a formal, rigorous warning about the risk of bowel necrosis.
2013.
Yeah. Clinical practice finally had to shift to newer, safer gastrointestinal binders like Pataromer. But it's a sobering proof that just because a treatment is considered the undisputed standard of care for 50 years doesn't mean it is perfectly safe.
Or free from devastating side effects.
Exactly.
It really forces you to question your assumptions.
And speaking of questioning assumptions, before we wrap up, the sources highlight some major misconceptions that still float around even among healthcare workers.
Oh, there are plenty. Let's do a quick myth-busting. Misconception 1. Bananas are the ultimate high-potassium food.
Culturally famous, yes. But nutritionally, they are entirely mid-tier.
Really?
Yeah, a medium banana only has about 400 to 450 milligrams of potassium. If you are actually trying to replenish dietary potassium, you should be eating potatoes with the skin on, white beans, spinach, or avocados. All of them significantly beat the banana.
Wow, good to know. Okay, misconception 2. High potassium always causes obvious symptoms like muscle cramps before it gets dangerous.
Dangerously false.
Yeah.
Many patients with severe hyperkalemia levels well above 6.5 or 7.0 feel absolutely nothing.
Nothing at all.
Or maybe just a vague, non-specific sense of fatigue right up until the exact moment their heart goes into a sudden, lethal arrhythmia. It is a silent killer.
Which is why routine lab monitoring is so critical. You simply cannot wait for symptoms.
Exactly.
For anyone listening who isn't running a code in an ER, this might feel a bit abstract, but the reality is that potassium imbalance sits at the intersection of almost every common chronic condition in modern healthcare.
Absolutely. Millions of people are taking medications every single day that alter this invisible gradient.
Right.
If you take an ACE inhibitor for your blood pressure, or an ARB, or a potassium-sparing diuretic like spironolactone, those drugs actively raise your serum potassium.
And if you take a loop diuretic, like furosemide, it actively flushes it out of your system.
Right.
So every time a doctor adjusts your meds, they're doing a complex potassium risk assessment in their head. It's the very reason they obsess over your routine blood panels.
It really is.
But beyond the medications and the ECG changes, I want to leave you with one final provocative thought from the source material to mull over on your own.
Oh, the interconnectedness of the human body goes far beyond just the kidneys and the heart.
Exactly. We didn't even have time to dive deeply into acid-base balance, but here is the core idea. Potassium and hydrogen, the tiny ion that makes your blood acidic, compete for the exact same doors into your cells.
Right. It's a constant microscopic trade-off.
When one goes in, the other has to come out to maintain the electrical charge. Think about the implications of that. A change in your breathing rate, say hyperventilating during a panic attack, alters the acidity of your blood.
Yeah.
And just by shifting the acid in your blood, you can literally alter the electrical charge of your heart, because your body will evict potassium from your cells just to make room to hide the excess hydrogen.
It's wild.
We tend to treat the body like a series of separate, neat compartments. You know, the lungs over here, the kidneys down there, the heart in the middle. But at the molecular level, they're all playing the exact same high-stakes game of musical chairs.
It's a beautiful, terrifying system. I mean, the flutter of a lung can dictate the rhythm of a heart.
It really is. So the next time you peel a banana or look at a routine lab report, take a second to appreciate that you aren't just looking at a mundane checkbox. You are looking at the raw electrical voltage that keeps you alive. Thanks for joining us on this deep dive. I want you to think back just for a second to a time when you were in a really vulnerable situation.
Right.
Like maybe you were sitting in a hospital ER,
Yeah.
or you were on the phone with a crisis hotline.
Yeah, those really high-stress moments.
Exactly. And do you remember that specific moment when a complete stranger, like a nurse or a counselor, just walked into the room, and within minutes, you felt this like profound sense of ease?
Like you could just finally exhale.
Yes. You probably walked away assuming that person was simply, a naturally gifted, empathetic soul. Like they just had the magic touch.
Oh, absolutely. We tend to romanticize that kind of human connection, right? We assume it's just instinct.
Right. But the reality is actually far more clinical. That feeling of instant trust isn't magic. It's usually the result of highly engineered, testable mechanics.
It's a very specific skill set.
Yeah, known as therapeutic communication. And that is our mission for this deep dive. We're unpacking the deliberate architecture that healthcare providers use to get patients to open up.
And, the underlying psychology of these techniques is something you can actually apply to your own everyday conversations.
Which is the best part. We got some fascinating sources on the table today, ranging from modern nursing textbooks to historical psychiatric literature from the 50s, all the way to current bioethics journals.
It's a really rich area of study.
It is. So to understand how this architecture works, we have to establish a baseline. Like, therapeutic communication is fundamentally different from just a normal social chat.
Oh, completely.
Because in everyday life, a conversation is reciprocal, right?
Yeah.
Both people are seeking connection or validation, or they're just, passing the time.
Right. But the clinical literature defines therapeutic communication as strictly goal-directed.
Goal-directed.
Yes. I mean, every pause, every shift in posture, every single question is deployed to serve the patient's needs, not the provider's comfort.
So it's not about making friends.
Not at all. It is literally treated as a clinical intervention. You're using communication as a form of medicine to establish rapport, get accurate diagnostic info, and help the patient problem solve.
Okay, so the first major hurdle a clinician faces in doing that is just getting past the patient's internal filter.
Yes, the filter's huge.
Because when someone walks into a clinic, they almost never offer the raw, unedited truth right away.
No, they're terrified. Or embarrassed.
Right, they edit their answers based on fear or just the really intimidating power dynamics of, sitting half naked in a paper gown while someone stands over you with a laptop.
Yeah, it's not a natural environment.
No. So bypassing that filter requires actually manipulating the boundaries of the conversation.
And this is where we look at textbooks on interpersonal relationships in nursing. Like, the widely cited work by Arnold and Boggs focuses heavily on the actual literal framing of questions.
Like the mechanics of the sentences.
Exactly. A core intervention they teach is swapping out closed questions for open-ended ones, because it completely changes the cognitive load on the patient.
How so?
Well, think about it. If a nurse asks, "Are you in pain?" that closed question primes a one-word answer.
Right, yes or no.
And more importantly, it gives a patient who minimizes their discomfort an easy out.
Oh, wow. Yeah, they just say no so they don't bother the busy doctor.
Precisely.
Yeah.
But if the nurse says, "Tell me what you're feeling right now," they shift the mental task. The patient isn't just answering a binary prompt anymore. They have to narrate an experience.
Yeah, I had to tell a story.
Right. And in that narrative, the patient might casually bring up, debilitating nausea or severe anxiety about paying for their meds' vital clinical data that a yes or no question would have just permanently buried.
It really reminds me of dealing with poorly designed automated tech support.
Oh, gosh, yes.
Like when your internet goes down and the robot voice is like, "Are you calling because your router is blinking red? Say yes or no."
But it's not blinking red.
Exactly. It's completely dead. But the prompt forces you into this binary box that doesn't actually capture your problem.
This is a perfect analogy. A closed clinical question traps a patient in a diagnostic box of the clinician's own making.
It prevents them from revealing what's actually wrong.
You're predetermining the boundaries of their experience before they even get to speak.
That's wild.
Yeah, and another mechanical shift that changes the patient's response is just replacing the word why with what or how.
Wait, really?
Mhm.
Just dropping the word why?
Just that one word. Asking a patient, "Why didn't you take your medication?" almost guarantees they get defensive.
Well, yeah, it sounds judgy.
It does. From a psychological standpoint, the word why often triggers the amygdala, the part of the brain associated with threat detection. It literally sounds like an accusation demanding a justification.
So the patient feels like they're being interrogated for a crime,
Exactly.
and they just shut down. Or they make up an excuse.
Right, but if the provider simply asks, "What got in the way of taking your medication?" they change the neurological response entirely.
Oh, wow. What got in the way?
Yeah. By framing the obstacle as an external what, you bypass the defensive reaction. You engage the prefrontal cortex, which handles objective problem solving,
So the blame is totally removed from the patient.
and placed on the external factor. The patient transitions from being like a suspect defending their character to a partner solving a logistical puzzle.
That structural shift makes total sense. But, okay, there is another tool in the literature that seems completely counterintuitive to me.
Oh, I know where you're going with this.
Yeah, the use of deliberate silence.
Yes, silence.
Like, silence is formally classified as an active clinical technique, not just a gap between sentences.
It's an active, powerful tool, but the education literature shows that novice clinicians are absolutely terrified of it.
I mean, I would be too.
Research on new nurses shows they consistently panic when a patient discloses something really heavy. If a patient says, "I'm terrified of dying," the novice will typically tolerate only 1 or 2 seconds of silence before they just jump in and start speaking.
Because the natural human instinct is to fill that dead air.
Right.
When someone tells you they're terrified, you want to instantly fix it. You want to say, "Don't worry, the doctors are great, you're going to be okay."
And that instinct to fill the space is exactly what clinical education tries to train out of providers.
Really?
Yeah, because that urge usually results in what they call false reassurance.
False reassurance, okay.
Saying everything will be fine when you don't actually know the prognosis, that only serves to relieve the clinician's own discomfort with the awkward silence. It does nothing for the patient's anxiety.
Oh, I see.
False reassurance is basically a conversational dead end. It sends the message that the patient's fear is an inconvenience.
It totally invalidates what they just told you.
It dismisses their reality completely. Patients actually need processing time. The literature suggests a minimum of 5 to 6 seconds of uninterrupted silence after a difficult disclosure.
6 seconds. That is an agonizingly long time to just sit there in
It
silence.
feels like an eternity. But they need that neurological lag time to process their own emotions, to formulate their next thought, or honestly, just to cry.
Wow.
By deliberately maintaining silence, the provider is actively holding space. They're signaling that it is safe for the patient to keep exploring that really difficult feeling.
It's just so striking to me that holding space and trying to get the patient's unedited truth is the gold standard today. Because if you look at the history of the medical establishment,
Oh, it's a totally different world.
yeah, there was a long period where the prevailing consensus was that truthful communication was actively detrimental to a patient's health.
It's hard to believe now, but the history of therapeutic communication is rooted in this deeply paternalistic era. There's this landmark study published in the Journal of the American Medical Association back in 1961 by a physician named Donald Oken.
The Oken study, yeah.
He surveyed practicing doctors about their communication habits, and he found that roughly 90% of them routinely withheld cancer diagnoses from their patients.
90%. They would literally tell the patient's family, but intentionally lied to the patient sitting right there in the bed.
Yeah, and this wasn't driven by malice. It was just rooted in the bioethical framework of the time.
They thought they were helping.
Exactly. The prevailing wisdom was that patients lacked the psychological resilience to handle terminal news. Doctors genuinely believed that full disclosure would destroy a patient's hope.
And accelerate their physical decline.
Right. Paternalism dictated that the physician's duty to protect the patient from harm was way more important than the patient's right to know what was happening to their own body. Silence and deception were used as protective clinical tools.
Which is just wild to think about. But that paradigm obviously collapsed.
Thankfully, yes.
Because by the 70s and 80s, the sources indicate a total inversion. The rise of the consumer rights movement and modern bioethics established patient autonomy as the paramount right.
It was a massive cultural shift.
Yeah, and replications of Oken's study a couple of decades later showed the numbers had entirely flipped. The vast majority of physicians were suddenly favoring full disclosure.
So the control of the narrative shifted fundamentally from the provider to the patient. But the actual mechanics of how to conduct these therapeutic relationships, that traces back to the post-war psychiatric wards.
Okay, let's get into that.
So Hildegard Pepla, a World War II Army nurse, is really considered a pioneer here. In 1952, she published this huge work called Interpersonal Relations in Nursing.
And she was heavily influenced by Harry Stack Sullivan's theories on interpersonal psychiatry, right?
Exactly. Pepla argued something incredibly radical for the time. She said the nurse-patient relationship itself was the treatment.
Which was huge because nursing at the time was so highly task-oriented.
It was just checking boxes.
Yeah, administering pills, changing dressings, following orders. But Petitpla elevated the interaction itself to a therapeutic level.
She did.
And she designed this famous four-phase model for the clinical relationship, right? Orientation, identification, exploitation, and resolution.
Those are the four.
Now, the first two make total sense to me. Orientation is just setting the parameters of care, and identification is the patient starting to trust the nurse.
Right.
But that third phase, exploitation, that sounds incredibly toxic in a healthcare setting. What does that actually mean?
I know the terminology really reflects the era, and it can sound super jarring today. But in Pepla's framework, exploitation refers to the patient's constructive use of the relationship.
Constructive use, okay.
Once trust is established, the patient actively exploits or uses the resources, the time, and the clinical expertise of the nurse to work through their own health challenges.
So they're milking the system for their own good.
Exactly. It is the phase of maximum patient empowerment. They are extracting value from the healthcare system for their own healing.
Okay, that makes way more sense.
And then the final phase, resolution, involves carefully severing that therapeutic tie as the patient gets better and returns to independence.
So the patient is leveraging the relationship for their own benefit. And following Pepla, the sources show a really strong integration of psychological theories into nursing.
Oh, heavily. The work of psychologist Carl Rogers is central here.
Right, from the early 60s.
Yeah, in 1961, he introduced the 3 core conditions for therapy: empathy, unconditional positive regard, and congruence, which basically means genuineness.
Being authentic.
Right. And then nurse theorist Joyce Travelby synthesized these ideas in 1971, coining this amazing concept called the therapeutic use of self.
Which means what exactly?
It suggests that a provider's disciplined presence is actually a clinical instrument. It requires the clinician to stay self-aware and consciously use their personality, their tone, and their emotional regulation as an intervention.
But relying purely on a provider's emotional intelligence became a huge liability once truth-telling was mandated, didn't it?
Oh, for sure.
Because when doctors were suddenly required to deliver devastating news, doing it without a structured framework led to disastrous outcomes.
Clinicians under pressure would just panic.
Right. They'd deliver the news way too bluntly, or they'd retreat behind this wall of dense medical jargon. They needed to engineer actual protocols for these high-stakes conversations.
Because empathy without structure can easily lead to psychological trauma for the patient.
Exactly.
And that necessity birthed frameworks like the Spikes protocol, which was published by Walter Bale and his colleagues around 2000. It was specifically designed for oncology, for breaking bad news.
Right, and it's an acronym.
Yes, it walks the clinician through a very deliberate psychological pacing.
So the steps are setting, perception, invitation, knowledge, emotions, and strategy.
That's right.
And the PPIS reception seems particularly crucial for pacing the conversation.
Oh, it's vital. The perception step requires a clinician to ask the patient what they already believe is happening before delivering the news.
So asking something like, what have you been told so far about your MRI results?
Exactly. It forces the clinician to calibrate the delivery. Because if the patient firmly believes they are just there for a routine scan, the clinician instantly knows they have to bridge a massive psychological gap.
You have to find out where the patient is on the map before you can safely guide them to this terrible new destination.
That's a great way to put it.
And then the I invitation takes it a step further by actually asking for permission to share the data.
Yes. The clinician asks, are you someone who wants all the medical details, or would you prefer I just focus on the big picture and the treatment plan?
Wow, that is so respectful.
It really is. It respects the patient's autonomy and their cognitive limits in that exact awful moment.
Right.
Then, in the case step knowledge, the provider gives the facts in small, digestible chunks. They avoid jargon, and they pause frequently.
Which prevents that anxiety-driven beta dump that overwhelmed doctors usually default to.
Exactly. Now, there is another high-stakes framework that focuses on instruction rather than bad news, and it addresses the massive problem of health literacy.
Oh, the teach-back method.
Yes. Patients routinely nod along to discharge instructions, like how to manage a surgical drain or take a complex set of pills, without actually understanding a word of it.
Because no one wants to look stupid.
Right. But the teach-back method completely bypasses that fear.
Because instead of a nurse asking, do you understand, which inevitably prompts a defensive yes, the provider shifts the burden of clarity.
They put it on themselves.
Yeah, they say, just so I know I explained this well, can you tell me how you'll take this medication when you get home?
It's brilliant. It is an evaluation of the provider's communication skills, not the patient's intelligence.
Exactly. If the patient explains it incorrectly, they don't feel ashamed. They just assume the nurse needs to clarify.
It opens the door for correction without damaging that rapport.
It's such a great psychological trick. But, the proven success of frameworks like Spikes and Teachback has sparked a really heated debate in modern nursing education.
The scripting debate.
Yes, because if scripting certain interactions improves outcomes, hospital administrators naturally want to standardize and script as much of the bedside experience as possible.
Which leads directly into the authenticity trap.
Right, because hospital customer service initiatives have heavily promoted programs like ATET, right? Acknowledge, introduce, duration, explanation, and thank you.
Yeah, popularized by the Studer Group. It provides nurses with these highly structured, almost verbatim scripts for interacting with patients.
And hospital systems love it.
Because it's measurable. And it often yields short-term gains in patient satisfaction scores. But critics in publications like the Journal of Clinical Nursing argue that aggressive scripting creates hollow empathy.
Hollow empathy.
Yeah. It violates Carl Rogers' core rule of congruence. If a provider recites a scripted line like, I understand this must be very difficult for you, but their tone and body language don't genuinely reflect that sentiment,
Patients instantly detect it.
they absolutely know it's fake.
It feels like getting one of those automated apologies from an airline app when your flight is canceled.
Yes.
As opposed to a human being actually looking at you and genuinely acknowledging how frustrating it is.
Huge difference.
This tension between genuine connection and professional distance really brings up the clinical distinction between empathy and sympathy.
Which is a crucial distinction.
Because in a casual setting, we use those words totally interchangeably. But the nursing literature draws a hard boundary.
They represent two entirely different psychological mechanisms. Empathy requires accurately perceiving a patient's emotional state and reflecting it back to them. You validate their experience without absorbing their distress as your own.
It operates like a mirror.
Exactly. Sympathy, on the other hand, is feeling sorry for the patient. It is rooted in pity.
And pity creates weird dynamics.
It inherently establishes a power imbalance. When you pity someone, you distance yourself from their suffering, creating this wall between provider and patient.
So sympathy isolates, but empathy connects.
Bingo.
Speaking of communication misconceptions, we have to address this pervasive myth that appears in, like, every corporate seminar and self-help book ever written.
Oh, I bet I know which one.
The idea that 93% of communication is nonverbal.
Ah, yes. The Morabian myth.
It implies that the actual words you use barely matter compared to your vibe or your body language.
And nursing education actively works to debunk this because it is a deeply dangerous misapplication of a very narrow psychological study.
So where did it come from?
Well, back in 1967, a psychologist named Albert Morabian conducted research where subjects listened to a recording of a single neutral word, like the word maybe,
Okay.
but it was spoken in a tone of voice that clearly conflicted with the word's meaning, while they looked at a facial expression that also conflicted.
Oh, got it. So if someone is aggressively shouting the word fine, you believe the shouting, not the vocabulary.
Exactly that. Morabian's formula only applies to situations where emotional cues are incongruent. It absolutely does not mean that 93% of all human communication is nonverbal.
That's a massive distortion.
It is. The words carry the critical diagnostic data. Think about it. If a patient quietly says, "My chest feels like it's tearing," but their body language appears calm.
If the nurse ignores the words because the nonverbal vibe seems chill, they're making a fatal error.
A severe clinical error. Words matter immensely.
Recognizing that words matter and that communication breakdowns are literally the leading cause of adverse events and malpractice claims in hospitals, the medical field has developed tools to ensure critical data isn't lost.
Which is why we have things like SBR.
SBR, yeah. Situation, background, assessment, recommendation.
Right. SBR is a standardized structural tool used during handoffs, like when one nurse finishes a shift and passes a patient to the next nurse.
It forces the communication out of a messy, chaotic narrative and into a rigid sequence.
You state the immediate problem, the relevant history, your clinical assessment, and what you think needs to happen next. It eliminates the guesswork.
So cognitive overload doesn't cause a provider to just drop a vital piece of context.
Precisely.
Another really fascinating application of these mechanics is motivational interviewing.
Oh, I love motivational interviewing.
It's used heavily in primary care for behavior change, right?
Yeah.
Like getting a patient to quit smoking or change their diet.
Yes.
Instead of lecturing the patient on the dangers of smoking, which, as we know, triggers that defensive amygdala response.
Oh, why trigger?
Right. Instead, the provider uses open-ended questions to evoke the patient's own reasons for wanting to change.
It is explicitly designed to resolve ambivalence. By carefully guiding the conversation, the provider helps the patient articulate their own intrinsic motivations.
Because when the patient hears themselves argue for the change,
It is infinitely more effective than a doctor just wagging a finger and telling them what to do.
it's brilliant. And, the mechanics of therapeutic communication, motivational interviewing, the teach-back method, using what instead of why, and just holding space with silence, these aren't just for clinicians.
No, they apply directly to our everyday lives.
Totally. Like, if you are supporting a grieving friend, your first instinct might be to offer false reassurance. You might want to say, "At least you had so many good years together," or "Everything happens for a reason."
And in a clinical context, we know those phrases function as total conversation killers.
They shut the person down.
They invalidate the person's current distress. Applying therapeutic communication in real life means learning to just sit in the awkward silence.
Let it be awkward.
Use open-ended questions to let them narrate their grief, and mirror their emotions through true empathy, rather than distancing yourself with pity and sympathy.
It really forces you to reevaluate how you handle every difficult conversation.
It does.
To close out this deep dive, the bioethics journals present a final, really provocative thought regarding how we handle information today.
This is a fascinating debate right now.
Yeah, because we discussed how paternalism and lying to patients in the 60s was highly unethical. But some modern bioethicists argue that the pendulum of informed consent may have swung way too far into blunt transparency.
Right. The current ethical discussion really centers on this concept of asking before telling.
Asking before telling.
Yes. Rather than assuming that full, unvarnished transparency is always the most therapeutic approach, clinicians are exploring whether a patient's appetite for devastating information should actually be elicited first.
It challenges the assumption that radical honesty is always the highest moral good.
It really complicates things.
It does, because sometimes the most trust-building thing you can do isn't just dropping the blunt truth on someone because you feel legally or morally obligated to. It's carefully asking them how much of the truth they actually want to carry in that exact moment.
And when they give you their answer.
You give them the 6 seconds of silence they need to process it. Because the ability to instantly put someone at ease isn't magic. It is an architecture of empathy, and now you understand the blueprints. Right now, as you are listening to this, your body is walking a microscopic, high-wire tightrope.
Yeah, a really, really precarious one.
Exactly. I mean, if the pH of your blood drops from its perfect physiological midpoint, which is about 7.4, down to just 6.8, the fundamental building blocks of your body physically break.
They just fall apart. Cellular enzymes start to misfold and crumple.
Right. They lose their shape, they abandon their functions, and then the electrical conduction system in your heart destabilizes. And very quickly, that leads to death.
It's terrifying when you think about it. The survivable window is incredibly narrow, basically just 7.35 to 7.45.
And that narrow window is under constant assault, right?
Oh, constant. Just through the basic act of cellular respiration, living, eating, moving, we generate massive amounts of acid every single day.
Which means we are all just one physiological misstep away from our own blood becoming a toxic swamp.
Pretty much, yeah.
So for you listening today, whether you're a nursing student prepping for an ICU shift, a clinician brushing up on your labs, or just someone fascinated by how you're surviving right this second, we are taking a deep dive into acid-base balance.
It's a huge topic.
It really is. So our mission today is we're going to decode arterial blood gases using the famous Rome shortcut.
Yes.
We'll explore the terrifying historical crisis that birthed the modern ICU and dismantle some major textbook misconceptions about how your body actually defends its pH.
I love that we're starting with the defenses, because
Yeah.
to even approach a blood gas readout, we have to establish how the body defends that tightrope balance before medical intervention even enters the picture.
Right. And the body utilizes 3 distinct layers of defense.
Yeah, and the critical variable separating them isn't location, it's actually speed.
Speed. Okay, let's look at the timeline. The first layer is essentially instantaneous, right? Operating in seconds.
Exactly. These are the chemical buffers circulating in the blood.
So if we think of hydrogen ions as like the microscopic sparks of acidity, buffers act like fire blankets.
That's a great analogy. They chemically bind to excess hydrogen or conversely to basic hydroxide ions.
Right, instantly neutralizing them so the overall pH doesn't wildly swing.
Then the second line of defense steps in over a matter of minutes. And this one is driven by the respiratory system.
Okay, the lungs.
Yeah. The medulla in your brainstem acts as a chemical sentinel. It's constantly monitoring the carbon dioxide levels in your cerebrospinal fluid.
Because carbon dioxide in the body is functionally synonymous with acid.
Exactly. When CO2 mixes with water in the blood, it forms carbonic acid.
So the lungs control the acid by controlling the CO2. I mean, if the medulla senses too much acid, it triggers an increase in the depth and rate of breathing to literally blow the carbon dioxide out of the system.
Right now.
I always think of this when someone is having a severe panic attack.
Yeah.
They hyperventilate, blowing off so much CO2 so rapidly that they can induce respiratory alkalosis in under 10 minutes.
Right. Their blood becomes too basic simply because their lungs are dumping acid faster than the body is producing it.
Wow. Which leaves the final layer of defense to clean up the long-term mess. The kidneys.
The kidneys. This is the slow, methodical defense. They physically excrete or reabsorb hydrogen ions into the urine.
And they manufacture or excrete bicarbonate, which is our primary metabolic base, right?
Yep. But they require 6 to 12 hours just to initiate this process.
Oh, wow.
Yeah, and achieving their maximal buffering effect takes 3 to 5 days. In some chronic conditions, it can take up to 2 weeks.
2 weeks. That is slow. But hey, I do want to pause on those chemical buffers you mentioned in the first layer.
Okay, sure.
Because anyone who has opened a nursing or physiology textbook will recognize bicarbonate as the absolute star of the show.
Oh, 100%. It's paired with carbonic acid in literally every diagram.
Right, so the natural assumption is that bicarbonate is doing the heavy lifting in our circulating blood.
And that assumption is actually one of the most pervasive blind spots in early clinical education.
Wait, really?
Yeah, I mean, while bicarbonate is crucial, the primary buffer in whole blood is surprisingly hemoglobin.
Hemoglobin, the oxygen transport molecule.
The very same. Gram for gram, hemoglobin performs more acid-base buffering work in your whole blood than bicarbonate, plasma proteins, and phosphate combined.
That is wild.
It manages roughly 60% of your daily acid load.
Okay, that fundamentally changes how you look at a complete blood count.
Yeah.
I mean, anemia isn't just an oxygen delivery problem, it's a buffering vulnerability.
Exactly.
How does an oxygen carrier manage that much acid, though?
Well, it comes down to molecular architecture. Hemoglobin contains a high concentration of specific amino acid side chains, particularly histidine residues.
Okay, histidine residues.
Yeah. The structural geometry of these histidine residues makes them highly effective at binding and releasing free hydrogen ions based on the surrounding pH.
So hemoglobin is just constantly soaking up acid in the peripheral tissues and then releasing it in the lungs to be exhaled.
Exactly. It's the frontline bouncer for the blood.
That's amazing.
Yeah.
But knowing how the body does this internally is very different from a doctor being able to measure it externally at the bedside.
Right, right. I mean, the underlying chemistry for all of this, the Henderson-Hasselbalch equation, that was established way back in the 1910s.
But having an equation on a chalkboard doesn't save a suffocating patient.
No, it doesn't. The translation from abstract chemistry to bedside clinical application required a catalyst. And that catalyst was a devastating public health crisis.
Which was what exactly?
Well, in the summer of 1952, the Blegdam Hospitalet in Copenhagen faced just an overwhelming polio epidemic.
Oh, right. Polio attacks the motor neurons.
Yeah. And in the most severe bulbar cases, it paralyzed the patient's diaphragms and intercostal muscles.
So they were completely unable to pull air into their lungs.
None at all. The virus wasn't destroying their lung tissue, it was destroying the mechanical pump.
Wow.
Because they couldn't exhale, carbon dioxide accumulated in their blood far faster than hemoglobin could buffer it.
So they were experiencing catastrophic respiratory acidosis.
Exactly, with mortality rates for the sickest patients hovering between 80 and 90%.
And the negative pressure ventilators, the iron lungs, they couldn't handle the sheer volume of patients.
No, they were totally overwhelmed. And iron lungs were useless for managing airway secretions in patients whose throats were also paralyzed.
Right. So the traditional technology failed.
Completely. But an anesthesiologist named Bjorn Ibsen realized the only way to save them was to completely bypass the upper airway.
Okay, what did he do?
He proposed a really radical intervention, performing tracheostomies and manually forcing air into the lungs using a rubber bag. Basically, positive pressure ventilation.
The logistics of that are staggering, though. I mean, you have a ward full of paralyzed patients who need to breathe 15 to 20 times a minute around the clock.
Yeah.
You can't just hook them up to a modern mechanical ventilator because those didn't exist yet.
Yeah.
Who is physically squeezing those rubber bags for weeks on end?
So the hospital organized a massive conscription of roughly 1,500 medical and dental students.
1,500 students.
Yes. They worked in relentless 8-hour shifts, just sitting at the bedside, squeezing the bags by hand, 24 hours a day.
That human mobilization essentially created the very first intensive care unit.
It really did. Mortality dropped to like 20 or 25%. But the manual bagging created a new physiological problem.
Oh, right, because if a student squeezes the bag too aggressively, they blow off too much CO2 and the patient becomes alkalotic.
Exactly. And if they get tired and squeeze too slowly, the CO2 builds up and the patient becomes acidotic.
So the clinical teams were flying blind. They desperately needed a way to measure the acidity of the blood in real time to adjust how they were bagging the patients.
Yes, and this urgent need pushed a Danish biochemist named Paul Astrup to invent one of the world's first practical bedside blood gas analyzers.
So every ABG machine sitting in a modern hospital today traces its lineage directly back to those medical students manually keeping polio patients alive in Copenhagen.
It really does. It's an incredible legacy.
But Astrup's machine just gave clinicians the raw data. I mean, staring at a slip of paper showing a pH of 7.2 while a patient is coding, that isn't enough.
No, you need to act. Clinicians needed a framework to translate that math into an immediate diagnosis.
And that necessity birthed the Boston approach and the classic bedside heuristic known as ROAM.
Yes, Rome. To utilize Rome, you first have to memorize the three unshakable reference
Okay,
ranges.
let's lay them out. First is pH.
Right, pH is 7.35 to 7.45. Second is the respiratory variable PaxO2, that's 35 to 45 millimeters of mercury,
Okay, 35 to 45. And finally, the metabolic variable bicarbonate,
which is 22 to 26 milliequivalents per liter.
which brings us to the acronym itself. ROME stands for respiratory equals opposite, metabolic equals equal.
It is fundamentally a pattern recognition tool. So if you look at the lab results and the pH has dropped into acidosis, you check the CO2.
Right. And if the CO2 has gone up, meaning pH and CO2 moved in opposite directions, the primary issue is respiratory acidosis.
The logic holds perfectly too, because CO2 acts as an acid. If the lungs fail to exhale it, retaining that acid naturally pushes the pH down, opposite directions.
Makes total sense. Conversely, if the pH is low and you check the bicarbonate and it is also low, they moved in the same direction. They are equal.
Exactly.
That tells you the primary issue is metabolic acidosis. The body lost its base buffer, dragging the pH down with it.
It provides instant directionality during a crisis.
I would think of Rome like a compass. I mean, it tells you if you are heading north toward a respiratory issue or south toward a metabolic issue. But a compass doesn't tell you what city you're standing in.
Right. A respiratory acidosis pattern tells you the patient isn't moving enough air, but it doesn't distinguish between, say, a severe COPD exacerbation and an opioid overdose that suppressed the brainstem.
So Rome spots the pattern, but the clinician still has to diagnose the underlying cause.
And part of diagnosing that full clinical picture is determining whether the body's other physiological systems are attempting a rescue. We call this compensation.
Right,
Observing compensation in real time illustrates exactly why that speed difference between the lungs and the kidneys matters so much.
Let's apply this to a fast compensation scenario. Let's say a 24-year-old arrives in the emergency department in diabetic ketoacidosis, or DKA.
Okay, classic case.
Their body, unable to use glucose, has started breaking down fat, which floods the bloodstream with keto acids. We draw an ABG, and the pH is a disastrous 7.15.
Ouch.
And the bicarbonate has crashed down to 8.
Okay, so following Rome, both pH and bicarbonate are low. They moved in the same direction. Metabolic equals equal.
So this is a primary metabolic acidosis.
Exactly. The keto acids have overwhelmed and consumed the circulating bicarbonate.
The metabolic defense is broken. So this is where the lungs, that rapid second layer of defense, initiate the rescue.
Right. The medulla detects the plummeting pH and immediately triggers small respirations. That deep, rapid, labored breathing.
The patient is literally trying to exhale the acid load.
Yes. And when we look at the CO2 on the blood gas, it has dropped from a normal 40 down to, say, 20. The lungs are compensating rapidly.
Okay, now contrast that acute crisis with a slow compensation scenario. A 68-year-old patient with severe, long-standing COPD.
Right. Their lungs have been mechanically compromised for years.
Let's say their ABG reveals a pH of 7.33, a mass of CO2 of 68, and a bicarbonate of 34.
So running the Rome compass on that, pH is slightly low, CO2 is wildly high. Opposite directions, we're looking at a primary respiratory acidosis.
But their fast defense, the lungs, is the very thing that's broken. They can't just breathe faster to fix it.
Right. Therefore, the metabolic system has to shoulder the burden. Over months and years, the kidneys have steadily retained bicarbonate to buffer that chronically retained CO2.
Ah, so that is why their bicarbonate level is elevated to 34.
Exactly. Which beautifully explains why their pH is 7.33. It's mildly acidotic, but for a CO2 of 68, you'd expect a much more dangerous pH.
The kidneys are blunting the impact. But this raises a trap that catches a lot of learners, right? If the kidneys or lungs are compensating perfectly, does the pH ever just return to a perfect 7.40?
Almost never. While the primary disorder persists, physiological compensation will blunt the pH shift, but it will not completely normalize it.
Okay, so a perfectly normal pH on a blood gas isn't always a sigh of relief.
Definitely not. A perfectly normal pH paired with highly abnormal CO2 and bicarbonate is the illusion of normalcy.
The illusion of normalcy.
Yeah, it strongly suggests a mixed acid-base disorder. You aren't looking at one problem being elegantly solved. You are looking at two independent disease processes occurring simultaneously.
Just artificially canceling each other out on the pH scale.
Exactly. Like, for instance, a patient with chronic COPD who also develops acute DKA.
Wow, okay. So relying purely on the Rome pattern without respecting the underlying physiology is dangerous.
It leads to what we call the fix the number fallacy.
Right. If we look back at the history of treating that DKA patient we talked about, For decades, doctors looked at the severely low bicarbonate on the lab report and thought, well, they need base.
Right, let's just hang a bag of IV sodium bicarbonate and neutralize the acid.
It seems intuitively correct to treat an acid with a base. If they are full of acid, why wouldn't you just give them a base to neutralize it?
Because clinical outcomes revealed it was often actively harming patients.
And the reason why really reveals the complexity of human biology. The blood-brain barrier is highly permeable to carbon dioxide, but relatively impermeable to bicarbonate.
Yeah, so when you push rapid IV bicarbonate into a patient's bloodstream, it immediately reacts with the circulating acid, right? It neutralizes it, but it generates a massive amount of CO2 as a byproduct.
And that newly generated CO2 diffuses rapidly across the blood-brain barrier into the cerebral fluid.
Exactly. However, the bicarbonate you infused is left behind in the bloodstream.
So the blood pH looks fantastic on your next lab draw, but the patient's brain is suddenly flooded with CO2, creating a paradoxical central nervous system acidosis.
You've essentially weaponized their own chemistry against their brain.
That is horrifying.
And furthermore, once insulin therapy allows the body to clear the original keto acids, all that extra IV bicarbonate you administered induces a severe rebound alkalosis.
Wow, so that's why modern protocols strictly withhold IV bicarbonate unless the pH drops to life-threatening levels, usually below like 6.9 or 7.0.
Exactly. And this really underscores why the Henderson-Hasselbalch equation, which forms the foundation of Rome, isn't universally accepted as the only way to understand acid-base physiology.
Right, because in 1981, Canadian physiologist Peter Stewart introduced a competing framework known as the strong ion approach.
Yes. Stewart argued that treating bicarbonate as an independent variable, like something the kidneys just casually adjust, was mathematically flawed.
So he posited that pH and bicarbonate are actually dependent variables.
Right. They are the forced result of three other independent factors: the total weak acid concentration, the PaSO2, and the strong ion difference.
The strong ion difference, which is the net balance of fully dissociated ions like sodium, chloride, and potassium.
Yes. And while Rome is sufficient for standard clinical care, Stewart's strong ion model elegantly explains phenomena that Rome completely fails to account for.
The classic example being fluid resuscitation.
Right. If you infuse a patient with massive volumes of normal saline, which is just more 0.9% sodium chloride, they predictably develop hyperchloremic acidosis.
But normal saline doesn't contain any hydrogen ions. It's essentially just sterile salt water. Under the traditional Rome model, adding salt water shouldn't cause an acid shift.
Exactly, but Stewart's model explains the mechanism perfectly.
How so?
Well, think of the blood plasma like a crowded dance floor with a strict capacity. Normal saline has a chloride concentration significantly higher than normal human plasma.
Right, it's disproportionately high in chloride.
So when you flood the plasma with all that extra negatively charged chloride, you alter the overall electrical environment, the strong ion difference.
And to maintain electrical neutrality in that crowded room, the body forces water molecules to dissociate, leaving more free hydrogen ions wandering around.
Yes. The chloride influx chemically forces the pH into acidosis without a single drop of actual acid being added to the bag.
That is mind-blowing. So to catch these blind spots in complex ICU cases, clinicians must layer mathematical tools on top of Rome, like calculating the anion gap.
Right, which relies on the law of electroneutrality. The positive electrical charges in your blood, primarily sodium, must balance the negative charges, which are mostly chloride and bicarbonate.
But when you subtract the negative from the positive, there is always a small gap of about 8 to 12 mil equivalents, right?
Exactly. Those are the unmeasured anions, proteins and phosphates just hanging out.
So if that gap suddenly widens to like 25 or 30, it tells you a rogue unmeasured acid has invaded the bloodstream and is taking up negative charge space.
Yes, and clinicians use the mnemonic muddy piles to hunt down those hidden culprits. Things like methanol ingestion, uremia from kidney failure, DKA, or lactic acid from severe sepsis.
And once they find the cause, they use Winter's formula to predict the exact CO2 level the patient should have for a given metabolic acidosis.
It's a mathematical check to ensure the lungs are compensating appropriately.
Because if the patient's actual CO2 is higher than Winter's formula predicts, it means their lungs are failing and they might need to be intubated.
It is a profound shift from simple pattern matching to rigorously confirming the physiological math.
It really is. And you know, this intense multi-layered regulation makes the current pop culture obsession with alkaline diets and alkaline water so scientifically frustrating.
Oh, don't even get me started. The marketing promises that drinking high pH water will alkalize your blood, theoretically preventing disease.
Right, but the premise reveals a total misunderstanding of the physiological defenses we just outlined.
Completely. Your body fiercely guards that 7.40 set point. Between hemoglobin acting as an instantaneous chemical sponge, the lungs adjusting ventilation minute by minute, and the kidneys fine-tuning excretion, dietary intake is just irrelevant to systemic blood pH.
I mean, chugging alkaline water will absolutely change the pH of your urine.
Sure, but urine is the body's chemical trash can. It's a completely different compartment where the kidneys dump excess ions to ensure the blood remains pristine.
So altering your urine pH is not alkalizing your blood.
No, it's not. If your lungs and kidneys are healthy, you couldn't fundamentally change your blood pH with diet if you tried.
So the clinical reality always comes back to respecting the speed of those organ systems, trusting hemoglobin as the frontline buffer, and understanding that compensation blunts a crisis, but it doesn't cure it.
Perfectly summarized.
You know, we spend so much time in medicine viewing acidosis as the ultimate villain, right? Like an imbalance that must be aggressively corrected.
We do, yeah.
But there is a physiological phenomenon that flips that entirely on its head, proving that sometimes the imbalance is exactly what saves you.
Ah, you're talking about the Bohr effect.
Yes,
Yes.
Bohr effect. It is one of the most elegant evolutionary adaptations in human biology.
It really is amazing.
Let's break it down for the listener. When your body is under severe metabolic stress, say you are fighting a systemic infection, or you're deep into a marathon, your peripheral tissues are starving for oxygen.
Right. And they begin generating high amounts of acid as a metabolic byproduct.
Traditionally, we view that accumulating acid as a threat.
However, that localized acidic environment triggers a structural change in the hemoglobin molecules passing through those tissues.
Okay, what kind of change?
The acidosis actually shifts the oxygen-hemoglobin dissociation curve to the right.
So in simple terms, the acid weakens hemoglobin's chemical grip on oxygen.
Exactly. It forces the hemoglobin to dump its oxygen payload much more readily than it would in a normal 7.4 pH environment.
Wait, really? So the very acid signaling that your tissues are in metabolic distress is the exact trigger that forces your blood to deliver more life-saving oxygen precisely where it is needed most.
Yes, it's a genuinely elegant evolutionary trick.
That redefines how we view that physiological tightrope. A slight shift toward acidosis isn't always a failure of the system. I mean, in the most critical moments, that imbalance is the lifeline keeping the entire system intact.
It's an incredible paradox. Sometimes the imbalance is the cure.
What a mind-bending physiological twist to end on. Thanks for taking this deep dive with us. We'll catch you next time. So I want you to, imagine a really specific, incredibly high-stakes scenario right now. You are a triage nurse or maybe a clinical social worker, and you're sitting across a small room from a patient.
Right, under those buzzing fluorescent lights.
Exactly. And you are trying to predict this incredibly rare life or death event. You literally have to figure out if the person sitting right in front of you is going to survive the night.
It's an immense weight to carry.
It really is.
Yeah.
And honestly, how do they do it? Because usually when we talk about a medical diagnosis, there's this, this expectation of precision. Like you break your arm, the x-ray shows that jagged white line, and the doctor points and says, well, there it is.
Yeah, it's very binary. It's broken or it's not broken.
Yeah.
We really like things to be visible and neatly categorized in medicine. But in mental health, and especially in crisis care, that x-ray machine just doesn't exist. You are looking at a diagnostic landscape that is entirely invisible to the naked eye.
And that is exactly why today our mission on this deep dive is to unpack how clinicians actually navigate that invisible landscape. We are exploring a whole stack of fascinating clinical and historical sources to understand the science of suicide risk assessment, basically the science of asking the question that saves a life.
And this really matters for you right now listening to this because the whole landscape of mental health care is fundamentally shifting. I mean, back in July 2022, the United States launched the 988 Suicide and Crisis Lifeline, which was modeled directly on 9/11.
Right.
With that kind of infrastructure, universal screening is rapidly becoming standard practice. It's no longer just happening in locked psychiatric wards.
You see it everywhere now.
Exactly. If you go to a primary care clinic, a school counselor, or even just a general medical setting, these assessments are becoming just a normal part of the routine.
So we are going to give you a roadmap for how this actually works. We'll cover the pretty shocking origin of the field, the major medical misunderstandings that persisted for literally decades, and why a specific UK utility change completely altered how we view mental health.
It is really a history of trial, error, and some pretty massive paradigm-shifting discoveries.
But, before we can even understand how clinicians actually assess risk, we really have to clear up the biggest misconception that stops everyday people, and sometimes even professionals, from doing it in the first place.
Oh, absolutely.
I mean, I like to think of this old fear as being a lot like Fight Club.
Okay, Fight Club.
Yeah.
Yeah.
Because, the first rule of Fight Club is you do not talk about Fight Club. And for a really long time, the unwritten first rule of suicide was that you don't talk about it.
Yeah.
People were just terrified that bringing it up would somehow plant the idea in someone's head.
Yes, that is the single most persistent myth in the entire field. It's this pervasive idea that asking someone directly if they are suicidal will, push a vulnerable person over the edge.
Right, which sounds logical if you're scared, but...
But the clinical sources are incredibly clear on this. It is empirically false. There was this landmark systematic review in 2014 by Doddsey and colleagues that looked at this exact question.
And what did they find?
They found absolutely zero evidence that asking about suicide increases suicidal ideation. Zero. In fact, they found the exact opposite.
So it actually brings the temperature down.
Precisely. It reduces distress. And if you think about the psychology of it, it makes total sense. I mean, a person in an acute crisis is often dealing with this immense shame and isolation.
Yeah, they feel completely alone.
Right. So direct, plain language questions, literally just asking, are you thinking about killing yourself, takes this terrifying, isolating monster in the room and turns it into a tangible thing you can actually discuss. Euphemisms just create more ambiguity. So breaking that taboo is really the fundamental first step in harm reduction.
Wow. So where did this practice of direct questioning actually start? Because from the sources, it didn't come from some pristine ivory tower. It traces back to a psychologist named Edwin Schneidman in the late 1940s.
Yes, Schneidman is a huge figure here.
Right. So he was asked to review Veterans Administration hospital records in Los Angeles, and he just stumbled onto this cache of actual suicide notes.
And those notes completely changed the trajectory of his work and really the whole field of psychology, because reading them made him realize that clinical theory at the time was just way too detached from the messy reality of an actual crisis.
So fast forward a bit to 1958, and Schneidman co-founds the Los Angeles Suicide Prevention Center with Farborough and Lippman. And this is widely regarded as the first suicide prevention center in the world. But they weren't just writing academic papers, right? They were fielding real, live crisis calls.
Yeah, and that is a crucial detail for understanding the DNA of suicide risk assessment. It was born on crisis phone lines. It was harm reduction in real time.
Not just in abstract psychiatric wards.
Yeah, exactly. These clinicians were on the phone with people right in the middle of a spiraling event, trying to figure out if they needed to send the police or just stay on the line, that they didn't have the luxury of time to, dance around the subject.
Right, they had to be direct.
They had to figure out what distinguishes someone who is deeply distressed from someone who is actually about to act. Schneidman even coined the term suicidology a bit later, in 1968, and the concept of postvention.
It was pure real-time triage. Okay, let's unpack this. We know we must ask, and we know from the data that we shouldn't be afraid to ask.
Yeah.
But for a huge chunk of the 20th century, the medical field took the answers to those questions and used them for the completely wrong goal.
Yeah, they really did.
They treated it like a perdition game.
That was the 20th century mindset, essentially. The historical framework in medicine was all about sorting patients into buckets, like low, medium, and high-risk tiers, and then you administer treatment based on that specific label.
I mean, it sounds totally logical. That's what you do in an emergency room for physical trauma, right?
Yeah.
The gunshot wound gets seen before the sprained ankle.
It makes sense intuitively, sure, but the data shows it was a massive failure for mental health. The real turning point in the literature is this massive 2017 meta-analysis by Joseph Franklin and his colleagues.
Oh, this study blew my mind.
It's incredible. They looked at roughly 50 years of research on suicide risk factors, half a century of data. And they found that predictive accuracy hadn't meaningfully improved in all that time. Categorizing individual patients into risk tiers performed only marginally better than chance.
Only marginally better than a coin toss. That is just wild.
And it gets worse. Researchers like Matthew Large pointed out a really dangerous side effect of this whole prediction mindset. He argued that formal risk categorization creates a dangerous illusion for the clinician. Well, think about what a low-risk label does to a busy triage nurse. It tells them they can step back, maybe under-monitor that patient and focus on someone else. But the statistical reality is that the vast majority of suicides occur in people who were never flagged as high risk in the first place.
Because suicide is statistically rare to begin with, so high-risk categories are just tiny, tiny slices of the population.
Right. It's a low base rate event. A low-risk label is just a probabilistic statement about a massive group of people. It is not a safety guarantee for the specific, complex individual sitting right in front of you.
But wait, I have to ask, if we can't accurately predict who will attempt suicide, why are we doing assessments at all? If the sorting buckets don't work, what is that nurse even doing with that questionnaire?
What's fascinating here is how the field responded to that exact crisis of confidence. Leading organizations like the Zero Suicide Institute and the Joint Commission, they didn't just abandon the assessment. They fundamentally changed its purpose. They shifted the definition from prediction to risk formulation.
Risk formulation. Break that down for me. How is that actually different from prediction?
Well, prediction is about generating a label high, medium, low, and essentially handing down a verdict. Risk formulation is completely different. It's an ongoing collaborative narrative. It's the clinician sitting down with the patient and identifying the specific modifiable drivers of risk for them in the specific moment.
So it's more of a partnership.
Exactly. The clinician isn't a judge anymore. They are a partner trying to build a concrete safety plan based on what is driving the pain today and what resources the patient actually has right now.
So if the goal is no longer slapping a label on someone, the actual tools used in the clinic had to evolve dramatically, right? Because some of the old practices were, looking back, just completely illogical. Take the no suicide contract.
Oh, right. Also known as the no harm contract. This was widely used from the 1970s straight through the 1990s.
Yeah, and this was a literal written or verbal promise where the patient agreed not to harm themselves before their next appointment. I mean, to me, this sounds like making someone sign a piece of paper promising their house won't catch fire.
That's a great way to put it.
Right. It makes the person holding the clipboard feel like they have legal comfort, but it does absolutely zero to stop the flames.
And that is exactly how the research evaluated it. Studies consistently showed these contracts had zero demonstrated protective effect. None. And worse, they created that dangerous illusion of safety we just talked about. A patient could sign the contract, look totally compliant, and get discharged while still having an untreated plan and full access to lethal methods at home.
So if the contract was just a hollow piece of paper promising no fire, what is the modern replacement?
It's called the Safety Planning Intervention. It was developed by Barbara Stanley and Gregory Brown in 2012.
But wait, isn't a safety plan just another piece of paper? How does writing down a strategy actually stop someone in an acute crisis?
Because it's not a hollow promise to a doctor. It is a personalized, concrete, step-by-step cognitive map for the patient. You see, during an acute suicidal crisis, the prefrontal cortex, the part of the brain responsible for logical planning and impulse control, it essentially just goes offline.
It just shuts down.
Right. So a safety plan does the thinking for them when they can't. It maps out their specific personal warning signs, internal coping strategies they can do alone, social settings that provide distraction, specific professionals to call, and crucially, steps for removing lethal means from their environment.
It's like actually buying the fire extinguishers and mapping out the emergency exits before the smoke even starts. That makes total sense.
Exactly.
And it wasn't just the contracts that failed. The old static risk checklists failed too. Like there was one in the sources called the SAD Person Scale from 1983.
Yes, the SAD Person Scale.
It was an acronym standing for demographic things like sex, age, depression, previous attempt. It was supposed to be this quick memory trick for emergency departments.
But studies, like the one by Cooper and colleagues in 2016, totally debunked it. They proved that these static scales performed terribly. And if you look at the mechanics of why they failed, it's pretty obvious. You just cannot sum up demographic data to capture acute human distress.
Right, because under that old acronym, a 45-year-old single man might score as moderate risk just for existing, while a 20-year-old woman in acute immediate distress might score low risk because she doesn't hit enough demographic check marks. It's treating a static identity like it's a clinical state.
Exactly. A checklist score is not a clinical decision, which is why the rise of modern tools looks entirely different. Today, clinicians use tools like the Columbia Protocol, also known as the CSSRS.
And the origin of the Columbia Protocol is actually pretty fascinating on its own. In 2004, the FDA put a black box warning on antidepressants, linking them to increased suicidality in youth.
Right, that was a huge moment.
Suddenly, the FDA needed a highly standardized way to measure suicidal events across all their drug trials. So Kelly Posner at Columbia University developed this protocol, and it worked so well it migrated out of drug trials and into everyday emergency rooms and schools. But how does it actually work? What makes it better than the SAD person's acronym?
It uses branching logic. So instead of just adding up arbitrary points, it acts as a structured funnel. You start with a gateway question, something like, have you wished you were dead or wished you could go to sleep and not wake up?
Okay.
If the patient says no, you move on. But if they say yes, the logic branches down into the severity of that ideation, then into whether they have a specific intent, and finally, whether they have a concrete plan.
I see. So it guides the conversation naturally from vague distress all the way to immediate danger.
Yes. And for non-psychiatric settings, there is the ASQ, the Ask Suicide Screening Questions. That was developed by Lisa Horowitz at the National Institute of Mental Health, specifically for general medical nurses to use in under 2 minutes.
Wow, under 2 minutes.
Which is vital because a massive percentage of people who die by suicide saw a general healthcare provider in the weeks before, often for something totally unrelated like a stomach ache or a mild injury. You need a fast, reliable branching tool to catch that invisible risk.
But, having a great screening tool and a written safety plan is only part of the equation. A safety plan is great on paper, but the most crucial step of that plan relies on modifying the physical environment. And this brings us to a massive accidental national experiment in the United Kingdom.
Ah, yes. The UK coal gas story.
This was incredible to read about.
It really is. So through the middle of the 20th century, the UK used coal gas to heat homes and power ovens. It contained high concentrations of carbon monoxide and was actually the country's single most common method of suicide.
Right.
But in the 1960s and 70s, the UK systematically converted its grid away from coal gas to natural gas, which is not lethal by inhalation in the same way.
And an epidemiologist named Neil Kreitman tracked the data. As coal gas was phased out, the overall national suicide rate plummeted. I mean, it didn't just dip a little, it fell substantially and stayed down.
And this is the defining proof of a concept called means restriction. Because the most critical finding wasn't just that deaths by gas dropped, it was that people did not simply switch to other equally lethal methods.
So what does this all mean? Does just removing a specific method really stop the underlying intent entirely? Like if someone is truly determined, wouldn't they just find another way?
If we connect this to the bigger picture, it changes everything we thought we knew about suicidal intent. The coal gas story proves that suicidal crises are acute and time-limited. The intent is not a permanent, fixed state. Think of it as a wave that crests, peaks in intensity, and then breaks.
A temporary wave.
Exactly. If you can remove easy access to a highly lethal method during that specific narrow window of crisis, you don't just delay a death, you often prevent it entirely. The wave crashes, the crisis passes, and the person survives.
That is profound. And you can actually scale that philosophy up from household utilities to an entire healthcare system. Just look at what happened in Detroit in 1999. The Henry Ford Health System launched a program with this impossibly bold name, Perfect Depression Care.
Yes.
Their goal was literally 0 suicides among their patient population.
And it wasn't just a catchy slogan either. They achieved it. But they didn't do it by just telling doctors to, try harder. They changed the systemic mechanics of how care was delivered.
Right. They built systematic screening directly into the electronic medical record at every visit. A nurse couldn't just bypass the questions. It was integrated whether you were there for depression or just a twisted ankle.
Yep, universal screening.
And if a risk was flagged, the system immediately routed them into rapid access to care, safety planning, and means restriction counseling. By fundamentally changing the clinical workflow, they saw a dramatic decline in deaths. I mean, they had several years where absolutely 0 patients in their health plan died by suicide.
Which became the prototype for the National Zero Suicide Framework that health systems across the country use today. Systematic, everyday risk assessment moves outcomes far better than waiting for a patient to show up in crisis triage.
So we've spent a lot of time talking about the physical environment, removing the lethal gas, restricting access to means. But the psychological and cultural environment matters just as much, making risk a constantly moving target. And here's where it gets really interesting to me. We actually get the vocabulary for modern psychiatric contagion from 18th century literature and opera.
You're referring to the media impact, the Werther effect, and the Papageno effect.
Exactly. The Werther effect is named after Goethe's 1774 novel, The Sorrows of Young Werther. It featured a highly sympathetic, romanticized depiction of the main character's suicide. It was so influential it was literally blamed for a wave of copycat deaths across Europe.
Yeah, David Phillips formally named this media contagion the Werther effect in 1974.
How we talk about suicide publicly, especially detailing the methods it bypasses the brain's natural defenses and can literally be deadly.
But the flip side of that is the Papageno effect. Named after a character in Mozart's opera The Magic Flute, who is actively talked out of suicide and shown a different path. We saw the mechanics of this life-saving effect play out in real life in Vienna in the 1980s.
Right, the subway cluster.
Yes, there was a tragic cluster of suicides on the Vienna U-Bahn subway system, and it was heavily driven by sensationalized front-page press coverage.
So Gerd Sonneck and other Austrian researchers sat down with the media in 1987 and created strict reporting guidelines. No detailed method descriptions, no front-page placement, no romanticized language, and subway suicides dropped by roughly 80%.
The cultural narrative acts as its own form of means restriction. But to really understand why this happens, we have to look at what is going on internally, inside the mind of the individual. This is where Thomas Joiner's 2005 interpersonal psychological theory of suicide is just so illuminating.
Joiner's theory breaks down the progression of lethal intent into three distinct pillars, right?
Right. First, there is thwarted belongingness, which is feeling profoundly alienated from others. Second, perceived burdensomeness, the absolute false belief that your existence is actively harming the people you love.
How sad.
It is. When those two combine, they create the desire for suicide. But, and this is critical, desire alone isn't enough to result in a lethal attempt.
This is the core of the theory. The third pillar is acquired capability.
Yes. Because humans have a powerful, deeply ingrained biological instinct for self-preservation. It is incredibly difficult to override the physical fear of pain and death. Joiner argues that the capability for lethal self-harm is not innate. It has to be acquired over time through habituation. Repeated exposure to pain, violence, or trauma slowly wears down that biological flinch response.
And this explains the ideation to action framework. The data shows that most people who experience suicidal ideation never actually attempt it, simply because they haven't acquired the capability to bypass that self-preservation instinct. It also highlights a major misconception in medicine. The idea that suicide risk assessment is just a one-time intake event. You check the box on day one and you're done.
Which is entirely false. Risk is highly dynamic precisely because things like burdensomeness and capability can fluctuate. Risk can escalate within hours. For example, the period immediately following discharge from a psychiatric hospital or during medication changes is one of the highest risk windows known to medicine.
The transition itself is a huge stressor.
Yes. This is why the Joint Commission in 2019 strictly required ongoing rescreening. You just cannot treat a moving target as a single static data point on a clipboard.
So let's bring all of this together for you. We started by looking at a triage nurse sitting across from a patient, trying to predict the unpredictable. What we've learned from the sources is that suicide risk assessment is no longer about crystal ball prediction. It's not about checking demographic boxes to cover a hospital's legal liability.
It's not at all. It is an active, collaborative safety net. It is rooted in asking direct, plain language questions without fear. It is about abandoning useless promises like the no suicide contract and instead building actionable, personalized safety plans for when a crisis hits.
And it is about recognizing that crises are acute, temporary waves. Modifying the physical environment to remove lethal means during those brief windows, whether it's changing the gas in the ovens or putting distance between a person and a firearm, it saves lives, period.
It's acknowledging that risk fluctuates constantly and the assessment must adapt with it.
Before we wrap up, I want to leave you with a final provocative thought to ponder on your own, building directly on Thomas Joiner's theory of acquired capability. We talked about how the ability to overcome the fear of self-harm is built through habituation to pain and fear. Joiner explicitly notes in his work how this capability is acquired. He lists things like prior attempts or combat exposure, but he also explicitly lists medical training.
That is a very profound and sobering reality.
I really want you to consider the quiet burden of that fact. The very nurses, doctors, and medics who are trained to sit in that triage room and administer these life-saving risk assessments might, by the very nature of their daily relentless exposure to pain, trauma, and death, carry a uniquely elevated risk themselves.
Wow, yeah.
Their biological flinch response is worn down just by doing their jobs. It fundamentally changes how we look at the people asking the questions. When we picture that clinician sitting across the room, asking the question that saves a life, they aren't just reading a script. They are human beings, carrying their own vulnerabilities, doing the incredibly hard work of keeping the rest of us safe.
It's a really powerful reminder of the humanity on both sides of that clipboard.
It really is. Well, thanks for joining us on this deep dive. We'll see you next time.
You know, usually when we talk about a medical diagnosis, there's this expectation of like mechanical precision.
Right.
Like you break your arm, the x-ray shows a jagged white line, and the doctor just points at the film and says, there it is, broken or not broken.
Exactly, yeah. That visual proof provides this immediate comfort to both the clinician and the patient. I mean, we are just totally conditioned to trust things we can categorize with a quick scan.
But the moment you step into the world of mental health, I mean, that x-ray machine is entirely useless. The diagnostic landscape gets really murky really fast.
Oh, absolutely. We're forced to rely on observable behavior and, subjective reporting rather than just a simple blood test, which is just the reality of psychiatric medicine, right? We're mapping this deeply complex, completely invisible landscape.
Yeah, and that murkiness is basically our mission for this deep dive, because today we are unpacking a really fascinating stack of clinical nursing sources all about anxiety disorders.
And we are not just looking at the high-level theoretical psychiatry here either.
Right. No, we are looking at the bedside reality. We want to know how healthcare professionals, specifically nurses, right, how they recognize and respond to the physiological storm of an anxious patient when it's like happening right in front of them in real time.
Because that bedside perspective really strips away all the abstraction. We are looking at the surprisingly contentious history of how the medical field even defined this condition, the very real biology it creates in the body, and exactly how nurses use concepts like cognitive bandwidth to de-escalate a patient who's in severe distress.
Let's unpack this, because right off the bat, our clinical sources point out this crucial, highly technical distinction from the DSM-5 that pretty much frames everything else we're going to talk about.
It really does, yeah.
Because in everyday conversation, people use the words fear and anxiety interchangeably all the time. But clinically, they are entirely different biological beasts.
Completely different, yeah.
Fear is the emotional response to a real imminent threat. It's that immediate fight or flight reaction, like you see a bear charging at you in the woods. Your body experiences fear.
Right. Fear is anchored entirely in the present tense. But anxiety is the anticipation of a future threat. So it operates in the future tense.
Oh, that's a good way to put it.
Yeah. So instead of the sudden urge to sprint away from a predator right now, anxiety manifests as like sustained muscle tension, hypervigilance, long-term avoidance behaviors. The body is essentially preparing for a danger that just hasn't arrived yet and, frankly, might never arrive.
And if you're listening and wondering why this distinction matters to you, I mean, just consider the sheer scale of the issue. Whether you are catching up on clinical literature or prepping for a stressful quarterly review at work, or honestly just trying to navigate the modern world, you are going to encounter this physiological cascade at some point.
Definitely. This is not some rare phenomenon locked away in a specialized psychiatric ward.
No, not at all.
The prevalence data underscores that perfectly, actually. According to Ronald Kessler's National Comorbidity Survey replication out of Harvard, anxiety disorders, when you group them together, are literally the single most common category of mental illness in America.
Wow.
Yeah, roughly 1 in 5 adults will meet the diagnostic criteria for an anxiety disorder in any given year.
1 in 5 adults? That is a staggering statistic.
It's massive. Exactly a quarter to a third of all adults will meet the criteria at some point in their lives. And conditions like generalized anxiety disorder and specific phobias present about twice as often in women as in men.
So for a nurse, this dictates that anxiety is this secondary or even primary condition that they'll be managing constantly on every single unit, regardless of why the patient was originally admitted to the hospital.
Exactly.
But to understand how a nurse treats that patient today, we really have to trace the history back, because it took an incredibly long time for the medical field to even agree on what they were looking at.
Oh, centuries.
Yeah. Before 1980, American psychiatry didn't even use anxiety disorders as a plural categorical term.
Right. The timeline reveals this really deep struggle for clarity. So, starting in 1769, you have a Scottish physician named William Cullen, and he coined the term neurosis.
Okay.
But he basically used it as a catch-all classification for disorders of the nervous system where physicians just couldn't find a clear structural lesion in the body.
So it was just a medical placeholder, like a really fancy way of saying we observe the symptoms, but we don't know the biology yet.
Pretty much, yeah. And then Sigmund Freud attempted to impose some order on that chaos in 1895.
Ah, Freud.
Right. He published this pivotal paper arguing that a very specific cluster of symptoms, chronic apprehension, physical palpitations, sweating, and sudden panic attacks, needed to be officially separated from general neurasthenia, which was the era's term for general nervous exhaustion.
Gotcha.
And Freud called this new unified syndrome anxiety neurosis.
Though we definitely have to acknowledge that Freud's theory about the underlying cause of these symptoms is totally debunked today.
Oh, completely.
Because he hypothesized that anxiety neurosis was the result of dammed up libido, essentially undischarged sexual tension converting itself into physical panic, which, I mean, he was entirely wrong about the mechanism.
Entirely.
But separating that specific cluster of symptoms into a distinct diagnostic category was still a massive structural leap forward for the field.
It was. But what's fascinating here is that the biological validation for that separation didn't actually arrive until the 1960s. And that was thanks to a Columbia psychiatrist named Donald Klein.
Right?
Klein was treating patients with severe panic attacks using a specific tricyclic antidepressant called imipramine. And he observed that the medication completely blocked the sudden, intense panic attacks in his patients.
Which seems like a massive breakthrough just on its own.
It was, but the real breakthrough was actually in the limitation of the drug.
Wait, really? How so?
Well, while imipramine stopped the acute panic attacks dead in their tracks, it did absolutely nothing for the patient's chronic anticipatory worry between those attacks.
Oh, wow.
Yeah, so they were still experiencing this constant low-level dread.
Okay, I love this part of the history because it acts like this perfect diagnostic key. It's like imagine a mechanic trying to fix a malfunctioning car, right?
Okay.
If the mechanic cuts one specific wire and the car's blaring security alarm instantly turns off, but the engine continues to overheat, that proves, beyond a shadow of a doubt, that the alarm system and the engine cooling system run on two completely separate electrical circuits.
Exactly. Klein proved a pharmacological dissociation. If a single chemical molecule turns off one symptom cluster, the panic, but leaves the other symptom cluster, the anticipatory worry, completely untouched, well, they just cannot be the same underlying disease.
Right.
Panic and generalized worry were biologically distinct circuits in the brain.
And that single pharmacological discovery is what dismantled Freud's unified anxiety neurosis, right? It directly led to Robert Spitzer's checklist revolution in the 1980 release of the DSM-3.
Yep. The psychiatric community finally officially split the diagnosis into the distinct categories we use today, recognizing panic disorder as fundamentally different from generalized anxiety disorder.
And because Klein proved these are distinct biological pathways, modern neurobiology has mapped exactly how this physiological storm plays out in the body, which is just fascinating.
It really is. At its core, an anxiety disorder involves a threat detection system running in severe overdrive. So the amygdala, which functions basically as the brain's alarm center, becomes hyperreactive.
Which kicks off this massive systemic chain reaction.
Right, so the amygdala triggers the HPA axis. That's the hypothalamic pituitary adrenal axis.
Okay.
And this is the chemical relay system that communicates with your adrenal glands, flooding your bloodstream with cortisol, the primary stress hormone.
Right.
And simultaneously, a structure in the brainstem called the locus coeruleus, which is essentially the body's norepinephrine factory, dumps excess norepinephrine into your circulation.
And that surge of norepinephrine is what drives the sympathetic cascade. Like, the physical symptoms are unmistakable. You get tachycardia, meaning a dangerously racing heart, diaphoresis, which is just sudden, intense sweating, tremors, dilated pupils, hyperventilation.
Yeah, and all of this acceleration happens while the brain's primary braking system is basically failing.
Oh, right, GABA.
Exactly. Gamma-aminobutyric acid, or GABA, is the neurotransmitter responsible for inhibiting these signals and calming the nervous system down. But during this storm, GABA is functionally underactive.
So the accelerator is pinned to the floor and the brakes have literally been cut.
Exactly.
Which brings us to the everyday reality of this in a hospital setting. because our sources detail this fascinating presentation of panic disorder in the emergency room. Patients will rush through the doors exhibiting chest pain, a racing heart, severe shortness of breath, and a profound verbalized fear that they are actually dying.
Yes,
And the DSM checklist for a panic attack literally includes fear of dying as an official diagnostic symptom.
it does. And triage nurses and ER physicians operate under a very strict, non-negotiable rule in these scenarios. You never assume the patient is just experiencing anxiety.
Because it's too risky.
Way too risky. A severe panic attack mimics a myocardial infarction, a heart attack symptom for symptom. The objective presentation of a hyperreactive amygdala is basically indistinguishable from the objective presentation of cardiac ischemia.
Okay, but let me push back on that for a second. If the symptoms of a panic attack and a literal heart attack look identical, like the diaphoresis, the chest pain, the elevated heart rate, how can triage staff possibly tell the difference just by visually assessing the patient in the waiting room?
Well, you've hit the nail on the head. They can't.
They just can't.
Visual assessment is entirely insufficient, which is exactly why objective cardiac workups are mandatory. The clinical team must run an EKG and draw blood to check for cardiac enzymes like troponin. A panic attack will peak and naturally resolve within about 10 to 20 minutes without causing actual necrosis or tissue damage to the heart muscle. But the clinical team cannot verify that without the lab results. You always have to rule out the body before you settle on the mind.
And that strict protocol shatters another major misconception that nurses are trained to avoid. You cannot assume that a patient sitting quietly in a chair looking physically calm isn't experiencing severe internal anxiety. The biological storm can be entirely internalized.
Absolutely. And since the physical symptoms can hide or, effectively mimic a lethal cardiac event, nurses require a highly structured way to actually communicate with these patients.
Right, because you have to know how to talk to them.
Exactly. So Hildegard Peplow, who was a huge pioneer in psychiatric nursing, developed this interpersonal theory built around anxiety as a central organizing concept. And she categorized anxiety on a continuum of 4 distinct levels: mild, moderate, severe, and panic.
I love this framework because it ties so beautifully into the Yerkes-Dodson principle, which explains the relationship between arousal and performance.
Yes, it's a perfect overlap.
Right. The concept is that a mild amount of anxiety actually improves your cognitive function. Under Peplaw's definition, mild anxiety heightens your environmental alertness and motivates learning. Like if you have exam day jitters, that mild anxiety sharpens your focus directly onto the test paper.
Exactly. Mild anxiety is highly functional. The danger lies in the tipping points along that continuum.
Yeah.
Once a patient crosses into moderate anxiety, you start to observe a narrowing of their perceptual field.
Yeah.
The patient begins to exhibit selective inattention.
Yeah.
They might hear a little less of what the nurse is explaining, filtering out peripheral information.
But when they hit severe or full panic levels, rational thought just collapses entirely.
Completely collapses.
The patient's perceptual field reduces to this incredibly tiny point. They might fixate on a single ticking clock on the wall, completely unable to process the words the medical team is saying. And in full panic, their behavior becomes profoundly disorganized.
Right. The cognitive bandwidth simply ceases to exist.
It's exactly like trying to download a massive 5 GB software update on a smartphone that has 1% battery life and a terrible dropping Wi-Fi connection. The system is technically powered on, but the bandwidth is completely gone. You cannot force complex data through a compromised connection.
That is a great analogy. And when the system is at 1%, the nursing intervention must fundamentally change. At the mild or moderate levels, a nurse can effectively use therapeutic communication. They can hand a patient a pamphlet and teach them about the potential side effects of a new medication.
Sure.
But when a patient escalates to severe or panic levels, teaching is immediately abandoned. You do not attempt to explain complex discharge instructions to a patient who has lost their cognitive bandwidth.
Right, the priority shifts from education to immediate safety and stabilization. The nurse literally stops trying to push the download and focuses on plugging the phone into a power source.
Exactly. You reduce the stimuli in the room, you dim the lights, you maintain a calm, steady physical presence,
Yeah.
you lower the pitch of your voice, and you issue incredibly short, simple 3-word directions like, breathe with me.
Because reducing that cognitive load allows the patient's autonomic nervous system a chance to actually reset.
Right. And if we connect this to the bigger picture, just consider how broadly this applies outside of a psychiatric unit.
Oh, totally.
Picture a parent standing in a pediatric intensive care unit, or a patient sitting completely alone waiting for a biopsy result. They are very likely experiencing that severe physiological cascade, recognizing that their cognitive bandwidth has shifted, that they literally lack the physiological capacity to process complex medical language in that moment. That has immediate consequences for patient safety and, honestly, just providing basic human compassion.
Yeah, managing the acute moment is all about recognizing that bandwidth. But treating the underlying disorder long term and debating how these fears are acquired in the first place is where the medical literature gets fiercely complicated.
It really does.
Yeah.
Because the origin of specific phobias and anxieties fundamentally shapes how we actually attempt to treat them.
Right.
Back in 1920, John Watson and Rosalind Rayner conducted the famous Little Albert experiment.
Oh, the baby and the rat.
Yes, they introduced a 9-month-old infant to a neutral stimulus, a white rat. But every time the infant reached for the rat, the researchers struck a steel bar with a hammer right behind him, creating this sudden, terrifying noise.
Right, so the infant became conditioned to associate the neutral rat with the terrifying noise. But the most revealing part of that experiment was the generalization, wasn't it?
Exactly.
The infant didn't just fear the specific white rat anymore. The learned fear generalized to other furry objects, like rabbits, dogs, and even a fur coat.
Yeah, and that experiment proved a monumental concept in behavioral psychology. Phobias can be acquired through simple classical conditioning. They don't necessarily stem from deeply buried, unconscious Freudian conflicts.
There's a huge shift.
A massive shift, because if a fear can be systematically learned through environmental conditioning, well, it stands to reason that it can be systematically unlearned.
Which directly laid the groundwork for Joseph Wolp's introduction of systematic desensitization in 1958, right? Which is basically the ancestor of modern exposure therapy.
Exactly. You gradually expose the patient to the triggering stimulus in a safe, highly controlled environment, slowly breaking that conditioned neurological response.
Now, exposure therapy is highly effective, but it requires months of sustained, really uncomfortable psychological work. And when a patient is suffering from acute, debilitating panic in the present moment, they understandably seek a much faster intervention.
Of course they do.
And here's where it gets really interesting. Biologically, the medical field attempted to solve that urgency through the widespread introduction of benzodiazepines. Ah, yes. Drugs like Valium became culturally ubiquitous from the 1970s through the 1990s, and they were prescribed constantly because, mechanistically, they work incredibly fast.
They do work fast. Benzodiazepines bind to those GABA receptors we discussed earlier. They artificially enhance the brain's braking system, shutting down the excessive neuronal firing and halting the anxiety rapidly. But the clinical field learned a severe, painful lesson regarding the difference between acute symptom suppression and actual sustainable treatment.
Right, because that fast relief comes with a really aggressive biological cost. Benzodiazepines carry a massive risk of physical dependence, tolerance building, and just brutal physiological withdrawal if stopped abruptly.
The resulting public health crisis from that dependence forced a massive shift in prescribing guidelines.
Which is why SSRIs are basically first line now.
It's exactly. Today, SSRIs and SNRIs, selective serotonin and norepinephrine reuptake inhibitors, are the first-line pharmacological treatment for sustained anxiety management. These medications take several weeks to build up efficacy in the system, but they focus on long-term neuroplasticity rather than just an immediate chemical shutdown.
So to use an analogy, a benzo is basically a fire extinguisher. It is highly effective at putting out a sudden, dangerous flare-up in the kitchen, but you cannot use a fire extinguisher to prevent fires permanently.
Right.
An SSRI is more like installing a building-wide sprinkler system. It takes much longer to install and calibrate, but it provides a safer, continuous baseline of protection.
That's a great way to think about it. The transition from rapid suppression to long-term management really highlights how treatment evolves. But beyond just the pharmacology, psychiatry is currently grappling with something even bigger.
Which is
how culture fundamentally rewires the brain to manifest anxiety in completely different ways. You know, the DSM is a Western diagnostic manual, and it does not represent a universal template for the human condition.
That is so true, and our sources emphasize this cultural variance heavily. The DSM-5 actually had to incorporate a cultural concepts of distress section just to account for presentations that fall outside Western biological assumptions.
Right.
Like, for example, among certain Latino populations, there is a recognized presentation known as ataque de nervios.
Yes. Ataque de nervios often presents with intense screaming, trembling, and a profound sense of losing control. And it's typically triggered directly by acute family conflict or grief. So the anxiety manifests through this really intense, externalized somatic and emotional expression.
Okay, wow. And then you contrast that with something like Taijin Kyofusho in Japan, which reveals how societal structure dictates the specific target of the fear.
Right.
Because in Western individualistic cultures, social anxiety disorder is generally characterized by an intense fear of embarrassing yourself. The anxiety is directed inward at your own potential humiliation.
But Japan operates heavily on an interdependent self-control where social harmony is deeply prioritized.
Right.
Consequently, Taijin Kyofusho centers on an intense fear of offending or embarrassing other people through your own perceived physical or social flaws. The underlying biological arousal is the same, but the culture provides the architectural blueprint for how the fear is actually experienced.
But if culture shapes the symptoms that much, it naturally begs a massive question about how we define a disorder at all.
It definitely does.
Alan Francis, the psychiatrist who literally chaired the task force for the DSM-IV, wrote a deeply critical book about this called Saving Normal. He basically argued that the current diagnostic thresholds are far too loose.
Yes, his critiques are very well known.
Like, if you look at generalized anxiety disorder, the baseline criteria require excessive worry about multiple domains for 6 months, accompanied by mild physical symptoms like fatigue or muscle tension. But aren't we just describing modern life? Like, with economic inflation, continuous global news cycles, and the pressure of modern employment, how does psychiatry avoid over-medicalizing just being a normal, stressed-out human being?
It's a really valid pushback. The clinical defense against over-medicalization relies heavily on two very specific criteria written into the DSM: proportion and impairment.
Okay, proportion and impairment.
Right. To qualify as a pathological disorder, the biological anxiety response must be genuinely out of proportion to the actual objective threat. And even more importantly, it must cause clinically significant distress or functional impairment.
So impairment is the absolute dividing line.
Exactly.
Feeling nervous about paying your mortgage is a standard human trait. But being so consumed by that worry that you suffer from insomnia for 6 months, lose the ability to concentrate at your job, and entirely isolate yourself from your family, that is functional impairment. The system is no longer functioning.
Right. When the biological response actually prevents the organism from executing the necessary functions of daily life, that is when it crosses the threshold into pathology.
So what does this all mean when we look at the full picture? We trace the evolution from William Cullen's vague label of neurosis in 1769 through Freud's early categorization directly to Donald Klein, proving with imperpan that sudden panic and chronic worry actually run on entirely distinct biological circuits.
And we established the critical baseline difference, right? Fear is the biological reaction to an imminent threat in the present moment, while anxiety is the anticipatory dread regarding a potential threat in the future.
Yeah, and we mapped out that physiological storm, the hyperreactive amygdala triggering the HPA axis, the locus coeruleus flooding the body with norepinephrine, and the failure of GABA to just apply the brakes. We demonstrated that this measurable physical reality is exactly why triage nurses are required to run objective cardiac tests to rule out a myocardial infarction before ever assuming a patient is just having a panic attack.
We also explored the practical bedside application through Peplaw's 4 levels of anxiety, understanding that when an individual escalates from mild anxiety into severe anxiety, their cognitive bandwidth just collapses.
It's just gone.
Exactly. The clinical response must shift away from education and problem solving, prioritizing environmental safety and simplified communication just to let the nervous system reset.
And honestly, you don't need to be wearing scrubs in an emergency room to apply that framework.
No.
Assessing someone's capacity before demanding comprehension is a profound tool for basic human connection.
It really is.
If you are navigating a conflict with a colleague or trying to comfort a partner and you recognize the physical markers that they have crossed into severe anxiety, you know their bandwidth is gone. Trying to force complex logic or problem solving onto them in that moment is like trying to push a massive data download through a broken connection. You just need to be present, lower the temperature of the room, and provide a safe baseline.
The biology dictates the intervention.
It really does. But before we wrap up this deep dive, I want to leave you with a final thought to ponder that builds on everything we've just unpacked about diagnosis and culture. We discussed how the modern psychiatric definition of an anxiety disorder fundamentally relies on the concept of proportion. The idea that the fear must be excessive relative to the actual danger.
Right, and the concept of functional impairment relies on a relatively stable understanding of what actually constitutes normal environmental stress.
But if the baseline actual danger of the world we inhabit continues to rise, driven by ecological instability, relentless economic pressures, and the constant digital influx of global crises, how will those diagnostic checklists have to evolve?
That's a huge question.
Right. If the environment itself becomes objectively more volatile and objectively more terrifying, does the definition of a disorder fundamentally change? Perhaps that diagnostic landscape is destined to become even murkier. Something to think about the next time you feel your pulse quicken while checking the morning news. Thank you so much for joining us for this deep dive. We'll catch you on the next one. Why does a 2-month-old baby get a whooping cough vaccine, but has to wait a full calendar year to get the measles vaccine?
Yeah, that's a massive gap that confuses a lot of people.
Right. And if you have ever worked in a pediatric clinic, or, if you are a nursing student cramming for your boards right now, or honestly, even if you're just someone who is endlessly curious about public health, you have probably stared at the childhood immunization schedule.
Absolutely.
And it looks incredibly intimidating. I mean, it's like a chaotic, color-coded tax form crossed with like an engineering blueprint. You've got the primary grids, the catch-up blocks, the footnotes.
It really is just the absolute definition of information density. I mean, people look at it and they just see a wall of dates and acronyms.
Exactly. And today, the mission for this deep dive is to decode that timeline. The timeline that every nurse, every clinician, and really every curious learner should know.
Because we aren't just going to look at what is on that chart. We are going to look at why it is there.
Right. Because when a parent asks you, why does my baby need this specific shot today? Answering, because the chart says so, just doesn't cut it.
It really doesn't. And to really get to the why, we have to fundamentally redefine what that schedule actually is.
Okay, so what is it then?
Well, a lot of people, even some practicing clinicians, assume the schedule is just a biological speed run. Like the fastest, safest way to get a kid vaccinated.
Right, like just check the boxes as fast as possible.
Exactly. But what you are looking at is actually a massive, highly complex optimization problem. It is basically a piece of health systems engineering.
Health systems engineering, I always thought of it as purely medical. What makes it an optimization problem?
Because you are balancing multiple, sometimes completely competing constraints. I mean, immunology is the foundation, of course.
Yeah, the biology part.
Right. But layered directly on top of the biology, you have manufacturing supply realities, you have insurance billing codes.
Oh, wow, I didn't even think about the billing codes.
Yeah, and you have the physical limit to how many clinic visits a family can realistically manage without just, dropping out of the system entirely. Plus, the actual epidemiology of what diseases are circulating right now in a specific region.
So biology is really just the starting point. It's like the outer boundaries.
Exactly. Everything inside those boundaries is negotiated. It's engineered. And that is why the U.S. schedule looks different from the U.K. schedule, which looks different from Nigeria's.
That makes a lot of sense. So to understand how we ended up with this multi-page, hyper-engineered chart, we should probably look at how we went from just a single shot to this massive, globally coordinated system.
We definitely should. Because for most of the 20th century, the schedule wasn't really a schedule at all.
It was barely a short list, right?
Yeah, barely. You had smallpox, then you had DTP, which is diphtheria, tetanus, pertussis, and then polio. That was pretty much the entire landscape.
And the underlying logic for all of this traces all the way back to 1796 with Edward Jenner.
Right, the cowpox experiment.
Yeah, he inoculated an 8-year-old boy named James Phipps with cowpox to protect him against smallpox.
And that single intervention established the core biological premise that really drives everything on today's chart, which is you introduce a controlled artificial exposure to train the immune system.
Before it inevitably encounters a wild, dangerous exposure.
Exactly. But the schedule as a system, that doesn't really happen until after World War II. That's when things just explode.
Right, because we get the DTP combo in the 40s and 50s. Jonas Salk develops the inactivated polio vaccine in 1955.
And then Albert Sabin brings out the live oral polio vaccine around 1961. So suddenly pediatricians just have a lot of tools.
Which I imagine create a massive amount of chaos.
Oh, total chaos. Someone had to sequence all of these new vaccines so they wouldn't conflict biologically or completely overwhelm families with endless doctor visits.
So who stepped in to fix that?
In 1964, the U.S. established the Advisory Committee on Immunization Practices, or ACIP.
Okay, ACIP.
Yeah, and their explicit job was to standardize these recommendations. Because Before that committee existed, timing was essentially just left up to the judgment of individual doctors.
Which sounds like a logistical nightmare. And globally, the World Health Organization steps in a decade later, right? In 1974.
Yes, with the expanded program on immunization, the EPI, and the realization the WHO had at that moment is fascinating.
What did they realize?
Well, they had just run this massive, successful campaign against smallpox. But they looked around and realized that 6 other diseases, diphtheria, pertussis, tetanus, measles, polio, and tuberculosis, were still killing millions of children in low-income countries.
And the vaccines for these already existed.
Exactly. The bottleneck wasn't the laboratory science anymore. The bottleneck was the schedule and the delivery infrastructure.
You know, organizing a schedule sounds like it should be a simple logistical puzzle, like setting up a train timetable.
A train timetable.
Yeah, like you just figure out when the tracks are clear and you send the trains through one by one so they don't crash.
It's a good analogy, but it breaks down pretty quickly when you look at the biology. It's actually more like trying to plant a complex garden where the soil chemistry is violently changing every single month.
Oh, wow.
Yeah, you're navigating a biological landscape inside the infant that is entirely dynamic.
Okay, let's get into those changing soil conditions then. The tug of war happening inside the infant's immune system, because you have to start by looking at what the baby inherits from the mother, right?
Right. During the 3rd trimester, a fetus receives a massive transfer of IgG antibodies across the placenta from the mother.
And IgG stands for immunoglobulin G.
Correct. Which are essentially small, highly specific proteins that act as lock and key defenders. And because they are small enough to cross the placenta, they provide passive immunity to the newborn.
Wait, hold on. A mother's antibodies are a good thing, right? They protect the baby, so why would we care if they interact with a vaccine? Isn't the baby protected either way?
It seems counterintuitive, I know. Those borrowed antibodies are crucial for keeping the newborn alive. But vaccines are essentially target practice for the baby's own immune system.
Okay, target practice.
Yeah, and if you introduce a live vaccine, like the MMR for measles, mumps, and rubella too early, the mother's aggressive IgG antibodies will instantly neutralize the vaccine virus.
They just wipe it out.
They clear it out completely before the baby's own T cells and B cells ever get a chance to even see it and build their own long-term memory.
Oh, I see. So the mother's security force is so good, it basically kicks the training dummy out of the building before the baby's security force can even look at it.
That is a perfect way to describe it. That is the exact mechanism of maternal interference. And it is precisely why the MMR vaccine waits until 12 to 15 months of age.
Because you have to wait for that borrowed immunity to completely fade.
Exactly.
But I've seen situations where there is a measles outbreak and public health officials suddenly recommend giving infants a dose at 6 months. How does that work if the mother's antibodies are still hanging around?
Well, in an outbreak setting, the risk calculation changes. You give that early dose at 6 months to try and squeeze out whatever protection you can as those maternal antibodies begin to wane.
Just in case they faded enough to let the vaccine work.
Right. But here is the critical rule for anyone studying the schedule. That early dose does not count toward the routine series.
Ah, because you can't guarantee it actually trained the baby's immune system.
Exactly. You still have to give the standard doses later on once you are absolutely sure the maternal antibodies are completely gone to guarantee durable immunity.
Okay, so that covers maternal interference. But once that borrowed immunity fades, you hit the opposite problem, right? A massive vulnerability gap.
Yes. The newborn's own adaptive immune system isn't fully mature yet.
And pertussis, or whooping cough, is basically the most terrifying example of this gap.
It really is. Infants under 2 months are highly vulnerable to the pertussis bacteria. They have no protection of their own, and the infection can cause fatal apnea.
Which means they don't just cough, they simply stop breathing. It's terrifying. And that is exactly why the DTaP vaccine, which is diphtheria, tetanus, and acellular pertussis, starts exactly at 2 months.
So 2 months is the magic number.
It is the very moment the infant's immune system can finally mount a meaningful antibody response to the acellular components of that vaccine.
Now, when you say acellular, what does that actually mean in terms of what the baby's immune system is looking at?
It means we aren't using the whole pertussis bacterial cell. We are just using purified pieces of specific proteins.
Okay.
So the infant's immune system has to be mature enough to piece that puzzle together and recognize those proteins as a threat.
So it's kind of like showing the immune system a wanted poster with just a few distinct facial features
Yeah.
rather than showing them the actual criminal.
That's a really good way to put it. but, because of that terrifying 2-month gap before the baby can even process that wanted poster, public health relies on a neighboring concept called the cocooning strategy.
Right, this is where you vaccinate the pregnant mother. Exactly. You give the mother the Tdap vaccine, ideally between 27 and 36 weeks of gestation.
So she builds up immunity right before birth.
Right. By boosting the mother's immunity then, she produces a fresh, massive surge of antibodies that pass across the placenta. You are actively building a bridge of borrowed immunity over that dangerous, unvaccinated window for the newborn.
That is so smart. But if we're timing the schedule around the mother's fading antibodies and the baby's own vulnerable gaps, why are some shots given over and over again?
You mean the boosters?
Yeah, like the DTaP is given at 2, 4, 6, and 15 to 18 months, and then another booster at 4 to 6 years. That is 5 total doses just to establish memory.
Well, a young immune system often needs repeated exposure to a specific antigen to build long-lived memory cells. And immunity to different pathogens just decays at different rates.
So the pertussis protection fades quickly.
Yes. The cellular pertussis vaccine requires constant reinforcement to keep the antibody levels high enough to prevent disease.
But the MMR is different.
Right. Meanwhile, a live attenuated vaccine like MMR replicates inside the body just enough to provide a massive, robust training session, which is why it only requires 2 doses for lifetime protection.
Okay, so immunology clearly sets the outer boundaries of this schedule. But when you look at the sources for this deep dive, the exact rules within those boundaries weren't just calculated in some pristine lab.
No, not at all.
They were forged by real-world trials, errors, and frankly, some massive historical disasters.
It is so vital to view the schedule as a living document. It is constantly reacting to post-marketing surveillance.
Post-marketing meaning after it's already approved and out there.
Exactly. The CDC and FDA co-manage a system called VAERs, which is the Vaccine Adverse Event Reporting System. It tracks safety signals after a vaccine is in wide use.
And the rotavirus vaccine is a perfect example of this living document in action, isn't it?
It really is. On the modern schedule, the rotavirus vaccine like Rototech has a very strict, weirdly specific rule.
What's the rule?
The first dose absolutely must be given before 15 weeks of age.
15 weeks? That's so specific. Why?
That 15-week cutoff is a direct response to a previous failure. In 1999, an earlier version of a rotavirus vaccine called RotaShield was actually withdrawn from the market.
Oh, wow. Why was it pulled?
The VAER system detected an elevated risk of something called intussusception.
Wait, intussusception, what exactly is that?
It's a severe condition where one part of the intestine slides inside another part, kind of like a folding telescope.
Ah, that sounds incredibly painful.
It is. It creates a dangerous bowel obstruction. And the surveillance data showed this risk was specifically elevated when the vaccine was given to older infants.
So rather than scrapping the whole idea of protecting babies from rotavirus, they engineered a timing solution.
Exactly. By restricting the first dose of the newer vaccines to infants under 15 weeks, they completely eliminated that specific age-related risk profile.
That's incredible. But, the rigorous federal surveillance systems that caught that issue, they were born out of a much darker history.
Yes, they were.
I'm thinking of the Cutter incident of 1955.
Yeah, that is one of the most significant pharmaceutical disasters in American history.
Set the scene for us. What happened?
So, Jonas Salk's inactivated polio vaccine was licensed in 1955. It was a huge deal, a moment of global triumph. But just 2 weeks later, disaster struck.
2 weeks.
Just 2 weeks. A batch produced by Cutter Laboratories in Berkeley contained live, incompletely inactivated poliovirus.
Oh, no. And they gave it to people.
Roughly 200,000 children received these defective doses.
That is staggering.
The outcome was catastrophic. It caused roughly 40,000 cases of abortive polio.
Wait, abortive polio? What does that mean? Like the virus just went away?
It means the infection caused mild illness like fever, sore throat, muscle weakness, but it stopped short of entering the central nervous system to cause full paralysis.
Okay, but still, 40,000 kids getting sick from a vaccine.
Right, the fact that it was causing any disease at all meant the vaccine contained live, dangerous virus. And tragically, it didn't stop at abortive cases.
What else happened?
It caused over 150 cases of paralytic polio in children and their family contacts, and 10 deaths.
That is horrifying. A vaccine meant to stop paralysis actually causing it?
It was a profound trauma for the public health system. But this disaster directly catalyzed the creation of far stricter federal manufacturing oversight.
So it changed the laws.
Yes, it led to the Division of Biologic Standards, which is the direct ancestor of our modern FDA vaccine regulatory apparatus. The safety net around today's schedule exists because of the lessons learned from that terrible failure.
It's amazing how much history is baked into that chart. But it's not just about timing and oversight either. Sometimes the schedule shifts because of pure chemistry.
Chemistry.
Yeah, like how the vaccine is physically constructed.
Oh, right. This brings up the concept of conjugate vaccines.
Which is fascinating. Walk us through that.
Take the Hub vaccine, which protects against a bacteria that causes a deadly form of meningitis in infants. Or the pneumococcal vaccine, PCV.
The sources for this deep dive mention that the bacteria that cause these diseases have an outer coating made of polysaccharides, right?
Yes, which are basically complex sugars. And early vaccines just use this sugar coating to try and train the immune system.
And how did that work out?
They completely failed in infants. An infant's immature immune system just could not see or mount a response to that sugar coating.
So the chemistry of the antigen wasn't clicking with the biology of the baby?
Exactly.
So if the baby can't see the sugar coating, what do? Do you strip the coating off? Or do you wrap it in something else?
You attach it to something they actually can see. In the late 1980s, scientists figured out how to chemically link or conjugate that weak sugar antigen to a strong, recognizable protein carrier.
Okay, so they glued it to a protein.
Exactly. When you inject this conjugated molecule, the infant's immune system immediately spots the carrier protein, attacks it, and in the collateral damage, it learns to recognize and fight the sugar coating too.
That is so clever. It's like a chemical disguise that forces the baby's immune system to learn.
A chemical disguise. That is exactly what it is.
That is incredible.
Huh.
But because the schedule is this complex, ever-shifting document full of chemical disguises and strict cutoffs, it leaves a lot of room for skepticism.
It really does.
And that skepticism has fueled major debates and dangerous misconceptions that nurses face every single day.
Which means we have to address the most consequential medical fraud in recent vaccine history.
You're talking about Andrew Wakefield's 1998 paper in The Lancet.
Yes, the infamous paper claiming a link between the MMR vaccine and autism.
The reality behind that paper is staggering when you look at the details in the source material.
It really is. First of all, it was based on a case series of just 12 children.
Just 12 kids.
Yes, and Wakefield had undisclosed financial conflicts of interest. He was actively being paid by lawyers who were preparing litigation against vaccine manufacturers.
That is a massive conflict of interest.
And worse, the data itself was manipulated to fit a predetermined conclusion.
So it was just outright fraud. And The Lancet eventually fully retracted the paper in 2010.
Right, and Wakefield was struck from the medical register and lost his license.
And since then, massive studies involving well over 1 million children across multiple countries have found absolutely zero association between MMR and autism.
Zero. But the psychological damage was durable, and it was devastating. Following that publication, MMR uptake in the UK plummeted from about 92% to under 80% in some areas.
And diseases don't care about retracted papers.
No, they don't. As a direct mathematical result of that drop in vaccination, measles, which had been nearly eliminated in the UK, returned. It was declared an endemic disease again in 2008.
That is so tragic. Which brings us to another huge misconception parents have. The too many too soon argument.
Oh, we hear this one a lot.
Yeah, parents look at that massive grid of shots and worry that the sheer volume of the modern schedule is going to completely overwhelm their baby's tiny immune system.
Visually, it is a very understandable fear. It looks like a lot. But biologically, it fundamentally misrepresents how the immune system works. In 2013, the Institute of Medicine conducted a massive formal review of the entire childhood schedule. They looked for cumulative safety issues and found absolutely zero evidence supporting the idea of immune overload.
But how is that possible, though, with so many more shots on the schedule today compared to, say, the 1980s?
Because of the purification processes we just talked about, like the cellular vaccines.
Oh, right, because we aren't using the whole cell anymore.
Exactly. Vaccine researchers like Paul Offit have pointed out that the total number of distinct antigens across the entire modern schedule is only a few hundred.
A few hundred. Is that a lot?
It's a tiny fraction of the antigens a child is exposed to by getting a single common cold.
Wait, really? A single cold?
Yes. The infant immune system's theoretical capacity to respond to distinct antigens is in the thousands simultaneously.
So a kid crawling on the floor, licking a plastic toy, and fighting off a runny nose is putting far more stress on their immune system than the entire vaccine schedule combined.
Precisely. which is why the trend of the delayed schedule is so deeply problematic.
This is where parents want to space out the vaccines to be gentler on the child.
Right. It sounds so reasonable on the surface.
Yeah,
Let's just take it slow, do one shot at a time.
but it's not actually safer.
There is zero demonstrated safety benefit to delaying doses. But mathematically, delaying doses does one very concrete thing. It physically extends the window of time that a child is completely susceptible to diseases like pertussis and head meningitis.
So you are basically artificially prolonging that dangerous gap we talked about earlier.
Exactly. You're just leaving them vulnerable for longer.
What about the natural immunity argument?
Ah, yes.
You know, the idea that getting the actual disease makes your immune system fundamentally stronger than a vaccine ever could.
Well, for some diseases, surviving a natural infection does provide robust immunity. But that argument completely ignores the terrifying cost of acquiring that immunity.
Right, because you actually have to survive the disease first.
Yeah. Exactly. Look at wild measles. If you catch wild measles, you face roughly a 1 in 1,000 risk of acute encephalitis, which is severe brain swelling that can cause permanent damage.
1 in 1,000 are not good odds when we're talking about severe brain damage.
They really aren't. And rarely, wild measles can cause something called SSPE, subacute sclerosing panencephalitis.
That sounds intense. What is that?
It is a fatal degenerative brain disease. And the truly terrifying part is that it doesn't even show up until 7 to 10 years after the original measles infection.
Wait, so a child could catch measles, survive it, seem completely fine, and a decade later develop a fatal brain disease because the virus was just hiding in their central nervous system.
Yes, that is exactly what happened.
Oh my God.
So when people talk about natural immunity, they are ignoring that vaccination provides comparable long-term protection without those massive catastrophic risks.
And when we zoom out from the individual child, these choices to delay a vaccine or rely on natural immunity, they don't just affect that one family, right?
Yeah, not at all.
They dictate the safety of the entire community.
This brings us to the math of the herd. Herd immunity.
Let's get into the math.
The schedule's coverage targets are meticulously calibrated based on how contagious a specific disease is. We measure that contagiousness with something called the basic reproduction number, or R0.
R0, and that is essentially how many people one infected person will spread the disease to, assuming they are in a completely susceptible population with no immunity.
Correct. And measles is one of the most contagious airborne viruses on Earth. Its R0 is estimated to be between 12 and 18.
So one person infects 12 to 18 other people. That's incredibly fast.
Because it spreads so easily, epidemiologists calculate that you need roughly 95% of the population to be vaccinated to reliably prevent the virus from transmitting.
95% is a really high bar, and we saw what happens when we dip below it during the Disneyland measles outbreak in 2014 and 2015.
Yeah, that was a wake-up call. There were 147 confirmed cases traced to exposure at the theme park, spreading across multiple states and even into Canada and Mexico.
And the crucial takeaway from that outbreak is that it happened because of localized pockets of under-vaccination.
Exactly. Think of the virus like a spark in a forest. If 95% of the trees are damp, meaning they are vaccinated, the spark just fizzles out.
But if your statewide average is 95%, yet one specific community or school district drops to 80%.
That is a dry patch of freeze. That is where the spark catches, herd immunity breaks down, and the disease rips through the population.
That makes total sense. You know, this tailored approach to epidemiology is also why the schedule is not identical worldwide.
Right.
Because I hear people say, well, in Europe they do it differently, so our schedule must be wrong.
It's a common misconception. The schedule molds to the environment it's in. For example, countries with endemic tuberculosis give the BCG vaccine right at birth.
But the U.S. doesn't do that.
No, the U.S. schedule omits the BCG vaccine entirely because TB incidence here is so low that the risk-benefit analysis shifts.
So it's hyper-localized.
Exactly. Different rotavirus strains, different yellow fever risks. Public health officials constantly tweak the schedule based on what is actively threatening the population.
Speaking of tweaking the schedule for efficiency, what about combo vaccines? Like the MMR or DTaP, you sometimes hear the myth that these combo shots are just bundled together for pharmaceutical profit.
The reality is much more practical than that.
Yeah.
Combination vaccines exist to reduce the number of physical injections and the number of clinic visits required.
Which goes back to the logistical constraints we talked about at the beginning.
Yes. The data clearly shows that when you reduce the logistical burden on families, you significantly increase the likelihood that a child actually completes the full series.
And as we just discussed with the forest fire analogy, completing the series is what keeps those vital herd immunity numbers above 95%.
Exactly. It all connects back to the math of the herd.
Let's bring this all back to you, the listener. If you are a nurse working in a clinic tomorrow, this schedule is your daily tool.
It's what you live by.
Right, you are calculating missed windows, figuring out the catch-up grids, but more importantly, you are sitting across from hesitant parents.
And when you understand the biological reasoning, why maternal antibodies mean MMR waits until 12 months, why the rotavirus cutoff exists because of V8-year surveillance, why delaying doses just extends the window of vulnerability, that is how you build trust.
Because answering "it's on the schedule" isn't enough anymore. When you can explain the mechanics of the acellular pertussis vaccine or how chemical conjugation works, you demystify the entire process.
And the impact of understanding that why cannot be overstated. This complex, intimidating chart is really a marvel of public health engineering. The CDC estimates that vaccination of cohorts born in recent decades has prevented hundreds of thousands of deaths and millions of hospitalizations in the U.S. alone.
It really is an incredible achievement. But as we wrap up this deep dive, I want to leave you with a thought about the future.
The future of this schedule.
Yeah. We started by comparing the schedule to a static engineering blueprint. But, as we've seen, it's actually a living ecosystem.
Absolutely.
With vaccine technology rapidly evolving right now, especially with the massive advancements in mRNA technology we've seen recently, how will the outer boundaries of immunology and the inner boundaries of logistics shift?
That's a great question.
How will this already dense blueprint stretch and adapt to accommodate entirely new classes of vaccines in the schedule of the future?
The tracks are always moving, the
Yeah.
pathogens adapt, the technology adapts, and the schedule has to adapt right along with them.
It's a constant balancing act, so
Right.
keep that in mind the next time you look at that chart.
You know, usually when we talk about a medical diagnosis, there's this expectation of absolute precision, like engineering.
Right.
You break your arm, the x-ray shows that jagged white line, and the doctor just points to the screen and says, there it is. It's broken or it's not.
Exactly. We rely on that visual evidence. I mean, it's comforting to have categories that are strictly binary, right? Things that feel like they're handed down by absolute biological laws.
Yeah, but diving into the stack of sources we have for today's deep dive, we're looking at nursing texts, obstetric research, clinical guidelines on what the medical world calls the stages of labor. And that expectation of precision just completely shatters.
It really does. It's a deeply constructed landscape.
Totally. And the thing that absolutely blew my mind reading through this material, and we're so glad you're here joining us for this, by the way, is that childbirth is this universal, fundamental human process. But the clinical definitions governing it have an incredibly dramatic history.
Oh, dramatic is the right word.
I mean, imagine a woman in labor in 1995 being rushed to emergency surgery for, failing a medical test, while that exact same woman today would be told she's progressing perfectly normally.
Because the rules literally change overnight. So our mission today is to walk you through this timeline from the very first contraction to the critical recovery period.
Right.
We are going to unpack the biology of what is actually happening in the body, debunk some major misconceptions like the idea that labor follows a steady, predictable clock, and understand why these 4 distinct stages are really the ultimate foundation for global nursing and medical practice.
Okay, let's unpack this, because we have to start at the very beginning of the process, which is stage 1. And the most important thing to grasp here is that the 4 stages of labor are defined by physiological endpoints.
Right, they are biological milestones.
Exactly. Opening the cervix, pushing out the baby, delivering the placenta, and then the uterus recovering. They are not defined by a fixed clock time. But reading the history in these texts, doctors spent a very long time acting like they were.
They absolutely did. And the historical misstep here is just one of the most fascinating examples of how medicine evolves.
Yeah.
To set the baseline, stage 1 begins with true labor.
Which is different from, practice labor, right?
Exactly. True labor means regular, progressively intensifying contractions that are actually causing measurable change to the cervix. It's a very distinct process from Braxton-Hicks contractions.
Right, the Braxton-Hicks.
Yeah. Those are the irregular practice spasms a woman might feel for weeks before labor, but they don't mechanically alter the body. So stage 1 officially ends when the cervix reaches 10 centimeters, meaning full dilation.
But the way they used to measure how fast you were supposed to get to that 10-centimeter mark is where things just get wild. I mean, it all goes back to 1954 and this obstetrician named Dr. Emanuel A. Friedman.
Right. So Dr. Friedman tracks cervical dilation over time in about 500 first-time laboring mothers at Columbia University. And he plotted their progress on a graph and produced this very neat S-shaped curve. Based on his specific group of 500 patients, he basically declared a universal biological rule.
Based on just 500 people.
Just those 500. He said a slow latent phase is followed by a steep active phase that kicks in exactly at 4 centimeters of dilation. He even derived expected speed limits from this.
Speed limits for birth.
Literally. He published that first-time mothers should dilate at a rate of about 1.2 centimeters per hour once they hit that 4-centimeter mark.
And if a laboring woman deviated from that strict 1.2 centimeters per hour speed limit, she was diagnosed with abnormal labor or failure to progress. And the texts point out that this diagnosis became one of the leading justifications for performing a C-section for decades.
Decades. Entire generations of women.
I was trying to wrap my head around this, and honestly, it feels a bit like judging modern highway traffic speeds using a map and data from 1950s dirt roads.
That is a perfect analogy. What's fascinating here is that we rarely see this kind of shift.
Well, the most shocking detail I found in the research is looking at who those 500 women actually were. Friedman's 1950s patients were heavily sedated. They were often under what was called twilight sleep, and a massive percentage of them had forceps-assisted deliveries.
Right.
And both heavy sedation and, pulling a baby out with metal tongs artificially alter the natural pace of labor. Yet that deeply flawed, highly specific benchmark ruled hospital wards for half a century.
It's staggering when you think about the surgical consequences of that benchmark. Like I said, entire generations of women subjected to major abdominal surgery just because their bodies weren't adhering to a timeline established by sedated patients in 1954.
Yeah.
And it really took until 2010 for the medical establishment to formally challenge this with modern data. That's when Jun Zhang and colleagues with the Consortium on Safe Labor analyzed over 60,000 contemporary U.S. births.
Wow, 60,000.
Yeah, a data set 120 times larger than Friedman's.
And what they found completely upended the system.
Entirely. The Zhang curve looked completely different. The data showed that in a contemporary, diverse population, active labor often doesn't clearly begin until 6 centimeters of dilation, not 4.
Okay, so a huge shift right there.
Huge. Furthermore, progress before that 6-centimeter mark can be incredibly slow. It can stall and start and be highly variable without being dangerous or pathological to the mother or the fetus.
The impact of that realization is just staggering to me. The text mentioned that in 2014, major medical bodies like ACOG, the American College of Obstetricians and Gynecologists, they formally moved the definition of the start of active labor to 6 centimeters.
Exactly.
You just don't see that very often.
Yeah.
A core textbook clinical definition being formally revised specifically to stop doctors from intervening too early and ultimately reducing the rate of iatrogenic, meaning medically caused, C-sections.
Yeah, the clinical takeaway is profound here. Patience is a medical intervention in itself.
I love that.
But to really appreciate what is happening during this redefined timeline, we need to look at the biological engine. Opening a human cervix to 10 centimeters requires a massive amount of physiological force.
That's exactly where my head went next. Now that we understand the map of stage 1, how does this dilation actually happen? The texts mention things like gravidity and parity, which I understand means how many times a woman has been pregnant versus how many times she has given birth.
Correct.
And those are the strongest predictors of how fast these stages go. But what is physically driving those uterine muscles to pry open the cervix in the first place?
So the entire mechanism is driven by a neuroendocrine loop. It's called the Ferguson reflex.
The Ferguson reflex.
Right. As the fetal head descends into the pelvis, it physically distends or stretches the lower uterine segment, the cervix, and the upper vaginal walls.
Okay.
Now, nerves in those tissues sense that extreme mechanical stretching. They send a rapid signal straight up the spinal cord to the mother's hypothalamus in the brain.
And the brain reacts to that.
Yes. The hypothalamus directs the posterior pituitary gland to release a surge of oxytocin into the bloodstream.
And oxytocin is the hormone that forces the uterine muscle fibers to contract.
Exactly. Endogenous, naturally occurring oxytocin binds to receptors on the uterus, causing a powerful contraction.
All right.
And that contraction pushes the baby further down into the pelvis, which causes more cervical stretching.
Ah.
That extra stretching triggers the brain to release a larger surge of oxytocin, which causes an even stronger contraction, leading to even more stretching.
Wait, so is this sort of like when someone brings a microphone too close to a speaker on a stage?
How do you mean?
Like the mic picks up the ambient sound, amplifies it through the speaker, then the mic picks up that louder sound, amplifies it again, and you get this screeching audio loop that just escalates and gets louder and louder until someone unplugs the system.
The mechanics of your analogy are spot on.
Yes.
Biologically speaking, what you're describing is incredibly rare. Yeah. Almost every system in human biology relies on self-correcting negative feedback loops to maintain equilibrium.
Like sweating when you're hot.
Exactly, your body's sweating to cool down your temperature. But the Ferguson reflex is one of the very few genuine positive feedback loops in human physiology. It is a self-amplifying cascade expressly designed to escalate in intensity until the stimulus, the baby, is entirely expelled from the body.
Wow. And while this positive feedback loop is raging, which, according to the sources, can take anywhere from 6 to 18 hours for a first-time mother, I was curious how the nurses are tracking it in real time, because they aren't just standing there guessing.
Definitely not.
I saw terms in the clinical guidelines like effacement and station, and frankly, I felt like I was reading a foreign language. What are they actually measuring with those?
It's a great question because we tend to focus entirely on dilation, the 1 to 10 centimeters. But dilation is only one piece of the puzzle. The cervix isn't just a flat door. It's a thick cylindrical structure, almost like the neck of a bottle. So effacement refers to the thinning and shortening of that tissue, and it's measured as a percentage from 0 to 100.
So if 0% effaced is a thick bottleneck, what does 100% effaced look like?
Okay, imagine stretching a thick turtleneck sweater over a bowling ball.
Okay.
Initially, the neck of the sweater is thick and stands up. But as you force the ball through, the fabric of the neck stretches so thin it essentially becomes flesh with the ball itself.
Oh, wow.
That extreme thinning is 100% effacement. The cervix must completely thin out before it can fully dilate.
Okay, that visual helps a lot. And what about station?
Station tracks the physical descent of the baby. Inside the mother's pelvis, there are 2 bony landmarks called the ischial spines.
Ischial spines, got it.
Clinicians use those spines as the 0 point on a map. If the baby's head is above those spines, it's measured in negative centimeters, like -2 or -3.
Still pretty high up.
Exactly. But as the baby descends past the spines and gets closer to birth, the numbers turn positive, +1, +2, all the way to +5 at delivery. Nurses combine all these metrics, dilation, effacement, station, along with the physical consistency and position of the cervix to calculate what is called a Bishop score.
And that score tells them what?
It's a predictive tool to evaluate how ready a body is for that Ferguson reflex to take over.
Okay, that makes sense. And to track all of this over those 18 hours, the sources highlight a tool called the WHO Partigraph. It was originally developed in the 1970s in Rhodesia, which is now Zimbabwe, and it's basically a paper chart that plots these cervical changes against time.
Right. And the brilliance of the partigraph is in its visual simplicity for busy clinical settings.
Yeah, just lines on a graph.
It uses pre-drawn alert and action lines. If a laboring woman's plotted progress drifts across the alert line, it tells the nurse to monitor more closely.
And the action.
If it crosses the action line, it triggers a mandatory clinical response, like transferring the mother to a higher level of care or evaluating for interventions. It's a direct, highly practical descendant of the curves we discussed earlier, designed to catch complications before they become emergencies.
Okay, so let's say this self-amplifying positive feedback loop of stage 1 has done its job. The cervix is 100% effaced, it's 10 centimeters dilated, the tissue is essentially gone, and the baby has descended into the positive stations. We're officially in stage 2.
Stage 2.
And reading the text, it seems like the entire physiological goal completely shifts here. It goes from a neuroendocrine process of forcing a door open to a purely mechanical process of navigating an object through a very specific bony hallway.
The transition from stage 1 to stage 2 is arguably the most dramatic shift in human physiology. Stage 2 is strictly defined as the time from that full 10-centimeter dilation to the actual delivery of the baby.
Right.
It is physically navigating the maternal pelvis.
And the baby isn't just dropping straight down a smooth tube, right? The texts outline this complex sequence called the cardinal movements of labor, but they just list them out. What is actually happening physically?
Well, think of the human pelvis as a curved, bony maze that changes shape.
Changes shape.
Yeah, the inlet, or the top of the pelvis, is wider side to side, but the outlet, the bottom of the pelvis, is wider front to back, and the baby's head is an oval.
Ah, so the shapes don't line up at first.
Exactly. To get an oval through a passageway that shifts its orientation by 90 degrees, the baby has to execute a precise sequence of twists and turns. These are the cardinal movements.
So it's literally an evolutionary lock and key mechanism.
Precisely. First, the baby must engage and descend. Then, it undergoes flexion, tucking its chin firmly to its chest to present the absolute smallest diameter of its skull to the pelvis.
Right, getting as compact as possible.
Yes. As it descends further into that changing pelvic shape, it must internally rotate, essentially turning its head to face the mother's spine. Once under the pubic bone, the baby extends its neck to navigate the curve of the birth canal. Finally, after the head is born, it must externally rotate, called restitution, untwisting its neck, so the broad shoulders can align with the widest part of the pelvic outlet for final expulsion.
Hearing the physics of that makes the clinical debate around pushing make so much more sense.
Mm-hmm.
Because stage 2 is divided into phases, right?
Yes, it is.
The texts talk about a passive phase, often called laboring down, where the fetus is descending through that maze, but the mother has no active urge to push, and then an active phase, where maternal pushing is synchronized with the contractions. Here's where it gets really interesting for me, and I want to push back on a huge misconception I held before reading this material.
Oh, what's that?
I always assumed the urge to push was just a psychological reaction to the pain. Like your body hurts, you feel pressure, so you actively strain to get the source of the pain out.
A lot of people think that.
Right. But the research explicitly states that pushing isn't just a psychological response at all.
No, you've hit on one of the most common misunderstandings about human birth. The overwhelming, uncontrollable urge to push is not a conscious decision born out of discomfort. It is the Ferguson reflex arc reaching its absolute zenith.
Wow.
As the baby's head crowns and heavily distends the lower vagina and the perineal floor, those stretch receptors fire so intensely that the subsequent oxytocin surges command the abdominal muscles and the diaphragm to bear down involuntarily.
Just completely taking over.
It is a profound neuroendocrine imperative.
Which explains why women describe it as an unstoppable force. And just like we saw in stage 1 with the timeline debates, there are massive debates about the timeline of stage 2, especially regarding medical interventions.
The historical approach to stage 2 was defined by strict, short time limits. If a woman had been pushing for 2 hours, traditional teaching dictated immediate intervention.
Using a vacuum or forceps.
Yes, a vacuum extractor, forceps, or rushing to a C-section to just pull the baby out of the maze.
Going back to that 1950s mindset of the clock ruling the biology.
Exactly. But contemporary guidelines are stepping back from the clock. They are shifting toward allowing much more permissive time limits, especially for first-time mothers. We now understand that variables like epidural analgesia can significantly lengthen stage 2.
Why is that?
Well, epidurals numb the stretch receptors in the pelvic floor, which dampens the Ferguson reflex, meaning the urge to push is delayed or diminished.
Oh, that makes total sense. The feedback loop gets interrupted.
Right. And modern medicine is learning to accommodate that physiology. As long as the continuous fetal heart rate monitoring shows the baby is tolerating the descent without distress, doctors are giving the lock and key mechanism the time it needs to work, rather than rushing to the operating room.
It is genuinely a relief to see clinical patients being codified into the protocols. So the baby has successfully navigated the twists of the pelvis, the cardinal movements are complete, and the baby has arrived.
The main event.
Right. In my mind, and probably in most people's minds, the dramatic part is over. The room breathes a sigh of relief. But reading the nursing texts, the tone shifts completely here. From a clinical perspective, the highest risk of mortality actually begins after the main event.
The clinical vigilance has to remain incredibly high because the physiological danger is far from over. We are now entering stage 3 and stage 4.
Okay.
Stage 3 covers the delivery of the placenta, the organ that sustained the baby, and that normally detaches and is expelled within 5 to 30 minutes post-birth.
I was reading about how they monitor this, and I saw these two terms. The Schultz mechanism and the Duncan mechanism. What is actually happening inside the uterus to detach this organ, and why does it matter which way it comes out?
So the placenta is deeply attached to the uterine wall. It shares massive vascular connections. When it's time for it to detach, it can peel off in 2 primary ways, named after the physicians who first categorized them.
Got it.
The Schultz mechanism is the most common. It means the placenta separates from the center first. Imagine an umbrella closing inward.
Okay, an umbrella closing.
Because it detaches centrally, the bleeding is trapped behind the placenta until the whole organ is delivered. The fetal shiny surface presents first, so clinicians often call it the shiny Schultz.
Add a Duncan.
The Duncan mechanism means it separates from the outer edges first. Because the edges peel away, maternal blood escapes continuously during the separation.
So it's messier.
Right. The rough maternal side of the organ presents first, earning the nickname the Dirty Duncan.
Shiny Schultz and Dirty Duncan.
Exactly. Clinicians watch for these mechanisms along with classic signs of detachment. They look for a sudden gush of dark blood, the lengthening of the visible umbilical cord, and the uterus rising in the abdomen and becoming firm and globular.
I think the text called that Calkin sign.
Yes, Colkinson.
Good to know they have specific visual cues to rely on. But once the placenta is out, we enter stage 4, the recovery period. This covers roughly the first 1 to 4 hours postpartum. The uterus begins a process called involution, meaning it's contracting back down to its non-pregnant size. But this is the window where the danger really spikes, right?
It is the most critical window for maternal survival. Postpartum hemorrhage, which is catastrophic rapid bleeding, is the leading cause of maternal death worldwide. And it most commonly happens right here in stage 4, usually due to a condition called uterine atony.
What causes that? Why does it just start bleeding?
Think about the physics of the placenta detaching. When it peels off the uterine wall, it leaves behind an open wound the size of a dinner plate,
Oh, wow.
with massive, exposed blood vessels pumping maternal blood. There is no bandage you can apply. The only physiological mechanism the body has to stop a woman from bleeding to death is for the muscle fibers of the uterus to crisscross and clamp down fiercely, acting as a biological tourniquet on those open vessels.
A biological tourniquet.
Yes. If the uterine muscle is exhausted from a long labor, which is what uterine atony means, a lack of muscle tone, it fails to clamp down. The vessels remain open and severe hemorrhage can occur in a matter of minutes.
So what does this all mean for how childbirth is managed? Because if birth is this deeply natural process shaped by millions of years of evolution, I was surprised to read about a massive global public health push for active management, which specifically means injecting synthetic oxytocin or pitocin during stage 3.
It's a very fair question.
Right. If the Ferguson reflex was so perfectly designed to get the baby out naturally, why do we suddenly need to intervene with synthetic drugs to get the placenta out and stop the bleeding? Doesn't the body know what to do?
It's an excellent challenge, and if we connect this to the bigger picture, it sits at the heart of a major global health debate. At an individual level, some midwifery models do favor a physiologic or expectant approach, letting the body's natural oxytocin slowly detach the placenta without medication.
Which makes intuitive sense.
It does, but you have to look at the data from a population scale. Routine active management is heavily championed by the World Health Organization. This protocol involves giving a prophylactic injection of oxytocin immediately after the baby is born, applying controlled cord traction to guide the placenta out, and vigorously massaging the uterus to stimulate those muscle fibers.
And they recommend this universally, regardless of how natural the birth was.
Universally. Because when you analyze global health outcomes, especially in resource-limited settings where blood transfusions aren't readily available, postpartum hemorrhage is a rapid, silent killer.
Yeah.
A body's natural physiology might work 90% of the time, but at a population level, that 10% failure rate equals hundreds of thousands of deaths. Administering a simple, low-cost dose of synthetic oxytocin to force that uterus to contract firmly and immediately is one of the most cost-effective, high-impact interventions in all of modern medicine.
It's a genuine case where an unglamorous routine protocol during the quietest stage of labor has an outsized, life-saving impact on a global scale. It really reframes the whole experience for me.
Yeah.
It's not just something that happens to you. It is this wildly complex, active biological machine. So to recap the journey we've just been on through these sources, the 4 stages map perfectly to 3 distinct mechanical tasks plus a critical recovery phase.
Right.
Stage 1 is the neuroendocrine process of opening the cervix, driven by the escalating positive feedback loop of the Ferguson reflex. Stage 2 is the purely mechanical navigation of the fetal oval through the shifting bony maze of the pelvis via the cardinal movements. Stage 3 is the detachment and expulsion of the placenta. And stage 4 is the vital biological tourniquet of uterine involution to prevent hemorrhage.
This is perfect summary.
We've seen how understanding the actual biology is leading modern medicine away from strict clocks and how sheer nursing vigilance in that quiet fourth stage genuinely saves lives.
The complexity of the system is just awe-inspiring. But for me, the lingering takeaway from these texts goes back to our earlier discussion of Dr. Friedman and Dr. Zhang. We saw how a fundamental biological rule, the expected start and speed of active human labor, turned out to be an accidental artifact of 1950s hospital practices. It wasn't human nature at all. It was a reflection of sedated patients with forceps deliveries being recorded as normal.
Which is still so crazy to me.
It really leaves you with a profound question to consider as you go forward. What other fixed medical definitions or expected timelines in our bottles, things we accept as absolute biological facts today, are actually just reflections of the specific flawed populations we chose to study decades ago?
That is a phenomenal question to end on. Are we still judging our health by 1950s dirt roads when we should be looking at modern data? It challenges us to look past the surface of any diagnosis, to realize that medicine is an evolving landscape, not just a binary black and white X-ray. Thank you so much for joining us on this deep dive. Keep asking questions, keep challenging the definitions you are handed, and we will see you next time. So, I want you to picture, just for a second, a microscopic, incredibly complex biological filter.
Right.
Now, imagine you have about 1 million of these tiny filters packed into a space roughly the size of your fist. And you actually have 2 of these fists, sitting right against your back muscle.
Yeah, your kidney.
Exactly, your kidneys. And those million tiny filters are called nephrons. And here is, the most crucial, totally uncompromising biological reality we are starting with for today's deep dive. You are born with your entire lifetime budget of these nephrons.
That's it. That's all you get.
Right. And once they're destroyed, they do not grow back. Like your liver can regenerate, which is amazing, but your kidney tissue just doesn't.
No, it really doesn't.
So today, our mission for this deep dive is to explore this silent attrition of these filters. We're looking at chronic kidney disease, or CKD, from the angle of the slow loss of filtration.
Which is such an important way to look at it.
Yeah, because we want to understand not just what it is, but how it quietly reshapes the whole body, the stages of how it progresses, and honestly, this massive medical controversy surrounding how we even define when those filters are failing.
It really is a fascinating history because, it is a fixed anatomical budget. From the day you are born, you are basically spending down that reserve.
Right.
But before we can even talk about how to track that progression, we kind of have to establish what chronic kidney disease actually is clinically.
Let's do it. What's the definition?
So, according to clinical guidelines, it's defined as abnormalities of kidney structure or function.
Okay, kind of broad.
Yeah, but practically speaking, that usually means looking at your glomerular filtration rate, or GFR.
And that's just a measure of how much blood your kidneys can filter per minute.
Exactly. And usually a GFR dropping below 60 is the trigger. Or it could be the presence of physical damage markers. So if protein is leaking into your urine, which is called albuminuria.
Right.
But, and this is a massive caveat, whatever abnormality is happening, it must be present for 3 months or longer.
Okay, let's unpack this right here.
Yeah.
Because I feel like in a lot of diseases, a time frame like 3 months is just, an arbitrary line drawn in the sand for insurance coding or something.
Mm.
Why is that 3-month rule the whole ball game here?
That is a great question, because in nephrology, that time frame is the absolute defining line between a temporary crisis and a permanent reality.
Oh, wow. Okay.
Right. So if your kidneys suddenly shut down because you got severely dehydrated, or maybe you had a really bad toxic reaction to a medication over a weekend.
Which happens.
It does.
Yeah.
That is acute kidney injury, or AKI. Your filtration rate might just completely plummet. But with IV fluids and some time, maybe in a few days or a couple of weeks, those cells can recover.
So the filtration bounces right back up.
Exactly, it bounces back. However, if that decreased function persists for 3 continuous months, that tells us the tissue isn't just stunned.
It's gone.
It is scarred over. It is permanently destroyed.
It's like the difference between, a stalled engine that just needs a jump start and an engine where the metal has completely rusted through.
That is a perfect analogy, yeah.
But to really understand how doctors track this slow rusting today, we have to look back at how chaotic the medical landscape used to be, right? Because from our sources, before 2002, there was no standard way to talk about this early, slow loss.
Oh, it was essentially the Wild West of diagnostics.
Oh, Wild West.
Truly. Nephrology simply didn't have a shared standardized language for early kidney disease.
So doctors were just using these vague, interchangeable terms like chronic renal insufficiency or chronic renal failure or mild renal impairment.
Which means absolutely nothing specific.
Right, which meant that you could go to one clinic, a doctor looks at your lab results and labels you as a sick patient with kidney disease.
Yeah.
Then you drive across town for a second opinion. That doctor looks at the exact same numbers and says, oh, you're relatively healthy, you just have a little mild impairment.
Exactly. And you can imagine the ripple effects of that chaos. I mean, if primary care doctors can't agree on who actually has the disease, researchers certainly can't compare their clinical trials to figure out how to treat it.
Obviously not. You're comparing apples to oranges.
Right. So in 2002, there was this massive intervention. The National Kidney Foundation convened a group called the KDO-QI Work Group.
KDO-QI, right.
Yes,
No.
chaired by Dr. Andrew S. LeVay. And they basically stepped in to force a standardized vocabulary on the medical community. They introduced a strict 5-stage system based entirely on estimated GFR.
Wait, I have to challenge that. You're telling me an entire diagnostic system for millions of people wasn't based on some, like, sudden breakthrough biological discovery.
Nope.
It was just a committee sitting in a room and drawing arbitrary lines in the sand.
Yeah.
How did the medical community accept that without a complete revolt?
Oh, well, there was pushback, absolutely.
I bet.
I mean, anytime you take a smooth, continuous biological decline and artificially chop it up into distinct stages, you're going to get friction.
Right, because biology isn't stepping stones, it's a ramp.
Exactly. But the medical community ultimately accepted it because the alternative was just so much worse. They desperately needed actionable mile markers along that attrition curve.
Just to have a shared language.
Yes. And we need to talk about what's actually driving that attrition. For about 2/3 of all cases in the developed world, it comes down to just 2 culprits.
Diabetes and hypertension. High blood sugar and high blood pressure.
Right.
And both of those diseases essentially act as, like, mechanical and chemical wrecking balls to the nephrons.
That's a great way to visualize it.
Yeah.
So inside each of those million nephrons is a microscopic tuft of capillaries. It's called a glomerulus.
Okay, the glomerulus.
And if you have chronic high blood pressure, you are basically blasting high-pressure fluid through delicate vessels that were simply not designed for it.
Oh, man.
So the vessels stretch, they scar, and eventually they just collapse.
And then with diabetes.
With diabetes, the high blood sugar makes the blood literally stickier and highly inflammatory, which thickens and damages the vessel walls until they just can't filter anything at all.
But I mean, if we know exactly what causes it, and we have this established 5-stage system based on a blood test that literally any primary care doctor can run.
Right.
Why is this disease still caught so late? Why are people showing up in emergency rooms needing dialysis when we've been tracking these stages for decades?
Because that brings us to one of the most remarkable and frankly dangerous facts about human anatomy.
Which is?
The hidden functional reserves.
The hidden functional reserve. Wait, let me make sure I'm hearing this correctly from the source material. You're saying a patient can be actively losing hundreds of thousands of nephrons and their routine physical would still say they're perfectly fine.
Yes, absolutely. You can lose up to 50% of your total nephrons before standard blood tests show a drop in your overall kidney function.
Up to 50%. How is that even biologically possible? I mean, if half the filters are gone, the filtration rate should instantly drop by half, right?
You would think so, but it's because the surviving nephrons compensate.
Right.
They undergo something called hyperfiltration. Think of it like a massive multi-lane highway.
Right, I'm with you.
If there's an accident and 3 lanes are suddenly closed, the traffic doesn't just stop. The remaining open lanes have to absorb all of those cars.
Oh, I see.
So the traffic speeds up, the friction increases, and the sheer volume of pressure means the pavement in those remaining lanes is going to degrade and crumble much faster than it normally would.
Wow. So the surviving nephrons are physically swelling and, like, increasing their own internal pressure to take on the workload of the dead ones.
Exactly.
They're literally destroying themselves just to keep the overall blood chemistry looking stable on a lab test.
That is exactly what's happening. And because of that hyperfiltration, chronic kidney disease is a completely silent disease until quite late, usually stage 4.
Which busts a huge misconception. People assume that if their kidneys are failing, they'll feel sick.
Right. They think their back will hurt, or they'll have trouble urinating, or they'll feel nauseous.
But they don't. You could be in stage 2 or stage 3, walking around feeling totally fine.
Completely asymptomatic, which means we are entirely reliant on the math of these blood tests to catch it early.
But even the basic blood test is highly misunderstood, isn't it? I mean, when people get routine labs, they usually look at their creatinine level.
Yes, serum creatinine.
And creatinine is just a natural waste product from normal muscle breakdown, right? And healthy kidneys filter it out. So if your kidneys are failing, creatinine builds up in your blood. It seems like a pretty straightforward metric.
Well, it seems straightforward until you account for human diversity.
How so?
Let's look at the mechanics of creatinine. Because it's a byproduct of muscle mass, the raw amount of creatinine in your blood is heavily, heavily dependent on how much muscle you actually have.
Oh, right. So if you take a 25-year-old bodybuilder who lifts weights 3 hours a day, and then you compare him to an 85-year-old frail woman who is mostly sedentary, they have vastly different amounts of muscle tissue generating that waste.
Precisely. So if we just look at the raw creatinine number, they might have the exact same level in their blood.
Really?
Yes. But for the bodybuilder, that's just because he has massive muscles constantly generating waste, and his kidneys are actually working perfectly to clear most of it.
Okay, but for the elderly woman?
For her, she barely has any muscle mass to generate waste. So if her creatinine is reaching that same high level as the bodybuilder, it means her kidneys have almost completely stopped filtering.
Wow. Which is exactly why you can't just look at the raw number on a lab sheet. You have to use those complex equations we mentioned.
Right. The estimated GFR or eGFR.
You have to adjust for age and sex and body size to figure out what the kidneys are actually doing.
Exactly. And as our understanding of this disease evolved, the medical community realized that even the eGFR wasn't telling the whole story.
So they changed it again.
Yeah, which led to the creation of the modern heat map. In 2012, a global kidney organization called KDOGO updated those original 2002 guidelines.
Okay.
They kept the 5 GFR stages, but they added a second axis to the chart. Albuminuria.
All right, albumin. That's a protein in the blood. And from what I read, in a healthy kidney, it's just too big to pass through the microscopic filter into the urine.
Correct. It's like trying to push a bowling ball through a screen door.
Good luck with that.
Right. So if albumin is showing up in the urine, it means the physical structure of the nephron filter is actively tearing.
So KDOGO categorized this leakage, right, from A1 to A3.
Yes. Because research showed that leaking protein is a massive predictor of kidney failure, completely independent of what your filtration rate is.
It's a structural warning sign.
Exactly. So now doctors use a grid. They cross-reference your GFR with your protein leakage to assign a color-coded risk level: green, yellow, orange, red, and deep red.
And this heat map totally explains why stage 1 CKD is so unique. Well, in stage 1, your GFR is completely normal,
Right.
90 or above. The filters are keeping up with the traffic.
Right.
So the only way you can even be diagnosed with stage 1 is if those early damage markers like albumin are showing up. The structural damage has started, even if the overall filtration rate hasn't dropped yet.
That is spot on. But, once that hidden reserve finally runs out and the GFR starts dropping into stage 3 and stage 4, the damage refuses to stay confined to the kidneys. It triggers a really devastating systemic domino effect.
Because the kidneys don't just act as passive filters, right? They are active chemical managers for the entire body.
They do so much more than just make urine.
So what does this all mean? Let's look at the cascading failures, starting with the bones, which I found fascinating in the sources. When your filtration rate falls below, say, 45 or 50, the kidneys begin to fail at 2 vital jobs.
Right, activating vitamin D and excreting phosphate.
It is a textbook example of how one failing organ takes down the whole neighborhood.
It really is. When your kidneys can't excrete phosphate, it builds up in your blood. And at the exact same time, because your kidneys aren't activating vitamin D, your gut basically stops absorbing calcium from your food.
So your blood is suddenly high in phosphate and critically low in calcium.
Exactly. And your body detects that imbalance and completely panics.
Because calcium is important for, everything.
Yeah.
Heart rhythms, muscle contractions.
Everything. So the rising phosphate triggers your parathyroid glands, these 4 tiny glands in your neck, to go into overdrive.
Okay.
They start pumping out massive amounts of parathyroid hormone. And the primary emergency job of that hormone is to find calcium and bring it into the blood to restore the balance.
But wait, if you aren't absorbing it from your food because of the vitamin D issue,
Yeah.
where does the hormone get it?
It goes to the body's largest calcium vault.
The skeleton.
It pulls it straight out of your bones.
It literally robs your skeleton.
It relentlessly leaches calcium from your bones, a condition called renal osteodystrophy. Your bones become structurally hollow, they fracture easily. But the tragedy doesn't actually stop with the bones.
Because where does all this stuff go?
Exactly. Now you have all this extra calcium and phosphate floating around together in your bloodstream, and they physically bind together to form calcium phosphate crystals.
And those microscopic crystals, they don't just dissolve, do they?
No, they don't.
They get deposited directly into the walls of your blood vessels.
Right. You are quite literally calcifying your own cardiovascular system from the inside out. Your flexible arteries turn into rigid, stiff pipes.
Which explains one of the most profound shifts in how medicine views this disease.
Yeah.
Back in 2004, the New England Journal of Medicine published this landmark study by Go and colleagues. They looked at over 1 million adults, and what they found completely disrupted the narrative.
It really shook the field.
They proved that as GFR declines, your risk of cardiovascular death spikes astronomically.
It's a very sobering clinical reality. For the vast majority of patients with moderate CKD, the dominant cause of death is a massive cardiovascular event.
Like a heart attack or a stroke.
Yes. And that happens long before they ever progress to end-stage kidney disease requiring dialysis.
So wait, they die of a heart attack before their kidneys actually fail.
Usually, yes.
That reframes the entire condition. We think of it as a kidney problem, but it's really a whole body vascular disease. The kidneys are just the first domino.
That is exactly how nephrologists counsel patients today. When you're in stage 3, the clinical focus has to be on aggressively protecting the heart, just as much as saving the remaining nephrons.
But, okay, if this eGFR number is dictating everything,
Right.
if it tells a doctor your heart attack risk, if it decides whether you get referred to a specialist, or if you can get put on a kidney transplant wait list, the math behind it has to be completely bulletproof.
You would hope so.
But it wasn't, was it? For a long time, these equations were actually the center of a massive medical and ethical controversy.
Yes. This is a critical piece of modern medical history. For nearly 2 decades, the standard eGFR equations used in laboratories worldwide, like the MDRG equation, and later the CKD EPI, they included a specific race correction factor.
A race coefficient.
Right. If a patient was identified on their chart as Black, the algorithm automatically multiplied their estimated GFR by roughly 1.16 to 1.21.
Meaning the math literally output a higher, healthier-looking kidney function number for a Black patient compared to a non-Black patient who had the exact same raw creatinine blood test results.
Correct.
So to look at this impartially, what was the original rationale for doing that?
Well, the original clinical rationale was based on early cohort studies that suggested Black populations, on average, had higher measured creatinine generation.
Which they tied to muscle mass.
Right. Researchers at the time hypothesized it might be tied to differences in average muscle mass. So the algorithm was an attempt to mathematically adjust for that to get a more accurate estimate of true biological filtration.
But the criticism of that approach was intense.
Oh, absolutely.
Because it assumed that race, which is, largely a social and cultural construct, was a concrete, universal biological variable that you could just plug into a chemical equation.
Yes. And the real-world consequences of that math were severe. Because the algorithm artificially inflated the apparent kidney function of Black patients, it made them look healthier on paper than their kidneys actually were.
Oh, wow. So what did that mean, practically?
It meant they crossed the clinical thresholds for specialist care and transplant waitlist eligibility months or even years later than white patients with the exact same lab values.
Years later.
Yes. It was a mathematical function that actively delayed life-saving care.
It's staggering to think about a background laboratory algorithm having that kind of power over human lives, just sitting there on a lab printout.
It really is. But after years of sustained advocacy and really rigorous debate within the medical community, in 2021, a joint U.S. task force formally recommended retiring the race coefficient entirely. A new race-free equation was adopted by U.S. labs. It's a rare instance in medicine where a deeply embedded diagnostic formula was overthrown and retired, not just for statistical recalibration, but because of its real-world systemic impact.
That is incredible. But, that actually isn't the only debate over how we calculate who has this disease. Here's where it gets really interesting.
The aging debate.
Yes. There's a massive controversy regarding the elderly, because we know that your glomerular filtration rate naturally declines as you age just through cellular senescence.
Right. The nephrons simply age, just like your skin or your joints.
So a healthy 20-year-old might have a GFR of 120, but by the time they were 80, even without diabetes or hypertension, their GFR might naturally drop to 55, just from the normal wear and tear of living for 8 decades.
That's entirely possible, yes.
So if the hard diagnostic cutoff for stage 3 CKD is a GFR of 60, aren't we taking an 80-year-old with a GFR of 55, pointing at them and saying, you have a chronic disease?
That is the big question.
Aren't we just pathologizing normal human aging? I mean, we're causing unnecessary anxiety, maybe changing their medications, sending them to specialists, all for something that is entirely natural.
You've just summarized a major debate in geriatric nephrology right now. Is it overdiagnosis?
Yeah.
But KDI Go, the guideline organization, has a very firm counterargument, and it's rooted in the data.
Okay, what's their defense?
They point out that even if a GFR of 55 is normal for an 80-year-old in the sense that it is statistically average for their age group, that lower filtration rate still carries a measurably elevated cardiovascular risk.
Really?
Yes, and a much higher risk of drug toxicity.
Oh, because their kidneys can't clear the medications out of the bloodstream as quickly. So a normal dose could become a toxic dose.
Exactly. So KDI Go argues that giving it a formal diagnostic label of CKD is clinically vital because it waves a red flag for the physician.
A warning label.
Right. It tells them to monitor the heart closely, to lower the dosages of standard medications so toxins don't build up, and to avoid prescribing certain drugs altogether that could push those fragile aging kidneys over the edge into acute failure.
So even if the decline is natural, it is still dangerous enough to require that warning label.
That's their stance, yes.
You know, when we zoom out from these clinical debates and look at the sheer scale of the disease, it is staggering.
It is a public health crisis operating entirely in the background. Because CKD tracks alongside the massive modern epidemics of type 2 diabetes and hypertension, the numbers are just astronomical.
Let's hear them.
According to public health data, roughly 1 in 7 adults in the U.S. currently has chronic kidney disease.
1 in 7 adults. And because of that hidden reserve and the hyperfiltration we talked about earlier, the vast majority of the people walking around in stage 3 have absolutely no idea they are slowly losing their nephron budget.
They are completely asymptomatic, and the societal and economic cost of this silent progression is unparalleled.
I really want to highlight the economics of this, because it led to one of the most unique healthcare policies in American history.
The 1972 Medicare carve-out.
Yes. So dialysis, which is the mechanical treatment you need when you reach stage 5 and your kidneys completely fail, is unfathomably expensive.
Yes.
Back in 1972, when dialysis machines were relatively new and incredibly scarce, hospital committees, sometimes they were literally called God panels, were deciding who lived and who died based on who could afford it and who had access.
It was an ethical nightmare. The financial burden of dialysis would instantly bankrupt almost any individual family.
So in 1972, the U.S. government under Nixon created a completely unique universal coverage carve-out.
Right. Medicare covers end-stage renal disease for dialysis regardless of your age.
Regardless of age.
If your kidneys fail, the government pays for the treatment.
It is one of the only disease-specific universal coverage policies in the country, and it underscores just how critical it is to prevent progression in the early stages, because the sheer amount of resources required at stage 5 is monumental.
Which means we really need to correct one final major misconception here.
Oh, about dialysis being a cure.
Yes. People hear about dialysis and they view it as a cure. They think you go to the clinic, they hook you up to the machine washes your blood, and you go home functioning at 100%.
Like getting an oil change for your car.
Right, but dialysis is absolutely not a cure. It is an incredibly exhausting, grueling mechanical process where your blood is pumped out of your body, pushed through a synthetic filter membrane, and pumped back in.
Yeah, even running perfectly.
Even running perfectly, dialysis only replaces about 10 to 15% of your normal, healthy kidney function.
10 to 15%. It just barely clears enough toxins to keep you alive.
Barely. It manages the most severe symptoms, but you are still living with profound physiological deficits. It does not restore the kidney tissue, it doesn't activate vitamin D, and it doesn't regulate your blood pressure hormones effectively.
Right, all those systemic things we talked about.
The only clinical intervention that even approaches normal function is an organ transplant, which is why kidneys make up by far the largest share of the transplant waitlist globally.
Which brings everything we've talked about right back to you, the listener. The reason we are diving into the mechanics of this disease isn't just to memorize clinical stages or understand the history of medical algorithms.
No, not at all.
It is about understanding the biological budget you possess right now. Those million microscopic filters in each kidney are taking the physical brunt of every prolonged blood pressure spike, and every chronic blood sugar elevation.
Every single one.
Protecting those tiny capillary tufts early on, before the hidden reserve runs out and the highway collapses, is quite literally the only way to safeguard the nephron budget you were born with.
It is entirely about recognizing the silent, invisible damage before the physical alarm bells finally ring. And, if we connect everything we've unpacked today, from the silent hyperfiltration to the complex debates over how we diagnose the elderly, it leaves us with a really profound question to consider regarding our own health.
Oh, I like this. What if the way we define normal aging is really just our failure to differentiate between inevitable wear and tear and preventable disease?
Exact.
How much of what we accept as simply getting older, the fatigue, the stiffness, the vascular changes, is actually a silent, systemic decline that we could have caught and slowed down years earlier with a simple blood test?
A slow loss of filtration hiding in plain sight.
You start with 1 million filters per kidney. The goal is to hold on to as many as you can for as long as you can. 4 million years ago, in this cave system in New Mexico, perfectly sealed off from the surface of the earth, bacteria were just thriving.
Yeah, Lechugiet Cave.
Right, Lechugia Cave, completely isolated. I mean, never touched by human hands, never exposed to human medicine at all.
Right.
Yet, when researchers recently went down into that cave and swabbed the bacteria they found, those microbes were, already completely immune to synthetic antibiotics, drugs that humans wouldn't even invent until the 1990s.
It's wild. It completely upends the way we, traditionally think about medicine.
Totally.
Because we tend to view antibiotic resistance as this very modern 20th century disaster. Like we accidentally created it in our hospitals.
And today, we're unpacking why that assumption is just fundamentally wrong. Welcome to the Deep Dive. Today, we're looking at a massive stack of clinical notes, microbiology research, and nursing texts to really understand the reality of antibiotic resistance for you.
It's such an important topic.
It really is. We are going to explore how superbugs actually fight back, the mechanics behind why the pharmaceutical market is fundamentally broken, and what antimicrobial stewardship really means for you, and, well, the healthcare workers trying to keep us safe.
Because the truth is, we didn't invent antibiotic resistance.
No, we really didn't. We just accidentally escalated an ancient war.
Exactly. And to understand the scale of that escalation, you really have to look at the very beginning of the antibiotic era.
Right.
When we picture the origin of these drugs, the default image is always Alexander Fleming, right? In 1928, discovering penicillin by accident on a dirty petri dish.
Yeah, the classic science class story.
Right, and we treat it as the ultimate triumph of modern science over nature.
But, the clinical history shows a much darker follow-up to that discovery. Because here's where it gets really interesting. If you read the transcript of Fleming's 1945 Nobel Prize acceptance speech, he doesn't take a victory lap.
Not at all.
The founding father of antibiotics uses his moment on the world stage to predict their undoing.
It's haunting, honestly. He describes an experiment where he deliberately exposed bacteria to non-lethal doses of penicillin and just watched them adapt to survive it.
Wow.
Yeah, he warned everyone in 1945 that public demand would lead to underdosing and, casual use, and that would inevitably breed resistant strains.
He saw the underlying biology for exactly what it was, and his timeline was incredibly accurate, too.
It really was. Within 3 years of that speech, resistant staph strains became a documented, life-threatening problem in British hospitals.
3 years.
Yeah. He forecast the crisis before the crisis even had a name.
Which I think raises a foundational question about what we are actually measuring here. When a doctor says an infection is resistant, we tend to think of it like a binary switch.
Right, like the bug is wearing a bulletproof vest and is just completely immune.
Exactly. But the clinical sources suggest it's a lot more complicated than a simple yes or no.
It is highly nuanced. In a microbiology lab, resistance is defined by something called a breakpoint. They use a measurement known as the minimum inhibitory concentration, or MIC.
MIC. Thanks.
Basically, lab technicians expose the bacteria in a petri dish to increasing concentrations of an antibiotic. The MIC is the lowest concentration of the drug that successfully stops the bacteria from visibly growing.
So there is a specific measurable line in the sand then.
Exactly. International committees look at that MIC data and establish a breakpoint dosage. If the bacteria can survive a dose higher than that breakpoint, the lab report classifies them as resistant.
And if they die at a lower dose?
Then they are classified as susceptible.
But, if I'm understanding the clinical notes correctly, What happens in a pristine, perfectly controlled petri dish doesn't always translate to the absolute chaos of a human body.
Oh, not at all.
Because you could have a lab report that says, this bug is susceptible to this drug, but when the patient actually takes the pill, nothing happens, they just stay sick.
That is the absolute nightmare scenario for clinicians. We call it the difference between microbiological resistance and clinical resistance.
Oh, okay. Break that down for me.
Well, in a lab, the drug has direct, unimpeded access to the bacteria. But in a patient's body, the drug has to navigate a very messy environment. Let's say the infection is deep inside a lung abscess.
Right.
The antibiotic physically might not be able to penetrate the tissue to even reach the bacteria. Or the bacteria might have formed a biofilm.
Oh, right. A biofilm is like a protective, slimy fortress they build on surfaces, right?
Yep.
Like on a catheter or, I don't know, an artificial joint implant.
Precisely. The bacteria secrete this sticky matrix that acts like a physical shield. The antibiotic molecules just bounce right off the outer layer.
Wow.
Yeah, so inside that fortress, the bacteria are technically susceptible to the drug. I mean, if you took them out and put them in a petri dish, the drug would kill them easily.
But clinically, because of the biofilm, they are acting resistant.
Exactly.
Right.
It makes diagnosing and treating these infections an incredibly murky process.
Okay, so if microbiological resistance is like a criminal escaping a trap in a controlled laboratory, clinical resistance is whether they survive in the wild.
Like a patient's body. Exactly.
Right. But if these bacteria are navigating complex human biology and building literal fortresses, how are they adapting so quickly? We spend billions of dollars and decades of research designing a single synthetic chemical to kill them, and they just figure out a loophole in a matter of years.
It's staggering.
What is the actual mechanism driving that speed?
Well, it is Darwinian natural selection, but running at a speed we can barely comprehend. Under the right conditions, a bacterial population can reproduce every 20 to 30 minutes.
Wait, really?
Sure.
So in the time it takes to eat lunch, an entire generation has lived and reproduced?
Yes, and every single time they replicate their DNA, there is a tiny chance for a random mutation. Now imagine a patient with a billion bacteria in their system.
Okay.
They take an antibiotic. Almost all of those bacteria die. But just one of them happens to have a random genetic mutation that allows it to survive the drug. Suddenly, that single survivor has zero competition for nutrients. Within a day or two, that one mutant strain reproduces and completely repopulates the space. And now the entire infection is resistant.
That's terrifying. The research points out that they don't just rely on waiting for random mutations.
Yeah.
They are actively trading genetic information with each other, which, accelerates the process exponentially.
Right. This is a mechanism called horizontal gene transfer. Bacteria have these small circular loops of DNA called plasmids, which exist totally separately from their main chromosome.
Right.
And these plasmids often carry the specific genes that provide antibiotic resistance.
It's like a biological USB drive loaded with a survival manual.
That is a perfect analogy. And through a process called conjugation, two bacteria can physically connect to each other and pass a copy of that plasmid across.
That's so creepy.
It gets worse. What makes this truly dangerous is that they don't even have to be the same species.
Wait, really?
Yeah. A harmless strain of E. coli living in your gut could theoretically possess a resistance plasmid and hand it directly over to a deadly Klebsiella bacterium just passing through.
So they are literally crowdsourcing their own survival.
Exactly.
And the specific tools they're trading on those plasmids are fascinating. The sources highlight 4 primary mechanisms of defense, and I really want to walk through the actual biochemistry of how they work because it's wild. Defense number 1 is enzymatic destruction.
Right. This is essentially chemical warfare. The bacteria produce an enzyme that acts like a pair of molecular scissors.
Okay.
Before the antibiotic can even reach its target on the bacterial cell, this enzyme intercepts it, snips the chemical structure of the drug apart, and just renders it completely harmless.
The classic example is beta-lactamase, which destroys penicillin. But the one that really stood out in the research is an enzyme called NDM1.
Yes.
It was first identified around, I think, 2008, and it specifically destroys a class of antibiotics called carbapenems.
And carbapenems are crucial. They are broad-spectrum, incredibly potent intravenous drugs that hospitals keep locked behind figurative glass.
Like the big guns.
Exactly. We only use them as an absolute last resort when every other drug has failed. Yeah. The fact that bacteria can trade a plasmid carrying the NDM1 enzyme, an enzyme that effortlessly shreds our last line of defense, that's why public health officials view horizontal gene transfer as a literal global security threat.
That makes total sense.
Uh-huh.
Okay, so defense number 2 is target modification. If the enzyme is like intercepting the drug, target modification is like changing the locks on the door, right?
Right. The bacteria alter the physical shape of the receptor site on their cell wall.
So the antibiotic still arrives, but its molecular key no longer fits the lock, so it just bounces off.
Exactly. And then defense number 3 is arguably the most resource-intensive for the bacteria, but highly effective. efflux pumps.
This one is wild. The bacteria literally build microscopic vacuum pumps into their cell membranes.
Yeah.
The antibiotic enters the cell, and before it can do any damage, the pump catches it and spits it right back out into the environment.
Yeah.
It is exactly like bailing water out of a sinking boat faster than it fills up.
It's a great visual, and it requires a massive amount of cellular energy to run those pumps constantly, but, it keeps the organism alive.
Right.
And the fourth mechanism is simply reduced permeability. The bacteria just shut down the microscopic pores, or porins, that the drug normally uses to enter the cell.
They just close the door.
Yeah.
So knowing that bacteria possess this highly sophisticated tradable arsenal of scissors, pumps, and changing locks, we have to go back to that cave in New Mexico, because it completely recontextualizes where these weapons came from.
If we connect this to the bigger picture, yeah, it really does. When you see a bacterium destroy a modern synthetic drug, the intuitive thought is that we invented the medicine, and the bacteria reacted by inventing the defense.
Right, but the bacteria in Lashugia Cave, isolated for 4 million years, they already had the efflux pumps and the beta-lactamase enzymes. Humans didn't invent antibiotic resistance.
We absolutely did not. Fungi and bacteria have been fighting a microscopic turf war over nutrients in the soil for millions of years.
Wow.
Fungi naturally evolved to secrete antibiotics to kill competing bacteria, and bacteria evolved these enzymes and pumps to survive the fungi. All human medicine did was borrow the fungi's weapons.
So the crisis isn't that we created these defenses.
No, the crisis is that by dumping thousands of tons of antibiotics into our bodies and our agricultural systems, we applied a massive, unnatural selective pressure. We killed off all the susceptible, undefended bacteria on the planet, leaving only the ones holding the ancient survival manuals to inherit the earth.
We took a million-year-old local arms race and turned it into a global biological world war.
That's one way to put it, yeah.
And when you realize how primed they are to survive, the speed of modern superbugs makes terrifying sense. Let's look at the poster child for this issue. MRSA, methicillin-resistant Staphylococcus aureus.
Right, so Staphylococcus aureus is a very common bacterium. It lives harmlessly on the skin or in the noses of about a third of the human population.
Okay.
But if it gets into a wound or the bloodstream, it can be lethal. And in the mid-20th century, staph quickly became resistant to standard penicillin.
So pharmaceutical scientists went back to the lab and developed a tougher, semi-synthetic drug called methicillin, which was explicitly designed to bypass the staph's enzymatic scissors, right?
Exactly. They introduced it in 1959.
And in 1961, just 2 years later, a microbiologist in the UK named Patricia Jevons isolated the first strain of staph that had adapted to survive it.
MRSA was born in 24 months.
That's just incredibly fast. And reading the clinical notes, there is a major shift in how MRSA operates today compared to a few decades ago. It used to be strictly a nosocomial infection, meaning you really only caught it inside a hospital if you had an IV line, a surgical wound, or like a severely compromised immune system.
Yeah, that is no longer the case. We are now dealing with community-acquired MRSA, or CA-MRSA.
Right.
These strains have evolved to infect completely healthy individuals out in the general public. We see outbreaks among athletes sharing gym equipment, military recruits in barracks, or inmates in crowded prisons.
Just healthy people living their lives.
Yeah. It causes severe, rapidly spreading skin infections that can easily turn systemic. The bacteria have broken out of the hospital environment.
While MRSA is the classic example of a superbug ignoring a drug, the sources also highlight a totally different kind of threat, Clostridioides difficile, or C. diff.
Yes.
And this one completely flips the script on how we view infections, because it acts more like an opportunistic ecological disaster than a direct attack.
C. diff perfectly illustrates how delicate the human microbiome really is. A healthy human gut is a densely packed ecosystem containing billions of beneficial bacteria. It operates like a highly competitive, old-growth forest.
Right.
There might be a few C. diff spores naturally present in that forest, but they are harmless because the beneficial bacteria are consuming all the nutrients and physically taking up all the space on the intestinal walls.
But then, a patient goes to the doctor for something completely unrelated, say a severe urinary tract infection
Mm,
or even a dental procedure,
yeah.
and they are prescribed a broad-spectrum antibiotic.
And that antibiotic enters the digestive tract, and because it is broad spectrum, it doesn't just kill the bacteria causing the UTI, it acts like a wildfire ripping through the gut, indiscriminately wiping out the entire protective forest of beneficial flora.
But the C. diff survives.
It survives because C. diff has the ability to form incredibly hardy, resilient spores that can withstand both the antibiotic and harsh stomach acids. Once the antibiotic course is finished and the chemical wildfire dies down, those C. diff spores wake up. They look around and find an entirely empty landscape with zero competition and unlimited food.
So they just take over.
They multiply exponentially and begin releasing toxins that attack the lining of the colon.
This leads to colitis, which is a severe, life-threatening inflammation of the colon. The clinical descriptions of the resulting diarrhea and tissue damage are just harrowing, and it hit me reading this. C. diff is an infection that is essentially caused by the very antibiotics meant to heal us.
Exactly.
It's clinical collateral damage.
It is the ultimate paradox of modern medicine. In the early 2000s, a specific hyper-aggressive strain of C. diff mutated and swept through hospitals in Quebec. Patients were coming in for routine, low-risk surgeries, receiving standard preventative antibiotics, and ending up with catastrophic colon damage simply because the drug cleared the path for the C. diff to take over.
That's awful. Now, if bugs like MRSA are outsmarting our drugs in 2 years, and broad-spectrum antibiotics are causing collateral disasters like C. diff, the logical question any listener would ask is, why don't we just invent new, highly targeted drugs?
It's a fair question.
Right. Why aren't pharmaceutical companies working around the clock to stay ahead of this?
Well, the science is certainly challenging, but the real barrier is economics. The market for antibiotics is fundamentally structurally broken.
How does a drug that literally saves lives end up being a bad business model?
Think about the incentives from a pharmaceutical executive's perspective. It costs upwards of $1 billion and takes a decade to bring a new drug through clinical trials to FDA approval.
A huge investment.
Right. Now, if you invent a new medication for a chronic condition like high blood pressure, diabetes, or cholesterol, a patient is going to take that pill every single day for the rest of their life. That guarantees decades of steady revenue to recoup the research costs.
But an antibiotic course is incredibly short. A patient takes it for 7 to 10 days, and at the end of that week, they are either cured or they are dead.
Exactly. The volume of sales is inherently low, but it gets worse.
How could it get worse?
If your company manages to invent a truly revolutionary, highly effective last resort antibiotic, the medical community will actively suppress your sales.
Wow.
Good hospital policy dictates that we lock that new drug away and say, do not prescribe this unless every other cheaper, older drug has failed. We have to hold it in reserve to prevent the bacteria from developing resistance to it.
So you spend $1 billion making a perfect product, and your primary customers are ethically obligated not to buy it.
Pretty much.
The sources provided a devastating real-world example of this mechanism in action with a company called Achaogen in 2019.
Achaogen is the ultimate cautionary tale for antibiotic development. They did everything right. They spent years developing a vital new antibiotic called plazomicin, designed specifically to target highly resistant, life-threatening urinary tract infections.
And the science was solid.
The science was brilliant. The FDA enthusiastically approved it.
And they filed for bankruptcy just months later.
Because the medical community appropriately held plazomicin in reserve, Achaogen couldn't generate enough revenue from the minimal sales to keep their laboratories open.
That is tragic.
When they collapsed, it sent a massive chilling effect through the industry. Most major pharmaceutical giants have completely abandoned antibiotic research because it basically guarantees a financial loss.
Which is why public health experts are now desperately arguing for pull incentives to artificially fix the market.
Right. If the free market won't pay for antibiotics, governments have to step in. The United Kingdom's National Health Service is currently testing a subscription model often called the Netflix model for antibiotics.
I love that name.
Yeah, instead of paying the pharmaceutical company per pill sold, the government pays them a massive, flat annual subscription fee just to have the drug available in their national arsenal.
So it completely severs the link between the volume of drugs sold and the company's profit. It pays for the value of the drug's existence, not its usage.
Exactly. It's like maintaining a fire department. You don't pay the firefighters per fire they extinguish. You pay them to be fully funded and ready when the alarm rings.
That makes perfect sense. But economics isn't the only deeply ingrained system being challenged right now. The sources show that some of the most fundamental behavioral rules of medicine are under intense scrutiny. And one of them directly challenges the agricultural industry.
Oh, this is a big one.
Yeah, if we're this worried about human prescriptions, how does agriculture fit into this selective pressure equation?
It is a massive piece of the puzzle. Historically, well over half of all antibiotics manufactured globally didn't go to human hospitals. They went to livestock.
More than half.
Yes, and they weren't just used to treat sick animals. They were routinely mixed into the daily feed and water of perfectly healthy chickens, pigs, and cows to artificially promote faster physical growth and prevent disease in tightly packed factory farms.
But how does a resistant bug inside a chicken actually reach a human being living in a city who, I don't know, maybe doesn't even eat meat? What is the actual mechanism of transfer?
The biological bridge is environmental. When millions of animals are fed antibiotics daily, their guts become breeding grounds for resistant bacteria. Those resistant bugs are excreted in massive amounts of manure.
Oh, I see where this is going.
Right. That manure is often used to fertilize crops, or it runs off into the local soil and groundwater. The resistant bacteria enter the human food chain through contaminated produce, or enter the water supply directly.
Wow.
Once a human ingests them, those agricultural bacteria can use horizontal gene transfer, like we talked about earlier, to pass their resistance plasmids directly to the human's normal gut flora.
It's a continuous invisible loop. And I should note, we are just reporting on what the clinical texts outline here. While the European Union banned the use of antibiotics for growth promotion in 2006, and the US FDA eventually tightened rules around 2017, the global economic incentives for cheap meat mean this remains a deeply contentious and ongoing driver of resistance worldwide.
It is heavily debated. Which brings us to the debates happening on the human side of the equation. One of the most controversial topics in the clinical texts right now centers around a 2017 paper published in the British Medical Journal challenging the oldest rule in the book.
The rule to always finish your antibiotic course.
Yes.
Hang on. My entire life, every doctor and pharmacist has drilled this into my head. Even if fever drops on day 3 and you feel totally fine, you have to finish all 10 days of the pills or you will create a superbug. It is medical gospel.
It has been the gospel for decades. But Martin Llewellyn and his colleagues published this BMJ paper arguing that for many common infections, the evidence supporting that rule is actually incredibly weak. In fact, they proposed the exact opposite. They argued that taking antibiotics for longer than clinically necessary might actually increase the selective pressure that breeds resistance because you are keeping the surviving bacteria exposed to the drug for a longer period, forcing them to adapt.
Wait, but if I start taking my pills on day 3 just because I feel better, aren't there still bacteria left in my system? Won't they just multiply and come back stronger? That feels incredibly dangerous to advise.
And that is exactly the pushback they received, and we have to view this impartially because it is fiercely debated. Many clinicians strongly oppose changing the messaging. Their primary fear is exactly what you just described: undertreatment.
Right.
If a patient stops too early without medical supervision, the infection could relapse, and a relapsed infection is often much harder to clear. The BMJ authors counter that we need highly individualized, shorter treatment durations based on clinical recovery rather than arbitrary 10-day rules.
It is a terrifying tightrope for a doctor to walk. You are balancing the immediate survival of the patient in front of you against the long-term survival of the drugs globally.
It is. And for anyone listening, this remains an active area of research. Guidelines are slowly changing for specific infections, but it requires strict medical guidance, not a decision a patient should ever make on their own.
With the pharmaceutical pipeline stalling, the agricultural loop constantly feeding resistance, and the basic rules of prescription under debate, what is the actual defense strategy for healthcare workers today?
The vanguard of our defense right now is antimicrobial stewardship.
So what does this all mean for you? Before we break down how stewardship works, we need to clear up the single biggest misconception that the general public holds about this entire topic.
The tolerance myth.
Yes, the idea that if I take too many antibiotics, my body will eventually become resistant to them.
We have to completely erase that idea from our minds. The human body does not become resistant to antibiotics. You do not build up a physiological tolerance to penicillin the way your brain builds up a tolerance to caffeine or alcohol.
Right.
The drug targets the biology of the bacteria, not the biology of the human.
The bug evolves, not you.
Exactly. When you take an unnecessary antibiotic, you are selectively breeding the toughest, most genetically fortified bacteria inside your own microbiome. Those superbugs are what stick around to infect you later or spread to your family.
Wow.
That is the core of antimicrobial stewardship, preventing that selective breeding. It is the organized, hospital-wide effort to ensure that a patient receives the right drug at the exact right dose for the right duration, targeting a specifically identified bug.
And reading the nursing literature, you realize stewardship isn't just a top-down policy for doctors. It is a grueling, daily operational reality for nurses on the floor.
It absolutely is.
It is a nurse practicing relentless hand hygiene and contact isolation to ensure a patient's MRSA doesn't physically travel on a stethoscope to the susceptible patient in the next room.
It is a nurse monitoring a patient on broad-spectrum antibiotics, noticing the onset of diarrhea, and instead of just writing it off as a routine side effect, advocating for a C. diff test before the spores can spread.
It's the frontline workers having the clinical courage to look at a doctor's chart and ask, does this patient really still need this IV antibiotic, or can we step them down? Because every single unnecessary dose is a microevolutionary event.
Every prescription alters the biological landscape.
So to summarize where we have been today, we started with Alexander Fleming's haunting warning that human behavior would rapidly undo his miracle discovery. We explored how bacteria leverage their 20-minute life cycles and tradable plasmids to deploy ancient weapons like NDM1 and efflux pumps.
Yep.
We looked at how fast MRSA breaks out of hospitals and how the collateral damage of broad-spectrum drugs essentially creates the devastation of C. diff. And we unpacked why fixing this requires massive interventions like the UK subscription model to repair a pharmaceutical market that actively punishes innovation.
It is a deeply interconnected web. And that brings up a crucial concept from the sources that I want to leave you with. The One Health framework.
The idea that human health doesn't exist in a vacuum.
Exactly. Everything we covered today, the isolated caves, the factory farms, the hospital wards, they are all linked. The One Health framework dictates that you simply cannot solve antibiotic resistance by strictly regulating a hospital in London or New York.
Right.
The resistant plasmids moving through the gut of livestock eventually end up in the soil, which washes into the agricultural runoff, which enters the human food supply, which walks through the front door of the hospital. We share a single, fluid, microscopic ecosystem.
It fundamentally changes how you view a trip to the pharmacy. The next time you are handed a prescription for an antibiotic, you aren't just taking a pill to clear up a cough. You are physically interacting with 4 million years of evolutionary history, and the choices we make with those drugs ripple through a global biological network.
It really puts it in perspective.
It does. The expectation of a clean, perfectly predictable medical diagnosis is just a comforting illusion.
We are navigating incredibly muddy waters. But by understanding the biology, the economics, and the history beneath the surface, at least we finally know which way the currents are pulling us.
Well said. Thank you for joining us on this deep dive. Stay curious, and we'll catch you next time.
Usually when you set out to learn a new language, you start with, the absolute basics, like greetings.
Right, yeah, like asking for directions or ordering a coffee.
Exactly. But what if the language you're trying to learn is written entirely in these jagged, bouncing, squiggly lines?
Oh, man, that is a whole different ballgame.
It really is, because these lines, if you learn to read them accurately, they can literally tell you if someone's heart is about to just stop beating.
Yeah, I mean, it is the ultimate high-stakes translation. You're reading the electrical shadow of a human heart, and it's happening in real time.
So, welcome to the deep dive. Our mission today is to decode that exact shadow for you.
We are unpacking the science, the honestly highly unusual history, and the life-saving mechanics of reading an ECG.
Right, the electrocardiogram. We've gone through this dense stack of clinical notes and historical documents to really distill the absolute core of cardiac tracings.
So whether you are, say, a nursing student prepping for clinicals, or just a curious learner, or even someone who just bought a smartwatch with a heart monitor.
Oh yeah, those are everywhere now.
Right. Understanding these tracings is, well, It's like gaining access to a secret medical code.
Okay, so let's unpack this. Because the history of how we got this technology is, I mean, it's just bizarre.
It really is. We are talking about a journey from a rather strange Victorian experiment to a Nobel-winning medical staple.
The story kicks off in 1887, right? In London, with this British physiologist named Augustus D. Waller. And his primary test subject wasn't even a human patient.
No, it was his bulldog.
A bulldog.
Yeah, the famously patient bulldog named Jimmy. So Waller used this primitive, really highly sensitive device called a capillary electrometer.
Which was what,
It
exactly?
was essentially this tiny glass tube filled with mercury and sulfuric acid. And he noticed that the meniscus, like the surface of the liquid, it would pulse slightly in response to minute electrical changes.
Oh, wow, okay.
So to capture the electrical activity of a beating heart, Jimmy the bulldog had to stand with his paws actually submerged in glass jars of saline solution.
Oh, wait, literally standing in jars of salt water.
Exactly. The salt water acted as the conducting electrodes.
That visual is just a bulldog in jars of salt water in a Victorian lab. I mean, it's hard to shake. But Waller actually totally dismissed his own invention, didn't he?
He did, yeah. He reportedly said he didn't think it would ever find a place in everyday medicine. He just viewed it as a physiological curiosity.
So who actually saw the clinical potential? Who turned that into a real diagnostic tool?
That was a Dutch physiologist named Willem Einthoven. So between 1901 and 1903, Einthoven engineered this thing called the string galvanometer.
Which I imagine was, a pretty massive upgrade from a tiny tube of mercury.
Oh, massive, both in sensitivity and, well, just its physical footprint. Waller's device sat on a little table. Einthoven's machine weighed hundreds of kilograms.
Hundreds. Good grief.
Yeah, it used a microscopic silver-coated quartz wire suspended between the poles of this tremendously powerful electromagnet.
Wow.
And the magnets were so intense that the machine needed constant water cooling. It actually took an entire team of technicians just to operate it in its own dedicated room.
And the patient experience wasn't exactly streamlined yet either. I mean, instead of the bulldog's paws, human patients had to sit in a chair and plunge both hands and one foot into these large buckets of saline.
Right, just to get a reading. And those were basically the first three-limb electrodes.
But Einthoven quickly proved he was a visionary, though. Like in 1906, he realized he didn't even need the patient in the same room as this massive hot machine.
Yeah, he successfully sent an ECG reading from a hospital ward straight to his laboratory over roughly 1.5 kilometers of ordinary telephone wire.
Wait, hold on. They were transmitting live medical data over telephone wires a full century before the smartphone.
They really were. He called it the telecardiogram.
How did they even conceptualize the math for that in 1906? I mean, the signal degradation alone, the interference, that must have been a complete nightmare to account for.
It was an astonishing feat of physics, honestly. Early signal processing. Einthoven didn't just build the machine and the transmission lines. To make sense of the signals coming over that wire, he created the entire mathematical language we still use today.
Which is how he eventually won the 1924 Nobel Prize, right? For mapping all this out.
Exactly. He mapped the mechanism of the ECG.
And that mathematical language, that's what we see on, every modern medical drama. The famous alphabet of the heart. The P, Q, R, S, and T waves.
Yeah, the classic PQRST.
Which I always just assumed those letters stood for some Latin medical terms, like some ancient anatomical reference,
A lot of people assume that. But Waller, with his original bulldog tracings, he had simply used A, B, and C to label the waves.
Okay, so why did it change?
Well, his mercury tube distorted the signal. It was sluggish, so it didn't capture the really sharp spikes. When Einthoven built his string galvanometer, he mathematically corrected that distortion, and the true waveform emerged.
Right.
So to differentiate his highly accurate waves from Waller's old ABC waves, Einthoven just started halfway down the alphabet at P.
Wait, so it was literally just a random bookkeeping choice?
Pure bookkeeping. He deliberately left the first half of the alphabet available, just in case future scientists discovered earlier, smaller electrical deflections that he might have missed.
That is wild.
Yeah, he just went alphabetically from there.
Yep.
P, Q, R, S, T. And that convention has just stuck around for over 120 years.
Unbelievable. Well, to understand what those letters actually represent biologically, we kind of have to look at the heart differently. We tend to think of it as a mechanical pump, right? A piece of muscle.
Right, but underneath that physical pump, it is fundamentally an electrical grid.
So how does the grid actually work?
To interpret the waves, you have to understand two core concepts: depolarization and repolarization.
Okay, break that down for us.
So when cardiac muscle cells are at rest, They maintain a negative internal electrical charge compared to the outside. They're essentially primed, like a drawn bowstring, just waiting.
And then the signal arrives.
Right. When the signal to pump arrives, these tiny microscopic channels in the cell membrane just snap open. Sodium ions, and a bit later calcium ions, rush into the cell.
And that massive influx flips the internal charge from negative to positive. That sudden electrical flip is depolarization, right?
Exactly. And that electrical flip is the exact trigger that tells the physical muscle fibers to actually contract and squeeze.
Got it.
But once the muscle contracts, the cell can't fire again until it completely resets. It has to actively pump all those ions back out to restore its negative resting charge.
And that resetting phase is repolarization.
Yes. So every single squiggle you see on the ECG paper is just tracking millions of these individual cells undergoing this massive ion exchange at the exact same moment.
So let's trace a single normal heartbeat on the ECG paper for you guys listening. It starts with the natural pacemaker of the heart, right? The SA node.
Yeah, the sinoatrial node sitting high up in the right atrium.
So the SA node fires off its electrical spark. And that wave spreads across the top chambers of the heart, the atria, causing them to depolarize and squeeze blood downward.
And that initial, relatively small electrical spread, that creates the very first little bump on our ECG strip, the P wave.
Okay, so P wave equals the top of the heart firing. Then the electrical signal hits a checkpoint before it goes down to the main pumping chambers, the ventricles.
Right, it hits the AV node.
And the electrical signal actually pauses there. On the ECG, this pause looks like a flat, quiet line right after the P wave called the PR segment.
It is a crucial pause.
I always like to think of this pause like holding open the elevator doors, you know? The electricity has to pause so the blood can physically load from the atria into the ventricles before the doors shut and the big contraction happens.
That is a perfect way to look at it.
Because if the electricity didn't pause, the top and bottom of the heart would squeeze at the exact same time and no blood would go anywhere. It would just be a mess.
It would be totally inefficient. That vital pause allows for actual mechanical filling. So once those elevator doors shut, the electrical signal just races down the anatomical superhighway of the heart.
Down into the ventricles.
Right, through structures called the bundle of His, the bundle branches, and the Purkinje fibers. It spreads through those massive, thick, muscular walls of the ventricles almost instantaneously.
And because the ventricles are so big and thick, this electrical burst is huge. I mean, this gives us the QRS complex, which is that really tall, sharp, jagged spike that dominates the paper.
Yep, the QRS is pure ventricular depolarization. Now, interestingly, the atria, the top chambers, they're repolarizing, they're resetting at this exact same moment.
Oh, really? At the exact same time as the big spike?
Yes, but the electrical voltage of those massive ventricles firing is so enormous that it completely buries the atrial reset on the graph. The tracing just hides it.
Wow, okay. So finally, after the ventricles squeeze out the blood to the rest of the body, they have to reset for the next beat.
Right, and that ventricular repolarization gives us the final, slightly wider bump on the strip, the T wave.
Okay, so P, QRS, and T. But you know, a lot of beginners look at this perfectly ordered sequence and form a pretty dangerous assumption.
They really do. They begin to think that every single QRS complex must inherently have a P wave triggering it right in front.
But the electrical grid can break down in ways where they completely separate, right?
Absolutely. In certain pathological conditions, like a complete third-degree heart block, that anatomical superhighway between the top and bottom of the heart gets completely severed electrically.
So no signals get through at all.
None. The SA node in the atria just keeps firing out P waves at its own normal pace, but none of those signals ever reach the ventricles.
So what do the ventricles do? Just stop?
Well, eventually they realize they are starving for a signal, and they start firing completely on their own. They rely on backup pacemaker cells at a much slower, kind of desperate pace, creating their own QRS complexes.
So the top and the bottom of the heart basically just completely divorce each other.
Yes, it's called AV dissociation. On the ECG, you'll actually see P waves marching along completely independently of the QRS complexes. They might even overlap or hide inside each other. The mechanical coordination is just entirely lost.
Which brings up a huge point. Because if the ECG flawlessly tracks this electrical elevator, and we see all the waves in perfect sequential order, P, Q, R, S, T, then a normal-looking rhythm must mean the heart is pumping blood perfectly, right?
See, this raises an important question. If we are only looking at the electrical shadow of the heart, how do we confidently diagnose what's actually happening inside the plumbing?
Right.
Because that assumption you just made, that a perfect electrical rhythm equals perfect mechanical pumping,
Right.
is quite literally the most fatal trap in all of cardiac care.
It seems so intuitive, though. Like, if the electrical trigger fires perfectly, the muscle should squeeze perfectly.
Yeah.
Where does that break down?
The ECG measures electricity, and only electricity, period. It does not measure physical movement. It does not measure blood pressure.
Okay.
There's this terrifying clinical state called pulseless electrical activity, or PEA.
PEA.
Right. In PEA, a patient is in full cardiac arrest. Their heart muscle might be entirely blown out from a massive heart attack, or they might have bled out internally. The muscle is not moving, and they have zero pulse.
But what does the monitor show?
If you look at the ECG monitor, the electrical conduction system is still firing signals into dead or empty tissue. So the screen might show an organized, nearly perfect PQRST rhythm.
That is terrifying. So a nurse or paramedic could look at the monitor, see a great rhythm, and assume the patient is fine while the patient is literally dying right in front of them.
Yes, this is exactly why experienced clinicians constantly drill the phrase, treat the patient, not the monitor. A healthcare provider must physically touch the patient and check for a pulse.
You can't just glance at a screen.
Exactly. You cannot assume blood is flowing just because the electricity is firing. The map is not the territory.
Wow. And that completely shatters that medical TV show trope, right? Where the monitor goes to a flat line, the machine goes beep, and the doctors immediately jump on the patient's chest to do compressions.
Oh, the PV flatline trope is another massive misconception. Yeah. I mean, while a true flatline, a state called a systole, is indeed a fatal cardiac arrest rhythm, a flatline on a monitor is far more frequently just a disconnected sticky pad or a broken wire.
It's just a technical glitch.
Right. Or a dead battery in the patient's telemetry box, which is that little portable monitor pack they wear around their neck on the hospital ward.
So if you just jump on their chest.
If you reflexively start doing aggressive chest compressions just because the screen went flat, you might literally be breaking the ribs of a perfectly healthy patient who just rolled over in bed and pulled a wire loose. So again,
Yeah.
check the patient first.
So if we know the shadow can deceive us, clinicians must have a system to decode the actual truth of the tracing. And it seems like the secret lies in the math of the physical grid paper it's actually printed on.
Yes, the paper grid is highly standardized. It converts physical distance on the page into very precise measurements of time. To read the language, you have to know the speed.
Which is what?
Standard ECG paper moves out of the machine at exactly 25 millimeters per second.
Okay, 25 millimeters a second. And the paper is covered in this tiny grid of boxes. One small box is exactly 1 millimeter wide.
Correct.
So because the paper moves at 25 millimeters a second, that tiny box represents exactly 0.04 seconds of time.
You got it. And those small boxes are then grouped into larger boxes outlined by a thicker line. One large box is 5 millimeters wide, which equals 0.2 seconds.
Okay, so a large box is 0.2 seconds. I feel like a really common beginner mistake would be assuming that one of those big boxes is 1 full second.
It is a very common mistake.
Yeah.
But if one large box is 0.2 seconds, you actually need 5 of those large boxes strung together to make 1 full second.
Oh, right. Basic math. And knowing this grid allows a clinician to just use their eyes and, a pair of little calipers to measure how fast the heart is beating without pulling out a stopwatch. There's that famous shortcut, the 300 rule.
It is a brilliant bit of mental math.
Yeah.
So if the heart rhythm is regular, you just count the number of large boxes between 2 of those tall R waves, the big spikes. If they are exactly 1 large box apart, the heart rate is 300 beats per minute. 2 boxes apart is 150. 3 boxes is 100. 4 is 75. 5 is 60.
So a clinician can estimate the heart rate from across the room at a single glance just by looking at the gaps.
Exactly.
But what happens when the rhythm is chaotic and totally irregular? Like in atrial fibrillation, where the atria are just quivering, the gaps between the R waves are going to be completely different sizes on every single beat.
The 300 rule instantly breaks down there. You can't use it.
So what do they do?
Instead, clinicians look at a standard 6-second strip of paper, which is usually marked off by hash marks at the very top of the page. They simply count the total number of QRS spikes in that 6-second window and multiply by 10.
Oh, that makes sense, because 6 times 10 is 60 seconds.
Right. That gives you the 60-second heart rate, even if the beats are wildly irregular.
Okay, so that's rate and rhythm. But a single strip of paper is ultimately just one vantage point. To really see the full 3-dimensional electrical field of the heart, clinicians rely on the famous 12-lead ECG.
The gold standard.
But the math here is initially super confusing for people. because it's called a 12 lead, but the nurse only places 10 physical sticky pads or electrodes on the patient's body. 4 go on the limbs, 6 go across the chest. So where do the 12 views actually come from?
They're generated through vector mathematics.
Oh, math again.
Right. The machine continuously compares the electrical voltage differences between varying combinations of those 10 physical electrodes. It mathematically generates 12 distinct viewpoints, or leads, of the heart.
And Einthoven started this, right?
He did. He started this concept with Einthoven's triangle. He proved that the 3 standard limb, leads lead 1, lead 2, and lead 3, form a perfect equilateral triangle around the heart.
Wow.
The math is so precise that lead 2 always equals the exact electrical voltage of lead I plus lead 3.
That's amazing. You know, I always picture this using a sports broadcast analogy.
Oh, yeah. Let's do it.
So a 12-lead ECG is essentially the Super Bowl TV broadcast. The heart is the football field. Lead 2 is the camera directly behind the quarterback, giving you the vertical view from head to toe.
Okay, yep. Lead V1 is the camera down on the sideline, giving you the horizontal cross-section. You need multiple camera angles to definitively prove a receiver's feet stayed in bounds, right? In medicine, you need all those angles to prove a heart attack is actually happening.
That is exactly how it works. Because a heart attack, an infarct, where the tissue is actually dying from lack of oxygen, it's localized physical damage.
Right.
So if the bottom wall of the heart is dying, you will only see the electrical warning signs in the specific cameras physically looking at the bottom of the heart, which are leads 2, 3, and AVF.
So a doctor can't just look at one weird squiggle on a single lead and declare a massive heart attack.
Never. Diagnostic criteria for a STEMI, which is a massive acute heart attack, specifically require ST segment elevation in 2 anatomically contiguous leads.
Contiguous meaning next to each other.
Right. You need 2 adjacent camera angles showing the exact same disaster to confirm the tissue death is real and not just, a momentary artifact from the patient coughing or moving around. That makes total sense. Now, if the ECG is this incredibly sensitive grid capturing every tiny electrical shift, I imagine a localized heart attack isn't the only thing that disrupts the signal. What happens if the blood itself is chemically off?
This is what gets fascinating. If we connect this to the bigger picture, the ECG isn't just a cardiac tool, it's a systemic warning system.
Meaning it looks at the whole body.
Exactly. It can act as a real-time bedside blood test. Take hyperkalemia, which is dangerously high potassium in the blood.
And potassium is heavily involved in that repolarization resetting phase we talked about earlier at the cellular level.
It absolutely drives the reset. So when potassium levels get too high in the bloodstream, the concentration gradient outside the cell gets totally ruined. The cells can't reset properly.
So how does that show up on the paper?
The ECG changes in a very predictable, staged sequence. First, the T waves, the repolarization waves, they get extremely tall and pointy. They appear peaked.
Okay, peaked T waves.
Then, as the potassium level worsens, the QRS complex gets really wide and sluggish. The P waves flatten out entirely and just disappear.
Wow.
And finally, the tracing turns into this terrifying, smooth sine wave right before the heart muscle becomes fully paralyzed and stops.
So an emergency room doctor can look at that sine wave and instantly know the patient has a critical chemical imbalance without having to wait like 45 minutes for the laboratory blood results to come back?
Exactly. It's an instant visual lab result. And it also reveals hidden microscopic anatomy.
Like what?
Well, in 1930, a condition called Wolff-Parkinson-White syndrome was described. Some people are just born with a microscopic extra electrical pathway that physically bypasses the AV node.
Oh, so it bypasses the elevator door pause.
Exactly. The electricity takes a shortcut and bleeds into the ventricles too early. The ventricles start depolarizing sluggishly before the main signal even arrives.
And how do they spot that?
On the ECG, this shows up as a shortened PR interval because the pause is missing, and a weird slurred upstroke on the QRS complex called a delta wave.
That is so cool. So clinicians deduced the existence of this tiny anatomical pathway just by looking at the electrical shadow decades before modern imaging could ever actually visualize the physical tissue.
Isn't that incredible? They just read the shadow.
The sources even mention it can detect environmental factors, too. Like the ECG can literally tell you if someone is freezing to death.
It can. In severe hypothermia, a distinct extra hump actually appears right after the QRS complex. It's called an Osborn wave.
An Osborn wave.
Yeah. It is a stunning visual reminder that the ECG reflects the entire physiological state of the human being, core body temperature included.
But, with all these incredibly specific visual patterns, delta waves for bypass tracks, sine waves for potassium, Osborn humps for hypothermia, why are human eyes still required to read these things?
The automation debate.
Right. I mean, computers can drive cars and write complex software code today. Why is an algorithm so easily fooled by a squiggly line that a tired nurse at 3 a.m. is legally required to double-check its work?
It is a massive debate, and it really revolves around automation bias. Modern ECG machines, they always print a handy computerized interpretation at the very top of the page.
Like normal sinus rhythm or something.
Right, or consider anterior infarct. But studies consistently show that algorithms frequently misread subtle ischemic changes. That's where the heart is starving for oxygen but hasn't fully died yet. Or they misread rare arrhythmias.
But I'd imagine if a clinician is overworked or maybe just lacks confidence in their own interpretation skills, the temptation to just blindly trust the machine's printed label must be overwhelming.
That temptation is highly dangerous. Medical guidelines strictly mandate that a qualified human must overread the machine. You simply cannot surrender clinical judgment to software.
It's just too risky.
Way too risky. And this is especially true because of confounders like LBBB, which stands for left bundle branch block.
Okay, so how does a block on one side trick the computer?
Well, if the left branch of that electrical superhighway is physically blocked, the electrical signal cannot take the fast lane. It has to detour slowly through ordinary, non-specialized muscle tissue just to get to the left side of the heart.
Okay, so it takes a scenic route.
A very sluggish scenic route. And this detour massively distorts the QRS and the ST segment and makes them look wide and bizarre. But more importantly, it completely masks the normal electrical signs of a heart attack.
Oh, wow.
Yeah, the machine gets hopelessly confused by the detour. Human experts actually had to invent an entirely new set of rules in the 1990s called the Scarbosa criteria, just to visually diagnose heart attacks when an LBBB is present.
That's wild. We're just constantly learning how this electrical shadow can trick us. Look at Brugada syndrome, right? Which was only defined in, 1992?
Yes, 1992. And Brugada syndrome completely overturned old assumptions. It is a genetic electrical anomaly.
Meaning?
Patients with Brugada have structurally perfect hearts, no clogged arteries, no dead muscle, but their electrical ion channels are faulty at a microscopic level.
So the hardware is fine, but the software is glitching.
Exactly. It produces a very specific, bizarre ST segment pattern in the chest leads, and it can cause sudden, fatal cardiac arrest. It proved that you don't actually need physical heart damage to have a fatal arrhythmia. A pure software glitch in the ion channels can be just as deadly.
Which I think perfectly dismantles the biggest misconception of all here, the normal ECG trap.
Oh, yes.
Because, say, a patient comes into the emergency room with chest pain. The tracing looks completely normal. They naturally assume they're 100% fine.
But a completely normal ECG does not rule out a heart attack.
Wait, really? How?
Well, if you are having a heart attack on the posterior wall of your heart, the very back, the standard 12-lead placement, doesn't actually have a camera angle pointing directly at it.
Oh, so the front looks totally fine while the back is literally dying?
Exactly. Furthermore, if the heart attack is in its very first hour, the electrical changes might not have even manifested on the skin surface yet. It takes time.
Ah, okay. This explains why ER protocols don't just do one ECG, declare it normal, and send you home.
Right. They do serial ECGs.
Meaning they repeat them every 15 or 30 minutes to catch any delayed changes. And they draw your blood to look for biomarkers like troponin, which is a protein that physically leaks out of dying heart muscle cells.
You have to combine the electrical shadow with the chemical reality. One tool is just never enough.
So bringing this all together, we are talking about a 120-year-old technology, right? Yet its footprint in modern healthcare is absolute.
Oh, it's everywhere.
It's universally used because it's cheap, it's completely painless, and it gives you answers in under 60 seconds. I mean, it dictates how we manage hospital wards, with nurses continuously monitoring telemetry and having to expertly manage alarm fatigue from all those false alerts.
It also directly guides life-saving interventions. Like when someone is in cardiac arrest, the ECG immediately identifies if the rhythm is shockable.
Like ventricular fibrillation, where the heart is just quivering chaotically.
Right. It tells the medical team exactly when to use a defibrillator to reboot the whole system.
And now we have this modern twist. Eindhoven's massive room-sized machine is literally strapped to our wrists right now.
It really is. Millions of consumer smartwatches can now record a single lead ECG to detect arrhythmias like atrial fibrillation.
We have basically brought the hospital into the living room. But that also means we've brought all the hospital pitfalls, the false positives, the limitations of only having one single camera angle, and the massive automation bias of just trusting a digital alert straight to the average consumer.
And if the ECG has taught us anything over the last century, is that we can look right at a perfect electrical rhythm on a screen while a patient's heart is mechanically standing completely still.
Right.
So we really have to ask ourselves, what other digital metrics in our modern lives are we blindly trusting, simply because we've confused the measurement for the reality itself?
The map is not the territory. The squiggly lines are just the shadow. They're not the beating heart itself. Well, thank you for joining us on this deep dive. Keep questioning the world around you, keep looking past the surface, and we will catch you next time.
When we look at how modern medicine tracks a patient's stability, there's just this immense reliance on the intake and output chart.
Oh, absolutely. The classic I&O.
Right. And it looks like this perfectly balanced accounting ledger, at the end of a nursing shift. You have this meticulous log of every single milliliter of IV fluid or water the patient consumed, measured right up against every milliliter of urine or drainage that left the body.
Yeah, it's very neat, very tidy.
Exactly. And the fundamental assumption here is that if those two columns match, well, the patient is perfectly hydrated and physiologically stable.
Which is, it provides a really comforting illusion of control, right? We basically try to map complex human physiology onto this super basic thermodynamic principle of, input equaling output.
But I'm guessing the clinical reality is a bit more deceptive than that.
Far more deceptive, yeah. A patient can have a flawlessly matched chart on paper where the total volume of water in their body is technically totally normal, but they are simultaneously experiencing a lethal fluid crisis.
Wow, wait, so how does that happen?
Well, the critical factor we constantly misinterpret isn't the total volume of water, it's the geographic location of that water within the microscopic compartments of the body.
Okay, and that spatial distribution is exactly our target for this deep dive. We're unpacking the true architecture of fluid balance today.
Right. It's fascinating stuff.
We're going to examine the biological mechanisms that drive water into hidden tissue compartments, which is often called third spacing. And we'll also look at why the reflexive medical instinct to just give IV fluids to a shock patient can sometimes trigger catastrophic organ failure.
Yeah, which goes against decades of medical training, by the way.
Right. And we'll also talk about how the biological mechanisms governing a trauma patient in the ICU are actually identical to the ones causing marathon runners to inadvertently drown their own brain cells.
It is all connected. So to really dismantle that reliance on the intake and output ledger, we basically have to start by mapping where the fluid actually lives.
Okay, let's map it.
So we frequently hear this baseline statistic that the average adult body is roughly 60% water.
Right, yeah, the classic science class trivia fact.
Exactly. Clinically, though, that total percentage is almost irrelevant. It really comes down to how that volume is partitioned.
Because we tend to visualize the body as a single vessel, just this giant water balloon of sloshing fluid. But the partitioning is actually highly segregated.
Very much so.
Like, of that total body water, 2/3 is entirely locked away inside the intracellular fluid compartment. It's just spoken for, just maintaining the function of your individual cells.
Right, which leaves only 1/3 of your total water in the extracellular fluid compartment. And this right here is the pivot point where our intuitive understanding usually just completely fails.
Also,
Well, of that extracellular fluid, the water outside the cells, only about 1/4 is actually circulating inside your blood vessels as plasma.
boy, only a quarter.
It's just a quarter. The remaining 3/4 is what we call interstitial fluid, which is basically the water bathing the tissues and filling all those microscopic gaps between the cells.
Okay, so if we map this onto a visual analogy for you listening, imagine your body is a house.
I love this analogy.
Right. So the plasma, the fluid inside the blood vessels, is the plumbing system. But the vast majority of the water in this house isn't in the pipes at all.
Not at all.
It's sitting locked inside the individual rooms, which are the cells,
Yeah.
or it is literally soaking into the drywall and the insulation, which represents that interstitial fluid you just mentioned.
And the massive clinical challenge here is that doctors and nurses can only easily access and measure the plumbing. When you take a blood pressure or draw labs or, measure urine output, you are only interacting with the plasma. You're staring at the pipes, completely blind to what is happening inside the walls.
That's wild. And the recognition of these distinct environments actually dates back to Claude Bernard in the 19th century, right? With his concept of the milieu intérieur.
Yes, the internal environment.
He proposed that our cells don't actually interact with the external world. They survive in this highly defended sort of primordial internal ocean.
But translating that concept into actual bedside medicine didn't really happen until James L. Gamble's work in the mid-20th century.
Right, Campbell.
Yeah, he was a Harvard pediatrician, and he was confronting this massive pediatric mortality rate from diarrheal dehydration. Prior to his work, the standard of care was basically just pouring uncalibrated saline solutions into these kids.
We were just topping off the tank.
Exactly. They assumed fluid was just fluid. But Gamble recognized that the body's compartments rely on highly specific electrical and chemical gradients.
So he mapped out the precise concentrations of like sodium, potassium, and chloride in the different fluid compartments.
Right, and he created these visual bar charts called Gamblegrams.
I love that name.
It's great, right? And it shifted medicine from blindly topping off the tank to precisely replacing the specific electrolytes a patient lost. So if a child lost bicarbonate and potassium, Gamble's charts allowed doctors to formulate a fluid that replaced those exact molecules.
Just to restore the osmotic pressure.
Exactly. And those osmotic pressures are what keep the water in the correct compartments.
But Gamble's work mostly addressed fluid that actually leaves the body, like through diarrhea. The map gets terrifyingly complicated when the fluid doesn't leave the body, but it just escapes the plumbing.
Yes. Welcome to the third space.
The phantom zone.
Basically, yeah. So Francis D. Moore, a surgeon who was analyzing trauma patients from World War II and the Korean War, he noticed this massive discrepancy.
What were the soldiers showing up with?
Well, they were arriving with severe injuries, their blood pressure was crashing, and their urine output had just completely stopped. They looked profoundly dehydrated.
But let me guess, the visible blood loss didn't match the severity of the shock.
Exactly. The surgeons would calculate the blood loss, and it just didn't add up. The soldiers were missing massive volumes of fluid that couldn't be accounted for on any external chart.
So where was it going?
Moore figured out that the trauma had triggered a systemic inflammatory response. The capillaries, the tiny porous pipes of the circulatory system, had become hyperpermeable.
They got leaky.
Super leaky. The fluid was leaking out of the intravascular space and pooling into the injured soft tissues, the bowel walls, the abdominal cavity.
Wow. So the water hadn't actually left the soldier's body?
Right. It was still inside them, but it was entirely lost to the circulation. It was sequestered in this non-functional third space.
Which just completely invalidates the standard intake and output chart. The nursing ledger can't measure fluid that's hiding in the body's drywall.
It absolutely cannot. And to make it worse, standard charts routinely ignore insensible losses.
Like breathing and sweating.
Yeah. An average resting adult breathes out and sweats roughly 800 to 1,000 milliliters of water vapor a day.
That's a whole liter.
Right. And if you have a patient on a ventilator or someone with a high fever, those unmeasured losses just skyrocket.
Which is why the daily weight of a patient is such a far more rigorous proxy for fluid balance than any written ledger.
Yes. The physics are absolute. 1 liter of retained fluid has a mass of exactly 1 kilogram.
So if a patient's intake and output chart claims they're perfectly balanced, but the scale shows they gained, say, 3 kilograms overnight.
You know, with absolute certainty that 3 liters of fluid have leaked out of their plumbing and are actively third spacing into their tissues.
That is just wild. And to visualize the sheer scale of this third spacing, we really should look at the protocols for severe burn victims.
Oh, yeah. The fluid shifts there are unimaginable.
Right, because when a patient suffers a major thermal injury, the capillary leak is catastrophic. So to prevent the plumbing from running completely dry, burn units use the Parkland formula to calculate resuscitation fluids.
And it is a lot of fluid.
The math is 4 milliliters of fluid multiplied by the patient's weight in kilograms, multiplied by the percentage of their body surface area that's burned.
So if we run those numbers for a standard 70 kilogram adult with a 40% total body surface area burn, which, to be clear, is an incredibly severe, life-threatening injury.
The result is staggering. 4 times 70 times 40. That is 11,200 milliliters.
Yeah.
11.2 liters of 5E fluid required in just the first 24 hours, with half of that volume mandated in just the first 8 hours.
It's massive. The clinical team is effectively forced to flood the patient's circulatory system just to maintain enough pressure to perfuse the brain and the kidneys.
even though they fully know that a massive percentage of that 11 liters is going to leak straight out of the damaged capillaries.
Oh, completely. It's going to cause the patient's entire body to swell to almost unrecognizable proportions.
Okay, I have to challenge the mechanics of that treatment protocol for a second.
Go for it.
If I'm the attending physician and I see a patient whose tissues are actively ballooning with liters of trapped third space fluid, my mechanical instinct is to just drain the system.
Sure, that makes intuitive sense.
Right. I'd want to give them a powerful loop diuretic like furosemide to force the body to excrete that excess water and relieve the swelling.
And administering a diuretic in the acute phase of a third space crisis is actually one of the most lethal conceptual errors a clinician can make.
Wait, really? Why?
It comes back to our map of the fluid compartments. Diuretics act specifically on the kidneys, and the kidneys are just a filter attached to the plumbing.
Ah, so they only have access to the intravascular volume.
Exactly. The fluid currently circulating inside the blood vessels. The kidneys have no physical mechanism to reach into the interstitial tissue and pull water out of the walls.
So if you push a diuretic,
The kidneys will aggressively filter and excrete whatever volume is currently in the plasma. But in a burn or trauma patient, the plasma volume is already dangerously depleted. It's all leaking into the tissues.
so the diuretic would just instantly drain the last remaining fluid from the pipes.
Yes, causing a catastrophic drop in blood pressure and inducing multi-organ failure. And the massive tissue swelling won't even go down because that fluid is sequestered away from the kidney's reach anyway.
Wow. So the only viable mechanism for removing that fluid is just time.
Basically, time and healing. The underlying inflammation has to resolve. Once the capillary leak seals, which is usually around day 3 to 5, the hydrostatic and osmotic pressures naturally pull that trapped fluid back into the blood vessels.
And only then can the kidneys filter it out.
Precisely. And waiting for the capillaries to seal brings us to probably the most contentious debate in modern critical care right now, the liberal versus restrictive fluid strategy.
Because for nearly a century, medical dogma basically dictated that if a patient had low blood pressure from sepsis or trauma, the immediate reflex was to administer a huge IV fluid bolus.
Right. Fill the pipes. Increase cardiac output.
And this was heavily based on the Starling equation from 1896, right? Which modeled capillary exchange purely as a balance of physical hydrostatic pressure pushing fluid out and the oncotic pressure of plasma proteins pulling it back in.
Yeah, it treated the blood vessel like it was just a passive, semi-permeable membrane, like a coffee filter.
But modern vascular physiology has identified a microscopic structure that completely breaks that old Starling model.
The endothelial glycocalyx.
The what?
Glycocalyx. It is this microscopic, gel-like meshwork of glycoproteins and proteoglycans that coats the inner lining of every single blood vessel in your body.
Oh, wow. So it functions like a biological Teflon coating.
Exactly like Teflon. It isn't just a passive barrier. It actively repels red blood cells, it houses regulatory enzymes, and most importantly, it traps plasma proteins to maintain the osmotic gradient that keeps water inside the vessel.
So what happens to this Teflon coating when a patient develops sepsis?
Well, the immune system releases this massive storm of inflammatory cytokines and enzymes. And these enzymes literally chew up and degrade that delicate sugar protein layer.
Just destroys it.
Yeah, and the body actually does this intentionally to allow white blood cells to slip out of the bloodstream and attack the infection in the tissues.
Right, but the biological cost of stripping that Teflon coating is that the plumbing completely loses its structural integrity.
Once the glycocalyx is degraded, the capillaries aren't just leaky, they are functionally shattered.
Which completely reframes our approach to resuscitation.
Completely. Because if the vessel lining is destroyed, pushing a rapid bolus of IV fluid doesn't meaningfully increase blood pressure. The fluid simply bypasses that degraded barrier and floods straight into the interstitial space.
And we actually have massive clinical data proving how lethal this traditional fluid reflex can be, like the FEAST trial.
Oh, yes. Fluid expansion as supportive therapy, published in 2011.
Right, where researchers studied over 3,000 critically ill children with severe febrile illnesses across sub-Saharan Africa. And the absolute gold standard protocol for a child in shock was to administer a rapid fluid bolus.
Because the underlying assumption was that the bolus would restore the volume in the pipes and improve tissue oxygenation.
But the trial was halted early, wasn't it?
It was, because the results were absolutely devastating. The children randomized to receive the standard fluid boluses had a 3.3% higher absolute mortality rate compared to the control group that received no bolus at all.
Wait, really? Giving the standard, trusted treatment actually pushed fluid through those Damaged glycocalyx barriers into their lungs, causing pulmonary edema, and into their brains, causing cerebral edema.
Yes, the textbook intervention accelerated their death. It was a massive, paradigm-shifting realization for the medical community.
That is deeply unsettling. But it also echoes the findings of the 2004 safety study, right?
Right, in Australia and New Zealand. For decades, ICUs spent insane amounts of money administering albumin, which is this large, expensive human protein, instead of just cheap saline.
Because the theory was that the massive albumin molecules wouldn't be able to leak out of the capillary.
Exactly. They thought it would hold the water in the pipes via oncotic pressure.
But the SAFE study proved there was zero overall mortality benefit to albumin over standard saline.
None at all. Because if the glycocalyx is destroyed, even massive proteins will hemorrhage out into the third space and they drag the water right along with them. The barrier itself is the critical failure point.
But here's the thing, the degradation of those vascular walls and the shifting of fluid compartments, that's not just a phenomenon restricted to trauma bays and ICUs, right?
Oh, not at all. The exact same hormonal triggers that mismanage fluid distribution during a severe infection, they can be hijacked during everyday activities.
Which bridges the gap to sports physiology. Because we see catastrophic fluid shifts occurring in amateur athletes who are literally just adhering to what they think are healthy hydration guidelines.
Yes. And the primary culprit here is antidiuretic hormone, or ADH.
Okay, so ADH is secreted by the pituitary gland, and its primary function is to instruct the kidneys to conserve water.
Right. It does that by inserting water channels, called aquaporins, into the kidney ducts. And your body naturally releases massive surges of ADH when you are under physical stress, when you are experiencing pain, or when your blood volume slightly drops from sweating.
Which perfectly describes the physiological state of a person running a marathon.
Perfectly.
So during the 2002 Boston Marathon, there was this study by Dr. Christopher Almond. His team drew blood from nearly 500 runners at the finish line. And he discovered that 13% of them were suffering from hyponatremia.
Which is dangerously low concentrations of sodium in the blood.
But crucially, they didn't develop hyponatremia because they sweat out all their body salt.
No, they developed it because they drank too much plain water. They basically followed the pervasive advice to drink at every single hydration station.
And because their systems were flooded with that stress hormone, ADH, their kidneys were chemically blocked from excreting that heavy water load.
Exactly. So the plain water had nowhere to go except into the bloodstream, where it massively diluted the existing sodium.
And this is where the physics of osmosis become incredibly deadly, because the blood plasma becomes hypotonic, meaning it's extremely watered down compared to the fluid inside the body's cells.
Right. And to equalize that pressure, that excess water is forcefully driven out of the plumbing and across the cell membranes,
rushing into the intracellular compartment, so the cells physically swell up.
And while a swollen muscle cell is painful, a swollen brain cell is life-threatening.
Because the skull is a rigid, fixed vault. It can't expand.
Right. So as the brain cells absorb this hypotonic water, they expand, increasing intracranial pressure. This is early hyponatremic encephalopathy.
And the external symptoms of this brain swelling, nausea, extreme fatigue, confusion, collapsing. The tragic overlap here is that these symptoms flawlessly mimic the signs of severe dehydration.
It looks exactly the same.
Huh.
So when a runner collapses at the finish line exhibiting confusion and cramping, the immediate instinct of a well-meaning bystander or a medical volunteer is to assume, oh, they're dehydrated.
So they hand them a bottle of water. Or worse, a medic hooks them up to an IV bag of hypotonic fluid.
Which instantly exacerbates the osmotic gradient. It pushes even more water into the brain, herniating the brainstem and literally killing the athlete.
It's terrifying. Fatalities at major marathons have been directly caused by this precise sequence of well-intentioned but physiologically backward medical care.
It really emphasizes why understanding these mechanisms is so crucial. But on the flip side, mastering these fluid shifts has actively engineered some of the most profound medical advancements in history.
Like oral rehydration therapy, or ORT.
Yes. Back in the 1970s, researchers investigating cholera and severe diarrheal diseases, they mapped out this specific protein embedded in the intestinal lining.
The sodium glucose cotransporter, right? SGLT1.
Right. And this transporter acts as a molecular pump. It couples the transport of one glucose molecule with two sodium ions.
So if a patient just drinks plain water, it moves sluggishly across the inflamed intestinal wall.
And if they drink purely salty water, the sodium remains in the gut and actually draws more water out of the body, worsening the diarrhea.
But if you create a solution with a highly specific molar ratio of sodium and glucose.
The SGLT1 transporter engages. It actively pulls the salt and sugar across the intestinal epithelium.
And that localized movement creates a powerful osmotic gradient that physically drags massive amounts of water along with it straight into the bloodstream.
It's brilliant. This simple, hyper-calibrated mixture of sugar, salt, and water bypasses the need for intravenous fluids entirely. It has saved tens of millions of lives globally.
Which is amazing. Yet we see this massive disconnect in the modern commercialization of hydration today.
Oh, don't even get me started on the IV drip bars.
Right. We have these wellness clinics and strip malls heavily marketing intravenous fluid bags to the general public for like hangovers or general fatigue.
People are paying out of pocket to bypass their perfectly functioning, highly evolved GI tracts and SGLT1 transporters. They're forcing uncalibrated fluids directly into their intravascular plumbing, completely ignoring the complex hydrostatic pressures and glycocalyx barriers we've just spent all this time talking about.
It trivializes a really fragile medical intervention.
Yeah.
And honestly, it assumes an infinite abundance of supplies, which we know is a deeply flawed premise.
Oh, definitely.
I mean, the fragility of our reliance on manufactured fluid compartments became terrifyingly clear in late 2024.
With Hurricane Helene.
Yeah. Hurricane Helene caused catastrophic flooding in North Carolina, directly incapacitating a massive manufacturing plant that produced a huge percentage of the nation's IV fluids.
Literally overnight, the abstract physiology of fluid balance became a brutal supply chain crisis.
Hospitals nationwide were forced to instantly ration IV fluids.
Yeah.
Bedside clinicians had to delay elective surgeries and rethink every single milliliter of fluid they administered.
It was a very stark reminder that a bag of normal saline isn't just a commodity. It is a meticulously engineered medical tool designed to manipulate the internal ocean of the human body.
And when you lose access to it, you realize how delicate the physiological architecture truly is.
Exactly.
So bringing it all together, the ultimate takeaway from this deep dive is that fluid balance defies simplification. It is not an accounting ledger.
Not even close.
It's this highly dynamic, actively negotiated distribution of water across selectively permeable membranes, protected by microscopic gel barriers and governed by stress hormones.
Whether we are looking at burn resuscitation, the feast trial, or runners crossing a finish line, the evidence is absolute. Blindly pushing more fluid is rarely the panacea we want it to be.
We really have to move past treating the body like an inert container.
Yeah. The human organism is constantly adapting to preserve its core functions, and our interventions just have to respect the complexity of those biological defenses.
Absolutely. So I want to leave you with a final mechanical reality to consider as we wrap up.
Sure.
Right now, without any conscious input from you, your body is managing a microscopic internal ocean. Your pituitary gland is titrating antidiuretic hormone, your endothelial glycocalyx is actively trapping plasma proteins, and your cell membranes are utilizing ion pumps to keep from drying out or rupturing.
It's constantly working.
You are quite literally a walking, self-regulating bag of seawater. And if the brightest minds in critical care have spent the last century repeatedly realizing how dangerously wrong their assumptions were about something as seemingly simple as water and salt, what other fundamental everyday functions of our own anatomy are we currently entirely misunderstanding? Picture this. An 84-year-old woman goes into the hospital for just a routine hip surgery. She's totally sharp. She lives independently and does the Sunday crossword every single week.
Right, a very familiar baseline for a lot of patients.
Exactly. But then 2 days after her surgery, she completely doesn't know her own name. She's frantically picking at her bed sheets and she's terrified, like insisting she's trapped in a strange house.
And her family is standing right there at the foot of the bed, absolutely panicking.
Yeah. Their immediate thought is always, this is it, we lost her, it's Alzheimer's. But I guess the question for today's deep dive is, what if it's not?
What if her brain isn't experiencing this permanent, irreversible decline, but it's actually just in the middle of a totally reversible acute metabolic crash?
Welcome to today's deep dive. We are tackling a massive, incredibly common mix-up in medicine, which is untangling delirium from dementia.
Yeah, and that panic from the family in your example, healthcare providers see that constantly. It stems from this really dangerous habit we have of taking two completely different neurological conditions and, well, just throwing them into the same bucket called confusion.
Which is such a disservice to the patient.
Yeah.
I mean, mixing these two up isn't just some vocabulary error. It leads to massive diagnostic blunders that cause real harm.
It absolutely does every single day.
So knowing the difference here is literally a life-saving skill. Whether you are a nursing student doing rounds or a caregiver looking after an aging parent, or you just want to understand how the brain works under stress, this is incredibly high yield for you.
It really is. And to start, we should probably lay down some foundational mechanics, right?
Yeah, let's use the smartphone analogy from the sources because I think that works perfectly.
Yeah.
How do we categorize dementia versus delirium using a phone?
Well, I love that analogy. If we use the smartphone model, dementia is basically a hardware issue.
Okay, so the physical parts of the phone.
Right. The battery is permanently degrading, the microchips are corroding over months and years. The physical structure of the brain itself is slowly failing.
And just to clarify, the sources note that the term dementia was actually retired from the psychiatric manual, the DSM-5, back in 2013, right?
Yeah, that's spot on. It was retired to reduce stigma. It's technically called major neurocognitive disorder now. But honestly, at the bedside, dementia is still the word everyone uses to describe that chronic hardware degradation.
Got it. So if dementia is the physical phone breaking down, where does delirium fit into that?
Delirium is a software crash. The hardware might be, somewhat weathered from age, but suddenly a rogue app starts taking up 100% of the RAM.
Oh, like a bad medication or an infection.
Exactly, or even severe dehydration. The operating system just totally freezes. Delirium is a flashing red alarm indicating a medical emergency.
So the brain is effectively screaming that it does not have the resources to function in that exact moment.
Yeah, it doesn't have the metabolic or physiological fuel, and it manifests as this acute, wildly fluctuating disturbance in thinking.
It's so fascinating. And history actually gives us a really great window into how long we've been trying to articulate this software crash. The etymology in the sources paints such a vivid picture.
It really does, especially when you look at the sheer age of the word delirium. I mean, it is older than dementia by nearly 2,000 years.
2,000 years, that's wild.
Yeah, it comes from the Latin word delirare, and literally translated, that means to go off the furrow or off the plowed track.
Oh, I love that. So the prefix de means away, and lyra means furrow. It's an agricultural metaphor.
Exactly, it's an ancient farming reference.
So if delirium is the mind wandering off the plowed track because of a temporary storm, like that infection or a new drug, then dementia, which comes from the Latin dement, meaning out of one's mind, is the track itself slowly fading away.
That is a beautiful way to visualize it. And that agricultural visual holds up really well for centuries. Starting with the Roman Encyclopedia Celsus in the 1st century AD, delirium was just a descriptive word.
Like it wasn't an official diagnosis yet.
Right, not at all. It was merely a way to describe at the bedside the feverish ravings of someone who was dying or just severely ill.
So it was just viewed as a symptom of being really sick. And for a long time, the medical community didn't view senile dementia as a specific disease either, did they?
Yeah, they didn't. They just assumed if you got old, your brain naturally weathered away. That was the prevailing assumption for most of the 20th century. Old age just equaled cognitive decline.
Until 1906, right, when Alois Alzheimer completely shattered that belief.
Yes. He was a German psychiatrist, and he presented this incredible case of a woman named Auguste de Ter. She was only 51 years old.
Wait, 51? That completely rules out the normal aging hypothesis right out of the gate.
Completely. She suffered from progressive memory loss, intense paranoia, and eventually her language just totally disintegrated.
Wow. And when she passed away, he actually examined her brain tissue, right?
He did during an autopsy, and he found these abnormal clumps of protein, which we now know as amyloid plaques, and tangled bundles of fibers called neurofibrillary tangles.
So he essentially proved that her cognitive decline wasn't just the natural passage of time.
Right. It was a discrete neurodegenerative disease that was actively destroying the brain's tissue.
Okay, so that perfectly establishes the hardware failure. The physical track is literally being destroyed by plaques and tangles.
Yeah.
But how did we finally get a biological grasp on the software crash, on delirium?
Well, that shift didn't actually happen until 1959. Two psychiatrists, George Engel and John Romano, published a paper that completely reframed it.
What did they do differently?
They called delirium a measurable state of acute brain failure. They actually hooked delirious patients up to an EEG, which measures the electrical activity of the brain.
Oh, so they could physically see it happening.
Yeah, exactly. They could literally watch the brainwaves slow down in real time. It showed the brain's metabolism was failing, like it just didn't have the energy to fire its neurons properly.
And the most important part, according to the sources, is that they proved this generalized disturbance was reversible, provided you found and treated the underlying cause.
Yes, the reversibility was the key finding there.
Which is great historical context, But if I'm a nurse on a busy ward today, I don't exactly have time to look at brain tissue under a microscope, and I definitely might not have an EEG machine handy.
No, you definitely won't in most standard rooms.
So how do you actually tell the difference between a fading track and a temporary storm just by talking to the patient?
Well, you're relying on the four bedside axes of distinction: onset speed, the course over a day, attention, and reversibility. Let's look at onset first.
Okay, onset. Delirium happens fast, right? Like hours to a few days, whereas dementia takes months to years.
Spot on. So if a family brings someone into the ER and says, Grandpa was completely fine at breakfast, playing Sudoku, but by dinner he didn't know his own name, that speed is your biggest red flag.
That speed screams software crash.
Exactly. The trajectory tells the whole story. The second axis is the course within a single day. Delirium fluctuates wildly.
Meaning they could seem fine 1 minute and totally out of it the next.
Yeah. A patient might be totally lucid, holding a perfectly normal conversation with you at 10 a.m., but by 4 p.m., they are profoundly disoriented, maybe hallucinating or severely agitated.
And dementia doesn't do that.
No, dementia is relatively stable hour to hour. A person with Alzheimer's is going to struggle to remember their granddaughter's name just as much in the morning as they do at night.
Okay, let's dig into the third axis, because the sources call attention the single best bedside discriminator. And I want to make sure I really understand the mechanics of this.
Sure, it's crucial to grasp.
So if I ask an elderly patient to spell the word world backward, they don't know what day of the week it is, but they can sit there and focus their mind to spell DLROW for me. That points to dementia.
Yes, that's exactly right.
But if they get distracted halfway through because, I don't know, a nurse walks by in the hallway, that points to delirium.
You've hit on the absolute crux of it. In early to moderate dementia, the brain's underlying energy supply is actually still somewhat intact.
So they have the power to focus.
Right, attention is relatively preserved. The patient can sustain focus on your request. They just might not remember the conversation 5 minutes later because the memory storage hardware is broken.
But in delirium, the attention mechanism itself is what's shattered.
Exactly. The brain is in a metabolic crisis, so it literally cannot hold a thought or filter out background noise.
So if you ask them to recite the month of the year backward, they start, get distracted by a beep from a heart monitor, and just lose the thread entirely.
Yeah, it's a mechanical inability to maintain focus. Which leads us to the fourth axis, which is reversibility and cause.
Right. We know dementia is caused by things like those Alzheimer's plaques you mentioned.
Yes, or vascular infarcts, which are basically microscopic strokes that cut off blood supply to tiny regions of the brain over time.
Oh, so that creates like a stepwise decline.
Right. And another common cause is Lewy body dementia, where abnormal protein clumps disrupt neurotransmitters. That causes cognitive decline paired with Parkinson's-like physical tremors.
And all of these are ongoing neurodegenerations. Medicine can maybe slow them down, but we can't reverse them currently.
Exactly. Now contrast that with delirium, which is driven by a fixable precipitant.
This is the part I really want to understand the how on. How does a simple urinary tract infection, a UTI, cause acute brain failure? It sounds crazy.
It is a fascinating and honestly terrifying cascade. When a younger, healthy person gets a UTI, their immune system handles it locally in the bladder.
Just a localized battle.
Right. But in a frail older adult, that local infection triggers a massive systemic alarm. The immune system just floods the body with inflammatory proteins called cytokines.
And those cytokines travel up to the brain.
They circulate in the blood, yes. And because an older brain's defenses, like the blood-brain barrier, are often weakened, those inflammatory markers actually breach the barrier.
Oh, wow. So the infection literally invades the brain's environment.
It does. And once inside, those cytokines trigger the brain's own immune defenders, the microglial cells, to just go into absolute overdrive.
So you get severe neuroinflammation.
Exactly. And that inflammation throws off the synthesis of key neurotransmitters, especially acetylcholine, which is vital for attention and awareness.
So a simple bladder infection launches a chemical attack that unplugs the brain's communication network.
That is exactly what happens. But if you give antibiotics and clear the UTI, the cytokine storm stops and the delirium usually resolves.
Applying this to the hip fracture case from the beginning, it makes total sense now. An 84-year-old has major surgery. The physical trauma, the anesthesia, the painkillers, it's a massive storm.
Right. All of those things launch a huge inflammatory and chemical storm in her body.
So 2 days later, her attention is broken. She's picking at the sheets. That is textbook delirium.
And it is incredibly common in frail elderly patients after surgery or in the ICU.
But, the hip fracture example sounds sort of obvious
Hmm.
because the patient is visibly agitated, she's vocal, she's moving.
Yeah, that's what people expect to see.
Right. When we hear delirium, we immediately picture someone thrashing around, pulling out their 5E lines, shouting, kind of like delirium tremens from severe alcohol withdrawal.
You're describing the hyperactive subtype of delirium. It's the dramatic, cinematic version everyone pictures in their head.
But the sources say the reality on the ground is very different.
Very different. The most common presentation in older hospitalized patients is actually the hypoactive subtype, and it is the most frequently missed by doctors and nurses.
Hypoactive meaning underactive. What did that actually look like for the person just sitting in the hospital bed?
Well, these patients are quiet, withdrawn, lethargic, and apathetic. They might just sleep all day or stare blankly at the wall.
And if you talk to them?
They might just answer questions with single syllables. The danger is that a quiet patient doesn't demand attention the way a shouting, agitated patient does.
The squeaky wheel gets the grease, especially in a busy hospital.
Exactly. Studies repeatedly show the vast majority of hypoactive delirium cases go completely unrecognized at the bedside.
That is just a silent catastrophe. Inside that quiet patient, the brain is still in a state of acute failure, right? The cytokine storm is still raging.
It's still a medical emergency, but nobody is noticing.
Which raises a really tricky scenario for you if you're working in a clinic. What happens when a patient has both?
Ah, yeah.
Let's say someone who already has Alzheimer's comes into the hospital for a minor procedure and develops hypoactive delirium on top of it.
You're touching on delirium superimposed on dementia, or DSD. This is a massive trap for healthcare providers.
That's so.
When a patient with pre-existing dementia has an acute worsening of their mental state, maybe they stop talking entirely. Families and clinicians alike often throw up their hands and assume, well, the dementia's just progressing.
They see the cognitive decline and just blame the chronic disease they already know is there.
Exactly. It's a huge blind spot.
And if you are listening to this, you can immediately see the danger. Because someone already has an Alzheimer's diagnosis, a totally curable urinary tract infection gets ignored.
Or a toxic reaction to a new sleeping pill gets missed.
Right. It just gets written off as inevitable decline.
Failure to catch DSD means a treatable, life-threatening insult goes entirely unaddressed. It is one of the most consequential diagnostic errors in geriatric medicine.
Before we move on to how we actually fix this, the sources mention a couple of neighboring terms that I want to clear up for anyone navigating this space. We hear the term sundowning a lot.
Right, sundowning is very common to hear.
And also something called pseudodementia. Let's start with sundowning. What is that exactly?
Well, sundowning is just a descriptive term for patients who become more confused, anxious, or agitated in the late afternoon and evening as the sun goes down.
So is it its own specific disease?
No, clinically, what gets casually labeled as sundowning is very often just undetected delirium layered on top of dementia. It's usually triggered by fatigue or poor lighting in the evening. It's not a distinct disease.
Okay, that makes sense. What about pseudodementia? Because that sounds like a fake hardware crash.
In a way, it kind of is. Pseudodementia refers to severe depression that basically mimics cognitive decline.
Oh, really? Depression can do that?
Yeah. The patient has slowed thinking, poor concentration, they complain about their memory. It looks remarkably like dementia.
Yeah.
But the mechanism is mood-based, not structural.
So if you treat the depression, does their memory come back?
Yes. Once you treat the underlying depression with therapy or medication, the cognitive issues clear up completely.
Wow, it's staggering how many things wear the disguise of dementia. So realizing that a quiet, withdrawn patient might actually be in a state of acute brain failure is sobering.
It definitely shifts your perspective.
But if there is neuroinflammation happening, how do we stop it? Historically, medicine took a pretty aggressive approach to the agitated, hyperactive patients.
Right. Yeah, for decades, the standard hospital practice was straightforward. If a patient was delirious and pulling out their tubes, you just gave them an antipsychotic or a heavy sedative, typically a drug called haloperidol.
Which, on the surface feels sort of logical to a stressed out medical team. The brain is hyperactive, the patient is a danger to themselves, so you give them a drug to calm the brain down.
But did it actually calm the brain down or just the body?
Right. The sources highlight this massive 2018 trial that finally answered that.
Yes, the MIND USA trial, published in the New England Journal of Medicine, they tested haloperidol and another antipsychotic, ziprasidone, against a placebo in ICU patients suffering from delirium.
And the results were a genuine bombshell, right?
Absolutely. The antipsychotics did absolutely nothing to reduce the number of days patients spent delirious. They didn't shorten the ICU stay, and they didn't improve mortality.
So if you're listening to this and you've ever had a relative given sedatives in the ICU to calm them down, this has to be a terrifying revelation. We weren't treating the brain at all.
No, we were just treating the symptom, the agitation, to make the patient manageable for the staff.
Because haloperidol just blocks dopamine receptors.
Exactly. That stops the thrashing around. But it does absolutely zero to stop the inflammatory cytokines from a UTI or to reverse the metabolic starvation of the brain.
So the biological fire of the delirium just continued to rage on underneath the chemical restraint.
It did. It was just masking the failure.
That is a colossal medical failure. But it leads into an even bigger bombshell from the sources, one that completely reverses a long-held 20th century belief.
This is probably the most important shift in how we view delirium today.
Yeah, because we've been talking about delirium as a reversible state. The old logic was, fix the UTI, the delirium goes away, the software reboots, and the phone works perfectly again.
Right. No lasting harm. That was the old teaching. That delirium was a temporary detour with no lasting cognitive cost.
But that's not true anymore.
Not at all. Longitudinal research following patients after they leave the ICU or cardiac surgery has completely overturned that. Studies show that patients who experience a severe episode of delirium have a significantly higher risk of accelerated cognitive decline and subsequent dementia in the years following.
Wait, so it's not harmless once it clears. It doesn't just reveal a vulnerable brain. An episode of delirium actively injures the brain.
It does. It leaves a scar. Severe neuroinflammation causes collateral damage to neurons. It really blurs that once tidy line between acute and reversible on one side and chronic and progressive on the other.
So delirium might actually be a catalyst that accelerates long-term hardware degradation.
Exactly. It actively damages the hardware.
Which makes the stakes astronomically higher for you and your loved ones. If drugs don't fix it, and merely having an episode of delirium causes permanent brain injury, how do we stop it?
The ultimate solution is prevention. And this is where the pioneering work of geriatrician Dr. Sharon Inouye completely changed the landscape.
What did she do?
Well, in 1990, she recognized that you can't prevent what you can't measure. So she invented a screening tool called the CAM, the Confusion Assessment Method.
Okay, how does that actually work at the bedside? What are the nurses actually measuring?
It's a quick algorithm that takes under 5 minutes. A nurse evaluates 4 features. First, is there an acute onset or fluctuating course?
Basically checking the timeline.
Right. Second, is there inattention? Like, can the patient squeeze your hand every time they hear the letter A in a sequence of letters?
Ah, testing that mechanical focus.
Exactly. Third, is their thinking disorganized? Are their answers rambling or illogical? And fourth, is their level of consciousness altered? Are they hyper alert or lethargic?
And how many of those do they need to flag for delirium?
If a patient has the first 2 plus either of the last 2, they are flagged.
So it forces the medical team to actively check for that broken attention mechanism, catching even the quiet, hypoactive patients.
Exactly. And once you can measure it reliably, you can test ways to stop it, which Dr. Inouye did in 1999 with a landmark trial also published in the New England Journal of Medicine.
Did she test a new drug?
No, she didn't test cutting-edge pharmaceuticals at all. She tested a multi-component intervention that targeted basic environmental and physiological risk factors.
That makes sense. If the brain is starving for metabolic resources, you have to support its baseline needs. So what did this intervention actually look like in practice?
It was fundamental, rigorous nursing care. They put up large orientation boards so patients always knew the date and where they were.
Okay, keeping them grounded in reality.
Right. They aggressively minimized nighttime disruptions, clustering blood draws and turning down alarms to ensure uninterrupted sleep. They got patients out of bed and walking to promote blood flow.
And pushing fluids to prevent dehydration, I imagine.
Yes. And crucially, they gave patients back their reading glasses and hearing aids.
Let's pause on that last one. Why would not having reading glasses trigger acute brain failure?
Think about the mechanism of sensory deprivation. If an older patient is lying in a hospital bed without their glasses or hearing aids, the world is a blurry, muffled, terrifying place.
Oh, I hadn't thought of it like that.
The brain has to work overtime. exhausting its limited metabolic reserves just to interpret shadows and mumbles. By giving them their glasses, you instantly reduce the cognitive load.
You remove that stress on the operating system. Did it work? Did delirium rates actually drop?
Dramatically. The intervention group had a substantially reduced incidence of delirium. Dr. Inouye proved that this acute, life-threatening brain failure is highly preventable.
Not with drugs, but just by engineering an environment that supports the brain's fundamental needs.
Exactly. Basic human needs.
That is profound. And it brings us right back to you, the listener, and why untangling these terms empowers you. Let's rapidly synthesize what we've covered today.
Sounds good.
Delirium is a fast-acting software crash. It fluctuates wildly, it breaks a person's mechanical ability to pay attention, and it is always driven by an underlying medical cause, like an infection triggering neuroinflammation.
Right, whereas dementia is a slow hardware degradation. It takes months to years to develop. It remains relatively stable within a single day. It spares a person's attention in the early stages, and sadly, it has no cure.
We also learned that hypoactive delirium, the quiet, withdrawn patient, is the silent killer because it is so easy to ignore.
And if we lazily assume that a sudden cognitive decline in someone with Alzheimer's is just the dementia getting worse, we might be masking a life-threatening but completely treatable emergency.
The boundaries between these two conditions are porous. Delirium causes lasting damage, meaning preventing that acute brain failure is one of the most critical things a healthcare team or an advocating family member can do.
Absolutely.
Whether you are charting notes on a geriatric ward or advocating for your own parent in an overcrowded, chaotic ER, knowing the difference between a chronic brain disease and a reversible check engine light changes everything.
It changes the questions you ask the doctor. It changes how you observe your loved one.
It shifts you from a place of panic to a place of action.
It really equips you with the vocabulary to intervene when the medical system might be missing the subtle signs.
And I want to leave you with a final thought to mull over today. We learned that Dr. Inouye proved a state of acute brain-injuring delirium can often be prevented simply by giving a patient uninterrupted sleep, hydration, mobility, and their reading glasses.
Yeah, basic physiological support.
So if the lack of those basic fundamental human needs causes the brain to rapidly fail, are modern hospitals themselves fundamentally toxic to the aging brain?
That is a very heavy question.
Think about it. The constant beeping of monitors at 3 a.m., the sensory deprivation, the windowless rooms. If the very places we go to heal are actively inducing cognitive trauma, what would it look like to design a hospital that actually healed the mind instead of just the body?
It's a design challenge we desperately need to solve.
Something to think about. We'll catch you on the next deep dive. You know, if you break your arm, getting an x-ray is, it's pretty satisfying in a weird way.
Oh, yeah, it's a very binary thing.
Right. Like you just look at the film
Yeah.
and the doctor points to this jagged white line and says, yep, there it is. Broken. It's incredibly clean.
I mean, we naturally gravitate toward that kind of medicine, things that can be easily visualized, neatly categorized, and then instantly fixed.
Exactly. But the moment you step into an intensive care unit and start looking at cardiovascular physiology, that comforting binary just completely vanishes.
It gets really murky, really fast.
Super murky. So today, we are taking a deep dive into a stack of physiology texts and nursing sources to unpack the actual physics of a failing human heart.
And it is fascinating stuff.
It really is. Specifically, for you listening, we're going to explore two monumental concepts you'll hear in any ICU, which are preload and afterload, and we're going to master a foundational rule of human survival called the Frank-Starling mechanism.
Which is just a brilliant piece of biology.
Definitely. But to start, I want you to do a quick mental reset. If you picture the heart as just like a squishy, passive bag that squeezes blood when the brain tells it to, I need you to throw that image away.
Yeah, that's not going to help us here.
Right. We need to look at it as a hyper-intelligent, self-regulating engine. Because by the end of this deep dive, you'll see exactly how the physical forces acting on this engine dictate why it runs, and more importantly, how it breaks.
And the reason this particular stack of sources is so compelling is that it sits right at the intersection of microscopic cellular biology, macrofluid dynamics, and really high-stakes bedside medicine.
We're literally talking about the physical forces keeping a human alive.
Exactly. Grasping these concepts, I mean, it isn't just an academic exercise for passing a physiology exam.
Right.
If you're standing at the bedside of a patient in cardiogenic shock, which is, this terrifying state where the heart pump is so weak it can't sustain blood flow to vital organs, understanding this, physics is the literal difference between saving their life and accidentally making them much, much worse.
Wow. Okay, so to understand how the heart fails, we first have to understand the invisible physical forces acting on it before and during a single heartbeat.
Right.
The sources focus really heavily on two terms, preload and afterload. So let's establish the technical definitions first.
That place to start.
So the text define preload as the stretch or the tension on the ventricular wall at the very end of diastole. So this is the exact millisecond just before the heart actually squeezes.
Yes, the true physiological definition there is end diastolic myocardial wall stress.
End diastolic myocardial wall stress, okay. And then we have the counterpart, which is afterload.
Right.
This is the resistance or the pressure that the ventricle has to overcome during the actual ejection phase, right?
Yeah, exactly. To push blood out to the body, the heart has to physically force open the semilunar valve.
Which is like a heavy door.
That's a great way to picture it. It's a heavy, pressurized door separating the heart from the aorta. So the true definition of afterload is peak systolic wall stress.
Okay, let's unpack this, because both of those technical definitions center on the concept of wall stress, which the sources note is governed by Laplace's law.
Right, and that geometric relationship, that is the core of everything we're discussing today.
So what exactly is Laplace's law?
Well, Laplace's law states that wall stress is equal to the pressure inside the chamber multiplied by the radius of the chamber.
Okay, pressure times radius.
And then all of that is divided by 2 times the thickness of the wall.
So it's pure structural engineering.
Exactly. It is structural engineering applied directly to living cardiac tissue.
Okay, let me try to ground this with an analogy just to make sure the physical mechanics are clear for you listening. If we think about a slingshot, is preload the act of pulling back the rubber band? Like getting that initial stretch and tension built up in the material.
Yes, perfectly said.
And then afterload would be like trying to shoot that exact same slingshot underwater versus through thin air.
Yeah.
Like the environmental resistance you have to fight against the moment you let go.
The math of Laplace's law actually supports that visualization entirely. Preload is the degree of stretch on the structural fibers right before the release, and afterload is the environmental resistance pushing back against those fibers during the release.
Okay, but I need to challenge the sources on something here because this always confused me.
Sure, go for it.
If true preload and afterload are both fundamentally about wall stress and the place's geometry, why is it that when you walk into a hospital, you constantly hear nurses and doctors talking about them in terms of simple volumes and pressures?
Yeah, that is a classic point of confusion.
Right. Like you hear about CVP, central venous pressure, being used as a stand-in for preload, or SVR, systemic vascular resistance, for afterload. If it's all about stress on the actual heart wall, why use these other metrics?
Well, that discrepancy comes down to a mix of historical evolution and just the harsh pragmatism of bedside medicine.
How so?
If we look back about a century, the term load, it wasn't a metaphor. Physiologists literally hung small metal weights on isolated strips of cardiac muscle in a laboratory to test tension.
Like literally hanging weights on muscle.
Literally. It was a tangible physical load.
Yeah.
But by the mid-20th century, as cardiologists tried to translate that isolated muscle research into whole organ diagnostics for living patients, they needed something they could actually measure.
Right, because obviously you can't open a patient's chest in the ICU and hang a metal weight on their beating heart to measure the tension.
Exactly the problem.
Yeah.
So they started using ventricular volume and arterial pressure as stand-ins.
But the sources say that's flawed, bro.
Very flawed. In the 1970s, physiologists like Kiichi Sagawa and Hiroyuki Shuga proved that using pressure and volume as proxies is fundamentally inaccurate.
Why?
They used pressure-volume loop analysis to argue that wall stress is the only mechanically honest definition precisely because of Laplace's law.
Okay, I think I see where this is going, but walk me through it.
Consider 2 different patients. Patient A has a severely dilated, paper-thin heart due to, say, a viral infection.
Okay, a thin, stretched-out heart.
And patient B has a thick, heavily muscled heart due to years of untreated high blood pressure.
Right, so if we plug them into Laplace's equation, where stress equals pressure times radius divided by wall thickness, the thin heart has a huge radius and a tiny thickness.
Exactly.
So its wall stress is going to be massive compared to the thick heart, even if the blood pressure reading inside them is completely identical.
That is the crucial insight, yes. A normal central venous pressure number on a monitor might reflect a totally safe amount of stretch for the thick heart, but spell absolute structural disaster for the thin, dilated heart.
Oh, wow. So the number on the screen is lying to you.
It can, yes.
Yeah.
The textbooks maintain the strict definitions of preload, But the clinical reality is that true wall stress is just incredibly difficult to calculate in real time at the bedside.
So clinicians use proxies like CVP and SVR because it's what they have.
Right. They just have to remain constantly aware that those proxies can be deceptive.
Okay, so if wall stress and physical stretch are so vital to how this engine runs,
Yeah.
how does the engine actually know what to do with that stretch?
Now we get to the magic.
Right, which brings us to the most famous concept in cardiovascular physiology, the Frank-Starling mechanism, or the law of the heart.
Yes.
The origin story in these sources is fascinating because it proves the heart manages all of this entirely on its own.
The discovery of that autonomy is arguably one of the most elegant moments in medical history. And it's hyphenated as Frank Starling because the foundation was built in two distinct stages.
Right, on two different continents, nearly a generation apart.
Exactly.
The visual history here is so great. We start in 1895 in Munich with a physiologist named Otto Frank.
A true pioneer.
He isolates a frog heart and connects it to this device called a kymograph, which features a rotating drum wrapped in smoked paper to trace pressure changes.
Such a classic Victorian-era science setup.
I know, right? So Frank physically stretches the frog's ventricle before it contracts, and the smoked paper reveals a clear spike. Like, the more he stretched it, the more pressure it generated.
Which established the foundational length-tension relationship for cardiac muscle. But it wasn't until 1915 in London that Ernest Starling took that isolated finding and applied it to a fully functioning organ system.
And his setup was wild.
It really was. Starling developed an incredibly complex heart-lung preparation using an anesthetized dog. The heart and lungs were kept alive and pumping, but Starling's team artificially controlled the venous return.
Meaning the amount of blood flowing back into the right side of the
Right,
heart.
and they controlled it using an adjustable reservoir.
So they are artificially pouring more blood in, essentially forcing the intact heart to stretch. And what they find is revolutionary.
Absolutely revolutionary.
In his 1915 Lineker lecture, Starling revealed that when you increase that venous return, the heart automatically pumps out a matching increase in stroke volume.
The amount of blood ejected per beat, yes.
Right, so if 2 extra ounces flow in, the heart immediately stretches and forces 2 extra ounces out.
And the detail that reshaped medicine forever was that the heart did this without any change in heart rate and with zero input from the nervous system.
It's difficult to overstate how massive a paradigm shift that must have been. I mean, they essentially proved the heart isn't just a dumb pump waiting for instructions from the brain.
Exactly. It proved the heart has intrinsic mechanical autoregulation. It optimizes its own output beat to beat based solely on the physical volume of blood delivered to it. It is a fully independent machine.
I want to zoom in on the cellular mechanics of that independence, though, because earlier we used a slingshot analogy, but cardiac tissue isn't just rubber.
No, it's alive.
Right, rubber snaps back purely because of passive elasticity.
Yeah.
What is actively happening inside the microscopic muscle cells of the heart to make this autoregulation possible?
Well, to understand the active mechanism, we have to look really closely at the sarcomere, which is the basic contractile unit of a muscle cell.
Okay, zooming way in.
Picture it as a series of overlapping filaments called actin and myosin. For decades, the assumption was that the Frank-Starling law was just about optimal physical overlap.
Just spacing them out right.
Yeah, the theory was that if you stretch the sarcomere to a length of exactly 2.2 micrometers, the actin and myosin filaments align perfectly, allowing them to grab onto each other and generate maximum pulling force.
Which makes sense intuitively. It's like perfectly spacing out a row of people playing tug-of-war so their hands don't bump into each other.
It does make sense. But modern cellular biology has given us a massive update to Starling's original law. It's known as length-dependent activation.
Length-dependent activation.
Okay, we now know that stretching the sarcomere doesn't merely physically align the filaments better. The physical stretch actually triggers a chemical alteration in the system.
Wait, how does a physical stretch change the chemistry of the cell?
So think of the sarcomere like a dense, complex fishing net. Embedded in this net is a regulatory protein called troponin C, which acts kind of like a biochemical lock.
Okay, component C is the lock.
And calcium is the key that turns that lock to initiate a muscle contraction. When you physically stretch the sarcomere, you are pulling that net tighter.
Which distorts the net.
Exactly. That physical tension distorts the physical shape of the troponin C protein, fundamentally increasing its sensitivity to calcium.
That is incredible engineering. So by physically stretching the muscle, you are twisting the biological locks so they catch more calcium keys.
Which means more actin-myosin cross bridges form for the exact same chemical signal.
Wow, it's a hyper-efficient feedback loop where physical tension amplifies chemical reactivity.
Precisely.
Okay, so if the heart has this brilliant self-optimizing chemical net, how do we end up with patients dying in cardiogenic shock?
That is the dark side of the physics, unfortunately.
Right, because if Frank Starling is a perfect regulatory mechanism, what happens when it gets trapped?
Huh.
Let's move from healthy theory into the physics of a failing heart.
This is where we see the physical laws just turn against the patient. Let's start with a normal, healthy ventricle. At rest, it fills up with roughly 120 milliliters of blood. That's your end diastolic volume.
Okay, 120 mils.
And when it squeezes, it efficiently ejects about 70 milliliters of that blood out to the body.
But when a heart begins to fail, say from a massive heart attack or chronic disease, it becomes weak and it starts to physically dilate. The chamber stretches out.
Yes, it balloons.
So that end diastolic volume might balloon from 120 up to 200 or even 300 milliliters.
And it does that as a desperate survival mechanism. The failing heart is trying to recruit the Frank Starling mechanism. The muscle is weak, so it dilates to stretch those sarcomeres, hoping to increase calcium sensitivity and generate a stronger contraction.
But this is where the Laplace's law springs a trap, right? Because as the heart dilates to get more preload stretch, the radius of the chamber gets wider and wider.
Yes. And returning to Laplace's equation, wall stress equals pressure times radius. As the radius expands, the wall stress basically multiplies. By trying to increase its preload, the failing heart inadvertently massively increases its own afterload.
Because it's suddenly fighting against its own huge geometry.
Exactly. It takes more and more energy just to open the semilunar valve. The heart enters this deadly downward spiral where it is working infinitely harder just to pump a fraction of the blood.
It's like shifting into a higher gear when you're already stalling going up a hill.
That's exactly what it feels like for the organ.
So, if the patient is trapped in that physical downward spiral, how do we fix the physics? The sources highlight an incredible piece of mechanical intervention called the intra-aortic balloon pump.
The IABP, yes.
And the way it manipulates these variables is just fascinating.
It's a masterclass in altering physical environments. It's literally a long polyurethane balloon inserted into the descending aorta.
And it operates on a strict timing cycle using helium gas, right?
Yes. It inflates while the heart is resting and filling, which actually pushes extra blood back into the coronary arteries to feed the heart muscle. But the magic happens in the exact millisecond before the heart squeezes.
Right, the balloon rapidly deflates.
Instantly.
And because it displaces so much volume, that sudden deflation creates a literal vacuum in the aorta. It instantly lowers the environmental resistance, the afterload.
The heart suddenly faces zero resistance, and blood is essentially sucked forward out of the ventricle.
It boosts the stroke volume immediately without requiring a single drop of chemical stimulant to whip the tired heart into working harder.
It physically proves that afterload is not a fixed static reality for a patient. It is a variable that we can manipulate.
Okay, but if the balloon pump is a physical machine that lowers afterload, what do we do when we don't have that machine?
That leads directly into the pharmacology sources.
Right, which focus heavily on two chemically related nitric oxide donor drugs,
Mhm.
nitroglycerin and nitroprusside. They're essentially chemical tools used to do the exact same physical engineering work.
They offer a really perfect contrast in how we manipulate the system. Let's look at nitroglycerin first. At standard doses, it is primarily a vasodilator. It specifically targets and relaxes the smooth muscle in the venous system.
The veins, okay, so because the veins expand, blood pools in the venous system rather than rushing back to the heart.
Yes, exactly.
So you've decreased the venous return, which means you've directly lowered the preload stretch and the resulting wall stress.
Which perfectly explains why a tiny nitroglycerin tablet under the tongue rapidly relieves the crushing chest pain of angina.
Because you are relieving the physical stress on the heart wall.
Precisely. Now compare that to nitroprusside.
Okay, how is that different?
It dilates the veins to reduce preload, just like nitroglycerin, but it also aggressively dilates the arterioles, which are the small branches of the arterial system.
So you were pooling blood in the veins to drop preload, while simultaneously widening the arteries to drop the resistance, effectively lowering the afterload too.
It lowers both sides of Laplace's equation simultaneously. That's why it is a frontline drug for hypertensive emergencies.
Where you need to rapidly unload a struggling ventricle that's fighting against massive arterial pressure.
Right. And the big takeaway here is that nearly every major drug class used for heart failure, diuretics, ACE inhibitors, ARBs, they exist fundamentally to manipulate the geometry of preload or the resistance of afterload. We use pharmacology to make the physical work of squeezing easier.
Okay, here is where it gets really interesting for me. With all these incredibly precise tools, you know, timing balloons to the millisecond, isolating specific veins or arteries with drugs, you would assume the underlying mechanical models taught in medical schools are totally airtight.
You would certainly think so.
But the sources reveal a massive crack in the foundation. We need to talk about the descending limb controversy.
Oh, this is such a good topic.
Because it turns out one of the most famous diagrams in all of cardiology is largely a myth.
It's true. If you open almost any medical physiology textbook from the last 50 years, you will see the Frank-Starling curve drawn as an inverted U.
Right, a curve that goes up and then drops off.
The graph shows that as you increase preload stretch, stroke volume goes up, it reaches a peak, and then it plummets. This is the infamous descending limb.
So the accepted theory was that if you stretch the heart too far, the actin and myosin filaments pull completely past one another.
Yeah, that they lose their overlap, the cross bridges fail, and the heart suddenly loses all contractility.
So generations of doctors and nurses have been taught that heart failure is the result of this pure physical overstretch, like a broken rubber band.
Exactly. But an exhaustive historical review published in 2002 by Dr. Arnold Katz in the journal Circulation dismantled that idea completely.
How did they get it so wrong?
Well, that descending limb was demonstrated in isolated, denervated animal hearts, stripped of all their surrounding tissue and pushed to absolute extremes in a laboratory.
So not a real clinical scenario.
Not at all. In a living, breathing human chest, reproducing that physical overstretch is virtually impossible.
Wait, why is it impossible? What physically stops the filaments from pulling apart?
The human body has intense mechanical limiters built right into its architecture. Externally, you have the pericardium, which is the tough, fibrous sac surrounding the entire heart.
Right.
It acts like a rigid leather bag. Once the heart fills to the volume of that bag, it simply cannot physically expand any further.
It just hits a wall.
Yes. And internally, within the sarcomeres themselves, you have this massive structural protein called titin.
And the text described titin essentially acting like a molecular bungee cord, right?
Very stiff bungee cord, yeah. As the sarcomere stretches, titin tightens. Long before the actin and myosin filaments can pull completely apart, titin reaches its maximum physical length and abruptly halts any further expansion.
So these structures act as a physical straitjacket against the descending limb.
Exactly.
But we know that patients do get volume overloaded and their cardiac output absolutely does drop. If their hearts aren't physically overstretching because the pericardium and titin are stopping them, what is actually causing the curve to flatten out and the pump to fail in real life?
The failure is chemical and structural, not a pure geometric overstretch. In a real patient, the heart fails because of a loss of intrinsic contractility.
Meaning what exactly?
Meaning muscle cells have died from previous heart attacks and been replaced by stiff scar tissue. Plus, the body attempts to compensate by releasing a massive storm of stress hormones, like adrenaline.
Which sounds helpful in the short term.
It is, but eventually those hormones become toxic to the remaining cardiac cells, causing them to fatigue and fail. So the graph flattens, yes, but the mechanism is entirely different than what the inverted U suggests.
So the textbooks got the shape of the graph right, but the physical reason for the shape entirely wrong.
Which is a huge problem.
Right, because holding on to bad models leads directly to dangerous decisions. The sources highlight how misunderstanding this physics leads to critical errors at the bedside. For example, using CVP, that proxy for preload, to blindly administer 2V fluids.
Yeah, for decades, the reflex in the ICU was simple. If the CVP pressure number on the monitor was low, the patient needed more fluid.
Just fill the tank.
Right. But a massive paradigm shift occurred, largely catalyzed by a landmark 1996 JAMA paper by Connors examining Swan-Ganz catheters.
What do they find?
The medical community realized that CVP correlates terribly with actual ventricular volume. The missing variable is compliance, or the physical stiffness of the heart muscle.
Right, because if a patient has a highly non-compliant stiff heart from years of hypertension, it takes very little fluid to rapidly spike the pressure inside that chamber.
And conversely, a very floppy, dilated heart can hold massive amounts of fluid without the pressure number rising significantly.
So if you blindly treat the pressure number on the monitor without considering the physical compliance of the tissue, you might drown a patient in IV fluid they don't need.
Or starve a patient of volume they desperately require.
Wow. Which brings up the absolute scariest misuse detailed in the texts, which is giving a pure alpha agonist vasopressor, specifically a drug like phenylephrine, to a patient who is actively in cardiogenic shock.
Oh, this is so important to understand.
I want to make sure the mechanics of this are crystal clear for you listening. On the surface, a patient in shock has a crashing, dangerously low blood pressure.
Yes.
And phenylephrine is a drug specifically designed to raise blood pressure. Why is giving it a potential death sentence?
Well, to understand the danger, you have to look past the blood pressure monitor and look at the receptor biology. Phenylephrine stimulates alpha receptors in the arterial walls.
Causing them to violently constrict.
Exactly. It raises blood pressure purely by massively increasing systemic vascular resistance.
And as we established when we were defining our terms, systemic vascular resistance is the primary driver of afterload.
Right. So imagine a heart in cardiopathic shock. It is already profoundly weak, struggling just to open the semilunar valve and push a tiny amount of blood forward.
Just barely hanging on.
Right. By administering phenylephrine, you are chemically clamping down on the aorta. You are basically building a concrete wall directly in front of a failing engine.
The tragedy is that the clinician might look at the monitor, see the arterial blood pressure number climb into a quote-unquote safe zone, and falsely believe the patient is improving.
When in reality, the systemic resistance is so high that the stroke volume drops to zero. The heart is beating against an insurmountable wall, forward flow completely ceases, and the vital organs just continue to suffocate.
Chasing a normal blood pressure number while ignoring the underlying physics of afterload will literally kill the patient.
It will.
So as we pull all these sources together, what are the overarching takeaways? We've seen that preload, the diastolic stretch and filling and afterload, the systolic resistance and ejection, they are totally distinct from a simple blood pressure reading.
Very distinct.
Along with contractility, which is the intrinsic strength of the muscle itself, these are the three independent dials that control stroke volume.
And we've explored the sheer brilliance of the Frank-Starling mechanism, how physical stretch alters the chemical locks of troponins to auto-regulate the system.
But we've also confronted the immense danger of relying on flawed proxies like CVP, or holding on to textbook myths like the descending limb when making life or death decisions.
You cannot just treat the numbers on a screen. You have to treat the physical reality of the engine.
Well said.
This deep dive actually prompts a fascinating question about where cardiovascular medicine goes next.
What do you mean?
Well, we established that the notorious descending limb of heart failure isn't caused by overstretch, right? Because of strict physical limiters. The pericardial sac and that giant molecular bungee cord, Titan.
Right, they stop the stretch.
Right now, nearly all our therapies for volume-overloaded heart failure focus on manipulating the fluid. We give heavy diuretics to drain the tank and relieve the pressure.
Just getting rid of the water.
But if the pericardium and Titan dictate the physical limits of the heart's compliance, could the therapies of the future move away from just draining the fluid?
Wait, are you suggesting we somehow alter the limiters themselves?
Imagine if, instead of trying to manipulate the water inside the balloon, we designed pharmacology that chemically altered the elasticity of the pericardium, or instantly made the Titan protein more compliant when the heart begins to fail.
We could fundamentally rewrite the physical limits of the failing engine.
Exactly.
Changing the molecular rubber of the balloon rather than just the water inside it. That is a brilliant concept to leave off on. So the next time you hear a monitor alarm or look at a textbook diagram, remember, you aren't just looking at a squishy bag, and you aren't just looking at a pressure number. You're looking at a dynamic, self-regulating engine governed by strict physical laws. Keep questioning the established models and keep looking for the physics beneath the surface. Thanks for joining us on this deep dive. Picture this. You are sitting in this drafty hospital room, right? You are wearing one of those paper-thin gowns that never actually closes in the back.
Oh yeah, the classic hospital draft.
Exactly. And your stomach is just absolutely growling. Your mouth is as dry as sandpaper, and you are just staring at the clock on the wall. It is 3:00 p.m., and your surgery is scheduled for 4:00 p.m.
Right.
You are agonizing over the fact that you haven't been allowed to drink a single sip of water, like not even a drop to wet your lips, since midnight.
Yeah, I mean, anyone who has ever been prepped for a scheduled procedure knows that exact kind of misery. It really feels like an arbitrary test of endurance right when your anxiety is already peaking.
Right. You sit there wondering if the surgeon's going to cancel your entire operation if you accidentally, like, swallow some tap water while brushing your teeth. And today, that is exactly the mystery we are taking a deep dive into.
It's a huge topic.
It is. We are looking at NPO status, which, for those who don't speak Latin, translates to nil per os, or nothing by mouth.
And, it remains one of the most common orders in all of clinical medicine. But surprisingly, it's also one of the most fundamentally misunderstood by both patients and, honestly, healthcare providers.
We've gathered a really fascinating stack of sources for this deep dive. We are pulling from clinical medical history, modern physiological research on how the stomach actually works, and the official fasting guidelines from the American Society of Anesthesiologists.
The ASA, yeah.
Right, the ASA. Our mission today is to explore the science behind this mandate. We want to look at the historical body count that forced it into existence and uncover why the classic nothing after midnight instruction is actually wildly obsolete.
Even though you will definitely still hear it in hospitals around the world today.
Exactly. Okay, let's unpack this.
Okay.
Because to truly grasp why you are still being told to starve yourself for 16 hours before a routine procedure, we have to look at the sheer terror that created the rule.
We do. And by the end of this deep dive, you will understand that perioperative fasting was never designed to be a punishment. It's an incredibly high-stakes calculation of fluid dynamics and human physiology.
Designed to protect you when your body's natural defenses are chemically shut down.
Exactly. So to understand the origins, we have to go back to an obstetrics ward in the 1940s.
Specifically, the lying-in hospital in New York, right?
In 1946?
Right, 1946. An obstetrician named Curtis Mendelsohn published this landmark paper in the American Journal of Obstetrics and Gynecology, and it completely altered the trajectory of anesthesia.
What did he actually find? Well, he reviewed roughly 44,000 pregnancies at his hospital where general anesthesia had been administered to laboring mothers.
Wow, 44,000 cases. And we need to contextualize what childbirth looked like in 1946, right? Because general anesthesia was practically the default for delivery back then.
Oh, absolutely. And they were typically using ether gas delivered through a very simple face mask.
Just a mask over the face.
Yeah. The clinical reality of that era created a perfect storm. You had these patients who were rendered completely unconscious. Endotracheal tubes, breathing tubes that seal off the airway, those were not standard practice yet.
So these mothers were unintubated.
Right, unintubated. And furthermore, because labor is inherently unpredictable, they were going to sleep with completely full stomachs.
Which is terrifying. And Mendelsohn's numbers really show why. Out of those 44,000 cases, he documented that about 1 in 667 resulted in aspiration.
Which is a terrifyingly high rate for something so catastrophic.
Yeah, I mean, the mothers were passively regurgitating or actively vomiting and inhaling their own stomach contents directly into their lungs.
Right. And I want to break down the mechanics of why that is so uniquely lethal, because when someone aspirates under ether, what is physically happening inside the lung tissue is just devastating.
Break it down for us.
Mendelsohn basically identified two distinct mechanisms of destruction. First, if the mother aspirated solid food particles, it created a catastrophic mechanical obstruction.
Like the food physically blocked the airways.
Exactly. It blocked the bronchi and they asphyxiated. It's mechanical. But the second mechanism was even more insidious. If they aspirated liquid gastric acid, that hydrochloric acid flooded the delicate alveolar sacs.
The sacs where oxygen exchange actually happens.
Right.
Wow. I mean, that sounds like pouring battery acid over the most fragile, permeable tissue in the human body.
That is a very accurate way to picture it. It triggers a massive inflammatory response. The acid essentially strips away the protective lining of the lungs.
Ouch.
Yeah, causing severe chemical burns and pulmonary edema. The lungs literally fill with fluid in response to the burn. And that specific chemical pneumonitis went on to be named Mendelsohn syndrome.
So this was a highly visible, highly traumatic cause of maternal death on the labor ward. And faced with healthy mothers dying from inhaling their own lunch, the medical community panicked.
Obviously. I mean, they had to do something. The emerging field of anesthesiology needed a solution immediately.
And they landed on a rule that was memorable, easily enforceable, and required zero clinical judgment. Nothing by mouth after midnight.
Just a universal mandate. Boom. Done.
Right. But it's like using a sledgehammer when you need a scalpel, you know?
Well, you have to remember, scheduling was completely chaotic in the 1940s. Predicting exact transit times for food in the gut was way beyond their diagnostic capabilities.
So administrators just implemented a blanket cutoff because it was the easiest thing to communicate to a massive nursing staff.
Exactly. I get why they did it in the 1940s. But it seems crazy that they didn't differentiate between someone drinking a glass of water and someone eating an entire steak dinner.
Right. Treating a glass of water consumed at 6 a.m. as the exact same biological threat as a steak dinner consumed at midnight defies basic logic. It completely ignores the nuance of biology.
But for roughly 50 years, institutional dogma just steamrolled physiological reality. The midnight rule became the absolute default setting.
Because NPO after midnight fits neatly on a patient chart, right?
Exactly, and it transfers the burden of compliance entirely onto the patient. But fast forward to the 1980s and 90s, and researchers finally acquired the tools to measure what actually happens inside the digestive tract.
They started questioning the foundational biology of the NPO order. Like, if we're trying to prevent Mendelssohn syndrome, what are we actually trying to control?
And everything hinges on protective airway reflexes. A healthy, awake person possesses a fierce physiological defense mechanism.
Meaning, if gastric juice travels up the esophagus, your body reacts.
Right, the epiglottis slams shut, you cough violently, and you swallow. Your brain fiercely guards your windpipe.
But general anesthesia fundamentally paralyzes that entire reflex arc.
Yes, the gates to the lungs are left wide open. So the ultimate goal, then, is to ensure the stomach is as empty and as non-acidic as possible at the precise moment the anesthesiologist pushes the induction drugs.
The entire scientific endeavor focuses on minimizing those two metrics, gastric volume and gastric acidity.
And so researchers began using ultrasound and aspiration tubes to actually track how different substances influence those two numbers over time.
And they quickly discovered that water and steak take entirely different routes.
Completely different.
The sources highlight that clear liquids, meaning water, black coffee, or pulp-free juice, sluice through the stomach incredibly fast.
Because water requires zero enzymatic breakdown, it essentially bypasses the heavy churning of the stomach, sliding right down the lesser curvature and emptying into the small intestine.
So what's the actual timeline there?
The half-life of a glass of water in an adult stomach is merely 10 to 20 minutes. It clears entirely in about 90 to 120 minutes.
Wow, that fast. But solid food triggers a massive biological cascade.
Oh, yeah. A meal high in fat or protein alerts receptors in the duodenum. Those receptors release hormones like cholecystokinin, which actually clamps the pyloric sphincter shut.
So the stomach basically turns into a blender.
Exactly. It secretes acid and churns the food for hours to liquefy it before it can pass. A heavy, fatty meal can easily remain trapped in the stomach for 8 hours or more.
So recognizing this profound difference in transit times, the American Society of Anesthesiologists officially dismantled the midnight rule.
They did. In 1999, with updates later in 2017, they introduced the evidence-based 2468 rule.
And this operates on a sliding scale of risk, right?
Right. According to the ASA, you need 2 hours of fasting for clear liquids, 4 hours for breast milk,
Okay, what about solid foods?
6 hours for infant formula or a light meal like tea and toast, and a full 8 hours for fried food, fatty food, or heavy meat.
That makes so much more sense. The brilliance of that tier system is its direct mapping to human anatomy. The time frames correspond to the actual ultrasonographically measured emptying curves of the stomach.
Right.
Wait, so under modern rules, if you have a scheduled afternoon surgery, you could theoretically wake up and have a cup of black coffee. Why isn't that happening in the real world?
What's fascinating here is the massive collision between evidence-based medicine and institutional inertia. The data clearly supports a 2-hour window for clear liquids, but the reality on the ground is dictated by habit.
Yeah, we found surveys in the source material showing a stunning disconnect. Surgeons, nurses, and even anesthesiologists continue to order the archaic midnight rule.
Because medical professionals often fall back on what they learned in residency 30 years ago. And there is also this pervasive yet misguided medical legal fear.
They assume that mandating a longer fast provides an extra layer of legal protection.
Exactly. They assume that if something goes wrong, they can say, well, the patient fasted for 16 hours. They prioritize administrative simplicity over physiological optimization.
The assumption is that if 2 hours of fasting is good, 16 hours must be safer. But the sources absolutely obliterate that idea.
They do. Prolonged fasting does not incrementally decrease stomach volume or acidity past that initial emptying window. It actually introduces entirely new measurable harms.
Like what? What happens to a patient fasting that long?
Well, we routinely subject patients to severe dehydration. We induce hypoglycemia, a critical drop in blood sugar, which is super dangerous for pediatric and diabetic populations.
And I imagine they get terrible headaches.
Pounding headaches. And paradoxically, dehydrating the gastric mucosa actually increases the incidence of severe postoperative nausea.
But the most glaring danger of a 16-hour fast is human behavior, isn't it?
Yeah.
When you strip away all hydration and sustenance from an anxious person for an entire day, they get desperate.
Yeah, and desperation breeds noncompliance. A starving, profoundly thirsty patient is highly likely to secretly cheat.
Right. They sneak a sip of water or a quick bite of food in the parking lot before walking into the pre-op area.
And that is terrifying for an anesthesiologist. A secret, unrecorded meal completely blindsides the care team. It is infinitely more dangerous to induce anesthesia on a patient hiding a full stomach than it is to simply allow a documented, controlled, 2-hour clear liquid fast.
So what does this all mean? It means the safe medical tradition was actually making postoperative recovery worse for the patient.
Exactly. And this realization catalyzed a monumental shift in surgical care starting in the early 2000s, known as the ERA's protocol, Enhanced Recovery After Surgery.
And ERA is completely inverted traditional teachings, right?
It did. The ERA's protocol looks at the metabolic disaster of fasting and prescribes the exact opposite. Instead of starving patients, ERAS actively encourages drinking a carbohydrate-rich, clear beverage up to 2 hours before elective surgery.
Wow. I mean, to a practitioner trained in the 1980s, handing a patient a carbohydrate drink right before the operating room probably sounds like malpractice.
It sounded insane to them, but the physiological rationale is airtight. Prolonged fasting forces the body into a severe catabolic state.
Let's explore that mechanism for a second. Why does starvation actively harm the recovery process?
Well, when you stop eating, your brain still demands glucose, right? So to protect the brain's fuel supply, your body releases a surge of stress hormones, cortisol, and glucagon.
Okay, and what do those hormones do?
They force your peripheral tissues to become insulin resistant. Your body essentially locks the cellular doors, preventing muscles from absorbing glucose, and instead begins breaking down your skeletal muscle to harvest amino acids for survival.
So you are intentionally triggering muscle wasting and insulin resistance mere hours before inflicting the massive physical trauma of surgery.
Yes. But by administering a clear carbohydrate beverage at the 2-hour mark, the fluid rapidly empties from the stomach, honoring the safety window.
And more importantly, the sudden influx of carbohydrates triggers an insulin spike.
Exactly. It flips the metabolic switch, the insulin shuts down the catabolic stress response, and pushes the body into an anabolic building state.
You preserve muscle mass, stabilize blood sugar, and drastically improve the body's ability to heal post-operation.
Right. The old midnight tradition was actively sabotaging the patient's recovery.
Okay, so we have mapped out the perfect scenario for elective cases. You control the diet, you time the carb drink, and the metabolism is optimized. But medicine is rarely a perfect scenario.
Oh.
What happens when a trauma patient rolls through the doors or an appendix bursts and we have absolutely no control over the clock?
Well, the entire 2468 framework relies on a verifiable patient history. When an ambulance brings in a multi-trauma patient or a laboring mother needs an emergency C-section, time goes out the window.
Right, you have to assume they just finished eating a massive Thanksgiving dinner.
Exactly. Anesthesiologists label this full stomach precaution. Fasting is a magnificent tool for risk reduction, but in an emergency, physical technique supersedes the clock.
And that's where they use a specialized protocol called rapid sequence induction, or RSI.
Right. And the defining feature of RSI is a physical intervention called cricoid pressure, often referred to as the Selleck maneuver.
It's basically a brilliant mechanical solution to a biological problem.
It really is. An assistant places firm downward pressure on the cricoid cartilage in the front of the patient's neck.
It operates precisely like stepping on a garden hose. Right?
That's a great analogy. By pressing the cartilage backward against the cervical spine, they physically pinch the esophagus shut.
So it creates a mechanical barricade.
Yep. As the paralyzing drugs take effect and those protective reflexes vanish, the pressure prevents any gastric contents from traveling up into the pharynx. And meanwhile, the anesthesiologist rapidly secures the airway with a breathing tube.
Okay, moving from emergency interventions to a fascinating debate buried in the sources, the great chewing gum controversy.
Oh, this is a fun one.
Hospitals have strictly banned chewing gum in the pre-op waiting room for decades.
Right. The prohibition stems from the cephalic phase of digestion. The theory is that the physical act of chewing tricks your brain into thinking a meal is arriving.
So the vagus nerve stimulates the stomach to secrete gastric juice.
Exactly, thereby increasing gastric volume and acidity, which theoretically elevates the risk of aspiration.
The logic sounds sound until researchers actually put it to the test, right?
Right. Clinical studies used ultrasound to track the gastric fluid volume in patients actively chewing gum before surgery.
And what did the data show?
It reveals a slight increase in fluid production, but the volume is completely clinically insignificant. It does not meaningfully alter the risk profile.
Yet, if you try walking into a pre-op holding area, chomping on a piece of gum today, the nursing staff will likely force you to spit it out or even threaten to delay your procedure.
It is a prime example of a ban sustained purely by institutional inertia rather than modern evidence.
Here's where it gets really interesting, though. While chewing gum is a minor administrative annoyance, there is a modern pharmacological curveball actively rewriting the anesthesia rulebook as we speak.
You're talking about GLP-1 receptor agonists.
Yes, drugs like Ozempic, Wegovy, and Mounjaro. These medications have saturated the market for diabetes management and massive weight loss, and they are causing absolute chaos in the operating room.
Because the core mechanism of a GLP-1 drug involves hacking the incretin system to artificially delay gastric emptying.
It essentially freezes the digestive conveyor belt, right? Keeping food sitting in the stomach much longer to promote a constant feeling of fullness.
Which works beautifully for weight loss, but it entirely dismantles the foundation of the 2-4-6-8 rule. Those ASA guidelines assume a normal, functioning digestive tract.
So a patient on Ozempic could strictly follow an 8-hour fast, stop eating at midnight, arrive for an afternoon surgery, and still have a stomach completely full of solid food.
Exactly. The aspiration risk skyrocketed so noticeably that in 2023, the ASA was forced to scramble and publish entirely new consensus guidance specifically targeting patients on GLP-1s.
So what are providers having to do now?
They're having to utilize point-of-care gastric ultrasound. They literally bring an ultrasound machine to the bedside, place the probe over the antrum of the stomach, and physically look through the abdominal wall to grade the volume of contents before they dare administer anesthesia.
Wow.
Yeah. If we connect this to the bigger picture, modern medicine can no longer rely on a wall clock to determine safety. Comorbidities like severe acid reflux, diabetic gastroparesis, and now blockbuster drugs like Ozempic, they demand that medical professionals evaluate every single patient as a unique, dynamic physiological system.
And this evolution in understanding why nothing by mouth matters impacts the healthcare system far beyond the surgical suite. The way a hospital manages MPO status ripples through every department.
Oh, absolutely. Enforcing archaic, prolonged fasting protocols creates massive bottlenecks. It drives up patient dissatisfaction scores, increases the incidence of post-operative delirium in elderly populations, and just wreaks havoc on hospital throughput.
Consider the daily reality of case delays. A patient is handed a piece of paper that says nothing by mouth. They interpret that literally, assuming a single drop of water will ruin the surgery.
Which is totally understandable.
Right, so they skip their essential morning beta blockers or antihypertensive medications. They arrive in pre-op, their blood pressure is dangerously high due to missing their dose, and the entire surgery has to be canceled.
And that's why the clinical nuance of knowing when to instruct a patient to take their essential medications with a small sip of clear water is a critical daily skill for frontline nurses. Fasting is a precision instrument. Used correctly, it ensures a safe anesthetic induction. Applied bluntly, it compromises healing.
I want to leave you with a final thought to mull over regarding the immense power of medical communication.
Yeah.
A patient sitting in a drafty gown, terrified they ruin their surgery by swallowing toothpaste water or suffering a hypertensive crisis because they skipped their heart medication, is really a victim of poor communication.
It's completely preventable.
When the medical establishment relies on outdated blanket phrases like MPO after midnight instead of providing clear, biologically sound explanations, it demonstrates something profound. The words medical professionals use to guide a patient's behavior are just as critical to a successful outcome as the surgical scalpel itself.
Well said.
So the next time you are staring at that ticking clock on the hospital wall, you will know exactly the science, the history, and the physiological balancing act happening behind the scenes. You know, usually when we think about like life-saving daily medications, we picture these incredibly sterile laboratories.
Right, yeah, white coats, beakers, that whole pristine vibe.
Exactly. We expect our medicines to be born from, safety and perfectly controlled environments.
Yeah.
But what if I told you that one of the most widely prescribed foundational classes of cardiovascular drugs in modern history didn't start in a pristine lab?
It really didn't.
What if it started with a deadly toxin that triggers basically catastrophic internal collapse?
Yeah.
Okay, let's unpack this, because the origin story of the drug that you, or maybe your grandparents, take every single morning involves a highly venomous snake right in the middle of the Amazon.
It is honestly the ultimate medical paradox. I mean, we took the exact mechanism that a predator uses to kill its prey, and we sort of reverse engineered it to keep millions of human hearts beating.
It's wild. And whether you are a nursing student frantically cramming for your next pharmacology exam, or you're just an insanely curious learner trying to understand modern medicine, this deep dive is absolutely for you.
Yeah, today we're looking at ACE inhibitors.
Right. You probably know them as the prill drugs, like lisinopril, captopril, and elapril. They're universally known as, blood pressure pills.
Which is true, but also a huge understatement.
Totally. Our mission today is to look at the sources and uncover why that label is actually doing the drug a disservice. We're going to explore why this drug is truly a heart remodeling powerhouse and how its most annoying, infamous side effects are directly linked to its superpowers.
Yeah, and to really grasp how these medications alter the architecture of the human body, we basically have to travel back to the Brazilian rainforest in the 1960s.
Okay, set the scene for us.
So researchers specifically, a Brazilian pharmacologist named Sergio Ferreira and a British pharmacologist named John Vane, were studying the venom of the Bothrops siraca.
And that's a deadly pit viper.
Exactly, a pit viper. And they noticed this very specific, immediate physiological effect in people who actually survived the snake bites. The venom caused a sudden, massive, and incredibly dangerous drop in blood pressure.
Like it essentially just bottomed out their cardiovascular system.
Right. And Ferreira isolated specific peptides from this venom. He called them bradykinin potentiating peptides, or BPPs.
BPPs.
Yeah, and he discovered that these peptides worked by blocking an enzyme in the human body that normally degrades a substance called bradykinin.
Right, so the venom stops the degradation, and then bradykinin just builds up. And since bradykinin is a massive vasodilator, meaning it, forces your blood vessels to open wide, the victim's blood pressure just completely plummets.
Which was a profound discovery all on its own. But the real scientific lightning bolt struck when researchers realized that this enzyme, the one that destroys bradykinin, actually has a second, completely different job in the human body.
Wait, really?
Yeah. Kininase II, which is the enzyme the snake venom was blocking, is actually the exact same molecule as angiotensin-converting enzyme, or ACE.
Oh, wow. So it's one enzyme doing two totally different jobs.
Exactly.
It destroys bradykinin, but it creates angiotensin II. And angiotensin II is a potent vasoconstrictor that spikes your blood pressure.
Right, so the snake venom was accidentally turning off the body's pressure-raising system while simultaneously cranking up the pressure-lowering system.
That's amazing. So the pharmaceutical industry sees this dual action mechanism, and I'm guessing immediately knows they need to put it in a pill.
They did, but turning venom into a pill proved immensely difficult. I mean, the first candidate was a compound called tepratide.
Okay. Did it work?
It worked beautifully to lower blood pressure in humans in the early 1970s, but there was a massive catch. It only worked if you gave it intravenously.
Ah, right. Because it was a peptide, if you tried to swallow it as a pill, your stomach acids and digestive enzymes would just chew it up and destroy it instantly.
Exactly. And a daily IV drip isn't exactly a practical solution for someone managing chronic high blood pressure at home.
Right, nobody wants to drag an IV pole around their living room forever.
Definitely not. So in the late 1970s, two chemists at the pharmaceutical company Squibb Miguel Ondetti and David Cushman took on the challenge of creating an oral version.
And they didn't just guess, right?
No, rather than blindly testing thousands of random chemicals to see what might block this ACE enzyme, they pioneered something revolutionary for the time, which was structure-based rational drug design.
Okay, here's where it gets really interesting for me. You can think of what Ondetti and Cushman did, like high-stakes lock-picking.
I like that analogy, yeah.
Back then, standard drug discovery was often like having a giant bucket of random keys and just jamming them into a lock one by one, hoping one eventually turns. But these two chemists took a totally different approach.
They studied the lock itself.
Exactly. They used a model of a related, well-understood enzyme carboxypeptidase A to map out the internal tumblers of the ACE active site. Once they knew the exact molecular shape of the lock, They custom forged the precise molecular key to fit inside and jam the mechanism,
And that custom-forged key was a small, orally stable molecule that could actually survive the human digestive tract.
which became captopril, right?
Yes, gaining FDA approval in 1981. It was an absolute triumph of rational drug design, happening years before the advanced computer modeling we rely on today even existed.
But captopril wasn't totally perfect, was it?
No, it wasn't without its flaws. It contained a specific chemical feature, a sulfhydryl group.
Which is basically just a sulfur-containing part of the molecule, right?
Right. And that sulfur group caused some pretty nasty side effects for some patients, specifically skin rashes and a condition called dysgeusia.
Dysgeusia. That's where you either develop a terrible metallic taste in your mouth or just lose your sense of taste entirely. That sounds awful.
It was. So chemists went back to the drawing board to refine that molecular key, and that effort led to the second-generation ACE inhibitors.
By getting rid of the sulfur group.
Exactly.
Yeah.
By removing the sulfhydryl group, they developed drugs like enalapril in 1985, followed by lisinopril and ramipril. They completely eliminated the metallic taste and the rashes.
And as a bonus, these new versions had much longer half-lives. So instead of taking captopril like 3 times a day, a patient could take lisinopril just once or twice a day.
Much better for patient compliance, yeah. And the generic names all end in pril, which is why they are affectionately called the prils in clinical practice today.
Okay, so now that we understand how they built the perfect molecular key to block this ACE enzyme, we need to look at what this enzyme is actually doing to our blood pressure in the first place.
We have to decode the RAAS cascade.
Right, the renin-angiotensin-aldosterone system. This is essentially the body's master control panel for long-term blood pressure and fluid regulation.
Let's walk through this highly calibrated system step by step because it's crucial.
Let's do it.
Step 1, your kidneys constantly monitor your blood pressure and blood volume. If your pressure drops or if the sodium delivery to the kidneys falls, specialized cells in the kidneys release an enzyme called renin.
Okay, so renin is step 1. Then step 2, that renin enters the bloodstream and acts like a pair of biological scissors.
Right, it finds a protein produced by your liver called angiotensinogen, and it snips a piece off.
Creating angiotensin of firth, but at this stage, angiotensin I is completely inactive. It just circulates, waiting for instructions.
Which brings us to step 3, the crucial moment. As that inactive angiotensin I flows through your blood, it reaches the lungs.
And the blood vessels in your lungs are heavily coated with ACE, angiotensin-converting enzyme.
Exactly. ACE grabs that inactive angiotensin I and converts it into the highly active hormone angiotensin II.
And angiotensin II is an absolute quadruple threat.
It really is.
First, it immediately constricts your blood vessels, spiking your blood pressure right now. Second, it signals your adrenal glands to release aldosterone,
Which forces your kidneys to hold on to sodium and water, increasing your total blood volume and raising the pressure even more.
Right. Third, it stimulates your brain to make you aggressively thirsty.
And fourth, and this is honestly the most critical point for long-term health, angiotensin II promotes pathological growth and scarring of the heart muscle and blood vessel walls over time.
We call this hypertrophy and fibrosis.
Yeah. So when a patient takes an ACE inhibitor, we block step 3. We stop the production of angiotensin II.
The vessels relax, so pressure drops. The kidneys stop retaining all that extra sodium and water.
Although it is vital to note here, because aldosterone levels drop, your body ends up holding on to potassium instead of excreting it in the urine.
Right, that is why hyperkalemia, dangerously high potassium, is a major monitoring concern for anyone taking a pril drug.
Absolutely. But what's fascinating here is how beautifully this illustrates the one enzyme, two jobs concept we saw with the snake venom.
How so?
By inhibiting ACE, the drug stops the dangerous angiotensin II. But because ACE is the exact same molecule as kinase T in it, the drug simultaneously prevents the destruction of bradykinin.
So bradykinin builds up, causing extra vasodilation, which pushes the blood pressure down even further.
Exactly.
Okay, let me push back on this whole concept for a second, though.
Sure, go ahead.
Angiotensin II is a highly conserved, natural evolutionary mechanism. It's a system designed to keep our blood pressure up and keep us alive if we get, say, severely dehydrated or suffer trauma and start bleeding.
That's true.
So aren't we just disabling our body's own critical emergency survival system?
It's a great question. Evolutionarily, yes, the RAAS cascade kept our ancient ancestors alive when they were running from predators or surviving droughts.
Right.
But modern humans live much longer, and we deal with chronic conditions like hypertension, diabetes, and obesity. Those chronic conditions leave the survival system permanently switched on.
Aye.
When angiotensin II is chronically elevated for years, that emergency response becomes toxic. Think of it like a fire alarm that just never turns off.
It literally remodels the heart, making it stiff, scarred, and weak.
Exactly. We aren't disabling a necessary survival system. We are turning off a false alarm that is slowly destroying the house.
That makes total sense.
Yeah.
But dealing with the angiotensin side comes with a highly specific, very famous catch on the bradykinin side.
Yes, it does.
Because when you block an enzyme with two jobs, you can't control just one of them.
You're talking about the infamous Prill cough?
Yes, the cough. Let's clear up a massive misconception about this. When bradykinin accumulates, it doesn't just lower blood pressure. It severely irritates the sensory nerve fibers in the airway.
Which causes a dry, persistent, tickling, non-productive cough.
And it affects roughly 5 to 20% of patients, with higher rates generally reported in women and people of Asian descent, likely due to, genetic differences in how bradykinin is metabolized.
Right. But the big misconception is that this cough is an allergy.
Yes, it is absolutely not an allergic reaction.
And that distinction is crucial for clinical practice. Because it's not an allergy, it is a mechanism-based class effect.
So if a patient develops this maddening cough on lisinopril, switching them to enalapril or ramipril will not solve the problem.
Not at all. The entire class of ACE inhibitors has to be abandoned because they all do the exact same thing to bradykinin. You have to switch the patient to a completely different class of drugs, like an ARB.
But the bradykinin buildup can trigger something far more serious than a cough, too. Angioedema.
Yes. This is rapid, localized tissue swelling, often in the face, lips, tongue, or airway.
And there's a dangerous misconception here, too. Patients often think, well, I've been taking lisinopril for 5 years without any problem, so I'm safe.
That's a huge mistake. The risk is highest in the first few weeks of starting the medication, sure, but angioedema can emerge at literally any point during therapy.
Wow, anytime.
Yeah, a patient could take the drug uneventfully for a decade and suddenly wake up with life-threatening airway swelling. Any new facial or tongue swelling on an ACE inhibitor is an immediate, drop-everything medical emergency.
That's terrifying.
It is. We also have to acknowledge a well-documented disparity here. Black patients have a 2 to 4-fold higher risk of developing this angioedema compared to other populations.
It's wild to visualize how this works. Think of the heart and vessels as a town threatened by a catastrophic downstream flood. That's the damage caused by angiotensin II.
Okay, I'm with you.
Taking an ACE inhibitor is like building a massive dam to stop that flood. It saves the town, but the water has to go somewhere.
Right, it backs up.
Exactly. It backs up and overthrows the reservoir, flooding a nearby neighborhood. That overflowing reservoir is the bradykinin causing the cough or the angioedema. The bug and a piece of the feature are mechanistically inseparable.
It's the biological price of admission for altering such a fundamental pathway. Yet these drugs remain among the most widely prescribed in the world.
Why is that?
Because they fundamentally change the trajectory of human organs.
To understand why this drug class represents a massive paradigm shift in modern medicine, we basically have to look at how medical thinking evolved, starting in the late 1980s.
Right, because at that time, doctors viewed heart failure as a one-way street. The heart got weaker, you gave patients diuretics to pee out excess fluid to manage their symptoms, and eventually the heart just gave out.
Then came the consensus trial in 1987. Researchers took patients with NYHA class 4 heart failure, meaning these patients had severe, exhausting symptoms, even while just sitting still in a chair.
The worst of the worst cases.
Exactly. They added enalapril to their standard therapy, and the results showed a shocking 40% reduction in 6-month mortality.
If we connect this to the bigger picture, we really have to ask why mortality dropped so drastically. It wasn't just because their blood pressure was a little lower.
It goes deeper than that.
It comes back to angiotensin II acting as a toxic cellular construction foreman. When the heart is failing, chronic angiotensin II tells cells called fibroblasts to lay down dense collagen.
It replaces flexible, healthy heart tissue with rigid scar tissue.
Yes. And enalapril essentially fired that foreman. It stopped the collagen deposition, allowing the heart to maintain its flexibility and compliance.
Suddenly, heart failure became a disease you could actively treat and slow down at the cellular level.
Exactly. And once researchers realized they could rescue patients in the final stages of heart failure, a new question naturally emerged.
Could we use this exact same mechanism earlier to stop the damage from happening in the first place?
Right. And that led to the SAVU trial in 1992. They gave captopril to patients who had just survived a heart attack and had suffered damage to their left ventricle.
Because when part of the heart muscle dies during a heart attack, the rest of the ventricle tries to compensate by stretching out, right? Like a rubber band stretched too many times until it gets flabby and loses its snap.
We call this ventricular dilation.
So what did captopril do?
Captopril halted that structural ballooning. By blocking angiotensin II early, they prevented the heart from pathologically stretching and dilating over time. It stopped the structural remodeling before it could destroy the organ's pumping efficiency.
That is incredible, and that success pushed the boundary even further. If it works for severe heart failure, and it works immediately after a heart attack, what if a patient hasn't had a heart attack at all, but they are just at high risk?
Which brings us to the HOPE trial in the year 2000.
They gave ramipril to high-risk patients, people with vascular disease or diabetes, who did not have heart failure, and who do not even have particularly high blood pressure.
Yet the drug significantly reduced heart attacks, strokes, and cardiovascular death.
The HOPE trial basically proved that blocking angiotensin II cools off vascular inflammation, didn't it?
Yes. Angiotensin II creates oxidative stress inside the endothelial lining of your blood vessels, making plaques unstable and prone to rupturing. Ramipril stabilized those vessels.
Wow.
These three major trials forced a total redefinition of the drug class. ACE inhibitors were no longer just blood pressure pills. They became cardiac and renal remodeling inhibitors that provide massive organ protection entirely independent of the blood pressure numbers.
So what does this all mean? If blocking this RAAS pathway is so miraculous, and it saves lives by protecting the heart and cooling off vascular inflammation, why don't we just hit the pathway harder?
What do you mean?
Like, why don't we use multiple drugs to block the cascade in 2 or 3 different places at once to get double the protection?
It sounds incredibly logical. I mean, the medical community thought more is better, too.
Yeah.
But when they rigorously tested that hypothesis, it failed spectacularly.
Really? How so?
Well, in 2008, the ON-Target trial tested an ACE inhibitor, ramipril, alongside an ARB, telmisartan.
An ARB is an angiotensin receptor blocker, right? It works one step further down the chain.
Exactly. Instead of stopping the production of angiotensin II, it just blocks it from binding to its receptor. The theory was, block the production and block the receptors for maximum defense.
Sounds foolproof.
But the reality was double the harm. The combination produced zero added cardiovascular benefit, but significantly increased adverse events.
Oh, wow.
Yeah, patients suffered severe hypotension, kidney impairment, and dangerous hyperkalemia. It became the definitive textbook example of why more drugs blocking the exact same pathway isn't automatically better. You cannot routinely combine ACE inhibitors and ARBs.
And the cardiology world faced another massive shakeup in 2014, didn't they? With the Paradigm HF trial.
Yes, they did. For 30 years, ACE inhibitors sat on the throne as the untouchable holy grail first-line treatment for heart failure.
But this trial tested them against a newer class of drugs called ARNIs, right?
You're right.
Angiotensin receptor neprilysin inhibitors, specifically a combination of sacubitril and valsartan.
And the RNIs reduced mortality so much more effectively that the trial was actually stopped early. Today, RNIs have largely dethroned ACE inhibitors in standard heart failure guidelines.
But that transition isn't just a simple swap, is it?
No, and this raises an important question regarding clinical safety, particularly for nurses managing these medication transitions.
Right.
ARNIs don't just block angiotensin receptors, they also inhibit an enzyme called neprilysin, and inhibiting neprilysin also increases bradykinin.
Uh-oh. So if you combine an ARNI with an ACE inhibitor,
You get a massive overlapping surge of bradykinin leading to an extreme risk of life-threatening angioedema. You can never combine them.
so what's the protocol?
Clinical guidelines enforce a strict 36-hour washout period when switching a patient from an ACE inhibitor to an ARNI to let the first drug completely clear the system.
We also have to talk about a massive trap regarding the kidneys. Throughout this deep dive, we've discussed how ACE inhibitors are renoprotective.
Yes, they protect the kidneys, especially in diabetic kidney disease, by lowering the pressure inside the tiny filtering units.
But in one specific condition, that exact protective mechanism becomes destructive.
The condition is bilateral renal artery stenosis, meaning the main arteries feeding blood to both kidneys are severely narrowed or clogged.
And the kidneys need a certain amount of pressure inside their filters to push waste out into the urine, right?
Right. In patients with this condition, angiotensin II acts as a clamp on the exit pipe of the kidney filter, keeping the internal pressure high enough to actually clean the blood despite the really poor inflow.
So if you give an ACE inhibitor to a patient with bilateral renal artery stenosis, You take away that crucial exit clamp.
Exactly. The internal pressure drops to zero, filtration completely stops, and you instantly throw the patient into acute kidney failure.
The mechanism that protects 99% of kidneys will shut down the kidneys in this specific patient. That is wild.
And a similarly devastating biological effect occurs during pregnancy. ACE inhibitors are a well-documented teratogen and are absolutely contraindicated in the second and third trimesters.
Why is that?
A developing fetus literally requires its own angiotensin II for normal kidney development. If a pregnant patient takes an ACE inhibitor, it blocks that fetal development, causing fetal renal failure.
Oh, man.
This leads to dangerously low amniotic fluid, a condition called oligohydramnios, which subsequently causes severe skull and lung malformations in the baby.
It's tragic. A drug that saves an adult's organs can prevent a child's organs from ever forming. We have covered an enormous amount of ground today, traversing from the venomous predators of the Amazon basin to the cellular mechanisms of massive clinical trials. Let's rapidly synthesize the 5 exam-style takeaways from our sources for everyone listening.
Number 1. Same enzyme, 2 jobs. ACE creates the damaging angiotensin II, but it also destroys bradykinin. That dual action is exactly why one single drug provides both the therapeutic benefits and the classic side effects.
Number 2. The cough is bradykinin, not allergy. It's a mechanism-based class effect. You can't just switch a coughing patient to a different prill. You have to change the entire class of medication.
Number 3. Protective beyond pressure. As proven by the Consensus, SAVE, and HOPE trials, these drugs prevent cellular remodeling, stop fibrosis, and reduce mortality in ways that are totally independent of simply lowering the blood pressure numbers.
Number 4. Watch the kidneys, watch the potassium, and watch for pregnancy. They can cause hyperkalemia. They will cause acute renal failure in patients with bilateral renal artery stenosis, and they are strictly teratogenic in the second and third trimesters.
And number 5. Angioedema is a lifelong, unpredictable risk. It is not just a first-week side effect. Any new airway, lip, or tongue swelling in a patient taking a prill drug, even 10 years into therapy, is a drop-everything medical emergency.
As we wrap up this deep dive, I want to leave you with one final thought to mull over. We learned today that captopril, the blueprint for an entire class of life-extending cardiovascular drugs, was reverse-engineered from the venom of a Brazilian pit viper using early structure-based design.
It really makes you wonder.
It does. If one of modern medicine's most foundational, organ-protecting miracles was hiding in the venom glands of a snake, just waiting for the right chemist to unlock its geometry, how many other miraculous, life-saving cures are currently slithering or crawling or growing deep in the rainforest right now, just waiting for us to decode their secrets before their habitats disappear forever?
It really forces us to acknowledge how much of our future medical survival might be deeply tied to the wild, untouched corners of the world.
The ultimate paradox. The venom evolved to cause catastrophic internal collapse, gave us the exact blueprint to keep millions of human hearts beating steadily year after year. Thanks for joining us on this deep dive. We'll catch you on the next one.
I want you to think back to the very first test you ever took in your entire life. You definitely didn't study for it. And, well, you didn't even know it was happening.
Right, because it happened within literally 60 seconds of you being born.
Exactly. And it was graded on this really rigid scale of 0 to 10.
It is basically the ultimate pop quiz.
Yeah.
And, arguably it's the most high-stakes assessment any of us will ever face, just given what those numbers dictate right after birth.
Yeah. So today we're taking a deep dive into the APGAR score. And whether you're like a nursing student prepping for an exam or just an insanely curious learner, this is going to be your definitive guide to how a newborn is scored in those first 60 seconds. It's such a fascinating topic, too.
It really is. Our mission today is to unpack the surprising, honestly kind of accidental origin of this universal checklist, break down what the 5 criteria actually measure biologically, and, explore how a simple 0 to 10 scale from the 1950s became the center of these massive modern controversies. Yeah, because the APGAR score is almost always taught as this fixed, timeless pillar of medicine. Like you learn the textbook definition, which is a rapid clinical checklist used to summarize a newborn's condition.
Right.
But its identity has shifted so dramatically over the years. I mean, it went from being this marginalized data collection tool to a literal life-saving trigger, and then eventually to a heavily distorted piece of legal evidence.
Which is wild But before we get into how the test works today, we really need to understand the environment that made it so desperately necessary in the first place. Because if we transport ourselves back to a delivery room in the early 1950s, we are not looking at the hyper-specialized, highly monitored room we expect today.
Not at all. The historical context is, frankly, a bit jarring. Back in the 50s, essentially all clinical attention was trained entirely on the laboring mother.
Just the mother.
Yeah, the obstetrician's job was to deliver the baby and just ensure the mother survived the process, which, I mean, was still remarkably dangerous at the time.
Wow, okay.
So once the baby emerged, if it looked pale or limp, or maybe was barely breathing, the medical team would often just set the newborn aside, like sometimes literally on a side table covered with a towel.
Wait, just left on a table? That sounds completely unthinkable now. I mean, you'd expect immediate alarms and a whole rush of pediatricians.
Right, but the paradigm was entirely maternal-focused, and compounding that danger was this complete lack of shared vocabulary for a baby in distress. If a newborn wasn't doing well, a doctor or nurse might just, jot down a vague impression on the chart.
I like what?
Things like poor color, breathing poorly, or literally just looked bad.
Looked bad. That is terrifyingly unscientific. I mean, that tells the next nurse coming on shift absolutely nothing about the baby's actual physiological state.
Exactly. It varied wildly depending on who happened to be looking at the baby, and frequently it wasn't even recorded at all. There was no standardized scale, no objective way to communicate urgency.
And that chaotic, super subjective environment is where we meet our innovator, Dr. Virginia Apgar. She is an absolute legend in medical history.
Oh, absolutely. She was an anesthesiologist at Columbia University's College of Physicians and Surgeons. And in 1949, she became the first woman appointed as a full professor there.
Which, in the mid-20th century medical establishment, is just a monumental hurdle to clear.
Yeah, and her background adds this really fascinating layer to it. She had actually trained as a surgeon in the 1930s, but she was actively steered away from surgery, which was the prestigious male-dominated field, toward the newer, lower-status specialty of anesthesiology.
Her mentor essentially told her that a female surgeon would never find financial backing or patient trust, right?
Exactly. So she took that redirection and just poured her brilliance into anesthesiology. She almost single-handedly built the anesthesia division at Columbia's Sloan Hospital for Women.
Which put her directly in the delivery room for thousands upon thousands of births.
Right. And her entire career as an anesthesiologist was built on vigilance. I mean, when you're keeping someone under anesthesia, your whole job is to watch for the most subtle, minute warning signs of physiological distress.
You're obsessively monitoring breathing, color, pulse.
Yes. So when she saw these pale, limp babies being ignored on side tables, her instinct was to apply that exact same rigorous observational discipline to the very first seconds of life outside the womb.
But according to our sources, she didn't actually set out to invent a global triage tool, right? Like, the most famous newborn assessment in the world started out as a basic data collection spreadsheet for a research paper.
Yeah, she was just trying to answer a really specific scientific question. She wanted to know, did the anesthesia given to a laboring mother affect how well her baby handled the transition to life?
Okay, so to study that, she needed to standardize her observations.
Exactly. She needed a consistent way to grade the babies so she could compare the data across hundreds of deliveries.
Wait, so you're telling me the most famous newborn triage tool in the world wasn't even meant to be a triage tool? It was just a spreadsheet. That's like a scientist accidentally inventing the modern fire alarm while they were just trying to measure room temperature for like a thermodynamics paper.
That is a great comparison. She was just doing her research. And there's this fantastic origin story that circulates in nursing schools about how she actually finalized the criteria.
Oh, the cafeteria legend?
Yes. The legend goes that a medical student asked Dr. Apgar over breakfast in the hospital cafeteria how one might systematically evaluate a newborn. And she supposedly said, "That's easy. You just take 5 signs and score them," and sketched the whole system out on a scrap of paper right there over her coffee.
Which is amazing. I mean, we don't know for certain if it happened exactly that way, but she did formally publish this system in 1953. And it caught on so rapidly because it solved a massive, complex problem for $0.
Right. It required no specialized equipment. It took under a minute, and it gave every nurse, midwife, and doctor in the room the exact same objective number to shout out.
So she realizes observation is key, but human beings are incredibly subjective. How did she actually force doctors to measure a baby objectively using just their eyes and hands? Let's break down the mechanics of the checklist.
Well, we should probably clear up a massive misconception first.
Oh, right. Because if you ask anyone who works in obstetrics what APGAR stands for, they'll probably list off appearance, pulse, grimace, activity, and respiration. APGAR. Except she didn't name it that.
No, she didn't. The acronym is a total myth, or more accurately, it's a backronym. Virginia Apgar published the original scale under her own surname, purely by coincidence.
A full decade later, right? Around 1963.
Yeah, about 10 years later, a pediatrician named Dr. Joseph Butterfield realized that her name perfectly aligned with the 5 vital signs of birth. So he coined the APGAR mnemonic as a teaching device for his medical students, just to help them memorize the criteria.
That is an unbelievable stroke of historical luck for her legacy. I mean, to have your name literally spell out your invention.
It really is.
So let's look at those 5 vital signs. Each of the 5 criteria gets a score of 0, 1, or 2. And you add them up at the end for a total score out of 10. Let's start with the A in the mnemonic appearance. This assesses skin color, right?
Yes, skin color. Because it's a visual proxy for how well oxygenated blood is reaching the extremities. A score of 0 means the baby is pale or blue all over.
Okay, and 1.
1 point is given if the body is pink, but the hands and feet are still blue. The medical term for that is aquacyanosis. And then 2 points if the baby is entirely pink from head to toe.
So a baby having blue hands, but a pink body, it's kind of like turning on the central heating in a really large house. The core, like the living room where the thermostat is, gets warm super fast, but the radiators in the furthest guest bedrooms take a few minutes to catch up.
That is the exact physiological mechanism at work. Peripheral circulation is the very last thing to fully open up after birth. The newborn's body is naturally prioritizing sending highly oxygenated blood to the brain, the heart, and the lungs.
So the hands and feet can wait.
Exactly.
Which means appearance is the category most likely to produce a perfectly healthy baby who never scores a 10.
Oh yeah, generations of nursing students are shocked to learn that a perfect 10 is actually quite unusual. If you were to check your own birth records or, your kids' records, you might see an 8 or a 9.
Most vigorously screaming, incredibly healthy babies score a 9 just because their hands and feet are a little blue for the first couple of minutes.
Right, it's completely normal.
Well, that should relieve a lot of nervous parents reading their charting. So next up is P for pulse, meaning heart rate.
Right. A score of 0 means no heartbeat. 1 point is given if the heart rate is below 100 beats per minute, and 2 points if it is 100 or above. And I really want to emphasize this category because it is the single most heavily weighted piece of clinical information in the entire score.
Because it dictates the immediate response in the room, right? Like, if that heart rate is under 100, you aren't waiting around to finish the rest of the checklist.
Exactly. A low heart rate at 1 minute is the fastest, most reliable trigger for a neonatal resuscitation team to intervene. Long before they evaluate muscle tone or color, if they hear a heart rate dipping into the 80s or 90s, the protocols demand immediate action.
Like clearing the airway and providing positive pressure ventilation?
Yes, immediately.
Okay, moving down the acronym to G-grimace, or reflex irritability. I imagine testing reflexes in a newborn is tricky. You can't exactly ask a 1-minute-old baby to follow a pen with their eyes or, tap their knee with a hammer. You'd have to rely on raw physical stimulus, right? Like tickling their feet.
Close to tickling, yes, but a bit more robust. Classically, the provider will flick the sole of the baby's foot, or they'll observe their reaction when a suction bulb is placed in their nose or mouth to clear fluids.
And how is that scored?
0 points means no reaction at all. 1 point for a weak grimace or a weak cry, and 2 points for a vigorous cry, a cough, a sneeze, or the baby actively pulling their foot away from the stimulus.
So it gives the team a real-time assessment of how intact and responsive the central nervous system is.
Precisely.
Then we have A for activity, which measures muscle tone. 0 points for a completely limp, flaccid baby, 1 point for some slight flexing of the arms and legs, and 2 points for active, spontaneous movement. Now, why is muscle tone such a critical indicator of oxygen?
Because muscle tone is one of the earliest physiological functions to drop when a baby is short on oxygen. The newborn brain is incredibly efficient and honestly ruthless about survival.
What do you mean?
If it senses hypoxia, a lack of oxygen, it will sacrifice skeletal muscle tone just to preserve the remaining oxygen for the vital organs.
Oh, wow. It just shuts off the power to their arms and legs to keep the main generator running.
That's a perfect way to put it. That's why a floppy baby is a universally recognized red flag in obstetric nursing. It tells you the oxygen reserves are critically depleted.
And finally, the R respiration or breathing effort. 0 for no breathing, 1 point for slow, irregular, or gasping breaths, and 2 points for a strong, regular cry.
Which is that lusty, echoing cry every parent in the delivery room is holding their breath to hear.
Yeah.
That sound represents a massive physiological shift. It is literally the sound of fluid being pushed out of the alveoli in the lungs, air rushing in, and the baby's respiratory system taking over the job that the umbilical cord has been doing for the last 9 months.
Incredible. So you tally those up, 0 to 10. Generally speaking, a 7 to 10 is reassuring. 4 to 6 is moderately abnormal. 0 to 3 means serious, life-threatening distress.
Right.
But, it feels completely counterintuitive that a doctor armed with just a stopwatch in their eyes could outperform modern technology. We live in an era of, Apple Watches, instant blood panels, continuous fetal monitoring. You'd assume a visual checklist from 1952 would have been replaced by high-tech lab equipment decades ago.
You definitely assume that. But the clinical data says otherwise. And this brings us to this foundational study published in the New England Journal of Medicine in 2001 by Dr. Brian Casey and his colleagues.
Oh, this is the one where they tested the old-school APGAR score against a highly invasive, high-tech chemical measurement, right? Umbilical cord blood pH. Let's explain what that blood test actually measures, because it sounds like the ultimate objective gold standard.
Biologically, it is. When a baby is deprived of oxygen during labor, their body switches to anaerobic respiration to survive. That process produces lactic acid as a byproduct.
Okay.
So by drawing blood directly from the umbilical cord right after birth and measuring the pH of the acidity, you get a highly precise chemical snapshot of oxygen deprivation.
So it's literally human observation versus a precise chemical blood analysis.
Exactly. And what Dr. Kissey's team found after examining nearly 152,000 births was just staggering. A 5-minute APGAR score of 3 or less predicted neonatal death in the first 28 days of life, better than the high-tech umbilical cord blood pH test.
Wait, really? How does that even make sense? How does a person just looking at a baby beat a definitive chemical analysis of their blood?
It reveals something really profound about the difference between a static data point and dynamic biology. A lab test gives you a number about the chemistry in the blood at 1 exact millisecond in time.
Right.
But a 60-second visual checklist performed by a trained human being captures a holistic picture of transitional physiology. It captures the heart actually pumping, the brain reacting to stimulus, the lungs expanding, the muscles firing.
It synthesizes the entire organism's struggle to adapt to the outside world.
Exactly. Whereas complex chemistry can sometimes miss that bigger picture of resilience.
The word resilience is key there, especially regarding the timing of the score. Because Dr. Apgar originally intended for this to be checked just once, at exactly 1 minute after birth.
Right. But clinicians quickly realized that the 1-minute score essentially reflects how rough the labor and delivery process was. It acts as a baseline trigger. If the score is low at 1 minute, you start clearing the airway, giving oxygen, or beginning compressions.
But the 5-minute score reflects something entirely different. It reflects how well the baby is responding to the help they are being given.
Yes. And today, the medical guidelines reflect that ongoing assessment. If a baby's 5-minute score is still below a 7, the team doesn't just stop scoring. They will assess the baby again at 10 minutes, 15 minutes, and even out to 20 minutes of life, charting the trajectory of the baby's recovery.
That makes a lot of sense. But because this number is universally recorded on every single birth chart, and because it's so easy for anyone to understand, it's a simple grade between 0 and 10, it inevitably became a weapon outside the delivery room.
Unfortunately, yes. Specifically, it became a focal point in birth injury and cerebral palsy litigation.
For decades, it was a favorite battleground for plaintiffs' attorneys. You can easily imagine the scenario in a courtroom. A lawyer presents a medical chart to a jury of laypeople and says, look, the baby scored a 2 out of 10. That is a failing grade. This is absolute proof of birth asphyxia.
The hospital negligently deprived this baby of oxygen, and that negligence caused this child's permanent brain damage.
Right. And it's incredibly persuasive. We are all conditioned from kindergarten to view a low score as a failure. But you're trying to use a 1-minute snapshot of a rough transition to predict a 60-year lifespan.
It's completely out of context.
It feels like looking at a basketball team having a terrible first quarter, like maybe they're down by 20 points. If you immediately declare that the coach is legally negligent, the players are terrible, and the franchise is permanently ruined, you're ignoring the rest of the game.
That is exactly it. Meanwhile, there are 100 other reasons they might be playing poorly in that specific quarter. The opposing team is shooting unusually well, your star player has the flu, or it's just a random cold streak.
Yeah.
In the medical context, there are dozens of reasons a baby might have a low APGAR score that have absolutely nothing to do with negligent oxygen deprivation.
Such as maternal sedation crossing the placenta, or, congenital anomalies and underlying infection, or just a difficult but entirely non-negligent delivery process. A low score is a symptom, not a definitive diagnosis of the root cause.
Right, and this legal misuse became so widespread and so damaging to the medical community that in 2015, the two biggest governing bodies in the field, the American College of Obstetricians and Gynecologists and the American Academy of Pediatrics, had to formally issue a joint committee opinion.
Oh, wow. What did they say?
They explicitly stated that the APGAR score alone cannot diagnose asphyxia, and it is a poor predictor of an individual baby's long-term neurological outcome.
They essentially had to draw a line in the sand and demand that the legal system stop using a 60-second observation as a lifelong causal verdict,
Yep.
which actually leads into another major debate surrounding the score. It's fairness to premature babies. If a baby is born weeks or months early, their biology just isn't equipped to ace this test.
Not at all. Premature babies naturally score low because their physiological systems simply haven't finished forming. For example, their nervous system lacks the myelin coating required to send rapid, robust signals to skeletal muscles, so they appear floppy and score poorly on activity.
Makes sense.
And their peripheral circulation is immensely underdeveloped, so they will almost always lose points on appearance.
So a preterm infant might score a 3 or a 4, not because they are in acute life-threatening distress from a botched delivery, but simply because of their sheer developmental timeline. The original APGAR score didn't have a handicap or an adjustment for prematurity. So how does modern medicine account for that without, artificially inflating the score?
Many modern medical centers have adopted what's called a combined APGAR approach. It is a really elegant solution to the context problem. Alongside the numerical score, the medical team notes exactly what resuscitative measures are being given at that exact moment to achieve that score.
Ah, because a baby who is pink, crying, and vigorously kicking all on their own and scoring a 9 tells a fundamentally different physiological story than a baby who is scoring a 9 only because a medical team is actively giving them CPR, intubating them, and pushing epinephrine.
Exactly. The combined score provides the vital context of what it took to get the baby to that state, which perfectly honors Virginia APGAR's original intention.
Right.
She didn't want a tool for judgment. She wanted a tool for intense, rigorous observation of the reality in the room.
Looking back at this incredible journey, it's just amazing. The APGAR score was born from a marginalized female anesthesiologist's desire to bring discipline and attention to a chaotic environment. It was retrofitted with a catchy acronym by a completely different doctor. It stood its ground against modern high-tech lab chemistry, and it's had to be fiercely defended against legal misuse.
And Virginia APGAR's legacy extends far beyond this single score, too. She went on to become a leading advocate for birth defect prevention, doing this groundbreaking public health work regarding rubella and folic acid supplementation through her later career as a director at the March of Dimes.
She even appeared on a U.S. postage stamp in the 1990s and, had a Google Doodle dedicated to her. That is a rare, spectacular degree of public recognition for a clinical scoring rubric that was supposedly sketched out on a scrap of paper over breakfast.
It really is a testament to the enduring power of a simple, brilliantly effective idea.
It really is. And that leaves us with one final thought to mull over today. We've spent this time focused on the APGAR score, but it actually sits alongside other highly specialized human observational tools you might encounter in medicine.
Right, like the Ballard score.
Yeah, the Ballard score, which estimates a premature baby's gestational age just by looking at physical signs like skin texture and ear cartilage. Or there's the Silverman-Anderson score, which grades respiratory distress based purely on observing chest retractions and nasal flaring. It really makes you wonder, in our modern world, where we are utterly obsessed with artificial intelligence, complex predictive algorithms, continuous digital monitoring, and chemical blood labs, what other complex, seemingly unsolvable problems in our daily lives might be solved if we just stopped relying on our technology, stepped back, and created a simple 5-point, 60-second checklist of human observation?
That is a very powerful question to walk away with. Sometimes the most sophisticated and reliable diagnostic tool in the room is simply a trained human being paying very close attention.
The very first test you ever took didn't require a microchip, a battery, or an algorithm. It just required 60 seconds and someone who cared enough to really look at you. Thanks for joining us on this deep dive, and we'll catch you next time.
If you walk into literally any intensive care unit right now, you're immediately surrounded by some of the most expensive, highly engineered technology on the planet.
Oh, absolutely. It looks like a spaceship in there.
Right. I mean, you'll see million-dollar ventilators breathing for people, experimental dialysis machines filtering blood, and these crazy IV pumps delivering highly toxic, life-saving drugs, just, drop by drop.
Yeah, and you naturally assume the danger in that room scales with the complexity of the machines.
Exactly. But the device responsible for one of the most massive, unkillable infection risks in that entire hospital, it isn't even plugged into the wall. It's a $3 piece of flexible tubing.
It really is.
So today we're doing a deep dive into the urinary catheter. Welcome, everyone. We're going to look beyond all the clinical jargon of insertion and care to uncover this fascinating story about infection, hospital economics, and honestly, a massive shift in how we think about the human body.
Because it really is the perfect blind spot in modern medicine. We have this deep-seated instinct to blame catastrophic outcomes on complex failures,
Right.
But the history of the urinary catheter shows us something entirely different. The greatest risk to a patient usually isn't the hardware itself, it's the human decisions.
The human decisions, right.
Yeah, the medical dogmas and just the sheer psychological momentum of how we manage that hardware on a daily basis.
Okay, let's unpack this.
Yeah.
Because when most of us hear the word catheter, we tense up a bit and we just lump everything into one very uncomfortable mental bucket.
Oh, for sure. Nobody wants to think about it.
No, they don't.
Yeah.
But to understand the stakes here, we have to separate them out. Because there are four main types, and they interact with your body in wildly different ways. First, you have the indwelling, or Foley catheter.
Right, the one most people are thinking of.
Exactly. That one goes up into the bladder and just stays there for hours, days, or even weeks. Second is the intermittent catheter, which is strictly an in and out situation. Inserted just to drain the bladder and immediately removed.
It's just temporary fix.
Yeah. Third is the external catheter, commonly called a Texas or condom catheter. That one is worn over the penis rather than inserted inside. And finally, the suprapubic catheter, which bypasses the urethra entirely and goes straight through the lower abdomen into the bladder through a surgical incision.
And the distinction you just made, that is where so much of the confusion begins. Because while they all technically do the exact same job,
Draining urine,
right, but the biological consequences depend entirely on how long they stay in contact with the body.
Okay.
Yeah, duration is the invisible threat here. And to really grasp why we handle these devices the way we do today, we have to look at how two vastly different medical philosophies collided over the last century.
It's basically a tug of war between adding hardware and taking it away. And the story really kicks off with the addition side of things.
Back in the early 20th century.
Right. Between 1929 and 1935, a urologist in Minneapolis named Frederick Foley came up with what we now call the Foley catheter. And looking at what he was trying to solve, his design was honestly brilliant.
It was a game changer, really, because the clinical reality before Foley was a complete mechanical nightmare.
I can't even imagine.
Well, think about it. If a doctor inserted a tube into the urethra to drain the bladder, there was nothing to keep it from just sliding right back out.
Oh, yeah.
So clinicians were literally taping tubes to patients' legs.
Tape. Ouch.
Tape, external straps, or sometimes a nurse just had to stand there and physically hold the tube in place.
That sounds terribly inefficient.
It was. So Foley introduced this remarkably elegant solution. He took a standard rubber tube and added a tiny inflatable balloon near the tip.
So you slide the tube in, you inject a little sterile water to inflate that balloon inside the bladder, and boom, it acts as an anchor.
Exactly. The tube can't fall out.
It's cheap, it's effective, and it completely revolutionized nursing care. Though there is this bizarre historical twist that Foley might not have even held the official patent for it.
Yeah, the manufacturing history is a total mess of lawsuits and competing claims. It's a whole thing.
Right, but the eponym just outran the paperwork.
It totally did. The word of mouth among surgeons and nurses was just too powerful. The adoption of this balloon-anchored tube was so rapid that it universally became known as the Foley.
Because it just worked so well.
Exactly. It solved such a profound daily annoyance for hospital staff that no one cared who owned the patent. They just wanted the device.
And here's the catch. That convenience is exactly what set the trap. Because if we fast forward to 1972, we meet a urologist at the University of Michigan named Jack Lapidus.
The foil to Foley.
Yes. He represents the complete opposite philosophy. He was dealing with a deeply tragic patient population, children and adults with neurogenic bladders.
Right, patients with spinal cord injuries or conditions like spina bifida.
Yeah, where the nerve signals to the bladder simply don't work, so they couldn't pee naturally.
And you have to understand, the medical dogma at that time was entirely focused on absolute sterility.
Like keeping everything perfectly clean.
Beyond clean. The prevailing belief was that the bladder was a completely sterile sanctuary. Therefore, any time you accessed it, you had to maintain strict surgical-level sterile conditions.
Gowns, masks, all of it.
Gowns, masks, sterile drapes, the works. So for a child with spina bifida, doctors would often insert a permanent, indwelling Foley catheter to keep the bladder continuously drained. Or they would even perform major surgeries to divert the urine outside the body.
Because they were terrified that if they kept inserting and removing tubes, they'd introduce bacteria, right?
Exactly, that was the fear.
But Lapides looked at the data and realized this permanent sterile tube was actually causing devastating chronic infections. It was causing kidney failure and death.
It was doing the exact opposite of what they intended.
Wait, so the medical establishment thought they were protecting patients with permanent sterile tubes, but they were actually causing the damage. It's like they were treating the bladder as this pristine, sealed vault. But the bladder is actually more like a self-cleaning oven, right?
What's fascinating here is that is the exact mechanism Lapides uncovered. Yeah. He had this radical realization that the bladder's natural rhythm, filling up, expanding, and then completely flushing itself out, that is its primary immune defense.
Because the physical rush of urine washes the bacteria away.
Precisely. And the stretching of the bladder wall actually triggers local immune responses. When you place a permanent Foley catheter, the bladder remains constantly empty and collapsed.
So you disable the physical flush and the mechanical immune triggers all at once.
You shut down the whole defense system.
Wow. So what did Lapides tell the medical community to do? Just stop worrying about sterility?
Essentially, yes. Which, as you can imagine, sounded like absolute heresy in 1972.
Oh, I bet.
He introduced clean intermittent catheterization, or CIC. He told patients and parents that they didn't need an operating room environment. They could just wash their hands with normal soap and water, use a clean but not surgically sterile tube, insert it to drain the bladder, and pull it right back out.
And just do this several times a day to mimic the body's natural rhythm.
Exactly.
I can only imagine the pushback from other doctors. I mean, he was basically telling them to break the cardinal rule of infection control.
Oh, the resistance was massive. Surgeons literally accused him of malpractice.
Seriously, malpractice.
Yeah, but the outcomes were undeniable. Lapides proved that periodic flushing of the bladder and removing the foreign object was vastly more protective than trying to maintain permanent sterility with an indwelling tube.
And today, clean intermittent catheterization is the global standard of care for these conditions, isn't it?
It is. It completely changed the field.
Okay, so if a permanent tube breaks the body's natural flushing system, what actually happens inside that stagnant environment?
Well, let's consider the math for a second, because this is the most important number in catheter care. The baseline daily risk of acquiring bacteriuria, which is simply the presence of bacteria in the urine while an indwelling catheter is in place, is roughly 3 to 10% per day.
Wait, 3 to 10% per day, compounded every single day?
Every single day.
So an infection isn't a roll of the dice, it's a ticking clock. If a patient is in the ICU for 3 weeks, it's not just a risk, it's a statistical certainty.
It is virtually guaranteed. By day 30, the colonization rate approaches 100%. It's a matter of when, not if.
Because the catheter basically defeats the bladder's natural flushing mechanism and offers squatters' rights to bacteria.
That's a great way to put it. But they don't just float around in the urine. Within 24 to 48 hours of that tube being inserted, bacteria attach to the plastic or silicone and begin secreting something called an extracellular polysaccharide matrix.
Okay, you're going to have to translate that for me. What on earth is an extracellular polysaccharide matrix?
Think of it as a microscopic, sugary slime shield.
A slime shield. Got it.
Yeah, the bacteria excretes this thick, sticky glue that completely coats the surface of the catheter. This creates a biofilm.
Okay.
And once the bacteria are embedded inside this slime, they undergo a behavioral shift. They start communicating with each other, they share genetic material, and they actually slow down their metabolism.
Like they're hunkering down for a siege.
Exactly. This slime shield is completely impermeable to the patient's immune cells. And much worse, it is highly resistant to antibiotics.
Really?
Yeah, an antibiotic concentration that would instantly kill a free-floating bacterium in a petri dish will just bounce right off a biofilm.
Which means we are dealing with a microscopic fortress.
Right.
I was reading about David Stickler's famous research on this over at Cardiff University, and he highlights a specific bacteria called Proteus mirabilis that takes this fortress building to a terrifying level.
Oh, Proteus mirabilis. It is one of the most destructive organisms you can encounter in a urinary tract, specifically because of how it alters the local environment. It produces an enzyme called urease.
And how does that affect the catheter?
Well, human urine is naturally rich in urea. The urease enzyme secreted by this bacteria breaks that urea down into ammonia.
Okay, and ammonia raises the pH, right?
Exactly. As the ammonia levels spike, the urine's pH skyrockets and becomes highly alkaline. Now, urine also contains naturally dissolved minerals, mainly magnesium and calcium.
Right, normal stuff.
Normal stuff, but those minerals only stay dissolved at a normal, slightly acidic pH. Once the ammonia makes the environment alkaline, those minerals literally crystallize and fall out of the liquid. They form a jagged rock called struvite.
Wait, so this soft, flexible silicone tube is actively turned into a calcified pipe by these bacteria?
Within days, the bacteria incorporate these struvite crystals directly into their slime shield. The biofilm becomes mineralized.
That is just wild.
So very quickly, the inside of the catheter can become completely encrusted and blocked by this bacterial concrete.
That is a plumbing nightmare. I mean, the device that was put in to drain the bladder is now a solid rock, blocking the exit.
Right.
The bladder fills up, the pressure builds, and that infected, highly alkaline urine has nowhere to go but backwards, refluxing up the ureters into the kidneys.
And because of that mineralized biofilm, doctors quickly realize you cannot out-medicate this problem. You have to outsmart it. You can pump the patient full of the strongest intravenous antibiotics available, and you might kill the free-floating bacteria, but the ones entrenched in the biofilm will survive.
So if biofilms make bacteria essentially unkillable, it seems obvious we should just change the building materials. I mean, what about technological solutions? We put silver and antimicrobial coatings on everything these days. Why not catheters?
That is a major debate, and it was the biomedical industry's massive push for the last 20 years. The theory was, hey, if you embed silver alloys or antibiotics into the silicone, it will poison the bacteria before they can build their slime shield.
Makes total sense on paper.
On paper, yes, but the clinical reality has been incredibly frustrating. We now have extensive Cochrane-level reviews, which are these massive, rigorous analyses of all available clinical trials, and they show that these expensive, high-tech coatings offer little to no reduction in symptomatic CAUTI or catheter-associated urinary tract infections.
But silver kills everything. Why wouldn't a silver-coated tube stop an infection?
It all comes down to the timeline. The silver might delay colonization by a day or two, perhaps slightly reducing asymptomatic bacteria in the very short term. But biofilms are inevitable. Proteins from the patient's own urine quickly coat the silver, neutralizing its effect entirely.
Wow. So we can't medicate it, and we can't engineer our way out of it with fancy space-age materials. What is the real solution then?
If the problem is duration, the highest leverage intervention is just taking the tube out.
Just take it out.
Yeah. Look at a landmark 2010 systematic review by Jennifer Meddings and Sanjay Saint. They analyzed hospital programs that ignored the high-tech materials and focused purely on human behavior. They implemented simple nurse-driven reminders and automatic stop orders in the electronic medical records.
So, like a pop-up on the screen forcing the doctor to answer, does the patient in bed 4 still strictly require this tube?
Yes. And if the doctor didn't explicitly justify it, the nursing staff had the authority to pull the catheter out. The results were staggering. Just by asking that question daily, hospitals cut catheter days by a third, and they halved their CIUTI rates.
Have them. Here's where it gets really interesting. The biggest breakthrough wasn't a silver coating. It was essentially a sticky note asking, does this patient still need this?
Exactly.
But why did doctors need a computer pop-up to remind them? I mean, weren't they paying attention?
Well, it goes back to Foley's balloon. Indwelling catheters were deeply ingrained in hospital culture as a tool of convenience. If a patient is elderly or confused or on diuretics, having a catheter saves the nursing staff from changing soiled sheets or assisting the patient to a bedpan every 2 hours.
I see.
It makes accurately measuring urine output effortless. The device would be inserted in the emergency room and then simply fade into the background noise of the hospital stay.
So it was victim of its own success. It worked so well mechanically that nobody thought about the biological ticking clock.
Yeah.
So what finally broke that culture of convenience?
A massive financial forcing function. In October 2008, the Centers for Medicare and Medicaid Services, or CMS, completely rewrote the rules.
Oh boy, follow the money.
Always. They announced they would no longer reimburse hospitals for the extra costs associated with treating certain hospital-acquired conditions. CIUTI was placed squarely on that list.
Oh, wow. So overnight, a CIUTI shifted from being a routine clinical nuisance that the hospital actually got paid to treat to a massive financial penalty.
It was a tectonic shift. Suddenly, if a patient developed a CIUTI, the hospital had to absorb the cost of the extra days in the ICU, the infectious disease consults, and the expensive antibiotics. That single financial lever changed physician behavior faster than decades of peer-reviewed studies.
Today.
Hospital administrators cracked down, demanding strict removal protocols and heavily restricting who was allowed to get a catheter in the first place.
But, whenever you tie huge amounts of money to a specific medical diagnosis, you inevitably trigger a massive turf war over how that diagnosis is defined. If I'm a hospital administrator losing thousands of dollars every time a doctor writes CIUTI in a chart, I'm going to argue about what truly constitutes an infection.
And you just hit on the great debate we are still fighting today, the difference between colonization and true infection. Because hospitals are now heavily penalized, the CDC's National Healthcare Safety Network, the NHSN, had to step in and engineer a highly specific definition for public reporting.
And they had to throw out some of the most classic signs of infection to do it, right? I know they dropped pyuria, which is the presence of white blood cells in the urine.
They did, yeah.
If I see white blood cells, my instinct is that the body is fighting an infection. Why drop that from the definition?
Because of the very nature of the device. A catheter is a piece of foreign plastic rubbing against the sensitive mucosal lining of the bladder. That friction causes constant inflammation, and the immune system naturally sends white blood cells to any inflamed area.
Oh, so it's just a physical reaction.
Right? Almost every single patient with a catheter will have pyuria within a few days, regardless of whether they are actually sick. By using white blood cells as a metric, doctors were simply diagnosing the physical presence of a tube, not a bacterial invasion of the tissue.
That makes a lot of sense. So what is the actual strict standard now to call it a true CIUTI?
The catheter must have been in place for more than 2 calendar days. The patient must exhibit systemic symptoms, meaning a fever, chills, or severe localized pain. And finally, you need a urine culture of 100,000 colony-forming units, or CFUs, per milliliter or more.
Meaning if you take a tiny milliliter of urine and put it in a lab dish, 100,000 distinct bacterial colonies will grow from it. That proves a massive bacterial load.
Correct. But the linchpin of that definition is the systemic symptoms, which brings us to the single hardest concept for families, and even some clinicians, to accept.
Okay, let's debunk the biggest misconception here. Let's paint the scenario. You're visiting your grandfather in the hospital. He has a catheter. You look at the collection bag hanging off the side of the bed, and the urine looks awful. It's cloudy, it's dark, and it smells terrible. Every human instinct screams that he has an infection and needs antibiotics immediately. It feels negligent for the doctor to just walk by and ignore that.
It feels incredibly wrong. But if we connect this to the bigger picture, the Infectious Diseases Society of America, the IDSA, is uncompromising on this point. What you are describing is asymptomatic bacteriuria.
Asymptomatic, meaning no fever, no pain.
Right. There are bacteria in the bag, creating cloudiness and odor, but they have not invaded your grandfather's tissue. The guidelines mandate that asymptomatic bacteriuria in a catheterized patient should never be treated with antibiotics.
Never. Even if the smell is clearing the room.
Even then. Cloudiness and foul odor are a guarantee when you have a biofilm converting urea into ammonia. But if you demand antibiotics based on the look of the bag, you aren't clearing the infection.
Because the biofilm protects them.
Exactly. Treating smelly or cloudy urine without systemic symptoms just breeds antibiotic resistance. You wipe out their good gut bacteria, and you train the bacteria on the catheter to become highly resistant superbugs. You treat the patient's symptoms, not the culture result or the smell.
That is such a vital reframing. Treat the patient, not the bag.
Yeah.
Okay, let's do a rapid-fire debunking of 2 more persistent myths that still cause harm on the hospital floor today. Let's talk about the balloon size. Myth. A bigger balloon, over the standard 10 milliliters, means a more secure catheter that won't leak.
Fact. That instinct consistently harms the patient. When you overinflate that balloon, it creates a massive, heavy water balloon pressing down on delicate tissue. This causes mucosal irritation and triggers violent bladder spasms as the body tries to expel it.
So it makes it worse.
Much worse. Those spasms actually squeeze urine out around the sides, causing more leakage while simultaneously causing tissue necrosis from the pressure.
Yikes. Okay, next myth. Prophylactic antibiotics protect the patient. If we know that compounding daily risk is ticking away, why not just put the patient on a low dose of antibiotics the day the catheter goes in, just in case?
Fact, they just select for resistant organisms. The biofilm still forms, but now it forms exclusively with bacteria that have already proven they can survive your antibiotic. Routine prophylaxis does not protect the patient, it actively endangers them.
Wow, okay. So, pulling all of this together for everyone listening, the narrative arc here went from Frederick Foley inventing a balloon that made it way too easy to leave a tube in out of convenience, to Jack Lapides proving that periodic clean removal is vastly superior to permanent sterility.
Because it always comes back to the ultimate lesson. CIUTI is a duration problem, not a hygiene net insertion problem.
It's the ticking clock.
Yes. The most powerful tool in preventing infection isn't a sterile drape or a fancy silver coating, it's the decision to remove the catheter.
So true. Lapides proved that our obsession with maintaining absolute sterility actually harmed patients, and modern data proves our obsession with leaving tubes in just in case causes inevitable infections.
It's a hard habit to break.
It really is. And it leaves you with a final thought to ponder based on today's sources. It makes you wonder, how many other areas of medicine, or even just our daily life, are we making worse by trying to over-control the environment, rather than just trusting the body's natural rhythms to do the work?
That is a phenomenal question to leave on.
Thanks for joining us on this deep dive. We'll catch you next time.
So, picture a nurse standing in a hospital room, and they're holding a standard lightweight canvas vest.
Just a totally ordinary piece of medical fabric.
Right. And usually, when we look at medical equipment, form follows function in this really unambiguous way, like a scalpel cuts tissue, a cast immobilizes a fracture.
Right. The object itself kind of dictates its reality.
Exactly, which is comforting. It leaves no room for interpretation. But the moment that nurse applies that simple canvas vest to a patient, all that clarity it completely vanishes. Depending on just a few invisible variables, that vest is either a basic, helpful, therapeutic postural support, or it is a highly regulated, legally perilous behavioral restraint.
Yeah, it really represents the absolute bleeding edge of clinical and legal liability.
Mm.
I mean, a single judgment call regarding that vest or a bed rail or a dose of medication can cross the line from standard care into civil or even criminal liability.
Wow, criminal.
Oh, absolutely. False imprisonment, battery. The margin for error is effectively zero.
That is wild. So if you are listening and navigating the healthcare system today, whether you're, an insider dealing with these protocols, or you're just looking closely at how hospitals manage the people you care about, this dynamic flips almost everything you assume about patient safety totally upside down.
It really does.
And so our mission for this deep dive is to explore the incredibly high-stakes reality of restraints in nursing and healthcare. We're going to look at how they went from being this absolute default safety measure to a strictly legally restricted last resort.
Yeah, and we really need to look at the mechanics of why they fail, too.
Right. The physics of how they cause harm. And of course, that incredibly rigid legal framework that governs them today.
Well, and to start, I think the most important thing to grasp is that the defining metric isn't the physical object itself.
Right, like the vest.
Exactly. The Centers for Medicare and Medicaid Services, or CMS, their guidelines establish that a restraint is defined almost entirely by clinical indication and intent.
So it's about the why, not the what.
Precisely. To use your vest scenario, if that vest is placed on a patient with a severe spinal injury sitting in a wheelchair, and it's specifically prescribed to prevent them from slumping forward and making their injury worse,
then it's just a standard postural support.
right. It serves a targeted therapeutic purpose.
But if you take that exact same canvas vest and put it on, say, a post-surgical patient who happens to be confused from anesthesia.
Just to tie them to the bed so they don't wander off.
Yeah. Then it instantly becomes a restraint. Because now it's being used to control behavior and restrict movement. It actually really reminds me of prescribing a heavy narcotic.
Oh, that's a good comparison.
Right, because the exact same pill at the exact same milligram dosage is either compassionate, highly regulated pain management or it's illegal drug diversion.
Yeah, the chemistry of the pill didn't change at all.
Exactly. The entire distinction rests on the physician's documented clinical intent and the specific diagnosis.
That captures the nuance perfectly. And, that line of intent gets even blurrier when you look at how the definition of restricting movement has evolved over time.
I mean, the rules have definitely changed.
Oh, massively. The most
Sure.
glaring example is actually the standard hospital bed rail.
Oh, yeah. This one surprised me.
Right. Because for the vast majority of the 20th century, raising all four bed rails it was simply what you did. It was the unquestioned baseline of patient safety. You leave the room, you pull the rails up so the patient doesn't roll onto the floor.
Which, I mean, that seems completely intuitive, right? Until you actually look at the physics of a frail, confused patient trying to bypass them.
Exactly.
Because if an elderly patient is in a low bed with the rails down and they roll out, they fall, maybe a foot or two?
Yeah, they might get a bruise, maybe a minor laceration.
Right. But when all four rails are locked in the up position, that same confused patient doesn't just decide, oh, well, I guess I'll stay in bed.
No, they try to climb over.
They attempt to vault over a metal barricade. And this fundamentally changes their center of gravity. Instead of a low impact roll, they are now pivoting their entire body weight over the top of the rail.
Which often leads to a catastrophic headfirst fall from a much greater height.
It's terrifying.
And worse still are the entrapment risks. Like a frail patient might try to slip through the gaps in the rails or slide between the edge of the mattress and the metal bars.
And their body slips through, but their head or chest gets caught.
Right, compressing the chest cavity or cutting off the airway entirely, resulting in mechanical asphyxiation.
Which is just horrific to think about.
It is. And it took decades of these mounting catastrophic injuries for the regulatory bodies to finally intervene. So now, the FDA and CMS classify the use of full-length four-side rails as a restraint in many contexts, precisely because it restricts voluntary movement while paradoxically making things more dangerous.
It's a complete inversion of the whole concept of safety, which kind of makes you wonder, at what point the law actually had to step in and force this change in bedside practice. Because these strict CMS guidelines we have today, they didn't just materialize out of a vacuum.
No, not at all.
They were written in direct response to a massive institutional failure.
Well, honestly, the modern regulatory framework is basically written in blood.
Wow.
Yeah. I mean, if we bypass the 18th and 19th century asylum eras, the straitjackets, the manacles, the patented cage beds.
Which is a whole other dark history.
Right. But if we just look at the American healthcare system in the 1970s and 1980s, you see a culture where physical restraints were just standard operating procedure.
It was just the norm.
Exactly. Government investigations during that era revealed that in long-term care facilities, anywhere from a quarter to over a third of the entire patient population was physically restrained at any given time.
Wait, over a third?
Yes, up to a third.
I'm just picturing an understaffed floor in a 1980s nursing home. You have, 2 nurses for 40 patients. If a third of those patients are tied into their beds or locked into jerry chairs with those lap trays they can't remove, that's not about complex medical treatment.
No, not.
That's purely a logistical mechanism to free up staff attention. It's literally just crowd control.
It was institutional crowd control masquerading as safety. And the sheer scale of this practice finally triggered the Omnibus Budget Reconciliation Act of 1987, which is usually just called OBRA 87.
Right.
And this legislation fundamentally re-engineered the legal landscape for nursing homes. It established a hard federal mandate, basically saying that residents have a legally protected right to be free from physical or chemical restraints imposed for discipline or staff convenience.
So it flipped the burden of proof.
Exactly. Restraint was no longer the default safety measure. It became a legally precarious last resort that required exhaustive clinical justification.
Okay, so OBRA 87 tackled the nursing homes, driving restraint use down into the single digits over the following decades. But that didn't fix the acute psychiatric settings, right? Or the emergency departments.
No, it didn't. The psychiatric side of the industry required a second, much more explosive catalyst.
Which was?
In 1998, there was a landmark investigative series by the Hartford Courant titled Deadly Restraint. And it exposed a terrifying reality across psychiatric facilities, group homes, and hospitals nationwide.
Oh, I've read about this. It was devastating.
They meticulously documented 142 restraint-related deaths over just a single decade.
142 deaths, and that's just within the scope of what they could actually uncover.
Right. The real number was likely higher.
And we aren't just talking about frail, elderly patients here. We are talking about adolescents, children, and adults who were physically overpowered and held down by staff.
Staff who routinely lacked any standardized training in crisis intervention or physical holds. You had patients tied to beds and left unmonitored for hours, or they were forced face down onto the floor by multiple adults.
Unbelievable.
And the fallout from this investigation was instantaneous and massive. It directly forced CMS and the Joint Commission to draft the extraordinarily strict federal regulations we operate under today, specifically 42 CFR Section 482.13.
And those are the regulations that establish the least restrictive alternative principle as absolute law, meaning, you cannot simply jump to a mechanical or chemical restraint when a patient becomes combative.
Right, you can't just tie someone down as a first response.
You have to implement and legally document a cascade of de-escalation techniques first, like verbal redirection, modifying the environment, or calling in trained crisis prevention intervention teams.
Yes. A restraint is only legally permissible when there is an imminent, undeniable risk of the patient causing severe harm to themselves or others, and every other less restrictive alternative has definitively failed.
But let's look at how this actually plays out on the floor, because if you have a chronically understaffed unit and say a patient has a known history of sundowning or becoming violently agitated at like 2 a.m.,
Which happens a lot.
a physician might naturally want to anticipate that, right? It seems entirely logical that they would write a PRN order, a standing as needed restraint order. So the night shift nurses have the authorization ready to go if chaos breaks out.
Well, they might want to, but writing a PRN order for a behavioral restraint is a direct violation of federal law.
Wait, really? A direct violation?
It is strictly, unambiguously prohibited. You cannot pre-authorize the restriction of a human being's fundamental liberty just in case they become difficult to manage.
Wow.
Yeah. If an emergency erupts and a patient becomes violently dangerous, trained staff can initiate an emergency restraint, but that action instantly triggers a relentless, legally mandated clock.
Right. This is the 1-hour face-to-face rule.
Yes. Within a highly constrained window, usually 1 hour, a physician or licensed independent practitioner must physically arrive, look the patient in the eye, and conduct a comprehensive face-to-face clinical evaluation.
They can't just phone it in.
Absolutely not. They must assess the patient's immediate physical and psychological state, figure out the underlying cause of the agitation, and document exactly why the restraint must continue.
They have to assess why the patient is agitated. Like, is it a psychiatric break, or are they hypoxic?
Right.
Or do they have a massive internal infection causing delirium? The face-to-face forces an actual clinical diagnosis rather than just rubber stamping the physical hold. And even then, the authorization expires incredibly fast, doesn't it?
Oh, incredibly fast. The expiration windows are deliberately suffocating to prevent patients from being forgotten in these devices.
Okay, so what are the windows?
For an adult, the order expires in roughly 4 hours. For an adolescent between 9 and 17, it's 2 hours.
And for a kid?
For a child under 9, the order is only valid for 1 single hour.
1 hour. So a doctor must continually reassess and renew that order hour by agonizing hour.
Exactly. The entire system is engineered to make maintaining a restraint as logistically exhausting as possible for the hospital.
So they only do it if they truly have no other choice. But the legal expiration of the order is only half the equation, really, because the moment those straps go on, the physiological danger to the patient just skyrockets.
Yes, it does. Yep.
We are looking at mandated, structured monitoring every 15 to 30 minutes, right? Sometimes continuous one-to-one observation.
Right. Staff must continuously verify peripheral circulation, checking pulses and capillary refill below the restraints. They're monitoring skin integrity, hydration, and toileting needs. But the absolute most critical metric they are monitoring is respiratory status.
Because the mechanism of death in these situations is rarely like a broken strap or a malfunctioning buckle.
No, almost never.
It is almost always positional asphyxia.
Positional asphyxia is a silent, rapid killer. In the 1990s, forensic pathologists like Donald Ray mapped the physiological mechanics of this.
And what did they find?
Well, when a human being is placed in a prone position, so face down on a bed or the floor, and any significant weight or pressure is applied to their back, it mechanically prevents the diaphragm from expanding.
The chest cavity literally cannot create the negative pressure needed to pull oxygen into the lungs.
Right. And as oxygen levels plummet, lactic acid builds up rapidly from the physical struggle. So the heart is suddenly starved of oxygen precisely when it is demanding it the most due to the adrenaline surge.
Which leads to fatal cardiac arrhythmias.
Exactly.
And the terrifying aspect of positional asphyxia to me is that it often looks like compliance.
Yeah, that's the scariest part.
Because if a patient's diaphragm is compressed, they can't scream. They might stop thrashing, not because of the DF. It makes total sense. And this physiological danger also explains why manual restraints, where staff use their own body weight and leverage to pin a patient, are classified as one of the highest risk interventions possible.
Absolutely.
Which kind of seems counterintuitive at first. Like, you'd think human hands are safer than locking mechanical leather straps to a bed frame.
You would think so. But a mechanical strap applies a fixed, quantifiable limit. A human being, on the other hand, in the middle of a violent altercation, is entirely uncalibrated.
Right, because of the adrenaline.
Exactly. Manual restraints occur during sudden emergencies. The staff members are experiencing massive adrenaline dumps. Their own fight-or-flight systems are fully activated. It is remarkably easy for an adrenalized healthcare worker to unknowingly apply lethal pressure to a patient's back or neck in an attempt to just secure a limb.
Because you can't standardize the force of an improvised human tackle.
No, you really can't.
So, okay, we have physical restraints, the vests, the bed rails, the manual holds, which present clear mechanical dangers to the airway and circulation. But the most heavily debated frontier in modern healthcare involves an entirely invisible mechanism of control, right?
Yeah.
Chemical restraint.
Ah, yes, the pharmacology of behavior management.
Right.
This is where clinical intent faces its absolute most intense regulatory scrutiny. Let's look at the ongoing crisis in long-term care regarding older adults suffering from dementia-related wandering and agitation.
Because for a long time, facilities were routinely utilizing powerful antipsychotics drugs like haloperidol or risperidone to essentially just sedate these patients.
Yes, they were using potent neurological agents to suppress behavior that was difficult for the staff to manage. But giving an elderly dementia patient an antipsychotic doesn't just make them, quietly sleepy.
It does a lot more than that.
It fundamentally alters dopamine pathways in an already compromised brain. The FDA ultimately intervened with a black box warning, which is their most severe classification, explicitly stating that these medications significantly increase the risk of death in elderly patients with dementia-related psychosis.
And we really have to look at the how here. Like, why is a standard antipsychotic suddenly lethal in a frail elderly patient?
Right, it's a good question.
It's not just a chemical timeout. These drugs can cause severe cardiac issues like QT interval prolongation, which can trigger sudden heart failure.
Yes.
Or they induce extrapyramidal symptoms like muscle rigidities and spasms. So an elderly patient might lose the neurological coordination to properly swallow, causing them to aspirate their own saliva or food into their lungs, leading to fatal pneumonia.
The physiological cascade is just disastrous. Therefore, if a facility administers an antipsychotic purely for environmental control, rather than as an explicitly documented individualized treatment for an underlying psychiatric condition, it is a chemical restraint.
And CMS actively targets and penalizes that practice.
They do. But the debate isn't isolated to long-term care either. It is currently raging inside emergency departments across the country regarding what they call the chemical takedown.
Right. So imagine you have a violently agitated patient brought into the ER by police. They are tearing apart the room, presenting an immediate physical threat to the nurses, the doctors, and themselves. The team administers a rapid intramuscular injection of a sedative or an antipsychotic to neutralize the threat.
And the clinical debate centers entirely on where the line is drawn there. Is that injection a legitimate, emergent medical treatment for acute delirium or psychosis?
Or is it functionally a chemical restraint utilized to manage the room?
Exactly, which would legally mandate all the rigid documentation, the continuous vital sign monitoring, and those face-to-face evaluations we discussed.
So if it's a chemical restraint, the clock starts ticking.
Yep.
But if it's medical treatment, it's just a chart note. The entire legal framework hinges on exactly how the charting is phrased.
It really does.
But, let's apply some friction to this regulatory framework for a second. Because if we look at the immense pressure these regulations place on healthcare facilities, a massive trend has emerged where nursing homes and hospitals proudly market themselves as 100% restraint-free.
Right. They use it as a banner of ultimate quality.
Yeah. But doesn't establishing zero restraints as an absolute non-negotiable metric create a deeply dangerous environment.
How so?
Well, if a nurse knows that applying a life-saving restraint to a patient who is actively pulling out their breathing tube will ruin the hospital's perfect compliance score, aren't we incentivizing them to either use sketchy, unregulated alternatives or simply falsify the documentation?
Wow. Yes. You are identifying the core paradox of absolute metrics in healthcare. When zero restraints transform from a noble philosophy into a punitive administrative metric, it severely compromises clinical judgment.
It puts them in an impossible position.
It creates a massive double bind. Nurses and doctors must evaluate. Is a restraint the absolute safest, most life-preserving option for this specific patient in this exact chaotic moment?
And if the answer is yes, but the hospital policy is an absolute zero, the system essentially punishes the clinician for saving the patient's life through the only viable means available.
Exactly. It forces staff into the shadows, utilizing unapproved physical barriers or off-label sedation just to avoid triggering the official restraint algorithm.
It overrides the nuance of individualized care entirely.
It really does. The tension between preserving a patient's physical safety and protecting their fundamental autonomy is it's the daily tightrope of clinical practice.
And this connects directly to how you, listening, interact with the healthcare system as consumers and family members. When you look up a nursing home or a care facility to see their CMS star ratings, you are looking at data derived directly from these exact restraint laws.
Yes, the rates of physical restraint and antipsychotic administration fundamentally dictate those public ratings.
Which ultimately dictates reimbursement rates and drives family placement decisions. So this is not just some abstract medical debate. It is a live public policy mechanism that shapes the financial survival of these institutions.
Completely interconnected.
So the object doesn't tell the story. The canvas vest, the metal rail, the haloperidol, they are inert. The moment human intent and the limits of human physiology interact with those objects, they become the epicenter of modern medical ethics and tort law.
That's beautifully put. And, consider the reality facing the system today. The regulatory frameworks governing restraints are more robust, punitive, and legally intricate than at any point in history.
They demand flawless care.
They demand flawless, deeply time-intensive, highly monitored care. Yet the environmental pressures driving the need for behavioral control like chronically understaffed units, an escalating mental health crisis, and a surging aging population suffering from profound dementia, those are all intensifying exponentially.
So the rules require infinite resources, but the system is running on fumes.
Exactly. When an immovable, punitive legal mandate collides with an under-resourced, deeply exhausted healthcare workforce on a medical floor at 2:00 a.m., the friction is immense.
Yeah.
We have outlawed the crude tools of the past, but we have yet to truly solve the structural crises that made those tools seem necessary in the first place.
It's a tension the system has yet to solve. Something to really think about the next time you walk down a hospital corridor. Thanks for joining us on this deep dive, and we'll see you next time.
So you definitely know the feeling. You're sitting in a clinical room, shivering a little in one of those drafty paper gowns.
Oh, yeah, those terrible gowns.
Right? And someone hands you a clipboard with a pen attached by a string. It's time for your procedure, and there's a form you have to sign.
And usually there's this expectation of it just being, an administrative hurdle.
Exactly. You sign the paper, the doctor does the thing, and you go home. It feels exactly like signing the terms and conditions on a new software update.
I mean, you don't read it. You just scroll to the bottom, click accept, and hope for the best.
You really do. We treat it like just one more piece of annoying paperwork standing between us and feeling better.
It feels incredibly routine.
But what if I told you that routine clipboard is actually a massive legal fault line? Like one forged by historic atrocities, Supreme Court battles, and the fundamental question of who actually owns your body.
It is a lot heavier than most people realize.
It really is. Today, we are taking a deep dive into a stack of sources covering medical law, nursing ethics, and the often misunderstood concept of informed consent.
Which is a huge topic.
Massive. And our mission today is to demystify what that ubiquitous hospital form actually means, dissect the shocking events that created our modern rules, and definitively clarify the exact legal role of a nurse in this entire process.
Right.
Okay, let's unpack this. Because making the leap from a quick signature in a drafty room to a heavy legal framework is huge. The sources we're looking at make one thing abundantly clear right away, which is that informed consent is not a piece of paper.
Far from it. The piece of paper is merely the artifact, the receipt, essentially, proving that a highly specific, legally mandated conversation took place.
The receipt.
Exactly. Informed consent itself is an ongoing process, and looking through the legal frameworks in our sources, that process has to contain 5 distinct elements before that pen ever touches the paper.
Okay, what are the 5?
So they are disclosure, comprehension, voluntariness, capacity, and an explicit decision.
I was actually looking at that list in the sources, and a couple of those elements seem a bit, I don't know, redundant on the surface, like capacity and comprehension. If I am awake, alert, and listening to a surgeon talk, don't I automatically have both?
Well, not necessarily, and that distinction is actually where lawsuits are born.
Really? How so?
So you might have the cognitive capacity to understand language and logic, but if the surgeon explains a complex neurosurgery using only dense medical
Like
jargon,
you have no idea what they're saying.
right, you lack comprehension, you didn't actually understand what was going to happen to you. Conversely, someone could explain a simple blood draw perfectly clearly, ensuring comprehension.
Okay.
But if the patient is severely intoxicated or suffering from acute delirium, they lack the legal capacity to weigh that information.
That makes sense. And then there's voluntariness, which implies you aren't being coerced.
Exactly.
But honestly, the trickiest part of this entire 5-step mechanism seems to be the very first one, disclosure. Because how much information is enough?
That is the million-dollar question.
Right. If a surgeon lists every single microscopic thing that could possibly go wrong, you'd be sitting there for 3 days and you'd be too terrified to get, like, a hangnail removed.
Oh, absolutely. Finding that line is the most contested part of medical law. For a long time, American courts relied on something called the reasonable physician standard.
Okay. What did that mean in practice?
This meant a doctor only had to disclose the information that a reasonable, similarly trained physician would customarily disclose in that exact same situation.
I have to say, looking at the legal history, that standard seems incredibly flawed.
Oh, it was heavily criticized.
I mean, it is essentially letting a guild of magicians legally decide how much of a trick they have to reveal to the audience. It meant doctors could completely justify keeping patients in the dark about major, life-altering risks, just as long as their peers were also keeping their patients in the dark.
Right. The medical profession was entirely defining its own duty to inform. It was a closed loop, and it incentivized a culture of silence. But that closed loop was completely shattered in 1972 with a landmark case called Canterbury v. Spence.
Oh, this is the back surgery case, right?
Yes. Jerry Canterbury was a young man who had back surgery for a herniated disc. His surgeon did not tell him that the procedure carried roughly a 1% risk of paralysis.
Because under that old standard, other doctors wouldn't have bothered mentioning a mere 1% risk either.
Precisely. They would have considered it too small to worry the patient about. But during his recovery in the hospital, Canterbury fell from his bed and did, in fact, become paralyzed.
Oh, it's awful.
It is. And when this went to court, the ruling caused a massive paradigm shift in American medicine. The court determined that failing to disclose even a low-probability, high-severity risk that a patient would want to know about is, in itself, an injury.
That is a fascinating mechanism. So the doctor doesn't even have to perform the surgery badly.
Right.
The surgery could be technically flawless, but simply withholding the information is the actionable offense.
Because it robs the patient of their agency. This case replaced that old closed-loop rule with the reasonable patient standard.
Meaning what exactly?
Meaning, doctors must disclose whatever a reasonable patient would need to know to make an informed decision, completely regardless of what other doctors typically say at the bedside.
That's a huge shift.
It really was. Now, a minority of U.S. states still use the old physician-centered standard, but Canterbury v. Spence shifted the fundamental center of gravity in medical law from professional custom to patient autonomy.
Which raises a really important question. If the patient's right to know, this sacred idea of bodily autonomy, is the new center of the legal universe, where did that idea actually come from?
Well, it certainly didn't appear overnight.
Because reading through the historical sources, it wasn't always this way.
No, not at all. We can trace the legal seed back to 1914 to a case called Schloendorff v. Society of New York Hospital.
Right.
A patient consented to an abdominal exam under anesthesia but explicitly refused surgery. While she was under, the surgeon removed a tumor anyway.
And that case gives us the quote that nursing and medical students still memorize to this day, from Justice Benjamin Cardozo. See, it's every human being of adult years and sound mind has a right to determine what shall be done with his own body.
Which is a beautiful foundational statement, though it is worth noting a fascinating legal quirk here.
Oh, yeah.
That famous quote was actually just dicta.
Meaning it was just a side comment in the judge's written opinion, right?
Yeah.
It wasn't the actual legally binding rule of the case.
Correct. The case itself was actually decided on the technicalities of hospital immunity. Cardozo was just sort of philosophizing on the nature of human rights.
Wow, so a side note became the absolute bedrock of bodily autonomy.
It did. Interestingly, the actual compound term informed consent wasn't even coined until decades later. In a 1957 California case called Salgo, where a patient woke up permanently paralyzed after a procedure because he hadn't been warned of the risk.
So the legal framework was slowly building in the courtrooms. But the ethical scaffolding, the deep moral reason we treat this as a human right today, didn't come from judges debating back surgeries.
No.
Our sources make it painfully clear that modern medical ethics were forged in the fire of some truly horrific atrocities.
If we connect this to the bigger picture, the evolution of these ethical mechanisms was entirely reactive.
Reactive to what?
Well, following World War II, the Nuremberg trials exposed the lethal, forced experiments conducted by Nazi physicians on concentration camp prisoners.
Right.
The resulting 1947 Nuremberg Code is widely considered the founding document of modern informed consent. It states right in its first line that voluntary consent of the human subject is absolutely essential.
But the sources also point out that the U.S. didn't just learn this lesson from looking overseas. We had our own domestic scandals that forced this doctrine into everyday practice.
We did, unfortunately.
The most infamous, of course, being the Tuskegee syphilis study.
Yes. A study spanning an unbelievable 40 years. From 1932 all the way to 1972, the U.S. Public Health Service enrolled nearly 400 black men in Alabama who had syphilis, but researchers deliberately never told them they had the disease.
They were just told they were being treated for bad blood.
Exactly.
And the most damning detail in the historical record is that the researchers intentionally withheld treatment for 25 years after penicillin became the standard, widely available cure.
It's horrifying.
They just wanted to observe the natural, fatal progression of the disease. They didn't stop until a whistleblower leaked the reality of the study to the press in 1972.
And Tuskegee wasn't an isolated mindset of the era. The sources detail the Cold War human radiation experiments where the government exposed thousands of people, including pregnant women and terminally ill patients, to radiation without proper disclosure, all for defense research.
That is just wow.
And then there were the Willowbrook hepatitis studies.
The Willowbrook case is chilling because of how it manipulated that element of voluntariness we talked about earlier. Researchers deliberately infected intellectually disabled children with hepatitis.
Yes.
To get the parents to consent, they sometimes made admission to this highly sought-after, overcrowded state facility conditional on participating in the study.
That is the ultimate example of coercion.
Yeah.
When a vulnerable population is denied basic care or access unless they submit to experimentation, consent cannot possibly be voluntary.
Definitely not.
These public outrages finally forced the government's hand. It led to the 1979 Belmont Report.
And the Belmont Report isn't just a list of rules. Looking at how it's structured, it's essentially a mathematical balancing act designed to prevent these specific abuses.
Very much so.
It codified 3 bioethical principles: respect for persons, which translates to autonomy; beneficence, which means acting in the patient's best interest; and justice.
The report acknowledged that these principles will often conflict. You have to balance a patient's autonomy against the doctor's duty of beneficence. But autonomy emerged as the heavyweight champion of that trio. Your body is yours.
But if autonomy is this absolute ironclad rule, what happens when a piece of your body is removed and sitting in a jar across the room?
Oh, this is where it gets complicated.
Is it still yours? Can someone else profit off a piece of you?
This brings us to a very bizarre legal gray area regarding excised tissue. Let's look at the foundational case of Henrietta Lacks from 1951.
She was a black woman treated for cervical cancer at Johns Hopkins, right?
Yes. Her cells were taken without her knowledge or consent, which, horrifyingly, was a standard legal practice at the time.
Just standard procedure.
Yeah. Those cells became known as HeLa cells, and they were the first human cells to reproduce indefinitely in a lab.
Incredible.
They literally changed the trajectory of human history. They were the foundation for the polio vaccine, cancer treatments, and countless other breakthroughs.
But her family remained completely in the dark, living in poverty while her cells were sold and studied worldwide for decades.
Exactly. Her specific case eventually forced massive changes to the laws governing research consent, specifically the 2018 revision of the Common Rule.
Right.
But the question of who actually owns the physical tissue gets even weirder when you look at the 1990 case of Moore v. Regents of the University of California.
Okay, let's get into this one.
So John Moore had his spleen removed as part of his leukemia treatment. Without telling him, his surgeon patented a cell line derived from Moore's unique tissue, the Mo cell line, which became massively commercially valuable.
Wait, I need to walk through the logic of this ruling. The doctor gets in trouble for not disclosing his financial interest? Right. But Moore still doesn't get a cut of the millions of dollars in profits from his own spleen. How does that work?
It seems entirely counterintuitive, I know. But the court drew a very fine legal line here. They ruled that the doctor did breach his fiduciary duty.
Meaning he violated that sacred legal trust where a doctor is obligated to act solely in the patient's best physical and financial interest rather than their own.
Exactly. Hiding his financial interest was a breach of that duty, and it was a breach of informed consent. That was actionable. Moore could sue the doctor for that deception.
Okay.
However, the court also ruled that patients have no property rights over their excised cells once they are removed from the body.
That's wild.
The court's reasoning was that granting property rights to patients over every removed appendix or blood sample would severely chill biological research and stifle medical innovation.
So the doctor is punished for the secret, but the patient still doesn't own the biological material once it hits the petri dish.
Exactly.
Because Moore proves that you lose ownership once the tissue leaves your body. That conversation at the bedside before the scalpel hits the skin is literally your last line of defense.
This absolutely is.
Which puts an unbelievable amount of pressure on the person holding the clipboard. And usually, that person is a nurse. Here's where it gets really interesting.
It does. This brings us to the single biggest misconception we need to debunk for anyone working in or interacting with the healthcare system.
Let's hear it.
The nurse who gets the patient's signature is not legally responsible for obtaining the informed consent.
Let me repeat that because it is the most vital takeaway in our nursing sources. The nurse holding the clipboard is not the one liable for the disclosure.
Not at all.
Wow.
The legal duty to disclose the risks, the benefits, and the alternatives belongs entirely and exclusively to the provider who is actually performing the procedure.
So the surgeon.
The physician, the surgeon, the advanced practice provider, meaning a nurse practitioner or PA who is doing the actual intervention, they hold the duty to inform.
So what is the frontline nurse's actual role in that high-stakes moment? Because they're the ones standing there with the paper.
The nurse's legal role is to witness the patient's signature, to confirm that the patient appears to be acting voluntarily, and, crucially, to act as a patient advocate.
Advocate.
Right. Let's walk through a real scenario. If a nurse hands you the form and you say, wait, what are the alternatives to this surgery? The doctor didn't mention any. The nurse's job is to stop the line.
They don't try to explain the surgical alternatives themselves to save time?
Never. Because doing so would mean the nurse is absorbing the physician's liability. They escalate the issue back to the provider. The nurse says, I cannot witness the signature until the surgeon comes back and answers your questions.
That distinction changes everything. It transforms the clipboard moment from, I, the nurse, am legally certifying that you understand complex anatomy, to, I am witnessing that you are signing this willingly and I will fiercely advocate for you if you look confused.
Exactly.
And the sources outline some really vital legal distinctions that frontline workers have to navigate regarding this, like the difference between battery and negligence in tort law.
Right, tort law being the area of law that deals with civil wrongs and damages. And the distinction here is massive.
How so?
If a provider performs a procedure with absolutely no consent at all, say amputating the wrong leg, or operating on a patient who explicitly refused, that is battery. It is unauthorized touching.
Okay, that makes sense.
But if they perform a procedure and the patient signed the consent form, but the doctor failed to adequately disclose a major risk, like the Canterbury paralysis case, that is negligence.
Negligence, got it.
Yeah.
There's also a major distinction made in the sources between capacity and competence. We touched on capacity earlier, but clinically, these two terms are worlds apart.
They are. The best way to understand this is to think of it like a driver's license.
Okay, I like analogies.
Competence is having your driver's license. It is a global legal status granted by the state, decided by a judge in a court of law. It says you are generally fit to make decisions.
Right.
Capacity, on the other hand, is whether you are sober enough to drive this specific car right now.
Oh, that's really clear.
It is a clinical situational decision made by a healthcare provider at the bedside.
So you can be a legally competent person, but temporarily lack capacity for one afternoon because you just woke up from anesthesia.
Exactly. And this leads to an obvious question. What happens when you are entirely unconscious? Let's say you're rolled into the ER after a car accident. You can't sign a form, you can't show capacity. Do the doctors just stand around waiting for a lawyer while you bleed out?
I would certainly hope not.
They don't, thanks to the emergency doctrine.
Oh, okay.
It provides implied consent. If an unconscious patient faces imminent, serious harm or death, the law assumes that a reasonable person would consent to life-saving care. The doctors can act immediately without explicit consent.
So understanding this entire framework, battery versus negligence, capacity versus competence, the emergency doctrine, it isn't just about passing a nursing exam or avoiding a lawsuit. It's about navigating the most complex, real-time ethical dilemmas we face in society.
And those dilemmas are constantly evolving. The ultimate live debate in clinical ethics today is the tension between paternalism and autonomy.
Meaning, when, if ever, can doctors override a competent patient's informed refusal of care, claiming it is for their own good?
Exactly. And the sources highlight a very specific paradigmatic test case for this. Jehovah's Witness patients who refuse blood transfusions on religious grounds.
Right, that's a classic ethical dilemma.
It is the ultimate stress test of autonomy, and courts have consistently upheld a competent adult's right to refuse a transfusion, even if it is a 100% medical certainty that the refusal will result in their immediate death.
Wow.
The patient's right to dictate what happens to their own body wins over the doctor's duty to save a life.
And that absolute right to refuse was codified on a national level in the 1990 case Fuzan v. Director.
Yes, that was the Supreme Court's first major right-to-die case. It affirmed that competent patients have a constitutionally protected liberty interest in refusing unwanted medical treatment, including life-sustaining treatment like feeding tubes.
And that single case is the entire reason we have modern advance directives and living wills today.
It is.
It's fascinating how this tension between individual autonomy and public health beneficence plays out everywhere. We saw it heavily debated with modern vaccine mandates. And regardless of where anyone stands politically on those mandates, you can see the exact same ethical fault lines from our deep dive.
You really can.
Do we prioritize the individual's absolute right to refuse a medical intervention? Or do we prioritize the broader public health need to stop a communicable disease? It's the same fundamental legal struggle.
The ethical framework is tested by every new societal crisis.
And a key point the sources make is about revocability. Consent is never locked in. You can withdraw your consent mid-procedure, assuming it's clinically safe to stop.
Right.
And if a surgeon is inside you and finds something totally unexpected, some new material finding, they generally need to wake you up and get new consent to treat it. They can't just say, well, I was already in there, so I fixed it.
No, they cannot. This raises an important question as we look to the future. These laws were built over a century for surgeons, scalpels, and physical procedures. They are severely struggling to keep up with tomorrow's technology.
Like what?
Think about genetic testing companies asking you to consent to sharing your DNA data. Do you really comprehend what you are consenting to 20 years from now when that data can be used in ways we haven't even invented yet?
Or the looming debate over artificial intelligence. Hospitals are struggling right now to figure out if they need to explicitly disclose to patients that an AI diagnostic tool was used to read their scans.
Exactly.
Is that part of the reasonable patient standard? Does a patient need to know a computer made the call, not a human?
It is the bleeding edge of medical law. The foundational rules, autonomy, disclosure, comprehension are the exact same, but the application is entirely uncharted territory.
So what does this all mean for you, the listener? We've traveled from the incredibly dark history of forced experiments that birthed the very idea of bodily autonomy to the realization that informed consent is not a piece of paper, but a continuous, living conversation.
Yes.
We've seen the legal loopholes of tissue ownership, and we've clarified the vital, fiercely protective role of the nurse who acts as your advocate when that final signature is requested.
The main takeaway is that your bodily autonomy was incredibly hard-won by those who came before you, and it is entirely yours to exercise and protect.
But as we look to that uncharted future, I want to leave you with a final provocative thought to mull over. We mentioned AI just a second ago. Imagine a hospital starts using a highly advanced AI to diagnose your illness or recommend a surgery.
Okay.
That AI was trained on millions of past patients' data, finding patterns no human doctor could ever see. If even the software developers who built the AI admit that the algorithm is a black box, meaning they don't actually fully understand how it reaches its conclusions.
How can a doctor ever provide you with truly informed consent?
Exactly. Can you, or anyone, legally consent to a medical decision that no human mind fully comprehends? Next time you're sitting on that exam table in that drafty gown and someone hands you a clipboard, take a second to think about the massive invisible machinery behind that single piece of paper. This has been another deep dive into the forces shaping our world. Thank you for listening, and keep questioning the world around you. You know, you're sitting there in the doctor's office, and the nurse snaps that little glowing clip onto your finger.
Right, yeah, it happens every single time.
Yeah, and if a few seconds later, it reads 100% and you just feel completely safe. I mean, we all do, you know.
Oh, absolutely. It is so routine.
It really is. It's basically informally known as the fifth vital sign, right alongside your temperature, your pulse, respiratory rate, blood pressure, all of that.
Yeah, it's just expected at this point.
Exactly. We assume that little glowing red number is just the absolute truth about what's going on inside our lungs. But what if I told you that number could actually be lying to you?
Well, it's a terrifying thought.
Right. And in an emergency room, I mean, that lie could literally be the difference between life and death,
It really could, and it honestly happens way more often than people realize.
which is crazy to think about.
It is. I mean, that little device, the pulse oximeter, is this absolute marvel of physics, you know? But it is also a master of illusion.
A master of illusion. I like that.
Yeah, because most people, and honestly, even some medical professionals, they fundamentally misunderstand what that number on the screen actually represents, and more importantly, what it's completely blind to.
Which is exactly why we are taking a deep dive into pulse oximetry today. We really need to look under the hood of this little plastic clip.
I completely agree. There's so much to unpack there.
So we're going to get into the completely accidental way it was invented, the physics trick it uses to, like, see inside your blood, and exactly why 92% is the specific number that makes clinicians start sweating.
Yes, the dreaded 92% cliff.
Right, the cliff. And of course, we'll cover the really dangerous scenarios where this trusted device just completely misleads the people who are trying to save your life.
Well, to really grasp any of that, we basically have to start with a massive mind shift for you, the listener.
Okay, lay it on us.
So when you look at that screen and you see 98%, your natural assumption is, great, my oxygen is at 98%.
Yeah, I mean, that's its entire job, right?
Right, but a pulse oximeter does not actually measure your oxygen.
Wait, really? If it doesn't measure oxygen, what is it even doing?
It measures a ratio of light absorption, and from that light, it makes an educated guess. It's really just inferring your oxygen saturation.
Okay, so it's an estimate.
Exactly. In medicine, there's a very strict distinction between two different terms, SO2 and SpO2.
Okay, break those down for us.
Sure. So SO2 is the ground truth. That is your actual arterial oxygen saturation. But to get that number, a clinician has to physically take a needle, puncture an artery usually right in your wrist to draw arterial blood, and run it through this big blood gas analyzer machine.
Oh, wow. Ouch. That sounds incredibly painful.
It is not pleasant, no.
That is definitely not what the little painless finger clip is doing.
No, far from it. So
No.
the finger clip gives you SpO2. The P just stands for peripheral or pulse.
Oh, I see.
Yeah, so it is purely an estimate of that arterial ground truth. And the gap between that estimate, just light bouncing around inside your finger, and the real physical truth of your blood is where some of the most fascinating and honestly sometimes life-threatening medical mysteries happen.
The gap between the estimate and the truth. That makes so much sense.
Yeah.
But how did we even figure out how to estimate this in the first place? Because the history in our sources for this device is just wild.
It really is.
Like, no one just sat down and said, I'm going to invent the pulse oximeter, did they?
Not the modern version we use today, no.
No.
I mean, the basic concept of optical oximetry does go all the way back to World War II.
Okay, World War II.
Yeah, there was this Yale physiologist named Glenn Millikan, and he built an ear oximeter back in 1942.
An ear oximeter.
Yeah, he clicked it to the ear. He was actually trying to monitor pilots for hypoxia, oxygen deprivation at extremely high altitudes.
Oh, that makes sense for pilots.
Right. He actually coined the word oximeter. But Millikan's device, and really all the commercial ones that followed it for decades, they were just an absolute nightmare to use in a clinical setting.
Nightmare, how? Like, were they just too big?
Too big, too clunky, and just incredibly finicky. I mean, the readings would constantly drift around.
So frustrating.
It was. And worst of all, They required this incredibly cumbersome baseline calibration for every single patient.
Wait, how did you calibrate an ear clip?
Okay, you're going to love this. You had to physically heat up the patient's ear to increase the blood flow.
You're kidding?
Nope. You heat it up, you take a reading, and then you literally squeeze all the blood out of the patient's earlobe to get this bloodless baseline reading.
Oh my God.
Yeah, and then you manually calibrate the whole machine before you could even start monitoring them.
That is absurd. I mean, you cannot do that in an emergency room while someone is actively crashing.
Exactly. It just doesn't work.
You need something you could just snap on and get a number instantly.
Which is exactly why the real breakthrough didn't happen until the early 1970s.
Okay, what happened in the 70s?
Well, it came from a Japanese bioengineer named Takuo Aoyagi. He was working at a company called Nihon Kohden.
Right.
And Aoyagi wasn't even trying to measure oxygen at all. He was actually trying to measure cardiac output.
Cardiac output. So basically, the volume of blood the heart is pumping every minute.
Exactly. He's looking at the heart, not the lungs.
Yeah.
And he was trying to measure it using this dye dilution method.
Okay, how does that work?
The idea is you inject a specific dye into the patient's bloodstream, and then you use a light sensor on the earlobe to track the concentration of that dye over time, as it washes through the body's circulation.
Right, that sounds pretty straightforward.
It does, but Aoyagi kept running into this massive technical roadblock. His readings were constantly getting ruined by this rhythmic, pulsating noise in the signal.
All right, let me guess. The noise was the patient's heartbeat.
Exactly. Every single time the heart beat, it sent a fresh surge of arterial blood through the earlobe.
And that messed up the sensor.
Completely. That surge physically changed the volume of blood sitting right under his sensor, which totally threw off his light absorption measurements for the dye.
Man, that must have been so frustrating for him.
It was infuriating. He was desperately trying to build electronic filters to smooth out this pulsating static so he could just clearly see the dye.
Oh, wow. So he's trying his hardest to eliminate the pulse. But then, wait, does he realize that the frustrating static on his radio is actually the broadcast he should be listening to?
That is a brilliant way to look at it. Yes, he had a total paradigm shift.
That's amazing.
Right. Aoyagi and his colleagues suddenly realized that this pulsating noise was the absolute key.
Because it was only arterial blood.
Exactly. That surge was purely arterial blood, freshly pumped straight from the lungs. All the other tissue in there, the skin, the cartilage, the bone, the slow-moving venous blood just returning to the heart, that was all just static background.
Because it didn't pulse.
Right, it didn't pulse. So by isolating only the part of the light signal that actively pulsed with the heartbeat, they could analyze the oxygen saturation of just the arterial blood.
Oh, wow.
Yeah, suddenly you didn't need to squeeze the blood out of the ear for calibration anymore. You literally just needed a pulse.
That is just incredible. An
Yeah.
engineering annoyance completely revolutionized modern medicine.
It truly did. I mean, the technology crossed over to the U.S. and was commercialized by a company called Nellcor in the 1980s.
I've heard of them.
Yeah, and almost overnight, anesthesiologists had a way to see oxygen drops in real time during surgery. Long before a patient's skin visibly turned blue.
Which is huge.
Huge. John Severinghaus, who is this legendary anesthesiologist, he later called Aoyagi's breakthrough one of the most important patient safety advances of the entire 20th century.
Wow. Okay. So isolating the pulse is the genius move here.
Yeah.
But I'm still a little fuzzy on something.
Sure, what is it?
That still doesn't really explain how a simple beam of light actually knows the difference between oxygenated blood and deoxygenated blood. Like, what is the actual physical mechanism happening inside that little plastic clip?
Good question. So the clip is essentially shining two very specific wavelengths of light right through your finger.
Okay, two lights.
Right. One is a red light at about 660 nanometers, and the other is an infrared light, which is invisible to the human eye at about 940 nanometers.
And then what?
Well, on the other side of your finger, like usually on the bottom part of the clip, there's a photodetector, and that measures exactly how much of each color actually makes it all the way through the tissue.
Ah, okay. And I'm assuming the oxygen in the blood changes how it absorbs those two specific colors.
You nailed it. It's all about the hemoglobin. That's the protein in your red blood cells that actually carries the oxygen.
Right.
Hemoglobin physically changes its shape and its optical properties depending on whether it's holding onto an oxygen molecule or not.
Okay, so how do the colors react?
So oxygenated blood, which we call oxyhemoglobin, it absorbs way more of the infrared light, and it basically lets the red light pass right through.
Okay, and deoxygenated blood.
It does the exact opposite. It absorbs much more of the red light.
Oh, which is exactly why arterial blood, the blood full of oxygen, looks so bright red to us, while the venous blood sitting in our arms looks darker and bluer. It's absorbing the red light instead of reflecting it back to our eyes.
Precisely. You're seeing the physics in action. The oximeter is just measuring that exact same color difference. It's just using a highly sensitive light detector instead of a human eye.
That makes perfect sense.
And this brings us right back to Ayagi's really clever trick, because the device has to filter out your skin, your fingernail, your bone, because all of that absorbs light too.
Right, because my bone obviously doesn't have oxygen in it that fluctuates every single second.
Exactly. So in physics terms, that constant unchanging light absorption from your bone and your static tissue, that is called the DC component,
Right.
direct current. And the pulsing surge of the arterial blood, that is the AC component, alternating current.
Got it.
So the microprocessors inside the oximeter, they literally just subtract the DC component out of the equation entirely.
Oh, wow. They just do the math and wipe it out.
Yep. It isolates the AC, compares the red versus infrared absorption in just that tiny pulsing surge, and then it spits out a percentage on the screen.
Which perfectly explains a really common issue you hear about in hospitals.
Which one?
Like, if a patient's hands are freezing cold, or maybe they are in shock and their blood pressure is dangerously low, the nurse often can't get a reading on their finger at all. The machine just sits there and beeps.
Exactly.
It's because there's just no pulse getting to the finger, so there's absolutely no AC component for the machine to measure.
That is the perfusion index at work, exactly. Some of the more advanced monitors will actually display the perfusion index as a number on the screen.
Oh, really?
Yeah, it tells the clinician exactly how strong that pulse signal is. If it's too weak, the SpO2 estimate is either going to be highly unreliable, or the machine will just give up and read absolutely nothing.
Okay, so the machine filters out the noise, does all this math, and gets the reading. Let's talk about the reading itself.
Okay, let's do it.
Because there is a very specific number that makes doctors and nurses, sit up straight. 92%.
Yeah, 92.
Why is that the magic number? I mean, why not 85% or just an even 90%?
To understand that 92% threshold, we really have to look at how hemoglobin actually behaves inside your body. It's described by something called the oxyhemoglobin dissociation curve.
Okay, dissociation curve.
Right. Because hemoglobin's willingness to hold on to oxygen, it isn't just a simple, straight one-to-one line.
Meaning what? It doesn't just slowly, evenly tick down like the gas gauge in my car?
No, not at all. It's an S-shaped curve, a sigmoidal curve.
Okay, and
Yeah. So when the actual physical pressure of oxygen dissolved in your blood plasma, which is called the PaO2, when that is high, your hemoglobin holds onto the oxygen very, very tightly.
okay.
This is the top flat part of the S-curve. Let's say your oxygen pressure drops from 100 millimeters of mercury down to 80, or maybe even 70.
That sounds like a pretty big drop in pressure.
It is a significant amount of pressure to lose, but because of how the hemoglobin tightly binds at that stage, your SpO2 reading on the screen will barely budge.
Really?
Yeah, it might just drop from 100% to like 96%.
Wow. So the oximeter reading is basically masking the underlying drop in pressure. I mean, you're losing oxygen, but the percentage still looks totally fine.
It is absolutely masking it. And honestly, that's fine physiologically speaking because your tissues are still getting the oxygen they need.
Right.
But here is the problem. Once that underlying pressure drops below roughly 60 millimeters of mercury, you suddenly hit the steep part of that S-curve.
The cliff.
The cliff. The hemoglobin suddenly starts letting go of oxygen very, very rapidly. It literally drops off a cliff.
Wow.
At that point, tiny microscopic drops in your actual oxygen pressure will cause massive rapid drops in your saturation percentage. And a blood oxygen pressure of 60 corresponds to an SpO2 reading of roughly 90%.
Okay, I think I'm picturing this perfectly now. It's like if I'm sitting at 92%, it's basically like the warning track on a baseball field.
Oh, that's a good analogy.
Right, like I haven't hit the wall yet. I'm still technically okay on the warning track, but the warning track is there to tell me I am mere inches away from crashing into a very steep drop-off. Like I'm standing right at the edge of the cliff.
The warning track is a fantastic way to think about it. 92% isn't just some arbitrary round number that medical boards just made up.
Right.
It is the physiological edge of the cliff. Below that point, your true blood oxygen is plummeting much, much faster than the SpO2 number alone might suggest.
That's scary.
It is. If you drop from 92 to 88, you are in a completely different, much more dangerous physiological state than someone who just dropped from 98 to 94.
Okay, that makes the 92% rule make total sense. But this brings up a genuinely terrifying scenario from our sources.
What's that?
What happens when you are standing on that warning track, or maybe you've actually already fallen off the cliff entirely, but the glowing little box just cheerfully tells you you're at 100% and perfectly safe? Like, when does this thing outright lie to us?
Yeah, this is where understanding the limitations of the technology becomes a literal matter of life and death.
Definitely.
Because the standard pulse oximeter only uses those two wavelengths of light, the red and the infrared. It has some catastrophic blind spots.
Catastrophic blind spots.
Yeah, and the most famous one, and arguably the most dangerous one in emergency medicine, is carbon monoxide poisoning.
Right. So say someone is pulls from a house fire, or they were working in a closed garage with a running engine.
Right.
They get wheeled into the ER, the clip goes on their finger, and it just reads 100%.
And that 100% is a complete and utter fiction.
Wow.
A standard two-wavelength oximeter simply cannot distinguish between oxyhemoglobin, which is the good blood carrying life-saving oxygen, and carboxyhemoglobin, which is blood bound to toxic carbon monoxide.
It literally cannot tell the difference.
Nope. To those specific red and infrared sensors, carbon monoxide looks essentially identical to oxygen.
So the patient could be critically starved of oxygen at a cellular level, like their brain is actively dying, and the machine will confidently tell the triage nurse that everything is 100% fine.
Yes.
That is terrifying. How do ERs even handle that?
Basically by just not trusting the machine.
Oh, really?
Yeah, whenever carbon monoxide poisoning is even suspected, like any house fire patient, they bypass the standard finger clip entirely.
What do they use instead?
They will use dedicated multi-wavelength co-oximeters that use 4 or even 8 different colors of light to differentiate the specific molecules, or they will just immediately draw arterial blood for a direct lab test. You absolutely do not trust a standard SpO2 reading in that scenario.
Are there other things that trick the light like that? I know the source material mentions something called methemoglobinemia.
Yes. Methemoglobinemia is a slightly rarer failure mode, but highly documented.
What causes that?
It can be triggered by certain drugs. Most commonly, it's benzocaine anesthetic sprays, like the kind they use to numb your throat before a medical procedure.
Oh, okay.
Or sometimes an antibiotic called Depsone. Basically, the drug causes a chemical oxidation reaction that alters the iron inside the patient's hemoglobin.
And that messes it up.
Yeah, the hemoglobin can no longer bind to oxygen properly.
So how does the oximeter misread that?
Well, this chemically altered hemoglobin absorbs red and infrared light almost equally.
Oh, I see. And the math relies on a difference between the two.
Exactly. The math inside the oximeter relies on a distinct ratio between those two colors. So when they absorb equally, the algorithm just gets totally confused and defaults to a fixed central point.
What does it read?
The reading on the screen will just stubbornly stick it right around 85%.
Just 85, no matter what the patient is actually doing.
No matter what, you could blast the patient with 100% pure oxygen, or they could be catastrophically crashing and literally turning blue, and the machine will just sit there calmly saying 85%.
That's wild.
It is. Anesthesiologists and ER doctors are specifically trained to recognize that stubborn 85% ceiling and floor as a massive red flag for methemoglobinemia.
Okay, so those are chemical tricks. But there is another major misconception we need to cover about what the SpO2 percentage actually represents, even when there are no chemicals involved at all.
Right, definitely.
Because people tend to think SpO2 tells you the total volume of oxygen in your blood.
Yep.
But it doesn't, does it?
Not at all, and this is what we call the anemia misconception. SpO2 only measures the percentage of available hemoglobin that is currently carrying oxygen.
Just the percentage.
Yes, it is a percentage of capacity, not a total absolute quantity.
Okay, I'm trying to wrap my head around that. If I have 98% saturation, how could I still be starving for oxygen? Like, what's a good way for us to picture this?
Think about it like hotel occupancy.
Okay, hotels.
Imagine a hotel manager bragging that they're operating at 100% occupancy. That sounds fantastic, right? They must be housing a ton of people.
Right, but what if they only manage a tiny little 5-room roadside motel?
Exactly. The percentage is totally maxed out. 100% of the rooms are full. But the total capacity to house people is incredibly low.
I get it now.
A severely anemic patient works the exact same way. They have very few red blood cells, very little hemoglobin overall, so the tiny amount of hemoglobin they do have might be completely saturated with oxygen.
And the oximeter looks at those 5 rooms, sees they are full, and just cheerfully reports 98%.
But because they have so little hemoglobin in the first place, their body is carrying a dangerously low total volume of oxygen. The tissues are suffocating, but the screen says 98%.
Wow. So the SpO2 is falsely reassuring them.
Correct. The patient is in a silent crisis.
So carbon monoxide, weird drug reactions, severe anemia, these are all really scary, but they are edge cases. They require specific, circumstances.
True.
But there is a far more common systemic illusion hiding right in plain sight, one that affected millions of people and literally took a global pandemic to fully expose at scale.
Yes, we really need to talk about the skin pigmentation bias.
Without a doubt, this is the most consequential controversy in the history of the device.
It really is. I mean, for decades, the industry standard for these devices, which was actually codified in international guidelines like ISO 80601-261, it claimed that pulse oximeters were universally accurate to within plus or minus 2 percentage points.
Which sounds incredibly precise and reliable.
It does. But in December 2020, right in the absolute darkest days of the COVID-19 pandemic, a researcher named Michael Schoeding published a bombshell study in the New England Journal of Medicine.
A bombshell. What did he do?
He and his team looked at paired data. So they took the pulse oximeter reading on the finger and immediately compared it to an arterial blood gas test, the ground truth SO2 in thousands of patients.
And what did they find when they compared the estimate to the truth?
They found that Black patients had nearly 3 times the rate of something called occult hypoxemia.
Occult meaning hidden. Right?
Exactly, hidden. The pulse oximeter on their finger was reading a perfectly safe 92 to 96%. They looked fine on the screen. But when they tested their actual arterial blood, the oxygen was dangerously low, like below 88%.
Wow. The oximeter was completely missing the hypoxemia. It was hiding the fact that these patients were literally suffocating.
Yes. The device was systematically overestimating the true oxygen saturation in patients with darker skin.
Why? Like, what's the physics there?
The underlying physical mechanism is actually pretty straightforward. Melanin, the pigment in skin, absorbs and scatters light. But the original calibration algorithms programmed into these microprocessors decades ago, they were based almost entirely on volunteer studies using lighter-skinned individuals.
Wait, hold on. If this plus or minus 2% standard was an international rule for decades, how did a blind spot this massive just go totally unnoticed? I mean, weren't doctors seeing this discrepancy in the ER for the last 30 years?
It's a profound question and honestly a really painful one for the medical community.
I can imagine.
The truth is, smaller studies actually did flag this pigmentation-related inaccuracy going all the way back to the 1990s.
He says some people did know.
They did. But before COVID, pulse oximetry was largely a clinical tool used by specialists in highly controlled settings, like ICUs and operating rooms.
Okay, so how did that mask the problem?
Those specialists were trained to look at the whole patient, not just blindly trust the number on the screen. They were looking for other signs of distress.
Right. But what changed was COVID-19.
Exactly. Suddenly, this niche monitoring device was being distributed globally. It was being used in overwhelmed ER triage tents and sent home with millions of lay people to make hard binary decisions.
Right, like if you're above 92%, you go home. If you're below 92, you get a hospital bed.
Yes. It stress-tested the old assumptions at a scale we had never seen before. And when you scale a bias algorithm across millions of people in a crisis, the hidden average breaks down and the systemic harm becomes glaringly obvious.
Because Black and brown patients were being sent home because the machine said 94% when their real oxygen was 87.
Exactly. This revelation finally led to massive safety communications from the FDA in 2021 and 2022.
It's about time.
Yeah, and by 2024, there was a major regulatory push demanding that manufacturers fundamentally change how they test these devices, requiring diverse clinical validation before approval.
It's just staggering to think about how much hidden bias exists in the tools we just assume are purely objective.
It really makes you rethink things.
It does. Okay, so the device can be tricked by ambient light, by carbon monoxide, by rare drugs, by low blood pressure, and by the very pigment of our skin.
It's quite a list.
But there's one final piece to this puzzle from our deep dive. Even if the device works perfectly, Even if you have a flawless algorithm and perfect blood flow, people still fundamentally misunderstand what a good reading actually means about their lungs.
This is perhaps the most dangerous everyday misconception in clinical practice.
Let's get into it.
People think a normal SpO2 reading of 99% means the lungs are doing their entire job correctly.
Which leads us to the critical difference between oxygenation and ventilation. I think most people just assume those are the exact same thing.
They really aren't. Your lungs actually have two distinct jobs.
Okay, job one.
Job one is oxygenation, bringing fresh oxygen into the blood. Job two is ventilation, getting toxic carbon dioxide out of the blood and exhaling it.
And pulse oximetry only measures the first job.
Only the first job. It measures oxygenation. It tells you absolutely nothing about ventilation.
What?
It has no idea if you are successfully clearing carbon dioxide from your body.
It's like the oximeter only tells you if the grocery delivery is making it to the house. It tells you absolutely nothing about whether the trash is being taken out.
I love that analogy. The groceries are arriving, but the trash is just backing up.
Right.
And if the trash backs up long enough, the house becomes unlivable. A classic, terrifying clinical example of this is a post-op patient who is oversedated, perhaps with opioid painkillers.
Okay, because opioids depress your breathing.
Exactly. They depress the respiratory drive, meaning the patient takes very shallow, very slow breaths.
But if they're wearing an oxygen mask in the recovery room, that tiny, shallow breath is full of pure oxygen.
Right. So their SpO2 might look like a perfectly reassuring 98 or 99%. The groceries are being delivered just fine.
But because they are barely breathing, they aren't exhaling enough volume to clear the carbon dioxide.
The trash is backing up rapidly. They are steadily retaining deadly levels of carbon dioxide in their blood. They could literally be drifting right into a coma or full respiratory arrest, and the pulse oximeter will just sit there glowing 99% and will not sound an alarm until it is far too late.
How do doctors monitor the trash then?
To catch the CO2 buildup, clinicians need a totally different monitor called capnography, which specifically measures the carbon dioxide in every single exhaled breath.
Okay, so trusting a pulse oximeter alone to tell you if someone is breathing well is a fundamental and potentially fatal error.
Absolutely.
And isn't this ventilation issue also why that 92% cliff we talked about earlier isn't actually a universal rule for every single patient?
That's a great point, yeah. If you have a patient with advanced COPD, chronic obstructive pulmonary disease, their baseline physiology has adapted over years.
Oh, so?
They chronically retain CO2. Because of this, clinicians often deliberately manage them to a lower target SpO2, usually around 88 to 92%.
Like they want them hovering right near the cliff?
Why? Because in severe COPD patients, their brain's trigger to take a breath is driven by low oxygen rather than high CO2 like the rest of us.
Oh, I see.
Yeah, so if you pump them full of supplemental oxygen and push their SpO2 to 100%, you completely remove their physiological drive to breathe.
Because their brain thinks they have plenty of oxygen.
Exactly. They breathe even slower, their CO2 spikes to lethal levels, and they stop breathing entirely.
Wow.
So 92% is a warning track for a healthy person, but it might be the exact safe target zone for someone with COPD.
This has been incredibly eye-opening. We take this little glowing clip totally for granted, but there is an entire universe of physiological complexity hiding right inside it.
There really is.
When you walk away from this deep dive, remember that SpO2 is an estimate of a percentage, not a hard quantity of total oxygen. Remember that 92% isn't just a grade on a test. It is the physical edge of a cliff where oxygen drops precipitously.
Good summary.
Thanks. Remember, the device can be completely fooled by carbon monoxide and cold hands, and that older algorithms had massive, massive blind spots for darker skin. And above all, remember the groceries and the trash. Normal oxygen on a screen does not mean normal breathing.
You know, if we pull back from all the mechanics for a moment, this entire deep dive really raises a much more profound question for you to think about.
What is that?
If a life-saving device invented in the 1970s and hailed as this absolute miracle of modern patient safety carried a hidden systemic bias that literally took a global pandemic to fully expose at scale.
Yeah.
How many other trusted diagnostic tools, risk scores, and algorithms in our modern hospitals are silently operating on narrow, outdated assumptions right now?
Wow.
It is a stark reminder to never blindly trust the technology and to always question the ground truth of the data you are handed.
That thought is definitely going to stick with me. Next time you're sitting on that crinkly paper and that little plastic clip snaps onto your finger, just remember, the number glowing in the red light is only telling you half the story. When you look at a comprehensive metabolic panel, there's usually this comforting expectation of certainty, you know?
Right, like it's a definitive answer.
Yeah, exactly. You read
Right.
it like a bank statement. If you see like a low potassium level, you just replace it.
Yep.
Or if the sodium is climbing, you adjust the patient's fluids. It feels entirely binary and,
Yep.
well, objective.
It does, but that's not always the case.
No, not at all.
Yeah.
Because then you look one line down at the serum calcium, and that comforting certainty completely vanishes.
Oh, it really does.
You essentially step into this diagnostic landscape that operates entirely on medical illusions,
Mm-hmm.
where a perfectly normal number can belong to a patient who is actively crashing, and an alarmingly low number might mean absolutely nothing at all.
Which is terrifying if you don't know what you're looking at.
Right. So today we are taking a deep dive into the human nervous system for you. We're looking at the telltale signs of calcium imbalance.
And it's really a medical detective story, honestly.
It really is. We're going to untangle the modern critical care debates surrounding it and explore how a few, like 19th century bedside tricks are literally still dictating modern medical protocols today.
Because, we're so conditioned to trust the numbers on the screen.
Yeah, totally.
We treat them as empirical reality.
Yeah,
But calcium forces you to question the methodology behind the number.
which is hard to do in a fast-paced environment.
Exactly. If you just take the lab value at face value, without understanding the physiological state of the patient sitting in front of you, you are going to make critical errors.
Okay, let's unpack this. Because the trap starts with the very definition of what we're actually measuring.
Right.
Let's say I'm looking at a critically ill patient, maybe someone septic in the ICU, and their total calcium comes back at 7.2.
Which is low. The normal range is 8.5 to 10.5 milligrams per deciliter.
Right, so 7.2 is low. The instinct is to panic and push IV calcium.
Right, of course it is.
But that total calcium number is hiding this massive structural division in how the mineral actually exists in the blood.
It's hiding the fact that total calcium is essentially a composite score of 3 completely different compartments,
Okay.
and only one of those compartments actually matters to the patient's immediate survival.
Only one.
Yeah, just one. So roughly 40% of the calcium in the blood is tightly bound to plasma proteins.
Mostly albumin. Right?
Predominantly albumin, yeah. And then another 10% is complexed with anions, things like phosphate or citrate.
Okay, so that's half of it right there.
Exactly. That leaves only about 50% existing as free ionized calcium.
And the ionized portion is the only part doing the actual physiological work, you know?
Right, it's the active part.
I actually like to think about this in terms of personal finance.
Oh, I like this analogy.
Yeah, so imagine a patient's total serum calcium is their total net worth.
Okay.
40% of their money is locked away in an untouchable trust fund.
Ah, the albumin-bound calcium.
Exactly, they cannot spend it. The 50% that is ionized is their liquid cash.
The money in their checking account?
Right, that's what they use to pay the daily bills.
Mm,
Firing nerves, contracting muscles, clotting blood.
all the vital stuff.
Yeah. So if I have a septic patient whose liver has stopped producing albumin, their trust fund is basically empty.
Their net worth looks terribly low on paper.
Exactly. Their total calcium is low. But if I actually measure their liquid cash, their ionized calcium, it might be perfectly adequate
That analogy hits the absolute core of the problem.
because you could overcorrect. Right.
Right. If you look at that artificially low total calcium and immediately push an IV replacement, you are treating a ghost.
Oh, wow. Yeah.
You risk driving their true ionized calcium dangerously high.
Which is hypercalcemia.
Exactly. Now, for decades, the medical workaround was to use the corrected calcium formula.
I've heard that.
Yeah, clinicians would take the total calcium lab value and mathematically adjust it based on the patient's albumin level.
Basically trying to guess the liquid cash based on the size of the trust fund.
Right, attempting to estimate the true physiological state.
But if you talk to nephrologists or intensivists today, they act like the corrected calcium formula is practically a relic.
Oh, they hate it.
Why has it fallen out of favor if it supposedly accounts for that albumin drop?
Because the formula assumes a static relationship.
Yeah.
And, well, critical illness is anything but static.
That's constantly changing.
Exactly. The affinity of albumin for calcium isn't fixed. It changes based on the patient's blood pH, their temperature, and even the presence of medications like heparin.
Wait, really?
Yeah, if a patient hyperventilates and becomes alkalotic, for example, their albumin suddenly binds calcium much more aggressively.
Oh, so it steals it from the ionized pool.
Yes, it literally locks up the liquid cache.
Wow.
And the formula cannot account for those dynamic, real-time shifts. Relying on it in a complex ICU patient is essentially just guessing.
So what do they do instead?
That is why the modern gold standard is to bypass the total calcium entirely and measure the ionized calcium directly via a blood gas analyzer.
It is fascinating that such a foundational question like, is this patient's calcium normal, requires you to bypass the standard metabolic panel entirely.
You just can't trust it.
But if we isolate that liquid cache, that ionized calcium, we have to look at what it actually does at the cellular level.
A physiology.
Right. Because I always pictured calcium as an excitatory mineral.
Most people do.
You think of it flooding into muscle fibers to trigger a contraction. But in the nervous system, it actually acts as a brake, doesn't it?
It acts as the ultimate gatekeeper.
The gatekeeper.
Yeah, the clinical picture of calcium imbalance basically revolves around the excitable cell membrane.
Okay, picture that for me.
Picture the cell membrane of a peripheral nerve as a wall lined with voltage-gated sodium channels.
Like doors in the wall.
Exactly. The ionized calcium sits on the extracellular surface of those channels.
Just hanging out outside the door.
Right. Because calcium is a divalent cation, meaning it has a positive 2 charge, its physical presence alters the electrical threshold required for that sodium channel to open up.
Oh, so it literally stabilizes the membrane. So if the ionized calcium drops, if you develop hypocalcemia, you lose the gatekeeper.
You completely lose the gatekeeper.
Yeah.
And the threshold for depolarization just plummets.
The doors swing open?
Yes. Those sodium channels open with almost zero provocation. Sodium rushes into the cell, and the nerve fires spontaneously.
Wow.
The entire nervous system becomes wildly hyperexcitable.
Here's where it gets really interesting, though.
Oh, yeah.
Wait, so if low calcium makes nerves fire spontaneously, is that why patients get that random tingling around their mouth?
Yes, exactly.
Because a lot of times the patient will complain of a weird tingling around their mouths or maybe numbness in their fingertips.
The classic early sign.
And it's incredibly easy to dismiss that as anxiety.
Oh, it happens all the time.
You think, oh, they were just stressed, maybe hyperventilating.
But those early paresthesias, the perioral and acral tingling, are the sensory nerves literally misfiring because the calcium brake has been removed.
That's incredible.
And dismissing that tingling is a massive clinical pitfall.
It's not just anxiety.
No. It is the absolute earliest warning sign of impending tetany.
Which is bad.
Very bad. If that hyperexcitability is allowed to escalate, it moves from the sensory nerves to the motor nerves.
So the tingling turns into actual cramping.
Right. Tingling turns into muscle cramping, then overt spasms, and eventually full-blown seizures.
Man.
It even destabilizes the cardiac conduction system. It physically prolongs the QT interval on an ECG, which sets the stage for lethal arrhythmias.
And I assume the physiology works in the exact opposite direction, too.
It does.
Like, if low calcium removes the brake and makes everything hyperexcitable, hypercalcemia does the reverse.
It overstabilizes the membrane.
It puts too many guards at the door.
Exactly. The sodium channels become stubbornly resistant to opening.
So what does that look like clinically?
The clinical result is profound sluggishness.
Okay.
Patients present with severe lethargy, muscle weakness, deep confusion, and in extreme cases, coma.
Because the nerves just won't fire.
Right. And the heart's electrical firing is rushed, leading to a shortened QT interval.
Once you understand the biophysics of that sodium channel gatekeeper, every single symptom you see at the bedside makes perfect logical sense.
It really does. But what's amazing is that clinicians figured this out long before they knew any of that science.
Yes, because long before anyone had mapped out voltage-gated sodium channels or understood the physics of cell membranes, clinicians were observing this exact hyperexcitability in real time.
It's wild.
Clinical pattern recognition completely outran basic science by decades.
We really have to look back to 19th century Europe.
Right.
In the 1860s, nobody knew what serum ionized calcium was. Basic endocrinology didn't even exist.
They were just looking at symptoms?
Exactly. But physicians observed a terrifying neuromuscular irritability syndrome they called tetany.
And they started figuring out ways to provoke it diagnostically.
Yeah, the most famous example being Armand Trousseau.
Oh, the French internist.
Right, working in Paris in 1861.
He noticed something bizarre.
He did. If he occluded the blood flow in a patient's arm, sometimes just incidentally by applying a tourniquet to draw blood, it triggered an incredibly specific involuntary spasm in the patient's hand.
The characteristic obstetrician's hand.
Yep. The fingers forcefully extend, the thumb adducts tightly into the palm, and the wrist flexes inward.
It looks so painful.
Trousseau realized that inducing ischemia in the arm exacerbated the underlying nerve irritability.
Because the nerve was already primed to misfire because of the low calcium, right?
Exactly, though he didn't know the calcium mechanism at the time.
Right.
And cutting off the blood supply just pushed it over the edge into a visible spasm. He named this a marker for latent tetany.
But there's a detail in Trousseau's biography that is just wild to me.
Oh, the two signs.
Yes. Nursing and medical students are constantly warned not to confuse his signs because Trousseau's name is actually attached to two completely unrelated medical phenomena.
It's a classic exam trick.
Right. There's Trousseau's sign of latent tetany, which we just discussed.
Oh.
But there is also Trousseau's sign of malignancy.
Yes, migratory superficial thrombophlebitis.
Right.
It is a blood clotting disorder that frequently acts as an early warning sign for hidden visceral malignancies, particularly pancreatic or gastric cancer.
And Trousseau discovered both of these.
He did.
But the dark irony is that in 1867, just a few years after publishing his work on the tetany spasms, Trousseau developed unexpected blood clots in his own leg. He found the second sign on his own body.
He actually used his own discovery to...
Wait, he diagnosed himself?
He did. He used his namesake discovery to correctly self-diagnose the gastric cancer that ultimately killed him a few months later.
Wow, that is a profound, if tragic, piece of medical history.
It really is. What's fascinating here is how it serves as a reminder of how heavily early medicine relied on the astute physical exam.
Pattern recognition.
Exactly. And Trousseau wasn't alone. In 1876, an Austrian surgeon named Franz Schwastek identified another mechanical trigger for tetany in Vienna.
Oh, Schwastek's sign.
Right.
Schwastek found that if you simply tap on a patient's facial nerve right in front of the earlobe, below the cheekbone, the facial muscles will involuntarily twitch.
Just a little tap?
Yeah, sometimes just the corner of the mouth, sometimes the entire side of the face pulls upward.
And again, he didn't know the basic science.
He just recognized the pattern of the hyperexcitable nerve.
Right. And what's fascinating here is how these 19th century observations transitioned into the modern era.
Because we still use them.
We do.
Right.
Today, we understand the exact molecular mechanisms behind them, yet Trousseau's and Schwastek's signs remain standard physical exam techniques taught in every medical and nursing school.
But their utility in a modern hospital room is highly debated.
Oh, heavily debated.
Because they are not equally reliable. It creates this massive bedside dilemma.
This raises an important question about shortcuts in medicine.
Yeah, let's start with Schwastek's sign. It is incredibly appealing because it is so easy to perform.
It takes 2 seconds to tap a patient's cheek.
Exactly. But you look at the modern data, and Schwastek's sign has a terrible false positive rate.
Very high.
Something like 10% of people with perfectly normal calcium levels will twitch if you tap their facial nerve.
So the specificity is incredibly poor.
Right.
If you get a positive Schwastek sign, it does not confirm hypocalcemia.
It just means you need to check.
Exactly. It simply mandates that you draw the patient's blood and check an ionized calcium level. It is a screening tool, not a diagnostic one.
But Trousseau's is different.
Right. Trousseau's sign of latent tetany, conversely, is highly specific.
Right.
If you induce that distinct carpal spasm, the statistical probability that the patient has true hypocalcemia is overwhelming.
But the execution of Trousseau's sign is where the problem lies.
It's not easy.
No, you can't just tie a quick tourniquet like you did back in the day.
Right, the modern protocol is stricter.
The protocol requires you to inflate a blood pressure cuff above the patient's systolic pressure and hold it there, cutting off the arterial blood flow for a full 3 minutes.
And 3 minutes of arterial occlusion is intensely uncomfortable.
I can't even imagine.
Yeah, particularly for a patient who is already sick, distressed, or, recovering from surgery.
It perfectly illustrates the classic shortcut problem in clinical medicine.
It really does.
The test that is easy to do, the cheap tap, is the one you can't fully trust.
Right.
But the test you can trust, the 3-minute blood pressure cuff, is the one clinicians are tempted to skip because it causes the patient distress.
But skipping these assessments is dangerous.
Because these calcium shifts aren't theoretical.
No, they happen constantly in specific clinical scenarios.
So where do we actually see this?
Well, the context of the patient dictates your index of suspicion.
Okay.
The most notorious trigger for acute hypocalcemia is thyroid surgery.
Oh, right.
A patient undergoes a total thyroidectomy to remove a malignancy. The surgeon has to navigate around the 4 parathyroid glands, which are tucked directly behind the thyroid capsule.
And these glands are microscopic, right? They're about the size of a grain of rice. And their vascular supply is incredibly fragile.
Extremely. They share a blood supply with the thyroid itself.
Okay.
So even if the surgeon meticulously preserves the parathyroid glands, the microvasculature is easily bruised or temporarily devascularized.
They just get stunned.
Exactly. And those 4 tiny glands are the sole producers of parathyroid hormone, or PTH.
Which is the primary engine the body uses to mobilize calcium into the blood.
Right. If they are stunned during surgery, PTH production halts and the ionized calcium crashes within hours.
That perfectly explains why post-thyroidectomy protocols are so strict.
You have to watch them like a hawk.
You are checking labs and doing bedside assessments for Chvostek's and Trousseau's every few hours.
Yep.
But there is another trigger that surprised me, mostly because of how mechanical the problem is.
Which one?
Massive blood transfusions.
Oh, yes.
Let's say a trauma patient is bleeding out, and they're receiving unit after unit of packed red blood cells. They can develop severe hypocalcemia rapidly.
That is a classic iatrogenic mechanism.
Meaning we cause it, essentially.
Basically, when blood is collected and stored by a blood bank, it is mixed with a citrate solution to prevent it from clotting in the bag.
Right.
Citrate works precisely by binding to calcium.
Because calcium is needed for clotting.
Exactly. When you transfuse that blood into a patient, their liver normally metabolizes the citrate into bicarbonate without any issue.
But if you are doing a massive transfusion, you are just overwhelming the system.
You completely overwhelm the hepatic clearance.
Wow.
Particularly because a trauma patient in hemorrhagic shock has poor perfusion to their liver anyway.
So the liver isn't even working at 100%.
Right. The citrate accumulates in the bloodstream and instantly chelates or binds the patient's circulating ionized calcium.
It just sponges it all up.
Yes. Suddenly, the patient is not only bleeding, but their heart muscle is losing the calcium it needs to maintain a strong contraction.
Which leads to severe hypotension and potential arrhythmias.
It's a cascade. It requires clinicians to anticipate the drop and proactively push IV calcium alongside the blood products.
Okay, so those are the classic avenues for a calcium crash.
Right.
Let's pivot to hypercalcemia, when the calcium climbs too high. The sources point out a really distinct diagnostic split depending on where the patient is located when the high calcium is discovered.
Oh, the location completely dictates your diagnostic algorithm.
Okay, how so?
If you see hypercalcemia in an ambulatory outpatient, like someone who just walked into a primary care clinic for routine lab work, the overwhelming statistical probability is primary hyperparathyroidism.
Which is what exactly?
Usually this is a single benign adenoma on one of the parathyroid glands that is autonomously secreting too much PTH, completely regardless of the blood calcium levels.
So it's just pumping out hormone when it shouldn't.
Exactly. But if that hypercalcemia is discovered in a patient who is already admitted to the hospital, the most likely cause completely flips.
Right. It's not the benign adenoma anymore.
No. In a hospitalized population, hypercalcemia is overwhelmingly driven by a malignancy.
Cancer.
Yes. It could be a tumor secreting a peptide that perfectly mimics PTH, confusing the body.
Wow.
Or it could be osteolytic metastases cancer cells that have spread to the bone and are actively destroying the bone matrix, releasing massive amounts of calcium into the circulation.
Man, that's heavy. But you know, you cannot talk about hypercalcemia without diving into milk alkali syndrome.
Oh, the history of this is incredible.
It is one of the most bizarre medical plot twists.
Truly.
Back in the early 20th century, the standard treatment for peptic ulcer disease was this thing called the sippy diet.
Right.
Doctors had patients drink massive, continuous quantities of milk and absorbable alkali powders, like calcium carbonate.
Because it worked. It was an effective way to neutralize stomach acid before the invention of modern pharmacology.
Right, but it flooded the gastrointestinal tract with so much calcium that it caused a toxic triad.
Severe hypercalcemia, metabolic alkalosis, and acute kidney injury.
But then we invented modern acid-suppressing drugs.
Yeah.
You know, H2 blockers and proton pump inhibitors.
Thank goodness.
Right. Sippy diet was abandoned, and milk alkali syndrome basically went extinct.
You couldn't find a case of it in the medical literature by the 1980s.
But today, shit is back.
It is.
And it hasn't been brought back by a new disease. It's been resurrected entirely by modern consumer wellness trends.
Yep. The aggressive marketing of over-the-counter calcium carbonate supplements for bone health and osteoporosis prevention has led to this culture of inadvertent overdosing.
People just think, oh, it's natural.
Exactly. Patients assume that because calcium is a natural mineral, more must be better.
Right.
They take heavy doses of calcium supplements, combine them with over-the-counter antacids for indigestion, and add high-dose vitamin D.
Oh, no.
They are perfectly recreating the sippy diet conditions from a century ago.
That's wild.
They develop the exact same toxic triad and end up landing in the emergency department with renal failure.
It just highlights this dangerous misconception that supplemental nutrition is inherently risk-free.
It's not.
It's just wild that a disease eradicated by medical advancement was resurrected by a marketing campaign.
If we connect this to the bigger picture, it really proves how interconnected and unforgiving the entire endocrine system is.
Everything affects everything.
Yes, you cannot view calcium in a vacuum. We've discussed PTH and vitamin D, but there is a silent partner operating behind the scenes that dictates everything.
Magnesium.
Magnesium.
Magnesium. Why is it that you can't fix a calcium imbalance without looking at magnesium first? Does it bind to the calcium in the blood?
No, it doesn't bind to it. It regulates the regulators.
Okay, what does that mean?
Magnesium is a required intracellular cofactor for the parathyroid glands.
Okay.
In order for the glands to package and secrete parathyroid hormone, they literally need magnesium.
So no magnesium, no PTH.
Exactly. If a patient is severely deficient in magnesium, it physically paralyzes the parathyroid glands.
Wow.
Furthermore, the peripheral tissues become resistant to whatever little PTH is circulating.
So you could have a patient actively seizing from hypocalcemia, and you could push intravenous calcium all day long, but it won't work. It won't hold. Because the body can't retain it in the blood, because the control mechanism is paralyzed.
Right. You have to infuse magnesium to wake up the parathyroid glands before the calcium gatekeeper can actually do its job.
So what does this all mean? We started with the illusion of the standard lab panel, explored how ionized calcium operates as the crucial gatekeeper for every nerve in your body, traced the history of Trousseau's 19th century tourniquet, and ended up at the intersection of modern wellness trends and hidden magnesium deficiencies.
It's quite a journey.
The physiological mechanics are fascinating, but the clinical stakes are just incredibly high.
The stakes are exactly why understanding this is a mandatory competency.
Yeah.
Missing these signs is universally categorized as a preventable harm.
Because we know what to look for.
Exactly. If you brush off a patient's tingling lips as anxiety, it can progress to laryngospasm.
Which is when the vocal cords lock shut, right?
Yes, the vocal cords lock shut and the airway is lost.
Terrifying.
And on the flip side, we must abandon the notion that hypercalcemia is always glaringly obvious.
Right, because of the rhyme.
Yeah, medical students memorize that classic rhyme. Stones, bones, groans, thrones, and psychiatric overtones.
Meaning kidney stones, bone pain, abdominal cramps, polyuria, and confusion.
Right. But waiting for a patient to develop bone pain and profound confusion means you've completely missed the window.
That's too late.
That rhyme only applies to late-stage severe hypercalcemia. Mild hypercalcemia operates completely silently.
So you wouldn't even know.
It is an insidious process. It is why we rely on routine laboratory screening, provided we actually understand how to interpret the numbers we are looking at.
The ionized cache.
Exactly. And, examining this delicate balance leaves me with one final thought, specifically regarding vitamin D.
Which is the primary driver for absorbing calcium from our diet in the first place, right?
Precisely. We know that vitamin D deficiency is one of the most common causes of hypocalcemia globally.
Okay.
Human physiology coordinates this extraordinary dance between the bones, the kidneys, and the gut to keep our ionized calcium locked into a microscopic, highly protected window.
Right, a very tight range.
But consider our modern environment.
Okay.
We now spend the vast majority of our lives indoors, heavily shielded from the sun, fundamentally driving our baseline vitamin D levels down across the entire population.
Oh, wow. I see where you're going with this.
Right. The system is designed for an environment we no longer live in.
We don't live outside anymore.
We don't. As our environmental exposure drastically shifts over decades, this raises an important question. Could the very definition of what human biology considers normal calcium regulation be forced to evolve?
Wow, that is a brilliant question to end on. It totally reframes how we look at the boundaries of human physiology.
It really makes you think.
It does, and it reminds us that that comforting certainty we expect from a simple blood test might just be the most convincing medical illusion of them all. Thank you so much for joining us on this deep dive. Keep questioning the numbers, look for the mechanics behind the symptoms, and keep exploring the world around you.
So, when a red warning light flashes on your dashboard, you pull over, right? I mean, the signal is pretty binary.
Right, yeah.
The engine is either fine or the car is explicitly telling you something is critically broken. And we tend to treat the human body the exact same way, especially in medical emergencies. We look for those obvious flashing lights like a sudden drop in blood pressure.
But in the world of critical care and trauma, waiting for that specific dashboard light to diagnose shock means you are already dangerously late to the party.
Exactly. So today, we're diving into a stack of clinical medicine and nursing sources to completely rewire how you think about human survival. Our mission for this deep dive is to break down the 4 types of shock, the warning signs that honestly trick even seasoned medical professionals, and how the field's understanding has evolved.
Right, from, 18th century battlefields to modern ICU protocols. And for those of you listening, whether you're managing patients clinically or just fascinated by how the human body triages itself in an absolute catastrophe, I mean, this changes everything.
It really does.
Recognizing shock early within that vital window we call the golden hour dictates life or death decisions globally. The protocols we're unpacking today are the literal foundation of triage.
Applied everywhere from a local trauma bay to an active battlefield. But to start, we really have to throw out the dictionary definition, don't we?
Oh, absolutely.
Because the general public equates medical shock with, well, a sudden drop in blood pressure. It's so deeply ingrained in pop culture. A patient crashes, the monitor's alarm because the pressure plummets, and someone yells that they're in shock.
Which is a fundamental misunderstanding of the physiology. Shock is not a macroscopic blood pressure problem. It's a microscopic cellular and metabolic crisis.
Make that distinction for us.
Sure, so the clinical definition is a state of inadequate tissue perfusion. Basically, the delivery of oxygen and nutrients to the cells has simply failed to meet the body's demands.
So the cells are suffocating on a systemic level.
Exactly, they're starving for oxygen. And when that delivery fails, your cells don't just stop working, they're forced into anaerobic metabolism just to survive.
Which is super inefficient, right?
Highly inefficient. It generates only a fraction of the necessary energy and produces dangerous byproducts, specifically lactic acid. Uncorrected, that mounting acidosis causes progressive cellular injury, cascading into multiple organ failure and eventually death.
Wow.
Yeah, the crisis is happening at the cellular level long before it ever registers on a standard vital sign monitor.
So waiting for low blood pressure, then, is literally waiting for the engine block to melt and seize up before realizing you have an oil leak. The blood pressure drop is just the final catastrophic system failure.
That's a great way to put it. Because the human body is built with incredibly robust compensatory mechanisms to keep that dashboard light off for as long as possible.
Yeah.
We categorize shock into 3 progressive stages based on those defenses.
Okay, let's walk through those.
The first is compensated shock. Your tissues are already starving, but the body fires up the sympathetic nervous system, flooding the system with catecholamines like epinephrine and norepinephrine.
And this triggers massive vasoconstriction and tachycardia, right? Just desperately trying to maintain that systemic blood pressure by any means necessary.
Yeah, the body is ruthlessly triaging its own blood supply. It clamps down the vessels in the skin, the gut, the kidneys, forcefully shunting whatever oxygen is left to the brain and the heart. So the vital signs might look perfectly stable.
But the invisible fire is already burning. And if the underlying cause isn't fixed, you inevitably hit the second stage, which is decompensated shock.
Right. The compensatory mechanisms are finally exhausted. The vascular tone gives out, the heart can no longer maintain the extreme pace, and, well, this is the moment the blood pressure actually crashes.
And the third stage is basically the point of no return.
Irreversible shock. The cellular damage and acidosis have progressed so far that even if you completely resolve the initial insult, say you surgically stop the bleeding or unblock the coronary artery, the cascading organ failure just can't be stopped.
Death is imminent.
Yeah, it is.
Which really reframes the entire approach to critical care. It explains why ICU teams are constantly hunting for what the sources refer to as occult or cryptic shock. They're looking for the metabolic smoke before the vital signs crash.
Exactly. Clinicians have to look for earlier, far more sensitive markers of poor perfusion. They're drawing blood to check for elevated lactate levels to catch that anaerobic shift. They monitor capillary refill times and watch for, sudden drops in urine output or a subtle altered mental status. You have to actively hunt for it.
I want to pivot to the history here because
Yeah.
this concept of hunting for microscopic cellular suffocation is actually relatively new. For centuries, the medical field was flying completely blind on this. The
Oh.
term itself didn't even originate in a physiology lab.
No, it didn't. It originated in the trauma of warfare. We trace it back to around 1743 to a French surgeon named Henri-François Ledron.
Right.
He was treating devastating gunshot and cannon wounds, and he used the term shock to describe the violent physical jolt of the projectile impacting the human body.
And then, across the English Channel around 1815, when surgeon Samuel Latham translated Ledran's work, bringing shock into the medical lexicon. But looking at the sources, the meaning started to drift over time.
It did. It shifted from the literal physical impact of the bullet to the mysterious physiological collapse that sometimes followed hours later. But nobody really understood the mechanism.
Yeah, I love this quote from the sources. In 1872, the prominent American surgeon Samuel Gross described shock as, get this, a manifestation of the rude unhinging of the machinery of life.
It's so poetic. But as a clinical diagnosis, it is entirely useless. You cannot push a specific IV medication to fix a rude unhinging.
Right. Nurse, push 50 cc's of unhinging reversal. It doesn't work.
Exactly. And that lack of mechanistic clarity fueled intense rivalries well into the early 20th century. During World War I, the sheer volume of crush injuries in the trenches led a physiologist named Walter Cannon to popularize the toxic theory.
His logic actually makes a weird kind of sense if you put yourself in a 1918 trench. You have a soldier with a crushed limb, maybe a tourniquet applied. When the tourniquet comes off, the soldier suddenly crashes and dies.
Right. So Cannon argued that the dying crushed tissue was releasing some kind of unknown poison or toxin into the bloodstream, triggering circulatory collapse.
But he was wrong.
He was. It was an elegant theory, but fundamentally incorrect. The true breakthrough required rigorous experimentation, which American surgeon Alfred Blalock undertook in the 1930s.
This is the same Blalock famous for the Blalock-Taussig shunt in pediatric heart surgery, isn't it?
The very same. Before his pediatric cardiac work, he systematically studied traumatized tissues in animal models. He meticulously measured the weight of injured limbs versus uninjured limbs, quantifying the exact volume of plasma and fluid shifting into the damaged tissues.
So he was literally weighing the fluid lost.
Yes, and he proved conclusively that circulatory collapse wasn't caused by a mysterious circulating toxin. It was caused by massive fluid loss out of the vascular space and into the surrounding tissues. The blood volume was simply plummeting.
He proved it was a volume and flow problem. The plumbing was failing.
Blalock proposed a categorical system in 1934 that heavily influenced our modern approach. But it was Max Harry Weil in the 1960s and 70s who finalized the modern framework by shifting the focus entirely to the actual mechanism of cellular suffocation oxygen delivery.
And this brings us to the core of the sources, the absolute mathematical foundation of this deep dive. Weil's focus gives us a literal equation for human survival. When the variables in this equation break, you get the four modern types of shock.
Right. It is the oxygen delivery equation, or DO2. The formula is cardiac output multiplied by arterial oxygen content. Essentially, how much blood is the heart moving to a minute, multiplied by how much oxygen is actually bound to the hemoglobin in that blood.
And cardiac output itself is just heart rate multiplied by stroke volume.
Yes. And stroke volume is where the plumbing mechanics become essential. Stroke volume relies on three specific variables: preload, contractility, and afterload.
Let me make sure I have this straight. Preload is the tank volume, like how much blood is actually returning to the heart to stretch the ventricles before the next squeeze.
Spot on.
Contractility is the pump, the inherent physical strength of the heart muscle. And afterload is the resistance in the pipes, the systemic vascular tone the heart has to push against to eject the blood. So tank, pump, pipes.
Exactly. Tank, pump, pipes. Every type of shock we treat today is simply a pathological failure of one of those specific variables. Let's apply this to the four categories. Wheel helps cement, starting with the most intuitive one.
Hypovolemic shock. This is a catastrophic failure of preload.
The tank is empty. There's an absolute loss of circulating blood or fluid volume, meaning there is simply not enough volume returning to the heart. Stroke volume drops, cardiac output plummets, and oxygen delivery fails.
The classic scenario is severe trauma and hemorrhage. And the sources dive into the advanced trauma life support, or ATLS, hemorrhage classifications, and the data perfectly illustrates our earlier point about compensated shock hiding the danger.
Oh, the ATLS classes clearly outline how deceptive the human body can be. You can have a healthy young trauma patient lose 30 to 40% of their entire circulating blood volume, a class 3 hemorrhage, and they will often maintain a completely normal blood pressure.
Wait, almost half of their blood is on the floor, but the monitor looks fine.
Because their vasoconstriction reserves are so robust, the body clamps down the pipe so aggressively that it masks the empty tank.
Yeah.
But they are hanging by a thread. The second those sympathetic reserves fail, they instantly crash into a class 4 emergency and the mortality rate skyrockets.
It's totally the Wile E. Coyote effect. He runs off the edge of the cliff and continues sprinting in midair, defying gravity. Everything seems fine until he looks down, the illusion breaks, and he plummets.
That's a perfect analogy. If you were waiting for the BP to drop, you were watching him fall.
Okay, let's move to the second failure point. If hypovolemic is an empty tank, what happens if the tank is completely full, but the oxygen still isn't reaching the tissues?
Then the problem is the pump itself. This is cardiogenic shock, a failure of contractility. The intravascular volume is adequate, but the myocardium, the heart muscle, is too damaged to generate an effective forward squeeze.
And the most common trigger here is an acute myocardial infarction, right? A massive heart attack.
Yeah. The mortality associated with cardiogenic shock is historically brutal, sometimes reaching 80% in earlier decades. The turning point was the landmark 1999 SHOCK trial.
What does that show?
It demonstrated that rather than just trying to medically stabilize these patients with drugs, aggressively pursuing early revascularization, so rushing them to a cath lab or surgery to physically unblock the coronary artery, significantly improved survival.
You have to restore blood flow to the dying pump muscle immediately. But even with modern cath labs, the sources indicate the mortality rate for cardiogenic shock still hovers around 40 to 50%.
Right, because when the primary engine fails, the downward spiral is incredibly rapid and difficult to reverse even with maximum intervention.
Okay, so we have an empty tank and a broken pump. What if the tank is full and the pump is squeezing perfectly, but the system still fails?
That brings us to obstructive shock. The failure is mechanical flow. Something outside the heart is physically barricading the blood from either entering or exiting the pump.
Like a physical kink in the hose?
Exactly. A prime example is cardiac tamponade. Blood or fluid rapidly accumulates in the pericardial sac surrounding the heart. This external pressure becomes so immense that the ventricles physically cannot expand during diastole to fill with blood.
Wow, so the pump works, the volume exists, but the fluid just cannot get in.
Precisely.
Yeah.
Which leaves us with the fourth and arguably most complex category, distributive shock. The tank is full, the pump is strong, there are no mechanical barricades. What breaks?
Afterload breaks.
Right. The pipes completely lose their vascular tone. It is a profound pathological vasodilation coupled with capillary leak. The blood vessels suddenly dilate to the size of storm drains.
So the heart can pump furiously, but without that vascular resistance, it can't generate enough pressure to force oxygenated blood deep into the tissue beds.
Correct. The most prevalent example globally is sepsis, which the sources note contributes to roughly 11 million deaths worldwide every year. An overwhelming infection triggers a systemic inflammatory cascade that essentially paralyzes the blood vessels.
And another critical distributive example is severe anaphylaxis, which is wild to me because I always thought of anaphylaxis as primarily an airway problem like your throat swells up, but it's actually a systemic vascular collapse.
It is textbook distributive shock. A severe allergic reaction triggers massive histamine release, which causes extreme vasodilation and sudden pulling of blood away from the central circulation.
Oh, okay.
This is exactly why epinephrine is the absolute first-line treatment for anaphylaxis. You need a powerful alpha-1 agonist to aggressively force those vessels to constrict immediately. Pumping a patient full of antihistamines won't reverse an active vascular collapse. It's too slow and doesn't address the acute loss of afterload.
That makes total sense. This breakdown of the variables, preload, pump, flow, and afterload, it completely changes how you view a patient at the bedside. Which brings us to a really fascinating section of the sources, the clinical counterintuitions.
Yes, the traps.
Right, because if you just blindly follow the textbook symptoms of shock, these different mechanisms will absolutely trick you. For instance, pop culture medical shows teach us that someone in shock is always pale, cold, and clammy.
And that physical presentation is very real, but it only applies to states with high systemic vascular resistance, specifically hypovolemic and cardiogenic shock. As the body frantically shunts blood away from the periphery to protect the core, the skin naturally becomes cold, pale, and sweaty.
But distributive shock breaks that rule entirely.
Completely. Because the underlying mechanism of distributive shock is pathological vasodilation. The vessels in the periphery are wide open. In the early stages of septic shock, the patient will often present with bounding pulses and skin that is flushed, pink, and warm to the touch.
Warm shock, that is terrifying. You could have a patient who feels feverish and warm, their skin looks perfectly pink, and they're actively dying of a cellular perfusion crisis.
Yeah, and if a clinician is anchored to the idea that shock always equals cold and clammy, they will miss early sepsis every time.
Here is another massive treatment trap I pulled from the sources. If we see a patient with crashing blood pressure, the universal instinct is to immediately hang a bag of IV fluids and open it wide. Push fluids to fix the pressure.
And 5E fluid resuscitation is the cornerstone treatment for hypovolemic shock.
Yeah.
It's also crucial in the early management of distributive shock to fill that dilated vascular space.
But if you misdiagnose the underlying mechanism, aggressive fluids can be lethal.
Oh, absolutely. Imagine treating cardiogenic shock with massive fluid boluses. The left ventricle is already failing. It cannot pump the volume it currently has. If you rapidly overload that failing pump with liters of saline, the fluid has nowhere to go but backward. It backs up into the pulmonary circulation, and you essentially drown the patient in their own bed by causing flash pulmonary edema.
And for obstructive shock, like the cardiac tamponade we discussed?
Pouring more volume into the tank does nothing to remove the mechanical barricade around the heart. That patient requires immediate mechanical decompression, like in needle pericardiocentesis, to physically drain the fluid from the sac.
Okay, I want to talk about my favorite physiological trap from the sources. We established that the body's primary defense against dropping cardiac output is a massive surge in sympathetic tone, driving the heart rate sky high. Tachycardia is the universal alarm bell for shock.
Right.
But there is a specific type of shock where the blood pressure drops, the patient crashes, and the heart rate actually slows down.
The bradycardic trick. It frequently catches students off guard on exams. This happens in neurogenic shock, which is a unique subcategory of distributive shock.
This typically follows a traumatic spinal cord injury, usually above the T6 level, right?
Correct. The physical severing of the spinal cord disrupts the descending sympathetic pathways. The brain is trying to send the panic signals, constrict the vessels, speed up the heart, but the connection is cut.
The sympathetic accelerator is totally disconnected.
Exactly. But the vagus nerve, which controls the parasympathetic brakes for the heart, doesn't travel down the spinal cord in the same way.
Oh, wow. So the vagus nerve remains perfectly intact.
Yes. So you are left with unopposed vagal tone. The blood vessels dilate, causing severe hypotension, and the heart, listening only to the vagus nerve, actually slows down.
Yeah.
You have a patient in profound circulatory collapse presenting with bradycardia. It completely contradicts the classic Sean presentation.
If you're waiting for the monitor to show a heart rate of 130 to diagnose shock, neurogenic shock will blindside you. It highlights exactly why you have to understand the specific physiological mechanism, not just memorize a checklist of symptoms.
And we are still refining our understanding of these mechanisms. The standard of care is constantly evolving as new data emerges.
Which brings us to the final piece of our deep dive, the moving targets in modern medicine. Even the most famous, universally taught protocols in this field are subject to fierce debate. If you talk about sepsis, you have to talk about Emmanuel Rivers and the 2001 Early Goal-Directed Therapy, or EGDT, trial.
The Rivers trial was a monumental paradigm shift. He implemented a very rigid, aggressive, step-by-step resuscitation bundle in the emergency department for the first 6 hours of septic shock.
And it involved placing central venous catheters to continuously monitor pressure, aggressive fluid pushes, blood transfusions, and specific inotropic drugs like dobutamine.
Right, and the results were staggering. In-hospital mortality dropped from 46.5% down to 30.5%. It literally rewrote hospital protocols overnight.
But then, looking at the sources, a decade later, 3 massive international trials in 2014 and 2015, Process, Arise, and Promise, they all attempted to validate EGDT, and they found that River-specific complex protocol didn't actually improve survival compared to general standard critical care. Does that mean the entire medical community was wrong for over a decade?
So one of the most fascinating phenomena in clinical research, Rivers was not wrong.
Really?
Yeah, the consensus today is that his core underlying philosophy, recognize sepsis aggressively, give fluids immediately, and administer broad-spectrum antibiotics as fast as possible, was so successful and adopted so universally that it permanently raised the baseline standard of care across the world.
Ah, so by 2014, the control groups in these new trials were already receiving phenomenal rapid care that simply didn't exist in 2001.
We call it the usual care caught-up phenomenon. River's complex protocol with the central lines and specific hemodynamic targets became obsolete, simply because his broader message completely revolutionized how the medical field approached sepsis. He forced the evolution of the standard.
That is an incredible legacy to leave on critical care. Another massive shift in the sources involves how we handle fluid resuscitation in the trauma bay for hypovolemic shock. For decades, the reflex was to pump massive volumes of crystalloid fluids, like normal saline, into bleeding patients to keep the blood pressure up.
And the logic seems sound on the surface, right? They are losing volume, so rapidly replace the volume.
But if you've ever wondered why paramedics and trauma surgeons don't just endlessly pump saline into gunshot victims anymore, the data from military medicine in Iraq and Afghanistan, alongside major civilian studies like the 2015 PRA-PPR trial, completely upended that practice.
We shifted entirely to damage control resuscitation. I mean, think about the physiology. If a patient is bleeding heavily, they are losing red blood cells, but they're also losing all their clotting factors.
Right.
If you rapidly pump liters of saline into their veins, you aren't giving them oxygen-carrying capacity. You are simply diluting whatever remaining clotting factors they have left.
So you are actively preventing their blood from clotting, making the hemorrhage worse.
Exactly. Trauma bays now utilize balanced blood products, aiming for a 1-to-1-to-1 ratio of packed red blood cells, fresh frozen plasma, and platelets, mimicking whole blood. Furthermore, they employ a strategy known as permissive hypotension.
Meaning they deliberately allow the patient's blood pressure to remain dangerously low.
Deliberately low, yes, until surgical control of the bleeding is achieved. Because if you have an unpatched hole in a major blood vessel, and you aggressively push fluids to drive the blood pressure back up to normal,
the increased hydrostatic pressure will literally blow the newly formed clot right off the wound.
yes, you will pop the clot, and the patient will bleed to death faster. You maintain just enough pressure to keep the brain alive until the surgeon can clamp the artery.
It is such a high-stakes balancing act. Speaking of raising blood pressure, the sources also note a major shift in how we use vasopressors. The intense intravenous drugs used to artificially clamp down the blood vessels in shock.
Yeah, for a long time, there was a fierce debate between using dopamine versus norepinephrine as the first-line agent. But the landmark SOAP-2 trial in 2010 provided the definitive answer.
Right. The trial found that while overall mortality rates between the two drugs were similar, dopamine caused a significantly higher rate of dangerous cardiac arrhythmias.
Because dopamine acts on different adrenergic receptors in a way that highly stimulates the heart rate, causing those irregular rhythms. Because of that trial, norepinephrine is now universally recommended as the undisputed first-line vasopressor for distributive states like septic shock.
It is incredible how dynamic this field is. Let's take a step back and summarize the ground we've covered today. Shock is fundamentally a microscopic cellular perfusion crisis, not just a macroscopic blood pressure reading.
Right.
We've traced the evolution of the concept from the battlefields of the 1700s to the realization that oxygen delivery is the ultimate equation for survival. We've explored how breaking the variables of preload, pump flow, and afterload gives us hypovolemic, cardiogenic, obstructive, and distributive shock.
And most importantly, we've seen how clinical signs like warm, flushed skin or a paradoxical slow heart rate can completely mask a dying patient if you don't understand the underlying mechanics.
It demands an intense level of clinical vigilance and a deep understanding of cellular physiology. Now, to wrap up this deep dive, I want to leave you, our listener, with a final provocative thought from the expert side of the table.
We talked extensively about how the human body's compensatory mechanisms, massive vasoconstriction and tachycardia, are incredibly effective at hiding the signs of occult shock until the very last possible second. But how might the next generation of technology redefine that timeline?
Oh, that's interesting.
We are rapidly entering an era of continuous AI biometrics and highly advanced wearable tech. Imagine a continuous monitor, or even a smartwatch, that doesn't just read your pulse rate, but utilizes advanced sensors to detect the subtle, invisible shift to anaerobic metabolism and rising lactate levels hours before your vascular tone ever fails.
That would mean we could finally see the oil leak in the engine before the dashboard light ever needs to come on.
It would completely redefine critical care, transforming the golden hour of intervention into the golden day.
What an incredible thought to end on. Thank you for joining us on this deep dive. Keep questioning the dashboard lights and stay curious.
When you walk into a modern hospital room, there's this heavy expectation of just absolute sterility.
Right, yeah, like it's a clean room or something.
Exactly. It feels like you're walking into, I don't know, a microchip manufacturing plant. Every surface is scrubbed down. The instruments are all hermetically sealed in plastic.
You can literally smell the bleach and the alcohol in the air.
You really can.
Yeah.
And you want to believe that once you're inside those walls, you are completely safe from the microscopic world.
But we project this idea of the clinical environment as like an impenetrable fortress against disease.
Right.
But when you look at the actual biological reality of what happens inside those walls, it just shatters that fortress illusion entirely.
It really does. So, welcome to this deep dive. Our mission today is to explore this hidden world of healthcare-associated infections, or HAIs. We're pulling from this massive stack of historical medical documents, CDC surveillance data, clinical studies, and we're looking specifically at the two major threats, which are CIUTI and CLABSI.
Yeah, the big ones.
Right. And we're going to understand not just what these infections are, but how the frontline defense against them relies, less on futuristic high-tech weaponry and a lot more on surprisingly simple, empowering nursing practices.
And this is really an exploration of human biology colliding with systemic process design.
Yeah.
I mean, it's not about fear-mongering at all. It's about understanding the genuinely fascinating history of infection control and how human behavior dictates public health outcomes.
So to ground just how prevalent this is for you listening, I want to share a statistic from a CDC prevalence survey that honestly just stopped me in my tracks.
It's a heavy one.
It is. So on any given day, if you look at a typical hospital floor with, say, 30 patients, statistically, at least one of those patients is fighting an infection they acquired during their stay, not the illness that brought them to the hospital in the first place. Roughly 25 to 1 in 31 hospitalized patients is fighting an HAI right now.
And if you extrapolate that across the entire healthcare system, I mean, you are looking at a staggering volume of preventable illness.
Yeah, tens of thousands of people.
Exactly. Which means to fight this enemy, the medical community first has to agree on how to actually identify it. And that has proven to be a surprisingly monumental task.
Okay, let's unpack this definition dilemma. Because the official definition of an HAI, which used to be called a nosocomial infection, right?
Yeah. Before regulators realized these happen just as frequently in outpatient surgical clinics and nursing homes.
Right. So the definition is an infection that was not present or incubating at the time care began. But biology, unfortunately, does not carry a stopwatch.
It really doesn't.
So the CDC's National Healthcare Safety Network, the NHSN, they use this surveillance rule. Basically, for most categories, an infection counts as an HAI if the onset happens on or after the third calendar day of admission, with the day you arrive being day 1.
Ah, yes. The famous day 3 rule.
Yeah.
It is the cornerstone of modern hospital epidemiology, and it is highly, highly controversial.
I kept trying to wrap my head around why it's so controversial, and I realized it's exactly like a hotel minibar dispute.
A hotel minibar.
Yeah, think about it. If you check into a hotel, and on day 1, you notice the candy bar's missing from the fridge, the hotel assumes the previous guest took it. You don't get charged.
Okay, I thought.
But if you're there for 4 days, and on day 4, a candy bar goes missing, they are definitely charging your room.
That's actually a great way to look at it.
Right. The day 3 rule is a pragmatic compromise for record keeping. It's not some biological law.
And what's fascinating here is how that day 3 cutoff creates these 3 major contested fault lines in medicine.
Okay, lay them out for us.
So the first one is present on admission versus facility onset. That day 3 rule roughly approximates the incubation period for common pathogens, right? But it inevitably misclassifies cases on the margins. You could get infected in the emergency room on day 1, show symptoms on day 2, and technically dodge the official HAI label.
Wow, okay.
Or you could be carrying a bacteria when you walk through the front doors and only show symptoms on day 4 from something you actually brought in yourself.
Because insurers and regulators demand a bright, clean line for billing. But like we said, biology just does not respect calendar days.
Exactly. Which brings us to the second major fault line, colonization versus infection.
Right, because what if I'm just naturally carrying a bacteria? Like, I might have something on my skin right now that isn't making me sick, but it could trigger a positive test.
Spot on. You can carry a pathogen, say, Methicillin-resistant Staphylococcus aureus, or MRSA, which is a highly antibiotic-resistant superbug.
Right, a really nasty one.
Yeah, and it can just live happily in your nasal passages without making you clinically ill. That's colonization.
Okay.
But if hospitals count every colonized patient as an infection, they massively inflate their rates. They end up looking incredibly dangerous on paper.
But on the flip side, if they ignore colonization entirely, they might miss a patient who isn't sick themselves, but is actively transmitting that superbug to, a really vulnerable patient in the next room.
Exactly. They have to distinguish between simply harboring a bacteria and actively suffering from it.
Which seems incredibly difficult to do at scale. So what about the third fault line? What happens when someone has a medical device?
Right. Device attributable versus incidental infections.
So say a patient gets a tube placed in their chest, and 3 days later they have a bloodstream infection. How do we definitively prove the device caused it, rather than some other underlying issue?
Well, the CDC uses incredibly strict checklist-style criteria to determine if a device actually caused the infection.
Because if they didn't, it would just be totally subjective.
Right. Relying on clinical judgment alone resulted in wild variations from hospital to hospital in the past. But, and this is but the rigidity of that checklist means some genuinely device-caused infections might slip through the cracks if they don't check every single box on the form.
Which sets up this massive tension between the clinical reality and the financial reality. And I really want to look objectively at the 2008 U.S. Medicare policy shift here, because it fundamentally altered how hospitals operate.
It's a massive shakeup.
It's huge. In 2008, Medicare stopped reimbursing hospitals for the extra costs of treating certain reasonably preventable HAIs. And on one side of the debate, you have policymakers who instituted this to drive accountability. The goal was to financially incentivize hospital administrators to improve patient care and take prevention seriously. Like, if a patient gets an infection on your watch, you pay for the treatment, not the taxpayer.
And honestly, the logic there is very sound from a regulatory standpoint.
Absolutely. But then you have the critics of this policy, particularly the frontline infection preventionists, and they argue it created a perverse financial incentive.
Right, because when millions of dollars are on the line, behavior changes.
Exactly. The argument is that clinicians now face immense pressure to game the numerator, so to speak. There's an administrative push to aggressively label any ambiguous infection as present on admission.
Or to just underdiagnose borderline cases entirely to avoid those financial penalties.
Yeah, which shifts the focus from genuinely improving preventative care to, mastering the art of defensive documentation.
And it's wild to think about how intensely we are struggling to define and track and argue over the paperwork of these infections today, considering the history here.
Oh, the history is incredible.
Yeah.
The very first massive breakthrough in preventing HAIs happened decades before anyone even knew what a germ was.
Yeah, the historical context here is critical. We really have to rewind to 1847.
The story of Ignaz Semmelweis. I love this story. So he's a Hungarian obstetrician working at the Vienna General Hospital, right? And he notices this horrifying discrepancy. In the maternity ward, staffed by male doctors, the maternal mortality rate from puerperal fever, which they called childbed fever, was roughly 18%.
Almost 1 in 5 women dying.
Just staggering. But right next door, in the ward staffed by female midwives, the mortality rate is only about 2%.
A difference of life and death, entirely dependent on which door a pregnant woman walked through.
Right. So Semmelweis realizes the male doctors are coming straight from the autopsy room to deliver babies, and the midwives aren't doing autopsies. But germ theory doesn't exist yet. Nobody knows what bacteria is. So he blames what he calls cadaverous particles.
Cadaverous particles. It sounds so archaic now.
It really does. So he mandates that doctors have to wash their hands with a chlorinated lime solution before examining the women. And within a year, the mortality rate in the doctor's ward plummets from 18% down to 1 to 2%.
It is arguably the first controlled natural experiment in HAI prevention. I mean, he proved that the physicians themselves were the vector of disease.
He proved it, and the medical establishment completely ignored and ridiculed him.
They were highly offended.
They were. They thought it was an insult to a gentleman's hands to suggest they were dirty or carrying particles. He was driven out of the hospital, and he ended up dying in an asylum in 1865. And in this tragic twist of irony, he actually died from a wound infection.
Oh, wow. I didn't know that part.
Yeah. He wasn't vindicated until Louis Pasteur and Joseph Lister definitively proved germ theory years later.
And right around that same time, during the Crimean War, so this is between 1854 and 1856, Florence Nightingale was making very similar breakthroughs, but she was doing it through the lens of statistics.
Right, she was a data pioneer.
She really was. She utilized her famous rose diagrams, which were essentially early forms of statistical data visualization, kind of similar to pie charts.
Okay.
And she used them to prove to military generals that soldiers were dying far more often from hospital-acquired diseases like dysentery and typhus and cholera than they were from their actual battlefield wounds.
That's incredible.
She forced massive sanitary reform simply by visualizing the data.
So they were fighting the invisible enemy and winning, without even knowing what the enemy actually was.
Because at a fundamental biological level, they were disrupting the chain of infection.
Okay, break that down for us. What is the chain of infection?
In modern epidemiology, for an infection to happen, a literal chain of events must occur. You need the infectious agent. It needs a reservoir to live in.
Like a dirty surface or a person.
Exactly. Then it needs a portal of exit, a mode of transmission, a portal of entry into the new body, and finally, a susceptible host.
So when I walk into that modern hospital room from our intro, all that plastic wrapping, the gloves, the bleach, that is just the hospital systematically targeting different links in that chain.
Precisely. Semmelweis was breaking the mode of transmission by washing the doctor's hands. Sterile technique blocks the portal of entry. Modern infection control is essentially just the systematic severing of that chain.
That makes so much sense.
But despite those early breakthroughs in the 1800s, it really took until the late 20th century to prove to modern hospitals that this chain could be broken systematically on a large scale.
Right, which brings us to the Scenic Project.
Yes.
This was a monumental effort from 1974 to 1983. The CDC ran this study on the efficacy of nosocomial infection control across hundreds of hospitals over a decade.
A massive undertaking.
Huge. And they proved definitively that hospitals with dedicated surveillance and control programs, meaning they had dedicated staff whose only job was tracking and providing feedback on infections, they reduced their infection rates by a third.
Which is a staggering public health victory.
It is. And the hospitals without those programs, they actually saw their rates rise over the exact same period.
And that study forced a complete paradigm shift in medicine, because before Scenic, a hospital infection was largely viewed as an unfortunate but unavoidable cost of doing business. You know, if you put sick people in a building, some will just get worse.
Right.
Scenic proved that an infection is a measurable, preventable event. It is a failure of process.
Which brings us out of the history books and onto the modern clinical battlefield. Because today, the primary threat isn't a doctor walking in directly from a Victorian autopsy suite.
No, thankfully.
The front lines of this battle today are the medical devices we deliberately leave inside patients. So let's break down the big two, CIUTI and CLAVSI.
Right. These two devices dominate hospital policy and prevention efforts. CIUTI stands for Catheter-Associated Urinary Tract Infection, and historically this has been the single most common type of HAI in U.S. hospitals.
And the frustrating part of the research is learning why it's so common. Foley catheters are often placed, and more importantly, left in, simply for staff convenience.
Yeah, that's a hard truth.
It is. It makes nursing care easier if a patient doesn't need to be helped to the bathroom, rather than there being a strict, ongoing medical necessity for the tube.
And the danger lies in the cumulative risk. Every single day that urinary catheter remains in place, it adds a compounding percentage point of risk for bacteria to enter the bladder.
It just ticks up every day.
Exactly. A catheter left in for a week carries a substantially higher risk profile than one removed after 24 hours. The human body is simply not designed to have a permanent plastic conduit to the outside world.
And then you have the more dangerous counterpart, CLEVSI, which is central line-associated bloodstream infection.
Right. Numerically, CLEVSI is far less common than COUTI, but it is vastly more lethal.
Because it goes straight to the heart, right?
Basically, yes. We are talking about a central venous catheter, a long tube threaded directly into a large vein, often ending just outside the heart. It's used for delivering potent medications or nutrition. But if bacteria or fungi enter the bloodstream through that line, the infection has immediate access to the entire body. Historically, the attributable mortality rate for CLAVSI has been estimated between 12 to 25%.
It's terrifying.
It is. And it also adds tens of thousands of dollars and extended intensive care days to a single patient's stay.
You know, I want to address something that people naturally assume when they hear about hospital infections.
Yeah.
It's so easy to think that only immunocompromised people or patients who are already incredibly weak get these infections.
Right. That's a very common misconception, yeah.
Right. But I like to think of your immune system like the thick stone walls of a medieval castle. You might have the strongest, thickest walls in the world. You might be a young, incredibly healthy athlete. But if you leave the drawbridge down and the front gate wide open, the invading army is just going to walk right in.
That is a perfect analogy. A central line or a urinary catheter is a mechanical drawbridge. It completely bypasses the body's natural defensive barriers, the skin and the mucosal linings.
Right.
Anyone with one of these devices is at severe risk, regardless of how robust their underlying immune system is.
It's a mechanical failure, not just an immune failure. Which leads to another major assumption. If someone gets an infection in a hospital, the immediate reaction is, oh, the hospital must be dirty, the room wasn't cleaned properly.
And environmental cleanliness is obviously a baseline requirement for any medical facility. However, looking at the data, environmental surface contamination is not the dominant driver of these device infections. Really, a spotless, highly sterilized room where an unnecessary catheter is left inside a patient for 10 days is vastly more dangerous than a merely adequate, normal room where the medical device is removed promptly.
Wow.
The duration the device remains inside the body is the absolute primary risk factor.
So, if the duration of the device is the biggest risk factor, how do hospitals actually solve this? I mean, you would assume that in the 21st century, with billions of dollars in research, the solution would be some massive technological invention.
Right, like some robotic, AI-driven, self-cleaning catheter.
Exactly. But the most effective tool turned out to be a laminated piece of paper.
It really did. You're referring to the Keystone ICU project in Michigan, which ran from 2003 to 2006.
Yeah.
A critical care physician named Peter Pronovost implemented a ridiculously simple 5-item checklist for CLABSI prevention across more than 100 intensive care units.
5 simple behavioral steps. I have them right here. Hand hygiene, using full barrier precautions during the insertion of the line, using chlorhexidine to clean the patient's skin, avoiding the femoral vein in the leg, which I guess has a higher infection risk, and prompt removal of unnecessary catheters. That's it.
And the results were published in the New England Journal of Medicine, and they were just staggering. The median CLABSI rate across those Michigan ICUs dropped by roughly 2/3 within 18 months.
That's unbelievable.
Many intensive care units hit 0 infections and stayed at 0 for months on end.
And this intervention cost almost nothing. It wasn't a multi-million-dollar technology upgrade.
Because the brilliance of the Keystone Project was that it engineered a culture change rather than a technological one.
Right.
The real power of that laminated checklist was that it fundamentally shifted the medical hierarchy. It gave a bedside nurse the explicit systemic authority to stop a central line insertion procedure, even if it was being performed by a senior veteran surgeon, if a single step on that checklist was skipped.
Overcoming that deeply entrenched hierarchy was the actual breakthrough.
Exactly.
And here's where it gets really interesting. Compare the success of that cheap checklist to the high-tech alternatives the industry tried to push.
Oh, the tech push was massive.
Right. Throughout the 2000s and 2010s, medical supply companies were heavily marketing these incredibly expensive antimicrobial and silver alloy-coated urinary catheters. They were pitched as the ultimate technological silver bullet for CIUTI.
And the premise was that the silver would actively kill bacteria on the tube.
Mm-hmm.
But large clinical trials consistently showed that those expensive high-tech fixes underperformed. At best, they barely match the results of cheap nurse-driven behavioral protocols.
Just basic protocols won out.
Yeah. A hospital protocol that empowers a nurse to automatically pull a catheter when a patient meets specific clinical criteria without having to wait hours for a doctor to write an order that does infinitely more to prevent a biological infection than a silver-plated tube ever could.
So we have this proven blueprint. Empower the staff, follow the behavioral protocols, remove the devices quickly.
Right.
But that only works when the hospital system isn't under crushing strain. And it only works when clinicians don't accidentally overcorrect out of fear.
And if we connect this to the bigger picture, that fear of missing an infection has led to a massive controversy in hospital medicine right now.
The overtreatment trap.
Exactly. Specifically regarding a condition called asymptomatic bacteriuria.
Okay, so it is crucial to understand that just because a laboratory finds bacteria in the urine of a catheterized patient, it does not automatically mean they have a CIUTI.
Correct.
To officially be a catheter-associated urinary tract infection, you need the presence of bacteria, but you also need clinical symptoms: fever, localized pain, elevated white blood cells.
Yes.
Because a huge percentage of patients with catheters have bacteria just hanging out in their bladder without causing any actual harm or sickness.
But hospitals are intensely scrutinized on their CIUTI rates. They are terrified of being penalized. So there is a systemic tendency to overtest the urine, even when the patient feels completely fine.
Just constantly checking.
Yeah. And they find the harmless bacteria, they panic, and they immediately treat it with prophylactic antibiotics.
But I don't get why we can't just pump the patient full of antibiotics to clear the line as a preventative measure. Why is giving routine antibiotics for asymptomatic bacteria a bad idea?
Because it doesn't actually prevent line and catheter infections, what it does do is fuel the global antimicrobial resistance crisis.
Okay.
You are simply training the bacteria in that hospital to become immune to our strongest drugs. And the reason antibiotics struggle so much with these specific device infections comes down to something called biofilms.
I want to visualize this. A biofilm isn't just a layer of germs, right?
No, it's more structured than that. Think of a biofilm as a microscopic slime city.
Slime City. Okay.
Yeah. When you insert a foreign object, like a plastic tube, into the warm, nutrient-rich environment of the human body, bacteria recognize it as a prime piece of real estate.
Because it's a safe surface.
Exactly. So they attach to the surface of the plastic, and they immediately begin excreting this sticky, protective, extracellular matrix over themselves.
Like building a dome.
Literally. This slime shields the microbial community from the patient's circulating immune cells, and it acts as a physical barrier against antibiotics.
So the antibiotic medication is just floating through the patient's bloodstream, but it literally cannot penetrate the slime city on the plastic tube to kill the bacteria inside.
Exactly. Once a mature biofilm forms on a central line or a catheter, attempting to eradicate it with intravenous antibiotics is often an exercise in futility. The bacteria are just too heavily entrenched in their matrix.
Wow.
That is the fundamental biological reason why the physical removal of the device is vastly superior to trying to medicate your way out of the problem.
That makes total sense. But doing all of this, successfully executing the checklists, empowering the nurses to demand prompt removals, conducting the careful auditing of device necessity that requires a hospital system that is functioning like a well-oiled machine.
It does. It requires immense systemic discipline.
And we recently saw a devastating real-world example of what happens when that systemic discipline breaks down.
We did. The COVID-19 pandemic served as a truly heartbreaking stress test for modern infection control.
Between 2020 and 2021, the CDC's NHSN data showed a well-documented, just catastrophic reversal of years of hard-won progress in reducing CLUTI and CLAB-SI rates across the country.
The entire system just buckled. You had severely overwhelmed staffing ratios where nurses were managing far more critical patients than safely allowed.
Right.
There were massive shortages of personal protective equipment, the basic gowns and masks needed to even enter a room safely.
It was chaos.
It was. And patients with severe respiratory distress were being placed in prone positions, meaning they were flipped onto their stomachs to help them breathe on ventilators.
Oh, wow. And managing the sterile fields of central lines and urinary catheters on a patient lying on their stomach is incredibly difficult. And crucially, routine infection control audits were entirely suspended.
Because the dedicated staff who normally track those infections were pulled to the front lines just to help the hospital survive the shift.
Exactly. And what this starkly demonstrated is that HAIs are not a fixed, inevitable property of medicine. They are a direct, real-time reflection of process discipline.
Because the moment the systemic discipline eroded under the strain of the pandemic, the infection rates immediately skyrocketed.
Exactly.
So why should you, listening to this, care about the difference between colonization and infection, or the minutia of the day 3 surveillance rule?
It's a fair question.
Right. Well, beyond the immediate, terrifying risk to yourself or a loved one if you are admitted to a hospital, these infections cost the healthcare system tens of billions of dollars annually. They require extended hospital stays, highly toxic secondary treatments, and they are a massive drain on finite medical resources. Furthermore, they are a central battleground for the antimicrobial resistance crisis. Every single unnecessary catheter left in for an extra day, every unnecessary course of antibiotics given to a patient who didn't actually have symptoms, it all adds immense evolutionary pressure to an already terrifyingly strained arsenal of effective antibiotics.
But there is a deeply empowering takeaway from all this data, especially regarding how modern healthcare is actually delivered. This deep dive shows that bedside nursing practice is the primary driver of population-level public health data.
Absolutely.
We tend to focus on the doctors writing complex orders or the lab scientists developing experimental new drugs. But the reality of infection control is the nurse executing the care bundle at 3 a.m.
Yes.
Is the nurse doing the daily assessment, asking, does this patient still critically need this central line? It is the nurse physically pulling the catheter out. They are the ones actually severing the chain of infection.
It is a potent reminder that sometimes the most sophisticated medical intervention we have is human diligence and behavioral discipline, which actually raises an important conceptual question for us to consider as we look to the future of medical engineering.
Okay, what are you thinking?
Well, we've established that the duration a device stays in the body is the ultimate risk factor, and we know how quickly these biofilms can form to shield bacteria from our strongest drugs.
Right, the slime cities form fast.
Exactly. So if a microscopic slime city can form on a standard plastic medical device in a matter of hours, how might the very materials we use to manufacture future medical devices need to fundamentally change?
So that's interesting.
Instead of just providing a sterile, inert plastic highway for bacteria to travel on, perhaps the biomaterials of the future will need to actively mimic the human body's natural dynamic defenses.
So instead of relying on a plastic tube in a perfectly sterile room,
Yeah.
we engineer a device that fights back the way our own skin does.
Pres-
Because right now, we are heavily relying on that expectation of a pristine fortress. But biology always finds a way in. Thank you for joining us on this deep dive. Keep questioning the invisible systems around you, and we'll catch you next time.
You know, you walk into any modern hospital ward, and there is this profound, almost comforting illusion of control.
Oh, absolutely.
Like everything is bright, it's sterile, it's highly categorized. You look down the hallway and you see those brightly colored signs taped to patient doors, right?
Right, the yellow one for this pathogen, the blue one for that one.
Exactly. Maybe a green one near the end of the hall. And it just projects this absolute certainty, this feeling that the medical world has like completely mastered the physical space and everything invisible within it.
Yeah, it creates the atmosphere of this highly organized fortress. I mean, the underlying message of that laminated piece of paper on the door is that the enemy, the pathogen, has been perfectly contained by our administrative protocols.
But when you actually read the literature, you know, when you dig into this stack of sources on isolation precautions in nursing, like we are today, you realize those tidy little signs are covering up a messy, ongoing battleground.
Messy is definitely the word for it.
Right. We treat these protocols like they descended from a mountain carved in stone, but the reality is this landscape is driven by evolving aerobiology, complex fluid dynamics, and frankly, a whole lot of historical trial and error.
Yeah, we are constantly negotiating with biology. The rules we follow today are really just the current uneasy truce we've struck with microorganisms that are actively trying to bypass our defenses.
So our mission today is to decode that rulebook for you,
Yeah.
to look past the laminate and understand what is actually happening invisibly in the air and on the clinical surfaces around you.
It's a huge topic.
It is. We're zeroing in on the modern CDC and HIC-PAC framework. That's the Healthcare Infection Control Practices Advisory Committee.
Yeah.
This is the standard two-tiered system taught in every single U.S. nursing program.
Right, and the foundation of that is standard precautions,
Yep.
which applies universally to every single patient encounter.
Which basically means treating all blood and body fluids as inherently infectious.
Exactly. Hand hygiene, safe injection practices, throwing on gloves for fluid contact. You do that whether the patient is there for a routine appendectomy or, a mysterious fever. It is the absolute baseline of clinical practice.
And sitting right on top of that baseline is the second tier, the transmission-based precautions, heavy hitters.
Right. Contact, droplet, and airborne.
Okay, let's unpack this. Because before we can understand the massive debates currently raging about how these rules are applied, we have to look at the mechanical foundation they're built on.
The physics of it all.
Yeah, exactly. We have to answer the physical question, how does this specific pathogen actually cross the space between a patient and a clinician?
Because pathogens aren't magic, even if they sometimes feel like it. They obey the laws of physics.
Right.
They need a physical vehicle to cross that space.
Yeah.
So let's look at contact precautions first. The vehicle here is direct touch, or a contaminated intermediate surface, a fomite.
So like a bed rail.
Exactly. If you're dealing with MRSA or VRE, those bacteria are heavily colonizing the patient's skin, the bed rails, the IV pole. The moment you walk into that environment, your uniform is at risk of becoming the vehicle.
Which dictates the protocol.
Right? Donning a gown and gloves before crossing the threshold, and keeping dedicated diagnostic equipment inside that specific room.
But, reading through the sources, there's this fascinating exception that completely upends this standard routine, and it involves Clostridioides difficile, C. diff.
Oh, C. diff. It is the ultimate trip-up in clinical practice.
Yeah.
It forces a complete behavioral override of the standard hospital routine.
Right, because everywhere else in the hospital, the gold standard, like the absolute reflex, is the alcohol-based hand sanitizer. You finish an assessment, you pump the phone, you rub your hands, you move on.
It's pure muscle memory.
But alcohol does not denature C. diff spores. And
Yeah.
it reminds me of working on a car engine. Imagine your hands are just coated in thick, heavy axle grease. If you pour rubbing alcohol on them, you aren't cleaning anything. You're just smearing the grease around your skin.
Right. It doesn't break it down.
Exactly. The only way to get it off is mechanical friction. You need heavy soap, running water, and vigorous scrubbing to physically pry that grease off your epidermis and wash it down the drain. You can't chemically kill the stoles with alcohol. You have to physically evict them.
I love that analogy because it perfectly captures the physical mechanics of the spore. C. diff spores have an incredibly hardy protein coat that evolved specifically to survive harsh chemical environments.
Like the stomach.
Precisely, the acidic human gut. So a splash of ethanol isn't going to breach it. You have to rely on the sheer force of soap and water. It's a vital concept because it breaks that deeply ingrained muscle memory of the healthcare worker.
Now, if a pathogen isn't relying on touch, it might be hitching a ride in a respiratory droplet. Which brings us to the droplet precaution category.
Right. The vehicle here is respiratory fluid expelled during a cough, a sneeze, or even just talking. These droplets are relatively large and heavy.
So gravity is doing a lot of the work.
Exactly.
Yeah.
Because of their mass, gravity is the dominant physical force acting on them. They're pulled down to the floor pretty rapidly, typically falling within a 3 to 6 foot radius of the patient.
That implies a safe zone. Like if you are standing 7 or 8 feet away, gravity has already done the protective work for you.
That's the clinical assumption. The required PPE is a standard surgical mask, donned when coming within that physical radius to block those macroscopic droplets from hitting your mucous membranes.
And notably, you don't need any specialized room ventilation.
No, not at all. The droplets are on the floor. They aren't, lingering in the HVAC system.
The sources list the usual suspects for this category, influenza, pertussis, mumps, rubella. But the standout that really caught my attention is Neisseria meningitis, bacterial meningitis.
Oh, yeah, that is a pathogen that instantly changes the temperature in the emergency department.
Because the timeline is so aggressive, right, it can kill a healthy adult within hours. If a nurse or a physician conducts a close-up assessment without a mask and the lab comes back positive for meningitis, that clinician urgently needs post-exposure prophylactic antibiotics.
It's a massive deal.
It's not a situation where employee health says, monitor yourself for fever, let us know. It's immediate intervention. It really hammers home that these precaution categories aren't just bureaucratic suggestions.
Right.
They map directly onto life or death clinical urgency.
Absolutely. But what happens when the droplet is so small that gravity is no longer the dominant force? That is when we cross into airborne precautions. We are no longer talking about macroscopic fluid hitting the floor. We are talking about microscopic aerosolized particles.
So they don't fall.
No, they float. They ride the thermal plumes and ambient air currents in the room, and they can remain suspended for hours after the source patient has physically left the space.
Wow. So a standard surgical mask is essentially useless against that kind of physics?
It offers virtually no protection. Airborne particles simply flow around the loose edges of a surgical mask or pass straight through the macroscopic pores of the material.
Right.
You need a fit-tested N95 respirator, which uses an electrostatic charge to trap microscopic particles, or a PPR, a powered air-purifying respirator. Furthermore, the environment itself has to be engineered.
The patient has to be in a specific room.
Yes, an airborne infection isolation room, or AIR.
The negative pressure room.
Exactly. The HVAC system actively exhausts more air from the room than it supplies, creating a pressure differential. When you open the door, air from the hallway rushes in.
Preventing the contaminated air inside from drifting out and infecting the rest of the ward.
Right. The system is also required to perform a minimum of 6 to 12 complete air changes per hour, physically scrubbing the room's atmosphere.
What's terrifying is that you need that level of engineering because these pathogens are wildly infectious.
What's fascinating here is just how efficiently some of these airborne viruses exploit the air. Look at measles. It has a basic reproduction number, an R naught of 12 to 18.
Jeez.
In an unprotected population, one case generates, on average, over a dozen secondary cases. To put that into perspective, in 1985, the CDC investigated an outbreak in Michigan.
Okay.
A child with measles had an appointment in a pediatrician's exam room. They finished the exam and left the clinic entirely. Sometime later, a second child, completely unrelated to the first, was brought into that exact same, now empty room.
Wait, the room is empty. The source of the infection is just gone.
The patient was gone, but the air itself was still contagious. That second child contracted measles simply by inhaling the lingering suspended aerosols in that enclosed space.
Oh, wow.
It's a chilling demonstration of why airborne rooms require high-velocity air changes before they are considered safe to re-enter.
It is chilling. And looking at this modern framework, contact, droplet, airborne, it feels so mechanically logical. You identify the physical vehicle and you block it. But going through the historical sources, it begs a massive question. If this is just applied physics and biology, how did it take the medical establishment nearly 150 years to agree on it?
Well, the delay was driven by a powerful combination of unseen biology and deep professional stubbornness.
Stubbornness?
Oh, yeah. If we look back to the mid-19th century, we see the very first crude attempts at infection control. During the Crimean War in the 1850s, Florence Nightingale didn't actually understand germ theory. She believed in the miasma theory that diseases were caused by bad air.
Right, the classic bad air theory.
But her intuitive response was to aggressively improve ward ventilation and physically separate patients based on their symptoms. It was primitive, but it was effective source control.
Which was happening almost concurrently with Ignaz Semmelweis in Vienna in 1847.
The tragic pioneer of hand hygiene. He demonstrated with rigorous data that maternal deaths from puerperal fever plummeted if physicians simply washed their hands in a chlorinated solution between performing autopsies and delivering babies.
But the medical establishment didn't just ignore his data. They actively destroyed his career over it.
They were deeply insulted. The prevailing mindset was that a gentleman's hands could not possibly transmit disease.
Wow.
The idea that the doctors themselves were the vectors of death was professionally abhorrent. Semmelweis was mocked, sidelined, and eventually died in an asylum.
That is so sad.
It is a stark reminder that solid infection control data often loses out to professional ego and established dogma.
It really does. And, it took until 1970 for the CDC to publish its first formal hospital isolation guideline. They essentially created a menu of precaution bundles. You had strict isolation or respiratory isolation, and nurses would just select the bundle that matched the patient's diagnosis.
Yeah, that was the model for a while.
But that entire paradigm slammed into a brick wall in the early 1980s. HIV and AIDS.
HIV completely shattered the existing logic of isolation. For decades, the philosophy had been identify the sick patient, diagnose them, and isolate them. But HIV presented a terrifying new reality. You had a deadly pathogen where patients could remain asymptomatic and undiagnosed for years. You simply didn't know who was infected.
So because they didn't know who was actually infected with HIV, they had to flip the whole philosophy from isolate the known sick patient to assume every single person is a risk.
Precisely why the CDC introduced universal precautions in 1985, formalized heavily in 1987. Healthcare workers were contracting HIV through accidental needle sticks and blood exposures. Universal precautions established the radical new baseline that all blood and certain body fluids must be treated as highly infectious, always.
But the sources highlight that this didn't entirely solve the problem on the floor.
No, it didn't.
Because at the exact same time, you had infectious disease experts like Patricia Lynch pushing back. She proposed a rival system called body substance isolation, or BSI, arguing that focusing only on blood was dangerously narrow.
Right.
BSI demanded protection against all moist body substances, feces, urine, sputum, from every patient.
Imagine being a charge nurse in the late 1980s or early 90s. You have two competing, fundamentally different sets of protocols being published and debated simultaneously.
That sounds awful.
One focuses strictly on bloodborne pathogens. The other requires gloves for touching absolutely any body fluid. It created massive confusion and compliance failures on the floor.
That sounds like an administrative nightmare. So how did we finally get to the system we use today?
In 1996, Julia S. Garner, leading the CDC's HICPAC, performed a brilliant piece of clinical synthesis.
Okay.
She took universal precautions, merged it with the best elements of body substance isolation, and created standard precautions. the universal baseline we discussed earlier.
Ah, okay.
Then she took the old, clunky, disease-specific bundles and streamlined them into contact, droplet, and airborne. She built a cohesive two-tiered architecture that finally made sense.
It's an elegant piece of rulemaking. But as we know, pathogens don't read rule books.
They certainly don't.
The tension in these sources really spikes when we look at what happens when the system breaks down. And it does break down. Usually it's a failure of human execution or a failure of the scientific model itself.
Human error is the most common vulnerability. A tragic and highly publicized example was the Dallas Ebola cluster in 2014.
Oh, right, I remember that.
Thomas Eric Duncan was the first person diagnosed with Ebola on U.S. soil. The hospital utilized contact and droplet precautions, escalating their PPE as his condition worsened. Yet two of the intensive care nurses treating him, Nina Pham and Amber Vinson, contracted the virus.
And the subsequent investigations revealed that the precaution category wasn't technically wrong, right? The failure was in the execution, specifically the doffing, the removal of the protective gear.
Yes.
It makes me think of an explosive ordnance disposal technician wearing a bomb suit. The suit works perfectly against the blast, but if the technician decides to unlatch the helmet while the shrapnel is still flying around the room, the suit becomes meaningless.
That's exactly it.
With Ebola, if a nurse exposes even a millimeter of bare skin at the wrist while sliding off a heavily contaminated fluid-resistant gown, the virus finds its window.
Doffing is incredibly perilous. You're dealing with healthcare workers at the end of a grueling 12-hour shift, cognitively depleted, physically sweating inside impermeable gear, and operating under immense psychological stress.
Just a recipe for a slip-up.
The Dallas cases forced the entire industry to realize that having the right PPE is insufficient if your donning and doffing technique isn't flawless and actively monitored by a trained observer.
Right.
But beyond human error, there are terrifying instances where the clinicians do everything perfectly, and the mental model of transmission itself is what fails.
Which brings us to the 2003 SARS outbreak in Hong Kong, specifically the Amoy Gardens apartment complex.
Over 300 residents in a single high-rise complex were infected with SARS-CoV-1, and the epidemiological mapping defied everything we knew about standard respiratory droplet transmission.
Because they weren't coughing on each other in the hallways.
No. The virus was moving vertically through the building's infrastructure.
Wait, I remember reading this in the sources and being completely baffled. How does a respiratory virus travel through a building's infrastructure?
Through the plumbing.
The plumbing.
Yes. The floor drains in the bathrooms utilized U-traps, those curved pipes designed to hold a little bit of water to block sewer gases from coming up.
Okay, sure.
But in many apartments, the floor drains were rarely used, and the water in the traps had evaporated. When a resident who was shedding massive amounts of the virus in their feces used the bathroom exhaust fans created a negative pressure environment.
Oh, no.
It literally sucked aerosolized, virus-laden fecal matter out of the dry plumbing pipes and into the apartments.
Literal airborne feces traveling backward through dry plumbing. I mean, there wasn't a precaution category in the 1996 CDC playbook for that.
Because the medical establishment desperately wants categories to be neat. We want respiratory viruses to exclusively utilize the respiratory droplet vehicle. We do not want them utilizing aerosolized sewage.
Here's where it gets really interesting. Because that deep institutional desire for neat, predictable categories brings us to the biggest scientific brawl in modern epidemiology.
The 5-micron controversy.
Yes, during the COVID-19 pandemic.
It was an absolute seismic shift in infection control. It forced a global reckoning regarding how we define the very air we breathe.
For decades, the rigid textbook definition separating a droplet from an airborne particle was based on a strict measurement. 5 microns.
Right.
The dogma stated that if a respiratory emission was larger than 5 microns, it was heavy, and it would fall to the floor within 6 feet. If it was smaller than 5 microns, it was an aerosol, and it would float.
And relying on that rigid metric, in early 2020, the WHO and the CDC confidently classified SARS-CoV-2 as a droplet-spread pathogen.
I remember.
The public health messaging was entirely built on this. Stay 6 feet away, wear a standard surgical mask, wash your hands, and you are protected.
While N95 respirators were fiercely rationed.
Exactly, restricted only for specific aerosol-generating procedures like intubating a patient.
I always assumed that 5-micron rule was the result of some massive, definitive clinical trial. But aerosol scientists, experts like Lindsay Marr at Virginia Tech and Jose Luis Jimenez at the University of Colorado began looking at this and essentially said, this is fundamentally bad physics.
They did a deep historical dive and realized the 5-micron rule wasn't based on modern fluid dynamics. It was a bureaucratic misinterpretation of tuberculosis research from the 1930s.
The 1930s.
Yes. Marr and her colleagues argued forcefully that human beings do not emit perfectly uniform 5-micron droplets. When we speak, when we cough, when we sing, we emit a massive, continuous spectrum of particle sizes.
Right.
And the physics dictate that in poorly ventilated indoor spaces, even particles much larger than 5 microns can dehydrate in the air, shrink, and travel much further than 6 feet.
And the undeniable tragic proof of this bad physics was the Skagit Valley chorale rehearsal in Washington State in March 2020.
The super-spreading event that irreparably broke the droplet model.
You had roughly 60 people gathered in a room for a 2.5-hour choir practice. They were aware of the virus. They actively tried to maintain distance, staying more than 6 feet apart.
Right, following the rules?
Following the rules. There was only one symptomatic person in the room. And out of those 60 people, 52 were infected.
You cannot mathematically or physically explain 52 infections in a room of that square footage using a 6-foot droplet model. It is impossible.
Just doesn't work.
The virus was not falling to the floor. It was accumulating in the air as fine aerosols, drifting across the room like cigarette smoke. The sheer force of the epidemiological math proved the aerosol scientists right.
And it took months of fierce debate, but eventually, by mid-2021, the CDC and the WHO had to bend to the physics. They revised their guidance, conceding that inhalation of fine aerosols was a primary route of transmission.
The medical establishment had to publicly renegotiate its own foundational science in real time.
Yeah.
If we connect this to the bigger picture, it illustrates exactly why a deep understanding of these mechanics is so vital for the clinician and the informed patient. When the underlying science is this messy and subject to revision, misconceptions thrive on the hospital floor.
People cling to simplified rules of thumb that often fail under pressure.
Exactly.
Let's actually clear the air on some of those operational misconceptions right now, because the sources dedicate a lot of ink to how these protocols are misunderstood in practice. Let's start with vocabulary. I hear isolation and quarantine used interchangeably by medical professionals all the time.
The media conflation of those terms during COVID really entrenched that error, but they are clinically distinct.
Okay, how so?
Isolation is for the infected. You isolate a patient who is confirmed sick or symptomatic to keep them away from the healthy population. Quarantine is for the exposed. You restrict the movement of an asymptomatic person who is exposed to a pathogen, waiting to see if they develop the disease.
Ah, okay, that makes sense. Here's a massive point of confusion on the floor regarding room assignments. If a patient is on droplet precautions, they must be in a negative pressure room.
That is a persistent myth, largely driven by the lingering trauma and hypervigilance from the pandemic. Droplet precautions do not require negative pressure.
They don't.
No, a standard private room with normal HVAC ventilation is perfectly adequate because those heavy droplets are settling out of the air. Reserving negative pressure AIRs is strictly for airborne precautions, where the virus is actively riding the air currents.
Which leads directly to the mask myth. There is a deep psychological reliance on the blue surgical mask to stop anything respiratory.
Well, a standard surgical mask is essentially a splash guard. It's highly effective at stopping large droplets from hitting your nose and mouth, but it does not form a seal against your face.
Right.
If you are dealing with tiny, suspended airborne particles, they will simply follow the air current right through the gaps of your cheeks. If a pathogen is airborne, anything less than a fit-tested N95 is an illusion of safety.
But the pendulum swings the other way too, right? Because of that fear, you see an over-application of airborne precautions. The assumption that any infectious respiratory illness demands an N95 and a negative pressure room.
That better safe than sorry mentality is understandable, but it creates massive operational bottlenecks. Seasonal influenza, for instance, requires only droplet precautions.
Okay.
If a hospital routinely places standard flu patients in airborne rooms, they will rapidly exhaust their specialized infrastructure. When a patient with active pulmonary tuberculosis or measles arrives, the resources they genuinely need to survive won't be available.
Let's look at one final misconception going back to contact precautions. A nurse is rushed, an IV pump is beeping, and they think, I'm just running in to silence the alarm and grab a trach. I'll just throw on some gloves. I don't have 45 seconds to tie a gown.
That shortcut completely neutralizes the precaution. Contact protocols mandate a gown and gloves for a reason. If you lean across a bed to silence that IV pump wearing only gloves, your unprotected scrubs will inevitably brush against the bed rail or the linens. You've now transferred MRSA or VRE to your uniform.
You become the vehicle.
Exactly. You will carry that fomite out into the hallway and introduce it to your next patient.
So what does this all mean? Why did we just spend this entire deep dive obsessing over fluid dynamics, historical U-traps, and the cognitive load of doffing PPE?
It matters because the stakes in modern healthcare are astronomical. Hospital-acquired infections, driven by protocol failures, cost health systems billions and drive the terrifying acceleration of multi-drug-resistant organisms. When a patient acquires VRE or C, diff, because of a broken chain of infection control, it dramatically prolongs their suffering and limits our pharmacological options.
And it extends far beyond the ICU. With the rapid resurgence of measles in under-vaccinated populations globally, a deep mechanical competency in airborne precautions isn't just a niche skill for an infectious disease specialist.
No, not at all.
It is an immediate, highly relevant necessity for every single healthcare worker.
And beyond the clinical mechanics, there's a profound philosophical lesson hidden in these sources. We are conditioned to view medical guidelines as absolute, settled truths.
Right.
But the collapse of the droplet versus airborne paradigm during COVID-19 proved that these categories are merely our best temporary attempts to impose order on a chaotic microscopic reality.
Those brightly colored signs on the hospital doors are essentially just clinical simplifications.
Exactly. This raises an important question, a final thought I'd like to leave you to ponder on your own today.
Okay.
If the strict 5-micron boundary between a droplet and an airborne particle was just a convenient clinical simplification of messy physics, one that spectacularly fell apart when tested by a novel virus, what other rigid life-or-death medical rules are we unquestioningly following today?
Wow.
What other foundational protocols are built on outdated science, just waiting for the next pandemic to expose them?
It fundamentally changes how you look at the physical space of a hospital. Think about that the next time you see a yellow contact precautions sign on a door. The invisible world is significantly messier than we like to admit.
And the rule book is always being rewritten.
Until next time, keep questioning what you think you know. Imagine you are a nurse, right? You're in this incredibly crowded emergency room.
Oh yeah, chaos everywhere.
Exactly, total chaos. And you have no x-ray machine instantly available, no CT scan ready to go, and you are standing over a patient who is visibly struggling to breathe.
Right, which is an incredibly high-stress situation.
Totally. And your only tool to figure out if they are, drowning in their own fluids or if their airways clamped completely shut is to listen.
Yeah.
Today's deep dive is about decoding that hidden acoustic language of the lungs. We are jumping into this really comprehensive and just deeply fascinating nursing guide on lung sounds. And our mission for you today is to explore how a simple acoustic vibration gives clinicians a real-time, completely non-invasive window into the body.
It really is the absolute definition of diagnostic muddy waters. I mean, you are trying to paint an accurate picture of a patient's internal organs using nothing but sound waves.
Yes, sound.
Just sound waves traversing through tissue and bone. When you listen to a healthy chest, your baseline is the sound of turbulent air moving through healthy, patent airways.
Patent meaning open, right?
Right, exactly. They are open, they are flexible, and the sound is soft and breezy. But what we are really focusing on today are the sounds that, well, the ones that deviate from that baseline.
Okay, let's unpack this. Because the source material introduces a specific term right at the top that sets the stage for everything. It calls these abnormal noises adventitious breath sounds.
Which is such a great word.
Right. It sounds like, I don't know, a grand adventure. But the Latin root actually means added or accidental. So adventitious breath sounds are the accidental noises of disease that get superimposed on top of healthy breathing.
Yeah.
The pops, the wheezes, the snores.
And understanding what those adventitious sounds mean requires us to look at how we even, know to listen for them in the first place.
Yeah, the history part is wild.
It really is. For most of human medical history, the lungs were essentially a black box. You could not see inside them without opening the body, which
is obviously something you want to avoid.
highly to be avoided.
Right.
So the origins of how we started interpreting these sounds take us back to Paris in 1816
Okay.
with a French physician named René Laennec.
Laennec's story is so surprising to me because it stems entirely from social friction. Like, he was examining a young woman who had symptoms of heart disease, and at the time, the standard diagnostic method was called immediate auscultation,
Right.
which literally meant the doctor pressing his bare ear directly against the patient's chest.
Yes. Immediate, as in no medium between the ear and the chest.
Exactly. But given her age, her sex, and Laennec's own admitted embarrassment, he felt that pressing his face to her chest was just completely inappropriate.
Yeah, he was quite a modest guy.
But he desperately needed to hear her heart.
So he finds himself in this difficult position and suddenly remembers a principle of acoustics he had observed children playing with at the Louvre.
At the art museum.
Well, the courtyard, yeah. They were scratching one end of a long wooden beam and listening at the other end. So it demonstrated how efficiently solid objects transmit sound.
Oh, wow.
Yeah. So relying on that memory, Lanak grabs a sheet of paper, rolls it up into a tight cylinder, places one end on her chest, and puts his ear to the other.
Wait, so he accidentally invents the stethoscope just to maintain professional boundaries?
That is exactly what happened. He just wanted some distance. The word itself comes from the Greek stethos for chest and scopen for examine.
That's amazing.
He eventually upgraded from, rolled up paper to wooden cylinders.
Yeah.
But the thing is, he didn't just invent the physical tool. He actually invented the entire vocabulary we use to describe what the tool hears.
And he did it by building this massive data set in a pretty grim environment, right?
Very grim. He worked at a hospital with a tragically high mortality rate from tuberculosis. He would listen to a living patient's chest with his new stethoscope, meticulously document the specific, nuanced sounds he heard, and then...
Oh, I know where this is going.
Yeah. When the patient inevitably passed away from the disease, he would perform the autopsy. So this allowed him to directly correlate the acoustic sounds with the physical damage in the lungs.
Wow. So he was creating a sonic map of lung disease, like fluid sounded one way, a collapsed airway sounded another?
Exactly. And in 1819, he publishes all this in a massive 2-volume work, coining terms that clinicians still use today.
But there is a dark irony to this whole thing.
Yeah, there really is.
Lanak himself died of tuberculosis just a few years later, in 1826, at only 45 years old.
Right.
And his diagnosis was confirmed by his own nephew, who listened to his uncle's chest using the very stethoscope Lanak had invented.
It's incredibly tragic.
Yeah.
But he gave medicine the ability to infer severe pathology without a scalpel.
Yeah, totally.
The terminology he left behind, that's where the medical community ran into significant complications.
Yeah.
In the early 1800s, Lanak and his peers categorized lung sounds using these highly poetic analogies.
Right, the source talks about this.
They would call something a cooing sound or a mucus rail. It was very descriptive, but entirely subjective.
It's essentially the medical equivalent of trying to objectively describe the taste of wine.
Yes, perfect analogy.
Like, what sounds like cooing to one doctor might sound like gurgling to another. But okay, I have to play devil's advocate here for a second.
Go for it.
If this tool's from 1816 and our ears are so subjective, why are nurses and doctors still relying on a 200-year-old tube to listen to someone's chest today? Like, isn't that totally outdated? Why not just wheel every patient to the MRI or CT scanner to see exactly what's wrong?
Well, scans take time. They require moving a potentially unstable patient out of the safety of the ICU or ER, and they rely on massive infrastructure.
Okay, fair.
A stethoscope gives instant actionable data right at the bedside. If a patient suddenly drops their oxygen saturation, a nurse can listen and instantly know if it's because a bronchus is spasming or if fluid is actively filling the lungs.
That real-time diagnostic speed is irreplaceable.
Exactly. But you were touching on the exact frustration physiologists felt in the 1970s and 80s.
Oh, with the names of the sounds.
Right. Researchers like Robert Loudon and Raymond Murphy pushed to tie lung sounds to measurable acoustic properties. So frequency, duration, and waveform.
They wanted to standardize it.
Yeah, they wanted a sound heard in Boston to be categorized exactly the same way in London.
But the source material notes that this standardization effort was ultimately incomplete. Like, they pushed for the term crackles, but rails, the older French term, never really went away.
No, it didn't.
Today, they are used completely interchangeably in hospitals everywhere, and Lanak actually preferred using Latin terms over French when he was at the bedside.
Right, because of the translation issue.
Yeah, because the French word râle meant rattle. He didn't want to terrify his French-speaking patients by using a word that sounded almost identical to le râle de la mort.
The death rattle.
Yeah, the death rattle. Talk about bad bedside manner.
Yeah, definitely want to avoid that. But navigating that historical baggage is fascinating. The problem is, knowing the history doesn't help us if we fundamentally misunderstand the physics of the sounds the stethoscope is actually picking up.
Which brings us to the biggest myth in the source material. Starting with the most misunderstood, adventitious sound of all,
Crackles.
crackles. There is a widespread assumption, which the source says is still informally taught, that crackles are the sound of air bubbling through fluid in the lungs. It paints this picture of like a kid blowing bubbles into a milkshake with a straw.
Right, and it is a very intuitive image. A patient has fluid in the lungs from pneumonia, you hear a crackling sound, you naturally assume it is bubbles.
Right.
But the biophysical models from the 1960s, particularly the work of Paul Forgax, prove this entirely wrong.
Completely wrong.
Yes, he proposed the sudden airway opening theory.
Okay, break that down for us.
So when you exhale, some of your small airways might collapse and stick closed. This happens because of excess fluid or a lack of surfactant.
Surfactant being the stuff that keeps them open.
Right, it's a slippery substance the body produces to keep our air sacs, our alveoli, from sticking together like the insides of a wet balloon.
Oh, I see.
Or they might stick because of fibrotic stiffening where the lung tissue gets scarred and rigid,
Yeah.
so they collapse.
And then when you take your next breath in, pressure builds up against those stuck airways until they reach a breaking point and suddenly snap open.
Precisely.
So instead of blowing bubbles in a drink, the physics are actually much closer to pulling apart two sheets of wet plastic wrap that got stuck together.
Yes. That mechanical acoustic click is the true source of the sound. Multiply that tiny snapping open by thousands of microscopic alveoli, all opening asynchronously across the lung, and you get that distinct, discontinuous crackling sound at the chest wall.
That is wild.
It is mechanical popping, not a liquid doubling.
That mechanism completely changes how I visualize it. I mean, it's not a fluid sound at all.
No, it's structural.
And the source breaks these crackles down into fine crackles and coarse crackles, which carry very different clinical stakes.
Very different. Fine crackles are higher in pitch, and they typically happen late in the inward breath, the inspiration.
Okay.
They sound remarkably like Velcro being pulled apart.
Just ripping Velcro.
Yeah. And this is a hallmark sign of a disease called idiopathic pulmonary fibrosis, or IPF.
What happens in IPF?
Well, the delicate, spongy tissue of the lung turns into stiff scar tissue. Because it is so stiff, it resists expanding. So when the patient inhales, the airways are forcibly ripped open at the very end of the breath, creating that high-pitched Velcro sound.
That sounds incredibly painful. And then coarse crackles are on the other end of the spectrum.
Right, coarse crackles are lower pitched, they happen earlier in the breath, and they do indicate the presence of fluid, even if it's not bubbling.
Fluid like what?
This could be exudate, which is a thick inflammatory fluid caused by infections like pneumonia. Or it could be pulmonary edema, which is fluid backing up into the lungs because of heart failure.
Right, the heart failure aspect. The bedside nursing application for coarse crackles is incredible to read about.
It's very visual.
Yeah, because when a patient's heart is failing, fluid starts backing up into the lungs and pools at the very bottom, the bases, due to gravity.
Exactly.
And bedside nurses will sometimes take a marker and literally draw a line on a patient's back to show how high up the crackles are creeping.
Because if at 8 a.m. the crackles are at the bottom of the ribs, and by noon they are halfway up the shoulder blades.
The fluid is rising.
Yes. That nurse knows in real time that the patient is actively decompensating. The heart is failing to pump effectively, and the water level inside the patient's lungs is rapidly rising.
Wow.
They don't need a new x-ray to know the medical strategy needs to change immediately.
You are tracking the trajectory of organ failure entirely by sound. It's brilliant.
It really is.
But okay, crackles are discontinuous, explosive little pops. If we contrast that with continuous sounds, we get into an entirely different set of aerodynamic rules.
We do.
Which brings us to wheezes and raunchy.
Right. By definition, a wheeze is a continuous musical sound that lasts longer than 250 milliseconds.
Okay.
The physics here are completely different from the plastic wrap popping of a crackle. Wheezes happen when an airway is narrowed. As air forces its way through that narrowed tube, it increases in velocity until it reaches a critical point that causes the walls of the airway to physically oscillate.
Oh, so it is less like popping plastic wrap and more like a flag snapping in a high wind.
Yes, or like blowing over a reed in a saxophone.
Right. The velocity of the air moving past makes the fabric or the tissue flutter and vibrate.
That fluttering of the airway wall is why wheezes are so famously associated with asthma.
Because the airways spasm and swell?
Exactly, they swell and become very narrow. Clinically, though, you have to distinguish between a monophonic wheeze and a polyphonic wheeze.
Monophonic meaning one sound.
Right. If you hear a monophonic wheeze, just one single note or pitch, it suggests a single fixed blockage in one specific pipe.
Like what kind of blockage?
That could be a tumor compressing an airway, or, a child who accidentally inhaled a peanut.
Oh, wow, just one blocked pipe.
Exactly.
But a polyphonic wheeze, which sounds like a whole chord of different pitches playing at once, means widespread narrowing across many different sized airways simultaneously.
Yes, which is the classic presentation for an asthma attack. All the pipes are narrowing at once.
Okay, so that's a wheeze. But moving from the wheeze, we have the rhonchus, or raunchy for plural, which is also continuous, right?
Correct, but raunchies are lower pitched. They sound coarser, almost like a deep snoring or a heavy gurgling sound.
So what's the physical difference?
While a wheeze is caused by the airway walls fluttering from structural narrowing, raunchy are caused by air moving past pools of thick mucus or secretions in the larger, more central pipes, the bronchi.
Okay, but distinguishing between a fluttering airway and a mucus-filled airway in a super noisy hospital room seems incredibly difficult.
It can be.
But the source outlines this diagnostic magic trick for this that is wonderfully low-tech. You just ask the patient to cough.
It is a perfect reminder that sometimes the best diagnostic tool isn't $1 million machine, but basic physical mechanics.
Right.
If the patient coughs and you listen again and the sound is gone or totally changed, you know it was a rhonchus.
Because the cough moved the mucus?
Exactly. The explosive force of the cough physically displaced the puddle of mucus. But if they cough and the continuous musical sound doesn't change at all, it's a wheeze.
Because coughing cannot magically fix a structurally narrowed, fluttering airway.
Exactly. The pipe is still narrow, so it still flutters.
That is such a cool trick.
It's incredibly useful.
So we have covered the routine adventitious sounds. We've got the popping crackles, the fluttering wheezes, the snoring rhonchi. But the guide takes a very sharp turn from the routine to the critical. We have to look at the alarms.
Yes, the red flags.
These are the sounds that signify acute, immediate danger and the misconceptions surrounding them that can actually cost lives.
Right. And there is a brief mention of the pleural friction rub, which sounds like walking on fresh snow or leather creaking against itself.
Yeah, the leather creaking thing, what is that?
That is the inflamed outer lining of the lungs, the pleura, grinding together due to inflammation. And that one doesn't clear with a cough.
Got it. But here's where it gets really interesting and a little scary. The primary alarm we need to discuss is stridor.
Stridor is basically an acoustic siren.
Yeah.
It is a high-pitched sound heard mostly when the patient breathes in. But unlike wheezes or crackles, which you hear over the chest, stridor is loudest over the neck.
The neck. Why the neck?
Because you are hearing the upper airway struggling, the larynx or the trachea. It happens in conditions like croup in children, anaphylactic shock where the throat swells from an allergy, or if someone is choking on a foreign object.
Okay, so it's high up.
Right. And the reason it is an absolute emergency is geometric. The upper airway is relatively small to begin with.
Okay.
If it starts narrowing enough to produce the high-pitched sound of stridor, the tissues are only millimeters away from closing completely.
Oh, man.
Narrowing in the neck escalates to total obstruction almost instantly.
So the moment you hear stridor, you are rushing to secure that airway before it shuts.
Without a second of delay.
But as dangerous as stridor is, the source outlines something that might be even more terrifying. Because it is deeply counterintuitive.
The silent chest?
Yes. It is a dangerous misread, known as the silent chest.
This is arguably the most vital takeaway from this entire deep dive. It is a diagnostic trap that has caught many well-meaning clinicians.
How does it happen?
Well, the logical assumption is that if you have a patient having a severe asthma attack and they are wheezing very loudly, they are doing terribly.
Right.
Therefore, if the wheezing gets quieter or stops entirely, they must be responding to treatment and getting better.
Because the bad sound went away.
Exactly.
And making that assumption can be fatal. Like, if you are listening right now and you're ever in a situation with a family member having an asthma attack, this is the one thing you need to remember. Silence is not recovery.
Never. In a severe asthma exacerbation, the airways are narrowing. As they narrow, the air velocity initially increases, causing the airway walls to flutter faster, making the wheeze louder.
Okay, that makes sense.
But if the attack continues to worsen, the airways become so critically narrow that almost no air can pass through at all.
Oh, no.
The volume of moving air drops below the threshold required to create turbulence.
So the airflow becomes so minuscule that the flag stops fluttering entirely?
Yes. The acoustic vibrations cease, the wheezing disappears, the chest goes silent.
It's terrifying.
But the patient is not better. They are in a state of impending respiratory failure. A silent chest in a patient who is visibly struggling to breathe is a massive red flag.
It's the ultimate trap.
Equating a disappearing wheeze with clinical improvement without looking at the patient's overall work of breathing is a notoriously dangerous misjudgment.
It's like standing in the eye of a hurricane, The sudden quiet doesn't mean the storm is over. It means you are in the most dangerous part of it.
That is a perfect way to put it.
And on a related note, the source brings up absent breath sounds in general. Like if you put a stethoscope on a chest and hear absolutely nothing, you should never write lungs clear.
No, absolutely not.
Yeah.
Absent breath sounds, the lung is not ventilating at all in that area.
So what could cause that?
Well, it could be a pneumothorax, which is when air leaks into the chest cavity and causes the lung to collapse like a deflated balloon.
Oh, wow.
Or it could be a massive pleural effusion, which is a huge pocket of fluid building up outside the lung, physically squishing it so it cannot expand.
So the lung just gets crushed.
Exactly. Or it could be a mucus plug completely blocking a major bronchus. The absence of sound is a major urgent finding that requires immediate intervention.
So with the stakes being this high, knowing the difference between a fluttering wheeze and a silent chest, or catching the high-pitched siren of stridor before a throat closes completely, we really have to circle back to the limitations of human biology here.
Yeah, we do.
Just how reliable are our ears when lives are on the line?
Well, the data is a bit unsettling, to be honest. The source cites studies going all the way back to Loudon and Murphy in the 1980s, showing that experienced clinicians frequently disagree on what they're hearing.
Wait, really?
Yeah. You can have 3 different doctors listen to the exact same patient. The first doctor documents coarse crackles. The second doctor insists it's ronchi.
Oh, no.
And the third doctor documents diminished sounds with faint crackles.
So it is that subjective taste of wine problem again, despite 200 years of trying to standardize the terminology.
Right. Our ears are subjective and our individual brains process acoustic patterns differently.
So if human hearing is a bottleneck, how is modern medicine solving it?
We are seeing a massive shift toward computerized auscultation and digital stethoscopes. And this was highly accelerated by the infection risks of COVID-19, where clinicians needed to assess lungs while maintaining physical distance.
Oh, that makes sense.
To make this technology work, researchers developed resources like the ICBHI 2017 Respiratory Sound Database.
Which is this massive public database used specifically to train machine learning algorithms.
Right.
They feed the AI thousands upon thousands of recorded waveforms, teaching the computer to objectively classify a crackle versus a wheeze based purely on mathematical frequency and duration. It just strips away human bias entirely.
It creates an objective standard. Finally. However, the source brilliantly grounds this high-tech future back in the reality of global medicine.
Because not everyone has an AI stethoscope.
Right. Despite all these AI advancements, the basic acoustic stethoscope, that simple concept Lalenik invented out of rolled-up paper in 1816, remains the fastest, cheapest, and most accessible diagnostic tool on Earth.
It's so true. I mean, if you are in a resource-limited setting, like a rural clinic without electricity for a CT scanner, or in the back of an ambulance speeding down a highway at night, a trained ear can instantly distinguish an asthmatic wheeze from a choking child's stridor.
Exactly.
That quick acoustic distinction literally dictates whether you hand a patient a bronchodilator inhaler or you prepare surgical tools to secure their airway.
The stethoscope remains the frontline tool of internal medicine because it translates invisible anatomy into immediate, actionable sound.
So what does this all mean for us? Let's recap for a second. We started our journey in 1816 with Latin accidentally inventing a tool that mapped the acoustic landscape of the lungs and tragically dying from the very disease he spent his life cataloging.
Yeah.
We debunked the milkshake bubble myth, learning that crackles are actually the mechanical sound of collapsed airways popping open like wet plastic wrap, revealing everything from fibrotic sparring to failing hearts.
Right.
We explored how wheezes are the fluttering flags of narrowed airways, while raunchy are the snoring pipes you can magically clear with a simple cough.
It's quite the acoustic tour.
It really is. And most critically, we learned to fear the silence. We learned that a silent chest in a struggling patient is not a sigh of relief, but a blaring alarm bell of impending respiratory failure.
That's the most important takeaway.
It is a powerful reminder that sometimes what you don't hear is just as important as what you do. But before we wrap up, considering everything we've discussed about the ICBHI database and digital stethoscopes, where does this leave the future of listening?
Well, there is a profound implication here regarding the future of AI in medicine. We built these AI databases to settle our human debates over crackles versus raunchy because our ears are flawed, right?
Right.
But what happens when machine learning surpasses the biological limits of human hearing entirely? Will AI eventually identify completely new microscopic subcategories of lung acoustics?
Like sounds that our ears literally cannot pick up.
Yes. It is entirely possible that artificial intelligence will discover a brand new diagnostic language hidden in the vibrations of the chest, a language that Lynette could never have imagined and that human ears were never biologically equipped to hear.
Man, we started out using sound to simply peer into the black box of the lungs, and now we are on the verge of building machines that hear secrets the body is whispering, secrets we were never meant to hear.
It's wild to think about.
The invisible world of internal medicine just keeps getting deeper. Thank you for joining us on this deep dive into the hidden language of breath. Keep listening, keep questioning, and we'll see you on the next deep dive.
So imagine you are standing in an emergency room and you're looking at a patient who presents this like complete medical paradox.
Right, a total contradiction.
Yeah, exactly. On the monitor, their blood pressure is just spiking to terrifying, potentially lethal levels. But mysteriously, their heart rate is rapidly, aggressively slowing down.
Which is not what you expect to see.
Not at all. And when you look at the patient, they are literally split in half. From the chest up, they are flushed, sweating profusely, complaining of this pounding, blinding headache.
Yeah.
But from the chest down, they're pale, their skin is freezing cold, and they've got severe goosebumps.
It is a bizarre, terrifying presentation.
Yeah.
Because looking at them, you're essentially seeing a body at war with itself.
Yeah.
The vascular system is, well, it's effectively acting as two completely independent antagonistic networks just stitched together at the chest.
And that split body presentation is the absolute classic fingerprint of a condition called autonomic dysreflexia, or AD.
Right.
It's a massive, life-threatening spinal cord emergency. And looking at a stack of clinical case studies, historical journals from the 1940s, and some really wild recent sports medicine white papers, our mission for today's deep dive is to unpack this crisis.
It's definitely a crisis you need to catch early.
Definitely. So we're going to explore the fascinating mechanics of how it works, its surprising origin story, how it's secretly weaponized in elite sports, which is mind-blowing, and most importantly, how you can recognize and reverse it before it's too late.
Because the stakes are incredibly high here.
Right, if you miss this, we're talking about seizures, retinal hemorrhage, strokes, myocardial infarction, or just death.
Yeah.
And it can happen in a matter of minutes.
Yeah, it's one of those rare physiological events where the body's own defense mechanisms become a literal lethal threat.
Which is terrifying.
It is. To understand what's actually happening to that patient in the ER, we kind of have to look at the circuitry of the sympathetic nervous system.
Right, the wiring.
Exactly. Under normal conditions, this system's outflow to the vascular bed is organized segmentally along the spinal cord. Basically from the first thoracic vertebra down to the second lumbar vertebra, so T1 to L2.
Okay.
And autonomic dysreflexia typically manifests in patients who have a spinal cord injury at or above the T6 level.
Okay, let's unpack this because visualizing the circuitry really helps. I like to move away from the basic, biology textbook analogies. I look at this like a two-way radio or like a closed-loop feedback system that's failing to reach a critical subnet.
I like that analogy.
Right. So under normal circumstances, a noxious stimulus in the lower body, say a severely distended bladder, sends a danger signal up the ascending spinal tracts.
The body's alarm players.
Exactly. The brainstem registers that noxious stimulus, triggers a sympathetic vasoconstriction to manage the stress, but simultaneously sends inhibitory signals back down the descending pathways to, turn the alarm down and modulate the response.
It maintains homeostasis.
Yeah, but that two-way communication is the key.
And that descending inhibitory signal, the turn it down message, is the vital piece of the architecture. And that is exactly what a high-level spinal cord lesion severs.
So the feedback loop is just physically cut.
Completely cut. Imagine a patient with a complete lesion above T6. That noxious stimulus below the injury still travels up the spinal cord, but it hits the lesion and essentially short circuits.
Wow.
It triggers a massive, unchecked reflex arc at the spinal level. The intact sympathetic nerves below the injury fire off this massive catecholamine surge.
So it's just dumping adrenaline.
Pretty much. You get intense vasoconstriction across a huge vascular bed.
Right.
The peripheral resistance skyrockets, and that is what drives the blood pressure to those astronomical levels.
It's like hydraulic shock. Like a water hammer effect in a massive plumbing grid.
Yeah,
All the valves below the chest suddenly slam shut,
that's exactly what's happening mechanically.
and the blood is squeezed out of the peripheral skin vessels, which perfectly explains the bottom half of the patient. They are pale, cold, and covered in goosebumps piloerection. Below the level of injury because the local sympathetic outflow is just going haywire.
But here's where it gets really interesting.
Okay.
The brain is sitting above the lesion, right? And it's registering this catastrophic hypertension via the baroreceptors in the carotid sinus and the aortic arch.
It knows the pressure's too high.
It knows it's going to blow a vessel, but its descending communication line is severed, the brain scrambling to deploy a workaround.
Because it can't send a signal down the spine.
Right. It realizes the descending spinal tracts are out of commission, so it leverages the only major parasympathetic pathway it has that bypasses the spinal cord entirely.
Which is?
The vagus nerve, or cranial nerve X. The brainstem uses the vagus nerve to heavily parasympathize the heart's sinoatrial node.
Oh, I see. Hence the severe bradycardia.
Exactly.
The brain is literally slamming on the heart's emergency brakes to stop it from pumping against that insane peripheral resistance.
Yes. And at the same time, the brain manages to send inhibitory signals to the sympathetic pathways that are above the level of the lesion.
So it's trying to open whatever relief valves it can reach.
Exactly. It dilates the blood vessels in the head, neck, and upper chest as wide as possible, desperately trying to create a low-resistance reservoir to bleed off all that pressure.
And there is our physiological split. The vasodilation above the injury causes the pounding headache from the engorged cerebral vessels, the intense facial flushing, and the sweating.
It's an incredible mechanical failure.
It really is. Flushed above, pale below, pulse plummeting. But, I mean, if you're looking at this patient's chart in a busy ER, it's pretty easy to get tangled up between AD and all the other various shocks associated with spinal injuries, right?
It is a very common diagnostic trap. Autonomic dysreflexia sits in a cluster of concepts that are, functionally distinct.
Right.
For instance, AD is fundamentally different from spinal shock.
Which is what happens right after the injury, right?
Yeah. Exactly. Spinal shock is the acute temporary state of flaccidity and a total loss of reflexes immediately following the initial trauma. AD actually cannot occur during spinal shock because the reflex arcs are completely suppressed.
Yeah.
AD is a hyperreflexic state that only emerges weeks or even months later once those spinal circuits reorganize and basically awaken.
So it's essentially a rebound into hyperexcitability.
Yeah.
And that also separates it from neurogenic shock.
Right.
Because neurogenic shock is a distributive shock issue, isn't it?
Correct. Neurogenic shock is characterized by a profound loss of sympathetic vascular tone, resulting in severe low blood pressure hypotension and bradycardia right after the injury.
So it's almost the exact opposite.
It is, in many ways, the physiological inverse of an AD crisis. You also have orthostatic hypotension, which is gravity-induced pooling due to compromised venous return, and poikilothermia, the inability to regulate temperature.
Wow, okay. So AD is really the acute hypertensive outlier in that whole group.
Exactly. It's the one spiking the pressure.
So what does this all mean historically? Because, humans have been suffering catastrophic spinal injuries since the dawn of time, combat, falls, industrial accidents.
Sure.
Yet looking through the historical journals for this deep dive, this dramatic split body crisis wasn't systematically defined until 1947. Why did it take until the mid-20th century for modern medicine to document this?
Well, if we connect this to the bigger picture, it actually reveals a pretty grim reality about early 20th century medicine.
Oh.
The reason autonomic dysreflexia wasn't documented before 1947 is that patients simply didn't survive long enough to transition out of spinal shock.
Wait, really?
Yeah. Prior to World War II, a severe spinal cord injury was essentially viewed as a palliative sentence.
A death sentence.
Pretty much. The prevailing medical dogma at the time was just sedation and immobilization. Bladders were either drained passively or just left to overflow.
God, so they were dying of secondary complications.
Yeah.
Sepsis, renal failure, infected bed sores.
The mortality rates were staggering. Most succumbed within weeks. So the physiological evolution of the injury never had time to progress to that hyperreflexic stage we were just talking about.
Right, they never lived long enough for the reflexes to come back.
Exactly. That paradigm only shifted when a neurologist named Ludwig Guttmann arrived on the scene.
The guy at Stoke Mandeville.
Yes. Guttmann was a Jewish neurosurgeon who fled Nazi Germany And in 1944, he took over a newly created spinal injury center at Stoke Mandeville Hospital in England, treating paralyzed Allied servicemen.
And from what I read, he practically went to war with the medical establishment at the time.
Oh, he absolutely did. Gutman refused to accept the systemic neglect. He introduced rigorous active management.
Like what?
He mandated turning patients every 2 hours to prevent tissue necrosis bed sores. He instituted strict schedule-based sterile catheterization to protect their kidneys. He essentially invented comprehensive spinal rehabilitation.
Wow.
And because of those interventions, alongside, the timely introduction of penicillin, these patients actually survived.
Which is the profound irony here. Autonomic dysreflexia wasn't some new disease mutation. It was a latent physiological consequence unmasked by survival.
Exactly. Discovered because patients survived.
Gutman and the physiologist Derek Whitteridge published their landmark findings in the journal Brain in 1947 because, for the first time, a critical mass of patients lived long enough for doctors to notice the pattern.
They saw the direct correlation between bladder distension and catastrophic hypertension.
And that correlation remains the cornerstone of clinical management today, doesn't it?
It does. Across all the modern literature, bladder distension is the undisputed primary trigger for an AD episode.
Something as simple as a full bladder.
A kinked indwelling catheter, an overfull collection bag, or simply a misvoiding schedule that accounts for the vast majority of these crises.
And what's the second most common?
The secondary culprit is typically gastrointestinal, specifically bowel impaction or severe constipation.
Okay, but I have to play the skeptic for a second here,
Go for it.
because I'm sure you're wondering this too. If the patient is paralyzed, right, and they have zero sensation below the chest, how can a full bladder cause this massive pain response?
It's a huge misconception, but it raises an important question regarding nociception versus conscious pain perception.
Nociception meaning just the nerve detecting a stimulus.
Exactly. The sensory nerves in the bladder wall or the bowel still detect the extreme stretch or irritation. Those afferent signals still travel to the dorsal horn of the spinal cord.
But they don't reach the brain.
Right. Instead of continuing up to the somatosensory cortex for you to consciously register, ouch, pain, the signal gets trapped at the lesion, and it synapses directly with the sympathetic efferents.
So it's entirely a spinal level circuit.
Completely. A completely insensate bladder one you can't feel at all will trigger a lethal episode that the patient never actually felt coming.
The nociception is real, even if the perception is absent. The body is screaming, but the brain's intercom is off.
That is a perfect way to put it.
Which actually leads to one of the most staggering things in the sports medicine white papers we reviewed. Because if you understand that this is a predictable mechanical spinal loop,
Uh-oh. I don't know where you're going with this.
someone who understands that loop could intentionally trigger it. And in the world of elite Paralympic sports, this physiological crisis was actively weaponized.
Yes, you're referring to the practice of boosting.
Yes, elite wheelchair racers with high-level SCIs figured out that if they deliberately induced a controlled episode of AD right before a race, it acted like a biological supercharger.
It is incredibly dangerous.
They were intentionally hacking their own autonomic nervous systems.
But from a strictly biomechanical standpoint, the logic is sound.
Explain that, because it sounds crazy.
Well, by purposefully triggering the reflex arc, for instance, by clamping their catheter to overfill the bladder, painfully over-tightening leg straps, or even, in some cases, sitting on a sharp object.
Oof, sitting on something sharp.
Yes, just to generate that noxious stimulus. These athletes force their bodies to dump a massive surge of epinephrine and norepinephrine into the bloodstream.
Which artificially spikes their stroke volume.
Right, and increases cardiac output. Furthermore, that intense peripheral vasoconstriction in the paralyzed lower extremities essentially squeezes pooled blood back into central circulation.
Oh, wow. So it forces all that blood up into the working muscles.
Exactly. It massively increases venous return, which drives extra oxygen delivery to their working upper body musculature. It is functionally a form of blood doping, achieved through targeted self-harm.
It's staggering to think about the risk calculus there. I mean, you are pushing your vascular system to the brink of a hemorrhagic stroke just for a VO2 max advantage.
And obviously, sports regulators didn't just let athletes race with a systolic pressure of 250.
Right, they cracked down on it.
The International Paralympic Committee formally banned the practice of boosting in 1994.
But how do you even police that?
The policing mechanism is directly tied to the underlying physiology. Before high-exertion wheelchair events, athletes undergo strict, unannounced blood pressure screenings.
Oh, smart.
If an athlete presents with a resting systolic reading over 180 millimeters of mercury, they face immediate medical evaluation or outright disqualification.
Because they know you couldn't get that high normally.
Exactly. The officials are screening specifically for that artificially induced sympathetic surge.
Which proves how predictable the syndrome is in a controlled environment.
Definitely.
But that brings up a massive clinical blind spot. If it's this predictable, why is a patient who rolls into a general ER with a blocked catheter in so much danger of being misdiagnosed? I mean, why is AD chronically underrecognized outside of specialized SCI clinics?
It comes down to a fundamental bias in how triage vital signs are interpreted.
Okay, what do you mean?
Well, imagine our patient from the beginning of the episode arrives at a community ER. They have the pounding headache, the sweating above the injury level. The triage nurse takes their blood pressure, and the monitor reads 120/80.
Which, to anyone trained in general medicine, is the textbook definition of normotension, like totally healthy.
Right. To a general ER physician, 120/80 looks perfectly benign. They might diagnose the patient with a severe migraine or maybe anxiety or just essential hypertension.
That may just give them a Tylenol or something.
Exactly. Offer a basic analgesic and send them to the waiting room. But the critical rule for autonomic dysreflexia is normal for you is not normal for them.
Because their baseline is different.
Because individuals with high-level spinal cord injuries lack descending supraspinal sympathetic tone, their peripheral vascular beds are chronically relaxed. So their normal baseline resting systolic blood pressure is usually low, often hovering between 90 and 110.
Oh, wow. So a reading of 120/80 isn't perfect. If their baseline is 90, that's a 30-point spike.
Exactly. A sudden elevation of 20 to 40 millimeters of mercury above their specific baseline constitutes a hypertensive emergency.
That's terrifying.
That 120/80 is a massive red flag. And while the medical staff is falsely reassured by a normal number on the monitor, the underlying trigger, the blocked catheter or the impacted bowel, is going entirely unaddressed.
And the hydraulic shock is just compounding.
Getting worse by the minute.
Normal is a myth when the anatomy has been fundamentally altered. And speaking of altered anatomy, I want to challenge the T6 threshold we established earlier.
Okay, the T6 debate.
Yeah, the literature constantly hammers on T6. Is T6 a rigid anatomical iron curtain, or is there a more complex physiological reason why that specific coordinate matters so much?
That is actually the subject of ongoing clinical debate among specialists.
Oh, really?
Yeah, T6 is taught as a hard diagnostic cutoff, mostly for simplicity, but it's more accurately a clinical heuristic. It represents where the splanchnic sympathetic outflow disconnects from the brainstem.
The splanchnic vascular bed. This is where it gets into the heavy plumbing of the body.
It is. The splanchnic bed is a massive network of capacitance vessels in the abdomen. It's controlled by sympathetic nerves that arise roughly from T5 to T9, and they converge on the celiac and superior mesenteric ganglia.
Okay.
This single vascular bed can hold up to a third of the body's total blood volume.
A third. Wow.
So if a spinal lesion is at or above T6, that entire enormous reservoir is disconnected from brainstem modulation. When an AD trigger occurs, that entire vascular bed constricts simultaneously.
Oh, man.
It displaces a massive volume of blood into central circulation, which is what drives the catastrophic spike in preload and afterload.
So it's not just local constriction in the legs. You are literally wringing out the body's largest internal blood sponge all at once.
That's a very visceral way to put it, but yes.
But human neuroanatomy isn't perfectly symmetrical, is it?
It isn't. The sympathetic chain spans multiple segments and collateral innervation exists. So while T6 is the classic benchmark, the clinical data absolutely shows a gray zone between T6 and T10.
Oh, so it can happen lower down.
Case reports document patients with lower lesions T8, even T10 experiencing clinically significant, albeit sometimes less severe, dysreflexic episodes.
Because a portion of that splanchnic outflow is still caught in the disconnected reflex arc.
Precisely. Which is why some specialists argue for diagnosing based on symptoms rather than a rigid spinal coordinate.
Which makes sense.
Yeah.
You treat the presentation, not the textbook coordinate. If they have the headache and the bradycardia, you just assume the crisis.
Absolutely.
So let's put this into practice. Let's say we are in the ER or a nursing facility, and we recognize it's autonomic dysreflexia. Given that this is fundamentally a mechanical plumbing issue caused by a trapped noxious stimulus, I'm guessing the first move isn't reaching for a systemic antihypertensive pill.
No, the clinical mantra here is sit them up before you dose them up.
Sit them up. Okay.
Pharmacological intervention is a backup, not the first move. Your immediate, absolute first-line action is positional orthostatic offloading.
Because they lack descending vascular tone, gravity is actually your best friend.
Exactly. You sit the patient bolt upright and lower their legs if possible. By utilizing gravity, you induce venous pooling in the lower extremities, which rapidly decreases venous return and takes the acute pressure off the cerebral vasculature.
So it's an immediate mechanical way to lower the blood pressure.
Immediate, non-pharmacological afterload reduction.
Smart.
Once they are upright, you aggressively remove any restrictive clothing, tight belts, or abdominal binders that might be acting as a noxious stimulus.
And then you go hunting for the primary trigger. Following the data, T6 and above, check the plumbing first.
T6 and above, bladder first. You immediately inspect the urinary catheter for kinks or blockages. You check the collection bag.
And if they don't have a catheter?
If the patient does not have an indwelling catheter, you must perform in and out catheterization immediately to decompress the bladder. However,
There's a catch.
there's a critical caveat. You must use generous amounts of topical anesthetic like lidocaine jelly.
Because the sheer mechanical friction of inserting the catheter adds a new noxious stimulus to the dorsal horn.
Precisely. Which could exacerbate this reflex arc. You don't want to worsen the AD episode while trying to treat it.
And what if the bladder is fine?
If the bladder is decompressed and the blood pressure remains volatile, you move to the gastrointestinal system to check for fecal impaction. And again, utilizing copious topical anesthetic before performing a rectal exam is absolutely mandatory for the same reason.
So it is mechanical problem solving first. Find the kink in the hose, remove the nociceptive input, and the spinal reflex loop should theoretically break.
Right. You only turn to fast-acting pharmacological agents if the trigger cannot be quickly identified or resolved and the blood pressure remains critically elevated.
What kind of meds do they use for that?
Depending on institutional protocols, fast-acting agents like nifedipine, which is a calcium channel blocker that relaxes vascular smooth muscle, or topical nitrate paste, which provides systemic venal dilation, are commonly used.
Just to artificially force the vessels open until the underlying irritant is cleared.
Exactly. It buys you time.
It's remarkable how mechanistic the human body is when you strip away the conscious perception. And I think what really sticks with me as we wrap this up is the everyday vigilance this requires.
It requires a lot.
Because, we've framed this deep dive in an emergency room, but for someone living with a high-level thoracic injury, a life-threatening split body crisis doesn't require massive trauma.
Not at all. The threshold for nociception can be remarkably low.
It can be triggered by things that wouldn't even register for most people. A leg bag strap pulled slightly too tight, severe menstrual cramps, an ingrown toenail,
Or even a bad sunburn on their legs.
a sunburn. A totally mundane irritant hits that severed feedback loop, and suddenly they are fighting for their life. It means patients and their care teams have to act as physiological detectives constantly.
It demands an exhaustive level of situational awareness, day in and day out. Autonomic dysreflexia serves as this profound reminder of the intricate architecture of our nervous system. We are wired with these aggressive, deeply embedded evolutionary fail-safes designed to maintain homeostasis, like the sympathetic alarm bells. But it begs a fascinating question.
Yeah, I wanted to ask, what does this all mean for the bigger picture of medical intervention?
Well, think about it. When medical advancements like Gutmann's revolutionary rehabilitative protocols or modern trauma surgery alter our fundamental anatomy, allowing us to survive previously fatal neurological injuries, how many other hidden physiological loops are waiting in the dark?
Oh, wow.
We successfully solved the acute survival problem of spinal cord injuries, but in doing so, we unmasked a latent biological circuit that we never knew existed.
Because no one had ever lived long enough for us to see it.
Exactly. It makes you wonder what other well-intentioned physiological fail-safes might become our greatest vulnerabilities as medicine continues to push the boundaries of human survival.
The alarms we haven't even heard yet. That is a thought that will definitely linger long after this deep dive.
It's a lot to mull over.
It really is. Well, just remember the clinical triad. Flushed above, pale below, pulse plummeting. Catch the baseline, utilize gravity, and hunt for the trigger. Imagine for a second that you are, well, in absolute peak physical condition.
Right, like you're a professional athlete at the top of your game.
Yeah, exactly. Maybe even a gold medalist. And you undergo this fairly routine foot surgery, and the operation goes perfectly. You go home to rest, but then, days later, you find yourself struggling to breathe, literally fighting for your life in an emergency room.
And it's not because of an infection or anything like that.
Exactly. No infection. You didn't tear a muscle.
Oh,
You were
okay.
being taken down by something completely invisible. It's this microscopic threat that formed entirely because you did exactly what you were told to do.
Which is to stop moving.
Right. You stop moving.
It's honestly one of the most counterintuitive paradoxes of the human body. I mean, we are conditioned from childhood to believe that resting is the ultimate form of healing.
Right. You get hurt, you go to bed.
Exactly. But in the context of human circulation, absolute rest can actually be the very trigger for a catastrophic medical event.
And that is the exact paradox we're diving into for you today. Welcome to the Deep Dive. We have this fascinating stack of sources in front of us today. We've got nursing protocols, some wild historical medical cases, and modern clinical trial data.
It's a really comprehensive pile.
It is. And our mission today is to explore this concept, the clot that forms when you stop moving. We are talking about deep vein thrombosis, or DVT. So, okay, let's unpack this.
Let's do it.
Looking at these sources, they draw a very hard line between different types of veins. What exactly is a DVT, and why is it so much more dangerous than just getting a bruise or a surface-level clot?
Well, the distinction is purely anatomical, but it really makes all the difference in the world. A deep vein thrombosis is a blood clot, or a thrombus, that forms inside one of the body's deep veins.
So, like where exactly?
Typically, these are buried deep inside the muscle of your calf, your thigh, or your pelvis. So if you think of the veins just under your skin as small, winding side streets.
Okay, side streets.
Right. If a clot forms there, yeah, it's painful, but it's relatively contained. The deep veins, on the other hand, are the massive high-speed return highways.
Oh, wow.
Yeah, they're responsible for channeling huge volumes of oxygen-depleted blood directly back to the right side of your heart and then immediately into your lungs to get reoxygenated.
Which means if a clot forms on that high-speed highway, there is no detour.
None at all.
If a piece of that clot breaks off, like it embolizes, right? It has a straight, unobstructed shot right into the heart and then into the pulmonary arteries.
Exactly. And when it lodges in the lungs, it completely blocks blood from picking up oxygen.
Right.
That is what we call a pulmonary embolism, or PE.
And that can be instantly fatal.
It can. In modern clinical practice, doctors actually don't even view DVT and PE as separate diseases anymore.
Really?
Yeah, they group them together under the umbrella term venous thromboembolism, or VTE, because honestly, they're just two stages of the exact same disease process. The clot forms in the leg, and it basically finishes its destructive journey in the lung.
Wow. So the entire goal of modern medicine, and really the main through line of all the nursing protocols in our sources today, is early recognition and prevention.
Prevention is everything here.
It's about understanding that something as basic as, bending your knees and walking is literally a matter of life and death. But to figure out how to stop these clots, we first need to understand the blueprint of how they form.
Right.
And reading through these historical documents, I was genuinely stunned to see that the prevailing theory on this isn't from modern times at all. It's from the 19th century.
Yeah, it's pretty wild. Despite all our advanced MRIs and, genetic sequencing, the foundational framework for understanding blood clots was actually established way back in 1856.
1856.
It's incredible. By a German physician and pathologist named Rudolf Virchow. He basically proposed that for a clot to form inside a blood vessel, one of three specific conditions had to be met.
And this is Virchow's triad.
Exactly. We still call it Virchow's triad today. It is literally the first thing taught in every single medical and nursing school when covering this topic.
So let's break those three conditions down because they really dictate everything else we are going to talk about today.
Okay, so the first pillar of the triad is stasis.
Which means?
This is simply blood flow slowing down to a crawl. The second pillar is endothelial injury, which means physical damage to the smooth, delicate inner lining of the vein itself.
Okay, stasis and injury.
Right. And the third is hypercoagulability. That's a systemic state where the blood's chemistry is altered. So it makes the blood fundamentally primed and eager to clot, even when there is no physical bleeding to stop.
Okay, I want to linger on that first pillar for a second, stasis, because it really highlights the mechanical engineering of our bodies.
Oh, absolutely.
If you think about the blood in your legs, it has a massive problem to overcome, which is gravity. It has to travel all the way from your ankle back up to your chest. And your heart alone just isn't strong enough to suck that blood upward.
No, it's not. So your body relies on your leg muscles, specifically the calf muscle pump. The soleus muscle in the calf is actually often called the second heart for exactly this reason.
The second heart, I love that. It's basically a biological plumbing system.
Huh.
Every time you take a step, that calf muscle contracts and physically squeezes the deep veins, just shooting the blood upward.
Mm-hmm.
And then these little one-way valves inside the vein snap shut so the blood doesn't fall back down.
Yeah.
But when that pump is turned off, like when you are immobilized in a hospital bed or sitting at a desk for 12 hours, the blood just pools.
It just sits there.
Right. If a plumbing pipe has a fast-flowing river of water, it stays clean. But if the water stops waiting, all the heavy sediment, the debris, the clotting factors, they all start to settle against the walls of the pipe.
And that sediment settling triggers a microscopic chain reaction.
Yeah.
And that cascade is dramatically accelerated if you introduce the second pillar, which was endothelial injury.
So physical damage to the pipe itself.
Exactly. If you undergo surgery like a knee replacement, or if you suffer trauma in a car accident, the lining of your vein is damaged. When that lining breaks, it exposes a protein underneath called tissue factor.
Tissue factor.
Yeah, and tissue factor is basically a biochemical alarm siren. It screams to the rest of the body, hey, we're bleeding, send the clotting crew right now.
Wow.
So even if the bleeding is purely internal, a clot will rapidly build at that exact site of injury.
So, I mean, if your pipes are flowing and the pipes aren't physically damaged, you should be completely safe from a clot, right?
Well, you'd think so.
Right, but that brings up the third part of the triad, hypercoagulability. Because what if the fluid running through the pipes is genetically primed to basically turn into sludge?
Exactly. Sometimes the blood itself is the core problem. Our sources highlight a condition called Factor V Leiden. It was identified in the mid-90s, and it's a genetic mutation that essentially breaks the off switch for blood clotting.
The off switch.
Yeah, so people with this mutation create clots much faster than their bodies can dissolve them. But the thing is, hypercoagulability doesn't have to be genetic. You can acquire it.
How does that happen?
Things like active cancer, systemic inflammation, or severe obesity can all basically dump chemicals into your bloodstream that lower the threshold for clotting.
And looking at this 165-year-old triad, it completely destroys the modern stereotype we have about who actually gets a DVT.
Oh, completely.
I think the average person assumes this is a disease strictly for the elderly or maybe someone confined to a nursing home. But Virchow's triad proves that age is entirely irrelevant if those conditions are met.
The triad does not care how young you are. It doesn't care how fast you can run a marathon. If the scales tip, a clot forms, period.
The story of David Bloom in our sources is just a heartbreaking example of this. He was this incredibly prominent, dynamic NBC News correspondent. And in 2003, during the invasion of Iraq, he was embedded with U.S. forces.
Right.
He was only 39 years old. But he spent days folded up with his knees to his chest inside this cramped Bradley fighting vehicle just bouncing across the desert.
He had almost no ability to extend his legs or activate that calf muscle pump we talked about. The stasis was absolute.
The pump was turned off, the sediment settled, and a massive DVT formed. And it eventually embolized into a fatal pulmonary embolism. I mean, he wasn't elderly, he wasn't sick. It was pure stasis-driven thrombosis caused entirely by his environment.
And we see this phenomenon regularly at the extreme opposite end of the health spectrum, too, like in elite professional athletes.
Right, going back to the surgery example.
Yeah, the tennis legend Serena Williams developed a life-threatening pulmonary embolism following foot surgery in 2011. And she was arguably in the top fraction of a percent of human physical fitness.
Truly peak condition.
But the physical trauma of the surgery created endothelial injury, and the prescribed recovery period created stasis. So 2 pillars of the triad were met, and her incredible fitness just couldn't stop the clot.
Chris Bosh is another prime example from the sources. He was an NBA All-Star, constantly moving, but his career was tragically cut short by recurring blood clots.
Yeah, he had an underlying hypercoagulable state.
So you combine that with the constant microscopic physical trauma of professional basketball and the endless hours sitting on airplanes, and boom, you trigger the triad.
Exactly. And if we connect this to the bigger picture, the realization that prolonged stillness is deadly forces us to look back at medical history with a lot of horror.
Oh, totally.
Because for a very long time, the medical establishment was prescribing the exact thing that was killing people.
The era of strict bed rest. Reading these older protocols, it is wild how universal it was.
It was the standard for everything.
Right. For much of the 20th century, if you had a baby, you were on strict bed rest. Heart attack, weeks of bed rest, surgery, do not move a muscle.
The logic was that a recovering body needed to conserve every single ounce of energy to heal tissue, and moving might, rip open surgical
It was
stitches.
incredibly intuitive logic at the
It
time.
was. But the outcomes data eventually revealed an absolute disaster. Doctors were noticing horrifying rates of sudden death in patients who seemed to be recovering perfectly from their initial surgeries.
And they didn't know why.
Not at first. It took decades of autopsies and outcome tracking to realize that the bed rest was allowing massive clots to form in the deep veins. Orthopedic surgeons were actually some of the very first to sound the alarm on this, particularly as joint replacements became more common in the mid-20th century.
Because replacing a hip or a knee is basically a worst-case scenario for the triad,
Oh,
right?
yeah.
You have massive bone and tissue trauma causing endothelial injury, plus the patient can't walk.
Precisely. The DVT rates in early orthopedic surgeries were astronomical. And this realization forced one of the most profound paradigm shifts in modern nursing and medicine.
Right.
Immobility went from being a prescribed treatment to a recognized pathogen. Today, if you wake up from a major surgery, a nurse is likely going to have you standing up and shuffling down the hallway within hours. Early mobilization is now the ultimate protective standard.
But wait, let me push back on that for a second.
Sure.
If getting up and moving is the cure, if activating the calf muscle pump sweeps the sediment away, why do the nursing protocols in our sources still mandate heavy blood thinners for patients in the hospital?
That's a great point.
I mean, if I am walking the halls, why are they injecting me with anticoagulants? Doesn't the walking basically cancel out the need for the drugs?
It raises an important question, but the flaw in that logic goes right back to Virchow's triad. You cannot view the triad as a single problem with a single solution.
Ah, okay.
Walking down the hallway absolutely solves the stasis problem. But what if you just had major abdominal surgery? You still have immense endothelial injury that is actively calling for clotting factors. Or what if you are hospitalized for cancer treatment? Your blood is still hypercoagulable.
So the movement only fixes 1/3 of the blueprint.
Yes, exactly. Walking cannot fix a chemical imbalance or a torn vein lining, and that is why mechanical prophylaxis like walking and chemical prophylaxis like blood thinners are not substitutes for one another.
They work together.
They do. Medications like heparin or the newer direct oral anticoagulants work synergistically with movement. The movement keeps the blood flowing, and the medication alters the blood chemistry to raise the threshold for clotting, preventing that tissue injury from triggering a massive response.
Okay, so what does this all mean for things like compression socks? Because for years, the conventional wisdom was just to put tight stockings on immobilized patients to keep the pressure up and prevent stasis.
Right.
It seems like a perfectly logical physical solution, right?
It does seem logical, and for decades, graduated compression stockings were used as this blanket preventive measure for almost everyone in a hospital bed. But the medical community eventually learned that you cannot just slap a mechanical Band-Aid on a complex system without testing it rigorously.
And that's where the CLOADS trial comes in.
Exactly. The UK CLOTS trial in the 2000s completely upended this assumption.
So what did the trial actually test?
They looked specifically at stroke patients. Now, stroke patients are highly vulnerable to DVT because they often suffer from paralysis and simply cannot move their legs.
So ultimate stasis.
Right. The researchers assumed thigh-length compression stockings would artificially squeeze the veins and prevent clots, but the data showed the exact opposite of what they hoped.
Wait, really?
Yeah. Not only did the stockings fail entirely to reduce DVT rates in these stroke patients, but they also actively caused harm. The constant tight pressure on fragile skin led to terrible ulcers, skin breakdown, and even restricted arterial blood flow.
Oh man, that is a massive backfire. Trying to passively squeeze the leg ended up causing a whole new set of injuries.
It forced a total reevaluation. It taught clinicians that you just cannot apply a universal passive fix to every single patient. Prevention requires an active, tailored approach based on individual risk factors, not just handing out tight socks.
And the urgency of getting that prevention right is magnified by how sneaky these clots actually are. Because even with early walking and even with blood thinners, a clot can still form.
They absolutely can.
And the most terrifying detail in these sources isn't just that they form, but that they often form in complete silence. There is this huge misconception that a DVT will always present as this massive, red, swollen, throbbing leg.
And that expectation is incredibly dangerous. While a classic DVT certainly can cause swelling and pain, a huge percentage of them are completely asymptomatic.
Just zero symptoms.
Zero. Or the symptoms are so mild, just a vague ache or a feeling of heaviness, that a patient will completely dismiss it as a muscle cramp or a pulled hamstring.
Wow.
Very frequently, the absolute first sign that someone has a DVT is when a piece of it breaks off, travels to the lungs, and they suddenly collapse with crushing chest pain and shortness of breath.
The silent nature of the disease is just deeply unsettling. But historically, that silence has also served as a very dark warning sign for other hidden diseases. There was a story in our sources about Armand Trousseau, a French physician in 1865.
Trousseau is a fascinating figure. He was a brilliant diagnostician studying thrombophlebitis, which is basically inflammation and clotting in the veins. And during his practice, he noticed a very strange pattern in a subset of his patients.
What did he see?
They would develop unexplained blood clots that would appear in one leg, resolve, and then spontaneously appear in an arm or the other leg.
Okay, so just popping up everywhere.
Right. These migrating, recurring clots were happening without any obvious stasis or injury.
So he realized he was looking at severe hypercoagulability.
Yes, and he made a groundbreaking connection. He discovered that this specific pattern of migrating clots was often the very first visible symptom of an occult or hidden visceral cancer, most notably stomach or pancreatic cancer.
Because the tumor is changing the blood.
Exactly. The tumor itself was secreting chemicals that threw the clotting cascade into absolute overdrive. Today, this phenomenon is still taught in medical schools as Trousseau's sign of malignancy.
But the truly chilling part of the story is how his research ended.
It is incredibly tragic, honestly. Just 2 years after publishing his findings in 1867, Trousseau felt a strange ache in his own body. He observed his own veins and saw the very pattern of migrating blood clots he had just documented.
Oh my God.
Yeah, because he wrote the paper on it, he knew instantly what it meant. He used his own physical symptom to diagnose himself with advanced pancreatic cancer, and he succumbed to the disease just months later.
The clots were the smoke and the hidden cancer was the fire. It is an amazing testament to the power of clinical observation. But obviously, how we look for that smoke has evolved a lot, because back in the 1940s, a doctor trying to figure out if you had a clot would basically just physically squeeze your leg.
You were talking about Hohmann's sign.
Right. The old bedside test where the doctor forcibly flexes your foot upward toward your shin to see if it causes deep pain in your calf.
Yeah, it was the gold standard physical exam for decades. But modern medicine completely abandoned it, and for very good reason. First of all, it is essentially useless from a diagnostic standpoint.
Because almost anything can make your calf hurt when you stretch it like that, right?
Yeah.
Like a cramped muscle or a ruptured cyst.
Exactly. The sensitivity and specificity are terrible. But more importantly, performing Hohmann's sign is actively dangerous.
How so?
Think about the mechanics. You have a fresh, gelatinous blood clot precariously clinging to the wall of a vein. Then a doctor comes along and aggressively stretches and squeezes the muscle surrounding that vein.
Oh, no.
Yeah, the physical manipulation can actually dislodge the clot right then and there, causing the exact pulmonary embolism the doctor is trying to diagnose.
It's literally squeezing a live bomb to see if it's ticking. So Hohmann's sign is out. Today, clinicians use a much more sophisticated algorithm. Our sources highlight this three-step pathway. First, instead of guessing, they use the Wells score, which is basically a strict mathematical checklist.
Right.
It assigns points for things like recent surgery, swelling, or cancer history to determine the mathematical probability that a clot is present. Then, they use a D-dimer blood test.
The D-dimer is fascinating. When a clot forms, your body immediately starts trying to break it down. As the clot degrades, it sheds these microscopic protein fragments into the bloodstream.
And the test looks for that.
Exactly. The D-dimer test detects that specific biochemical wreckage. So if the D-dimer is completely negative, you can be fairly certain there is no active clotting going on.
But if it is positive, you move to the ultimate tool, which is the compression ultrasound. It uses sound waves to actually visualize the blood flowing through the deep veins in real time. And here's where it gets really interesting, because this advanced ultrasound technology actually sparked a massive ongoing debate in the medical community.
It absolutely did.
Yeah.
Before ultrasound, a clinical DVT was just a DVT, and it was treated aggressively. But ultrasounds became so sensitive that doctors could suddenly pinpoint exactly where the clot was located.
Right.
This created a new anatomical distinction. They asked, was the clot proximal, meaning high up in the large veins of the thigh or pelvis? Or was it distal, meaning it was tiny and isolated solely in the deep veins of the calf?
And that matters, because a clot in the calf has a much longer, more difficult journey to get to the lungs than a clot in the thigh, right?
Precisely. The data eventually showed that distal calf clots have a remarkably low rate of embolizing. In fact, the body's natural enzymes often just dissolve them over time without any medical intervention whatsoever.
Wow.
And this realization caused a massive fracture in standard protocols. Historically, the moment a clot was found anywhere, the patient was put on powerful blood thinners for months. But blood thinners carry a significant risk of severe internal bleeding.
So doctors started asking, like, are we risking a brain bleed to treat a tiny calf clot that might never cause a problem?
Exactly. This led to a controversial new approach called watchful waiting for isolated distal clots.
Watchful waiting.
Right. Instead of prescribing dangerous anticoagulants, some clinicians now opt to simply perform serial ultrasounds every few days. They just watch the clot. If it doesn't grow or move upward toward the thigh, they never medicate it.
That's a huge shift.
It was considered medical heresy 20 years ago, and professional hematology guidelines are honestly still actively debating exactly when to treat and when to watch.
It shows just how incredibly nuanced our understanding of blood clotting is becoming. And that nuance isn't just for hospital wards. It applies to all of us living our daily lives. Because the triggers for Virchow's triad are hiding in our everyday routines. For example, economy class syndrome.
Yes, the World Health Organization actually launched a massive study called the RIGHT Project to investigate that specific phenomenon.
And the data they found is just stark. I mean, if you were listening to this deep dive right now while sitting on a flight that is longer than 4 hours, your risk of developing a venous thromboembolism has roughly doubled compared to when you were just waiting in the terminal.
Because your calf pump is off.
Exactly. The pump is off, and the dry cabin air is dehydrating you, making your blood slightly thicker. So it is pure stasis combined with mild hypercoagulability.
And everyday life events affect that hypercoagulability too. Taking estrogen-based birth control pills, undergoing hormone replacement therapy, or simply being pregnant prompts the liver to produce more clotting factors.
Which is natural, right?
It is. It's the body's evolutionary way of preparing for the bleeding of childbirth, but it dramatically increases the risk of a DVT.
And then there are massive, unpredictable global events that throw the entire clotting cascade into chaos. The COVID-19 pandemic is heavily featured in these clinical notes.
The vascular impact of COVID-19 was a terrifying surprise to the medical community in 2020. Clinicians were seeing patients whose lungs were full of microclots and whose legs were developing massive DVTs, even when those patients were already on high doses of preventive blood thinners.
Wait, how is a respiratory virus causing blood clots in the legs?
It comes back to endothelial injury and inflammation. COVID-19 triggered what we call a cytokine storm, a massive uncontrolled inflammatory response by the immune system. The virus and the inflammation aggressively attacked the inner lining of the blood vessels throughout the entire body. So the body misinterpreted this massive systemic inflammation as widespread physical trauma.
Oh, wow. So it thought it was bleeding everywhere.
Exactly. It essentially panicked, thinking it was bleeding out, and dumped massive amounts of clotting factors into the blood. It created a hypercoagulable state so aggressive that standard drugs just couldn't stop it.
That is terrifying. But medical research also delivers incredible, positive surprises regarding how our vascular system works. The Jupiter trial from 2009 is a perfect example of this.
Oh, the Jupiter trial is one of my favorite anomalies in modern medical research.
Tell us about it.
It was a massive multinational study looking at a drug called rosuvastatin. Statins are widely known and prescribed exclusively to lower bad cholesterol. The goal was to see if the statin prevented arterial plaques from bursting and causing heart attacks.
But they accidentally discovered a massive benefit for the venous system.
Yeah. They did. When they analyzed the data, they found that the patients taking the statin had a dramatic, statistically significant reduction in venous thromboembolism.
Which makes no sense.
It confused everyone at first because cholesterol plaques do not form in veins, they only form in arteries. So how is a cholesterol drug preventing DVTs?
Right, what was the actual mechanism there?
It turns out statins don't just lower cholesterol, they're also powerful anti-inflammatory agents. They soothe the endothelium, the inner lining of the blood vessels.
Okay.
By reducing systemic inflammation, the statin essentially calmed the vein walls down, preventing them from sending out those chemical distress signals that trigger a clot. It was a total accident of research that proved how interconnected our cardiovascular systems really are.
It is incredible how a drug built for one side of the circulatory system ended up protecting the other just by calming the environment.
Yeah.
So as we pull all these threads together, The core takeaways from this massive stack of research are incredibly clear.
Very clear.
First, Virchow's triad stasis, endothelial injury, and hypercoagulability is the ultimate blueprint. Every risk factor you will ever face traces back to one of those three pillars. Second, bed rest is no longer the cure. It is a profound risk. Early, active movement is the gold standard of prevention.
Movement is medicine.
Exactly. And finally, you cannot wait for obvious pain to warn you because a clot can be utterly silent until the exact moment it threatens your life.
And as you think about the silent, lingering nature of this disease, I want to leave you with a final concept to ponder that illustrates the true long-term stakes of a deep vein thrombosis.
Okay.
It is a condition called post-thrombotic syndrome. We focus so heavily on the immediate life or death threat of the clot breaking off and traveling to the lungs. But what happens to the leg itself after the crisis is over?
That's a good question.
Even if you were diagnosed early, even if you are given the right blood thinners, and even if the clot completely dissolves, the physical trauma of that clot sitting in your vein can permanently destroy those tiny, delicate one-way valves we talked about earlier.
Oh, no.
And when those valves are ruined, they never grow back. The blood can no longer fight gravity efficiently. It constantly falls backward and pools in your lower leg.
Wow.
For the rest of your life, you can be left with chronic, heavy swelling, persistent pain, and irreversible skin discoloration. It is the permanent structural footprint that a clot leaves behind long after it is gone.
Oh.
And it is the ultimate reminder that the true goal of medicine isn't just to survive a blood clot. The goal is to never let it form in the first place.
Imagine you are an ER nurse.
Okay.
And two patients just roll through the double doors from this massive car crash.
Oh, wow. Right into the deep end.
Right. So one of them is screaming at the top of his lungs, and there is just a geyser of blood shooting from a mangled leg. I mean, it looked like a scene straight out of a horror movie.
Naturally.
But the other patient is sitting perfectly still. They look, mostly fine, actually. But when they try to talk, there is this incredibly subtle, like high-pitched squeak every time they take a breath.
Oh, yeah. That's bad.
Right, because if you run to the screaming patient first, your quiet patient will be dead in 3 minutes.
Yeah, it is the absolute ultimate trap for a novice responder. I mean, your eyes are just completely hijacked by the dramatic bleeding.
Of course they are. It's human nature.
Exactly. But your training has to override your instincts.
And welcome to today's deep dive, everyone. We are looking at a really fascinating stack of sources today. We've got clinical protocols, medical history, triage frameworks, and the actual philosophy driving modern nursing exams.
It's a lot of ground to cover.
It really is. Our mission today is to unpack the intensely high-stakes world of prioritization. So, if you are studying for your medical boards right now, obviously you know how critical this is.
Oh, yeah. It's everything.
But even if you are just someone who's fascinated by how human beings make rapid-fire, literal life-or-death decisions under extreme pressure, this deep dive is absolutely going to change how you look at problem solving.
I completely agree.
Because we are exploring how nurses fuse clinical knowledge, meaning the physiology of what could kill someone, with workflow management, meaning what to physically do first. And they do this in a single split-second judgment.
Right. They basically have to instantly merge the what's wrong with the what now.
Exactly. Okay, let's unpack this, because where do we even begin with a concept this massive? Like, was there a specific moment in history where someone finally sat down and wrote out the rules for who gets saved first?
Well, to find the origin of that, we actually have to step far away from, modern sterile hospital rooms.
Okay, where are we going?
We have to go back to the battlefields of the 1800s.
Wow, really?
Yeah. So the foundational word we use today is triage, right? Which comes from the French verb tria, which simply translates to sort.
To sort, okay.
Right. And the person credited with weaponizing this concept, and I use that word intentionally, was a man named Dominique Jean Larrey.
Larry, wait, he was Napoleon Bonaparte's chief surgeon, correct?
He was, yeah. So during the Napoleonic campaigns, particularly during that brutally freezing retreat from Russia in 1812.
Right, the famous retreat.
Exactly. Larry observed this incredibly chaotic and highly ineffective medical response because before him, wounded soldiers were treated based on their military rank.
You're kidding?
No, seriously, like A general with a twisted ankle would absolutely get a doctor's attention before a private with a musket ball in his chest.
That is insane.
Or, alternatively, surgeons just treated whoever was physically dragged off the field first.
Just totally random.
Total chaos. So he essentially walked into that chaos and instituted a pure threat-level system.
Right, so he stripped away rank entirely.
Entirely. Larry began sorting the wounded strictly by the severity of their physical injuries, and he also realized that speed itself was a medical intervention.
Because you can't just wait around.
Right, so he pioneered these horse-drawn flying ambulances to actually retrieve the wounded while the battle was still raging, rather than waiting for the shooting to stop.
Wow. But, the sources point out something really fascinating about his underlying motivation for all this.
Yeah, it's not what you'd expect.
Right, because we tend to view doctors through this lens of pure humanitarian mercy, right? But Larry's triage system, it wasn't born out of a bleeding heart.
Not at all. It was born out of cold, hard military logistics.
Which makes sense for Napoleon's army.
Yeah. The explicit goal was to evaluate soldiers, find the ones who were treatable, patch them up, and then shove them back onto the front lines as quickly as possible.
Because they needed a functioning army.
Exactly. Preserving the strength of the fighting force was the priority, not necessarily, comforting the dying.
It's a pretty radical shift in thinking when you compare it to how normal society operates. Like, we are deeply conditioned by what I call the deli counter system.
Oh, right. First come, first served.
Exactly. You take a ticket, you wait your turn, and universally, everybody considers that fair. But Larry essentially walked up to the deli counter, ripped the ticket dispenser off the wall, and declared that fairness just doesn't matter when survival is on the line.
That is a great way to put it. And that military arithmetic, it migrated into civilian medicine over the next century, and it really became the absolute prime directive of modern nursing prioritization.
Which is?
Treat what will kill the patient soonest first.
Which sounds completely obvious until you are actually standing in a chaotic room with 5 injured people.
Oh, 100%.
Because knowing that you must treat what kills fastest is one thing.
Yeah.
But how do clinicians actually measure that? I mean, how do you look at a complex human body and instantly calculate the countdown timer on their life?
Well, you rely on the ABCs.
Okay, the famous ABCs.
Right. But to understand how those became the gold standard, we really have to look at how disjointed trauma care was up until the late 1970s.
Wait, the 70s? So who actually standardized this?
Yeah.
Was it like a gradual evolution, or did someone finally sit down and write a manual?
It was actually born out of a specific harrowing tragedy.
Oh, really?
Yeah. In 1976, there was an orthopedic surgeon named Dr. James Steiner. He was piloting a small plane with his family over Nebraska, and the plane crashed into a cornfield.
Oh, my God.
Yeah. His wife was killed on impact, and he and his children sustained severe, complex injuries.
That's horrifying.
It is. And when they eventually flagged down help and arrived at a local rural hospital, Dr. Steiner was just appalled by what he saw.
I can only imagine. I mean, you survive a plane crash, you think you're finally safe, and then you realize the hospital doesn't even know what to do with you.
Right. The medical staff there, they were well-meaning, sure, but the care was disorganized and completely inconsistent. They just didn't have a systematic way to evaluate multiple trauma victims.
So they were just winging it.
Basically. And Steiner realized that surviving the physical accident was merely phase 1. Surviving the chaotic hospital response was phase 2.
Wow.
So that experience drove him to collaborate with colleagues to create the Advanced Trauma Life Support Program, or ATLS. And that is really where we get the widespread formalization of the ABCs.
Airway, breathing, circulation.
Yes. The logic is brutally straightforward.
Right, because without an open airway,
oxygen can't get in, right, making your lungs useless. And without breathing, oxygen doesn't get into the blood. And without circulation, a beating heart, that oxygenated blood never reaches your brain.
it's a domino effect.
Exactly. And modern nursing actually expands this sequence to A, B, C, D, E.
Okay, what are the D and E?
They add disability, which means conducting a rapid neurological check to see if, the brain is swelling, and then exposure.
Exposure, meaning you have to physically undress the patient.
Right, because you cannot treat a hidden femoral artery bleed if the patient is wearing thick, blood-soaked winter clothing. You expose the skin to find the hidden threats and then immediately cover them up to prevent hypothermia.
Because hypothermia worsens bleeding.
Right. Dramatically worsens it, yes.
Okay, let's bring this back to that car crash scenario from the beginning, because it highlights how this framework prevents nurses from being distracted by the visual drama.
Oh, the screaming guy versus the quiet guy.
Yes. We have the patient with a mangled, bleeding leg, and the quiet patient with the squeaky voice. Tell me about the physiological mechanics of that squeak, what the sources call stridor. Why is that the immediate threat?
Okay, so stridor happens when the airway, like the trachea or the larynx, is severely swollen or obstructed.
Okay.
Imagine a wide pipe that suddenly swells shut until only a tiny pinhole remains. The lungs are desperately trying to suck air through that tiny rigid gap, which creates that high-pitched squeaking vibration.
So it's literally an alarm bell that the pipe is about to close entirely.
Exactly. When you hear stridor, you are listening to an airway that is perhaps minutes or even seconds away from complete irreversible closure.
And once that happens, the patient suffocates.
Right. Whereas the patient with the mangled leg, while visually terrifying, is dealing with a circulation issue.
The C and the ABCs.
Yes, unless it is a catastrophic, geyser-like arterial hemorrhage that will drain their blood volume in 60 seconds, a standard venous bleed gives you a slightly longer window to apply a tourniquet.
Meanwhile, the quiet patient is suffocating right in front of you.
Exactly.
It is just a profound mismatch between what looks most urgent and what actually is. But you know what I find incredible in our sources?
What's that?
That even these life or death foundational rules are subject to change based on new data.
Oh, right. What's fascinating here is the 2010 pivot by the American Heart Association.
Yes, the CPR change.
Right. For decades, CPR was drilled into everyone's head as ABC, airway, breaths, compressions. You tilt the head back, you give 2 rescue breaths, then pump the chest.
But they completely flipped it, right? To CAB compressions first. Why did they do that?
Well, researchers analyzed real-world cardiac arrests, and they found a fatal flaw in human behavior. Bystanders were wasting massive amounts of precious time trying to figure out the exact right head tilt maneuver.
Or they just didn't want to do mouth-to-mouth on a stranger.
Right. They were too hesitant. And during that hesitation, 0 blood was moving to the brain.
They were basically losing the patient while trying to follow the acronym perfectly.
Exactly. The AHA realized that the blood already has enough residual oxygen in it to sustain the brain for a few minutes, provided you physically pump it.
So they changed the rule.
They did start mashing on the chest immediately. Millions of medical professionals and everyday citizens had to entirely relearn the most famous medical acronym backwards just to eliminate that human hesitation.
That perfectly illustrates how prioritization is this, like dynamic science. Okay, so the ABCs solve the first 3 minutes of an emergency.
Right.
But a nurse's shift is 12 hours long.
Oh, absolutely.
Once a patient isn't actively dying, how do you prioritize the next 11 hours and 57 minutes of care? Because to figure that out, modern nursing borrows heavily from psychology, specifically Abraham Maslow.
Yes. Maslow's 1943 paper, A Theory of Human Motivation, was a seismic event in psychology.
A total game changer.
Totally. At the time, Maslow was deeply frustrated. He felt his field was trapped in this false binary.
How so?
Well, on one end, you had Freudian psychoanalysis, which was oppressively focused on neuroses, pathology, and the broken mind.
Right, digging through childhood trauma to figure out why you're miserable.
Precisely. And on the other end was behaviorism. Think of B.F. Skinner and his rats pulling levers for food pellets.
Right, classical conditioning.
Maslow argued that behaviorism treated humans like empty, mindless stimulus response machines. It entirely ignored our rich inner lives.
So what did he do?
He wanted a third force, which became humanistic cytology. Instead of studying the broken or the conditioned, Maslow decided to study the healthiest, most high-achieving people he could find. Minds like Albert Einstein and Eleanor Roosevelt.
He wanted to reverse engineer what makes a human being thrive.
Exactly. So he proposed that human motivation is driven by an ascending hierarchy of needs.
Right, starting from the bottom.
At the very foundation are our physiological requirements: oxygen, water, food, sleep.
The absolute basics.
Once those are secure, we seek safety and security, then love and belonging, then esteem and respect.
And at the very top.
Finally, at the pinnacle is self-actualization, the desire to reach our absolute ultimate potential.
And nursing education actually adopted this as a filtering mechanism.
It did, yeah.
It gives students an intuitive way to rank competing demands. The golden rule the sources mention is airway and breathing before feelings.
It creates a really clear boundary. Imagine a patient recovering from a major surgery. They are highly anxious, crying, and begging you to explain their biopsy results.
Which is a huge emotional need.
Huge. But you notice their oxygen saturation monitor is dropping to 88%.
Oh boy.
Right. Maslow's logic dictates you must aggressively fix the physiological oxygen problem before you even attempt to address the psychosocial anxiety problem.
Because a patient who is actively suffocating cannot cognitively process your emotional reassurance anyway.
Exactly. It just doesn't work.
And within that framework, there is another incredibly useful tool, the actual versus potential rule.
Yes. It solves the dilemma of competing physical needs. Generally, a problem that is currently happening outranks a potential risk.
Right, so like,
Well, if you have patient A who is experiencing moderate pain right now, and patient B who is simply at a high risk for falling out of bed but is currently tucked in safely, you go give patient A their pain medication first.
but the sources note that a potential risk can instantly hijack the priority list.
Oh, entirely. If you are walking toward patient A with that pain medication and you hear patient B trying to climb over their bed rails,
The potential problem just transformed into an immediate physical threat.
exactly. Patient B jumps to the front of the queue and you drop what you're doing to prevent the fall.
Okay, here's where it gets really interesting for me. Because if you say the name Maslow, everyone immediately pictures the pyramid.
Oh, yes, the famous pyramid.
It is arguably the most famous visual in the history of psychology. It's in every intro textbook, it's on dorm room posters, it's in every corporate HR PowerPoint presentation you've ever sat through.
So true.
But our sources reveal a massive historical blind spot. Maslow never drew the pyramid.
It is such a stunning piece of historical revisionism. You can read his entire 1943 paper, top to bottom, and you will not find a single triangle.
So where'd it come from? Who drew it?
The pyramid was actually invented in the 1960s by business management consultants.
You joking?
Nope. They took Maslow's nuanced, fluid ideas and flattened them into a rigid, color-coded triangle to sell corporate motivation training to executives.
Wow. Which means nursing students are often memorizing a second-hand, oversimplified corporate management diagram to make medical decisions.
Yes.
That seems, honestly, slightly dangerous.
Yeah.
What gets lost when we force complex human needs into a corporate triangle?
Well, we lose the fluidity of the human experience. I mean, Maslow himself didn't believe we move through these stages like a video game, unlocking one level before we are allowed to access the next.
Right, life isn't that linear.
It's not. Furthermore, late in his life, he actually added a tier above self-actualization called self-transcendence.
That's that.
It's the desire to connect to something greater than the self, which of course was completely left off the corporate pyramid.
Of course. And there are pretty severe critiques of using this strict hierarchy in a hospital setting, right?
The critiques are substantial. Cross-cultural research demonstrates that the hierarchy carries a heavy Western individualistic bias.
How so?
It places personal self-actualization at the absolute peak, whereas many Eastern or indigenous cultures might place collective harmony, elder respect, or relational needs far higher than individual achievement.
That makes total sense.
Moreover, people who are deeply food or safety insecure don't just stop loving their families.
Right. You don't pause your need for connection just because you missed lunch.
Exactly. And if a clinician applies this flattened pyramid too rigidly, it can actively endanger patients.
Give me an example of that.
Consider a deeply suicidal patient. Under a strict, literal interpretation of Maslow, physiological needs always come first, right?
Right.
So if that suicidal patient complains of mild nausea, a rigid follower might conclude they must treat the physiological nausea before dealing with the psychological safety risk.
Which is obviously a catastrophic failure of judgment.
Hmm.
A suicidal patient's psychological safety must absolutely override a minor physical complaint.
Exactly. The hierarchy is meant to be a heuristic, a general rule of thumb, not an unbreakable law of nature. Context is everything.
Which actually brings us to the most extreme context possible. We've talked about the ABCs for a single patient and Maslow for managing a small group on a hospital floor. But what happens when the entire medical system breaks down?
Oh, right.
When you are dealing with a mass disaster like a train derailment or a structural collapse, and you have 40 patients but only 2 medics.
Yeah, that's when you enter the realm of disaster triage. And this requires a complete inversion of the ethical compass we just discussed.
In what way?
Well, in the U.S., responders often use a system called START, simple triage and rapid treatment.
And the sources mention this was developed by Ho Hospital and the Newport Beach Fire Department in California. How does it physically work in the field?
It is designed for terrifying speed. A responder must evaluate a victim in under 60 seconds.
60 seconds, that's nothing.
It's incredibly fast. They use the RPM check, respiration, perfusion, and mental status.
Break down perfusion for a moment. How do they check that in under a minute?
They check capillary refill. So they press down hard on the patient's fingernail until the nail bed turns white. Then let go and count how many seconds it takes for the pink color to return.
Oh, okay.
If it takes longer than 2 seconds, it means blood isn't circulating properly to the extremities, indicating severe internal bleeding or shock.
Wow. Just from a fingernail.
Yeah. And based on that quick RPM check, the patient receives a colored tag.
Right, the tags.
Red means immediate. They have life-threatening injuries but can survive with rapid intervention. Yellow is delayed, meaning serious but stable. Green is for the walking wounded.
Okay.
And then there is the black tag.
Yeah. This is the part of the sources that genuinely stopped me in my tracks. The black tag is for the expectant, meaning their injuries are so catastrophic that they are incompatible with survival given the limited resources.
That's right.
Wait, so the absolute sickest patients, the ones who normally would get an entire team of surgeons and every machine in the hospital, are deliberately treated last or entirely abandoned.
They are provided palliative comfort if possible, but no life-saving resources are expended on them.
That is a total ethical flip. I mean, we expect the most desperate person to get the most help.
In a functioning hospital, yes, but in a disaster, normal hospital ethics will lead to a systemic massacre.
A systemic massacre, wow.
It is a grim mathematical reality. If you have 10 salvageable patients who need immediate tourniquets and chest seals, and one profoundly crushed patient who is unlikely to survive even with maximum surgical intervention.
Pouring all your time and bandages into that one unsalvageable patient guarantees the other 10 will bleed to death waiting for you.
Exactly.
So the explicit stated goal of disaster triage is unequal care.
The goal is to maximize total survival. You are forced to deliberately withhold resources from the most desperate cases to save the most salvageable lives. It is literally the trolley problem brought out of the philosophy classroom and dropped into the real world.
But this isn't just something that happens in earthquake rubble, right? Because this kind of algorithmic sorting happens inside modern, well-led hospitals too.
It does, yes. Modern emergency departments rely on standardized scoring algorithms to remove human hesitation. They use frameworks like the Emergency Severity Index or ESI, which is a 5-level system.
How does that work?
Level 1 requires immediate, all-hands-on-deck resuscitation. Level 5 is, a minor rash or a prescription refill.
But relying on math and algorithms to prioritize human life has a really dark side.
Yes, it certainly can.
The sources highlight a highly controversial example from the COVID-19 pandemic in 2020.
Right. During the early surges, hospitals were terrified they would run out of mechanical ventilators, so several U.S. states began drafting crisis standards of care protocols.
Which are basically algorithms to decide who gets a vent.
Exactly. Algorithms designed to automatically calculate who would get a ventilator and who wouldn't if the system reached total capacity.
Now, we are looking at this purely through the objective historical record provided in the sources. What exactly went wrong with these algorithms? Because the sources single out drafts from Alabama that actually sparked a massive federal response.
Right. So the early drafts of these scoring algorithms effectively deprioritize people with intellectual and developmental disabilities or individuals with certain chronic conditions.
Wait, how do they do that?
Well, the math was set up in such a way that these patients would be placed at the very bottom of the ventilator waitlist, effectively denying them life-saving equipment based on their pre-existing baseline.
It's like setting up a VIP lane at a nightclub. But the algorithm secretly decided beforehand that anyone wearing glasses isn't allowed in the VIP lane. Like the bouncer at the door isn't biased, he's just blindly following the math. But the math was rigged by the club owner.
That is a perfect metaphor, and it triggered immediate federal civil rights complaints to the U.S. Department of Health and Human Services.
I can imagine.
Several states were forced to drastically revise their protocols under federal scrutiny. It was a stark reminder that pure algorithms don't eliminate human bias, they simply hide it.
That's a chilling thought.
It is. An algorithm can quietly encode discriminatory value judgments about whose life is deemed worth saving, washing the bias in this, veneer of objective mathematics.
So what does this all mean? We have traced an incredible evolution today. I mean, we started with early 19th century battlefields where prioritization just meant stopping the bleeding fast enough to hand someone a musket.
Right.
Then we moved to the ABCs and Maslow's borrowed pyramid to balance physical and psychological needs.
Yep.
Then we looked at the brutal utilitarian math of disaster triage and algorithms, and it all culminates in where the profession is going right now. The sources note that the 2023 Next Generation NCLEX, which is the major exam all nurses must pass, has shifted its entire philosophy toward a dynamic clinical judgment model.
Yes. The exam has evolved beyond asking students to just memorize a checklist. It now tests whether a nurse can recognize subtle cues, analyze them, prioritize hypotheses, take action, and then immediately evaluate the outcome in a constant dynamic loop.
Because the patient's status is always changing.
Exactly. Prioritization is no longer viewed as a one-time decision you make at the door. It is a continuous act of reasoning.
And this matters so far beyond the hospital walls. I mean, the frameworks we discussed today, deciding who or what gets resources when there simply isn't enough to go around, they govern our entire society.
Oh, definitely.
They dictate how 911 dispatchers decide which caller gets the closest police car. They govern how the national organ transplant waiting list is managed. Even tech companies use these exact scarcity frameworks to decide which software bugs to fix first. Prioritization is just the universal discipline of making defensible decisions under pressure.
Which leads to a really profound takeaway when we reflect on this material.
Yeah. What's that?
Well, we look at extreme frameworks like start triage, where medics are forced to brutally abandon the most desperate, complex cases, the black tags, for the greater good. But if you turn that lens inward, it makes you wonder how often we unknowingly make that exact same black tag calculation in our own everyday lives.
Wow. How so?
Think about your workplace, your community, or even your own personal emotional energy. How often do we look at the hardest, most complex, most deeply entrenched problems around us and quietly decide to just walk past them?
We just put them in the black tag pile.
We do. We sacrifice the hardest challenges simply because we feel we don't have the time or the emotional bandwidth to fix them, choosing instead to focus on the quick, easy wins. We might be applying disaster triage to our daily lives, abandoning the things that need us most without even realizing it.
That is a really lingering thought. We walk into life expecting the clarity of an X-ray.
Yeah.
We want the world to be clean, binary, broken, or not broken. But the reality is that we are constantly navigating these diagnostic muddy waters. And when the machine is broken and chaos is the only constant, the most important skill you can possibly develop is deciding exactly where to look first. Thank you for joining us on this deep dive. We'll see you next time.
If you give a patient 0.5 nanograms of this drug per milliliter of blood, you might actually keep them out of the hospital, vastly improve their quality of life.
Right, but if that level creeps up to like 1.2 nanograms, you might kill them?
Yeah. Today, we are looking at the terrifying math of digoxin.
It really is the ultimate narrow therapeutic index drug, NTI. The margin for error isn't just thin. I mean, it is practically invisible.
And yet, it's one of the oldest medications that is still actively prescribed in modern cardiology.
It is, yeah.
Which is exactly why we're dedicating this entire deep dive to decoding it. Because if you are prepping for nursing boards or you're managing medications in an ICU or, you're just fascinated by the extremes of human pharmacology, this drug is constantly popping up.
Absolutely.
So we're going to break down how it forcefully rewires the heart's cellular machinery, the critical lab values that actually predict its toxicity, and the major misconceptions that trip up even really seasoned medical professionals.
But to understand why a fraction of a nanogram dictates life or death today, you kind of have to realize this exact same tightrope was being walked 250 years ago.
Yeah, I was looking at this timeline, and it is just wild to me.
Right.
We have to travel back to 1775 to this physician and botanist named William Withering in Birmingham, England. He was called in to treat a patient suffering from dropsy?
Dropsy, yeah.
Yeah.
Such an archaic, haunting word.
It really paints a picture. Today, we'd call it severe fluid retention from heart failure.
Right,
The
exactly.
patient is essentially drowning from the inside because their heart just cannot pump fluid effectively through the body.
And the standard medical treatments of the 18th century were just completely failing this patient. But they were also taking this folk remedy.
The family recipe.
Yeah, it was this muddy, complex mixture of more than 20 different herbs.
Yeah.
Just a recipe passed down from an elderly Shropshire herbalist who history sometimes remembers as Mother Hutton.
And because Withering was a trained botanist, he didn't just dismiss the sludge, right?
No, he didn't. He analyzed it. And he suspected that out of those 20 plants, one single ingredient was doing all the heavy medical lifting.
Which was Digitalis purpurea, right? The common foxglove plant.
Exactly. So he isolated the foxglove, and spent the next 10 years conducting these systematic clinical trials on his patients.
Which is incredible for the 1700s.
It really is. It all culminated in his 1785 book, An Account of the Foxglove. And that text is considered a foundational pillar of clinical pharmacology.
Because he was systematically tracking dose titration.
Yes, he wasn't just, handing them the plan. He was methodically figuring out the exact amount needed to trigger a physical response.
Wait, so let me ask you this. My initial assumption when reading about historical medicine is always that, they thought they'd found a miracle cure and then they only realized it was a deadly poison like decades later.
Oh no, not with this.
So he knew.
Yeah, Withering actually documented the toxicity from day one. He explicitly warned that pushing the dose even slightly too high caused, violent vomiting, bizarre visual disturbances, and a really slow, highly irregular pulse.
Wow. So he recognized the double-edged sword immediately.
He did. He knew this plant had a power over the cardiac system, unlike anything else in the known world. But, he also saw how easily it could turn lethal.
Right. He meticulously documented what the drug did and the exact signs that you'd given too much. But the actual black box of the cellular machinery was totally hidden from him.
Completely hidden.
Yeah.
I mean, they had no idea how it worked.
Yeah, because the active compound itself, digoxin, which actually comes from a related plant, Digitalis lanata, the woolly foxglove, that wasn't chemically isolated until the 1930s.
Right, and the mechanism of action wasn't even figured out until the mid-20th century.
So for 150 years, doctors were prescribing this incredibly potent, dangerous drug purely based on empirical observation.
Yeah, they could see the outcome, but the biological engine driving that outcome was just a complete mystery.
Okay, so let's open up that black box for the listener. From first principles, I want to really understand the physical mechanism here. How exactly does this molecule force a failing heart to pump harder?
Well, we have to look at the electrochemical gradient of a single heart muscle cell.
Okay.
Every cardiac cell has a pump on its outer membrane called the sodium-potassium ATPase pump.
The ATPase pump, right?
Yeah, and its entire existence is dedicated to using cellular energy ATP to continuously pump sodium out of the cell and pull potassium inside.
So it's maintaining a very steep concentration gradient.
Exactly. So digoxin comes along, finds that specific pump, binds directly to it, and just completely inhibits its function.
It just jams the machinery.
It completely shuts it down, yeah.
Okay, so to make sure this sticks, let me try mapping this onto a physical space.
Okay, let's hear it.
Imagine the heart cell is like a highly exclusive, incredibly crowded nightclub.
Oh, I like this.
Right, so the main exit door, the one everyone uses to leave the club, is that sodium pump. Digoxin is a rogue bouncer who just suddenly barricades that main exit. Okay.
Now, the regular patrons, the sodium, are trapped inside, and the room is just getting totally packed.
That is actually the perfect setup, because the cell has another door, a secondary transporter called the sodium-calcium exchanger, and the situation gets even more chaotic because of it.
Because that secondary door relies on the flow of the main door.
Yes, exactly. The secondary exchanger uses the natural outward flow of sodium to power its own job, which is to pump calcium out of the cell.
Ah.
But digoxin has ruined the sodium gradient. The main door is jammed, the sodium is backed up, so the secondary exchanger completely stalls.
It has no power.
Right. And the end result is that intracellular calcium levels begin to rise drastically.
Okay, going back to the nightclub analogy, because the main exit is blocked, the VIP section, the calcium, also can't get out through their special side door.
Right, they're stuck.
So all these highly energetic VIP calcium molecules are now stranded on the dance floor.
And calcium is the direct biological trigger for muscle fiber contraction.
Wow, okay. So having all that extra calcium trapped inside the cell means the physical contraction of the muscle fibers becomes much, much more intense. We call that a positive inotropic effect.
So the failing heart muscle is basically forced to squeeze with significantly more force.
Yeah. It's a massive rave on a cellular level.
But forcing the heart to squeeze harder is only half of the drug's mechanism, right? Because it also hits the brakes on the heart rate.
It does. Separately from the muscle contraction, digoxin increases vagal tone.
Okay, what does that mean exactly?
It stimulates the parasympathetic nervous system, which acts as the body's natural brake pedal. This stimulation slows down the electrical conduction specifically at the AV node.
And the AV node is the electrical gateway between the top and bottom chambers of the heart.
Exactly. We call this a negative chronotropic or dramatropic effect.
Which is why we see it used for atrial fibrillation, or AFib.
Right.
Because in AFib, the top chambers of the heart are quivering chaotically, just firing off hundreds of rogue electrical impulses down toward the ventricles.
Yeah, it's a mess.
So digoxin doesn't cure that chaotic rhythm, but by slowing down the AV node, it acts like a strict toll booth operator.
I love that. A toll booth operator, yeah.
It throttles how many of those chaotic impulses are allowed to pass through to the main pumping chambers, which keeps the overall heart rate from just spiraling completely out of control.
Stronger contractions, but a slower, more controlled rate. I mean, it sounds like the perfect combination for a failing chaotic heart.
It really does.
But because this mechanism physically alters the foundational electrical gradient of the cells, the line between therapeutic benefit and a fatal arrhythmia is terrifyingly thin.
Yeah, digoxin is the textbook NTI drug. It sits right alongside things like lithium and warfarin.
Oh, absolutely.
But the part of the story that truly shocked me when I was reading the research is that for decades, modern cardiology actually got the definition of safe completely wrong.
The paradigm shift here is massive.
Yeah?
Historically, clinicians defined the therapeutic range for serum digoxin as roughly 0.8 to 2.0 nanograms per milliliter.
That was the gold standard target.
It was. If a patient's blood work came back at 1.5, their doctor felt completely confident they were in the safe zone.
Then the DIG trial happens.
Right.
The Digitalis Investigation Group trial, which was published in the New England Journal of Medicine in 1997, they looked at almost 7,000 patients with heart failure.
A huge study.
Yeah, and I was reading these results, and I have to admit, I'm kind of baffled. The trial proved that the drug does not actually reduce overall mortality.
No, it doesn't.
It does not help you live longer. So given how dangerous the toxicity profile is, I just don't understand why any modern doctor would choose to prescribe this over incredibly effective, safer drugs like beta blockers or ACE inhibitors.
Well, it is a question that gets debated in hospitals literally every day.
I bet.
But the justification lies in what the DIG trial actually did show. It didn't extend life, sure, but it drastically reduced hospitalizations for worsening heart failure.
Oh, okay, so it's about symptom control.
We are talking about severe symptom control. Picture a patient who is already maxed out on beta blockers and modern therapies, but they are still suffocating from fluid buildup. They can't even sleep lying down.
That's awful.
Or an AFib patient whose blood pressure is just too low to tolerate other rate control drugs. Digoxin keeps them out of the ICU. It offers a massive quality of life benefit for a very specific, highly vulnerable niche.
But the 1997 trial wasn't the end of the story, was it?
No, it wasn't.
Because in 2003, researchers published a post-hoc analysis of that exact same DIG trial data in the journal JAMA. And when they broke down the numbers, they found this hidden warning that kind of changed everything.
They did. They realized that the patients who actually had the best outcomes, the fewest hospitalizations, and the lowest risk, had serum digoxin levels between 0.5 and 0.8.
Okay, wow, that's really low.
Very low. But patients whose levels were above 1.2, which remember was historically considered the perfect safe mid-range, they actually suffered increased mortality, particularly women.
That is wild. The physical pill didn't change at all. But the medical consensus on what constituted a poison just shrank drastically overnight.
Exactly. The new therapeutic range was redefined downward to a tiny window of just 0.5 to 0.9 nanograms per milliliter.
Outcome data finally caught up with centuries of empirical dosing.
It did. And with the safe range shrinking to such a microscopic window, recognizing when a patient has inadvertently crossed the line into toxicity is, well, it's one of the most critical skills a clinician can have.
Let's talk about that, because if a patient comes into the emergency room complaining of sudden, bizarre visual changes, that is your first major clue.
Oh, yeah.
And medical students are often taught this really vivid historical theory to remember it. It involves the Dutch post-impressionist painter Vincent van Gogh.
Right. Late in his life, Van Gogh's paintings, like The Starry Night or The Night Cafe, are just dominated by heavy, brilliant yellows and these massive swirling halos around the stars and artificial lights.
It's his signature style from that period.
Yeah, and medical historians have proposed that he might have been suffering from xanthopsia.
Xanthopsia, right.
Which is a condition that causes yellow-tinted vision, alongside seeing physical halos around lights. And both of these are hallmark, classic symptoms of digitalis toxicity.
Obviously, we have to note for the listener that this is entirely speculative.
Oh, 100%.
There is no hard medical record confirming Van Gogh was ever prescribed digitalis, though, it was sometimes used for suspected epilepsy back then. Art historians usually just argue he went through a period where he really favored the color yellow.
The historical debate is endless on that one. But as a teaching tool, it is absolutely brilliant.
It really sticks in your mind.
If you want to remember the unique visual toxicity of digoxin, you just picture the Starry Night.
Yeah.
Yellow vision and halos around lights.
Right.
When a patient on digoxin describes those visual changes, alongside severe nausea, vomiting, lack of appetite, and confusion, you are looking at systemic poisoning.
So visual symptoms and nausea are the subjective clues, but the immediate next step is getting them on a heart monitor.
Always.
And this is where nurses and doctors get completely faked out by what they see on the screen.
Yes, they do.
Because there's a very specific ECG finding a stooped ST segment depression that literally looks like a Salvador Dali mustache. I've always heard people associate that shape with digoxin toxicity.
It is arguably the single most common misconception regarding this drug.
Really?
Yeah, that scooped ST segment does not mean the patient is poisoned. It is simply the digoxin effect.
Wait, then why does it create that specific shape if it isn't toxic?
Well, think back to the jammed cellular pumps.
The nightclub doors.
Right. The ST segment on an ECG represents repolarization, the moment the heart is electrically resetting itself for the next beat.
Okay.
Because digoxin is blocking the sodium-potassium pumps, those cellular ions are physically struggling to get back to their baseline positions.
Oh, I see.
That electrical struggle literally pulls the baseline of the ECG downward, creating that scooped, mustache-like appearance.
So it shows up in patients who are taking a perfectly therapeutic, non-toxic dose.
Exactly. It just proves the drug is in their system doing its job.
Wow. Okay. So a Dali mustache is expected. What does actual fatal toxicity look like on the monitor then?
True toxicity manifests as highly dangerous arrhythmias.
Like what?
For example, paroxysmal atrial tachycardia with an AV block.
Okay, break that down for me.
This means that the top chambers of the heart are firing at an incredibly fast abnormal rate. But because digoxin is clamped down so heavily on the AV node's toll booth, those signals are blocked from reaching the ventricles.
Got it.
You might also see bidirectional ventricular tachycardia.
That sounds intense.
It is. It's where the electrical signal is so profoundly corrupted, it is literally ping-ponging back and forth across the ventricles in opposite directions on the monitor.
Jeez.
Yeah, so you had to combine those severe arrhythmias with the physical symptoms and then verify it all with a blood test.
But even the blood test can lie to you if you don't time it perfectly, right?
Oh, absolutely.
Because if a patient takes their morning pill, feels nauseous 2 hours later, and you draw their blood right then, the lab level might come back completely normal.
The timing is everything. Because the digoxin binds extensively to tissue, especially the heart and skeletal muscle.
Okay.
If you draw blood within the first 6 to 8 hours after a dose, the drug hasn't fully distributed into the tissues yet. It's still just circulating in the bloodstream.
So the lab is just measuring that free-floating amount.
Right, and it will give you a deceptively low or normal number, which completely masks the lethal amount of drug that's already bound to the heart muscle.
That's terrifying.
You must always draw the level at the trough, which is the absolute lowest point of concentration, ideally right before they're scheduled to take their next dose.
Okay, so drawing the level at the trough ensures you see the true baseline. But there is another lab value that we have to check alongside the digoxin level, and it introduces this massive paradox.
Potassium.
We need to talk about potassium, because I was always taught that low potassium is the biggest danger for a patient on digoxin. But the data shows that a high potassium level is actually the ultimate red flag for mortality.
This is the potassium paradox. And to untangle it, we have to completely separate chronic everyday toxicity from an acute massive overdose.
Oh, okay.
Because they behave in entirely opposite ways. Let's look at chronic toxicity first.
All right, lay it out for me.
A classic scenario. An 80-year-old patient on a stable, perfectly calculated daily dose of digoxin gets a severe stomach bug and becomes dehydrated. Or, maybe their doctor starts them on a new diuretic.
Right.
As a result, their total potassium drops. This is hypokalemia.
Okay, so in that everyday scenario, the low potassium is the driver of the danger. Why does a lack of potassium make the drug more toxic?
Because potassium and digoxin are physically competing for the exact same binding sites on those sodium-potassium ATPase pumps.
Oh, they're fighting for the same parking spot.
Exactly. If the patient's potassium drops, the competition disappears. Digoxin is left unopposed, so it binds much more aggressively to the pumps, heavily exaggerating the drug's effect.
Wow. So the dose didn't change at all, but because the potassium vanished, the drug suddenly grips the heart much tighter.
Yes, hypokalemia worsens the chronic poisoning.
That makes perfect sense for the slow, creeping toxicity. But what happens in an acute overdose? Say someone accidentally ingests a massive handful of pills all at once.
In a massive acute overdose, the biological mechanism flips entirely.
Really?
The sheer volume of digoxin floods the system and completely paralyzes the ATPase pumps all over the body. Not just the heart, but skeletal muscle too.
Huh.
Because those pumps are entirely disabled, potassium cannot be pumped into the cells at all. It gets trapped outside and leaks rapidly into the bloodstream faster than the kidneys can filter it out.
Which causes severe hyperkalemia.
Dangerously high potassium in the blood, exactly.
So the high potassium isn't causing the toxicity in this case. It's a massive downstream symptom of the pumps shutting down globally.
Yes. And we owe that realization to a toxicologist named Charles Bismuth in the 1970s.
What did he find?
He proved that in acute digoxin overdose, the degree of hyperkalemia is a direct predictor of whether the patient will survive.
Yeah.
He found that if a patient's serum potassium crossed roughly 5.5 milliequivalents per liter during an acute overdose, their mortality rate skyrocketed to nearly 100% without immediate intervention.
That is a staggering statistic.
It really is. The direction of the potassium abnormality tells you exactly what kind of poisoning you are dealing with.
Well, if a patient is in that nightmare scenario like massive acute overdose, potassium soaring past 5.5, their heart ping-ponging in bidirectional VTach, we actually have a highly specific antidote to save them.
We do.
I read about how they developed this antidote in 1976, and it sounds like absolute science fiction for the era. They didn't just, mix chemicals in a lab.
No, they didn't. Thomas Smith and his research team developed DigiFab, which was originally known as DigiBind. It was an incredibly early, groundbreaking use of biologics in toxicology. They systematically immunized sheep with digoxin derivatives.
Sheep.
Yes, sheep. The sheep's immune systems created specific antibodies to fight off the digoxin. The researchers then harvested and cleaved those antibodies into microscopic fragments.
So when you infuse those sheep antibody fragments into a dying, poisoned patient, they basically hunt down the free digoxin molecules in the bloodstream and bind to them.
Exactly.
They act like little molecular handcuffs, just rendering the poison completely inert.
That is exactly how it works. And the new digoxin antibody complex is highly water-soluble, meaning the kidneys can easily recognize it and excrete the handcuff poison straight out of the body in the urine.
That is incredible.
You just calculate the required number of antidote vials based directly on the patient's estimated total body digoxin load or their steady-state serum level, and the reversal of toxicity is rapid and profound.
The sheer brilliance of using targeted biologics